हॅलो.
गुड मॉर्निंग मॅम.
हा, गुड मॉर्निंग अक्षय. अं, आपलं जे नॉर्मल सेशन आहे ना ते 9:30ला सुरू होणार आहे. मग मला वाटतं तेव्हाच मॅक्झिमम लोक जॉईन होतील.
हो हो, चालेल मग काही issue
एक 9 सव्वा 9 पर्यंत तरी होतील. हा हा. आणि ते समाधान सरांनी तुला सांगितलं होतं त्याप्रमाणे तू ते दिवा किंवा हे केलंयस का, धन्वंतरी इमेज?
नाही. हो मॅम, एक डाउनलोड करून ठेवली.
चालेल मग. हा, मग आता मी परत एक 9 किंवा सव्वा 9ला जॉईन होते. म्हणजे आता जॉईनच राहते, फक्त आपण तेव्हा नंतर अजून बोलू. बाकी काही तुला डाऊट आहे?
नाही मॅम, काय.
हा, मी जे जे सेशनचे जसे असतील ना कोऑर्डिनेटर, तसं मी तुला सांगेल. आपण ते त्यावेळी बघूया. हा, चालेल.
चालेल. ओके मॅम.
ओके ओके. चल, थँक्यू.
Hello, Dr. Akshay. Am I audible?
Yes, sir, you are.
Uh, मैं वीडियो नहीं देख पा रहा हूँ. हॅलो.
सर तुम्ही वेबकॅम ऑफ केलाय का? त्यामुळं ब्लॅक ब्लॅक येते.
वेबकॅम ऑनच तर आहे. आता ऑफ केला, आता ऑन केला. काय प्रॉब्लेम झाला काही लक्षात नाही आलं माझं. मी कुठं सेटिंग मध्ये वगैरे जाऊ का?
हो सर, तुमच्या लोकल कम्प्युटरचा वरचा जर फ्लॅप बंद असेल त्यामुळं पण व्हिडिओ दिसत नाहीये.
फ्लॅप तर सुरूच आहे यार.
हा
सॉरी
सर.
सॉरी 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 सॉरी. एक मिनिट आणखी. याच्या व्हिडिओमध्ये त्याच्यानंतर व्हिडिओ सेटिंग्स, बॅकग्राऊंड, त्याच्यानंतर ऍड. एक मिनिट अक्षय सर, तुम्ही राहा याच्यामध्ये. हे बॅकग्राऊंड दिसत आहे का?
येस सर, परफेक्ट.
पण ते उलट नाही आहे ना?
नाही सर, नाही.
नाही. एकदम बरोबर आहे.
येस सर.
चला, थँक्यू. थँक्यू डॉक्टर अक्षय. Jayashree madam, am I audible to you? Dr. Jayashree Taide madam.
Yes, sir.
Good morning, madam.
Good morning, sir.
Good morning. We will start soon, madam.
Okay, sir.
हेलो।
मी बोललोच नाही आलं.
हेलो
योर वॉइस
अजीत
इज
सर,
गुड मॉर्निंग सर.
मेरे ख्याल से अभी 9:45 हो गए, 15 मिनट में हम सेशन शुरू कर रहे हैं। तो
यस
इनॉग्रेशन सेरेमनी जो है अपने डॉक्टर सपन जैन सर चीफ गेस्ट है, और डॉक्टर रवि श्रीवास्तव सर को आपने कॉल किया है सर?
मैंने कॉल कर दिया सर, और सर से रिक्वेस्ट भी किया है ज्वाइन होने के लिए. उन्होंने कहा वो ज्वाइन हो जाएंगे.
हाँ हाँ, क्योंकि सर की अभी थोड़ा सा भी स्टेक होल्डर्स की मीटिंग है ना, कुछ
जी
जल्दी में
सर.
है, तो इंसेसिव ऑफिस वगैरह ऐसा है। तो ठीक है, कोई बात
ओके.
नहीं। 9:42 हो गए, 45 मिनट्स को शुरू कर दो। हाँ,
यस सर.
डॉक्टर अवलस्कर सर आए हैं ना, वो धन्वंतरि स्तवन करने के लिए।
सर
डॉक्टर अमित
उनका
अवलस्कर।
उनका नहीं था सर कांटेक्ट नंबर, डॉक्टर अमित आवलस्कर सर.
मैंने उनको कॉल किया था अभी,
जी.
तो ज्वाइन होने वाले थे। मैं उनका नंबर भेज देता हूँ।
Good morning, sir. Are you
वेरी गुड
able
मॉर्निंग
to?
मैडम.
Good
Good
morning.
morning, ma'am.
I was just checking my voice is coming or not.
इट इज
Yes, you
क्लियर
are
and
audible,
audible.
ma'am.
Okay, okay. Thank you, ma'am. Thank you. Sir, sir is
डॉक्टर
there
अमित अवलस्कर,
for joining.
हेलो, डॉक्टर अमित अवलस्कर इज देयर?
तुम्ही तिकडनं हॅलो, डॉक्टर अक्षय. अमित अवळसकर सर ना. येस, थँक्यू.
हाँ।
पीछे वाले रूम में बैठ जाइए.
एक 5 मिनट में खत्म होने वाला। 5
रिटायर आईएएस लोग आएंगे.
सर, 5 मिनट में होगा क्या? अजीत सर,
यस सर.
Yes, we can start now. It is 9:45. Ravi sir is there. Dr. Sapan Jain sir is also there. So we can start. Dr. Amit Avlaskar sir also is there. So start, please.
थैंक यू वेरी मच। गुड मॉर्निंग ऑल। अपने हौसलों के दम पर अपनी प्रतिभा दिखा देंगे, भले ही कोई मंच ना दे हमको, हम मंच अपना बना लेंगे। जो कहते खुद को सितारा है, जगमगा कर उनके सामने ही चमक कर देंगे फीकी उनकी, और सूरज खुद को बना लेंगे, सूरज खुद को बना लेंगे। नमस्कार, गुड मॉर्निंग, केम छो, आपन कसे आहात? आयुर्वेदा टीचर्स एसोसिएशन के इस सुंदर और जिंदा दिल सफर में मैं डॉक्टर अजीत कुमार वहाने, महात्मा गांधी आयुर्वेद कॉलेज हॉस्पिटल एंड रिसर्च सेंटर वर्धा से आपका स्वागत करता हूं, मेरी को होस्ट डॉक्टर जयश्री तायडे मैडम के साथ। आयुर्वेद जगत के इस भव्य समारोह में आपका स्वागत। एटीए आयुर्वेदा टीचर्स एसोसिएशन द्वारा आयोजित 8th नेशनल कॉन्फ्रेंस एटेकॉन 2026 इनोवेटिव आयुर्वेदा, जिसका समर्थन किया है एनसीआईएसएम न्यू दिल्ली, जो संबंधित है मध्य प्रदेश मेडिकल साइंस यूनिवर्सिटी एवं मध्य प्रदेश आयुर्वेदा एंड यूनानी काउंसिल भोपाल, और इसके सह मेजबान है एलएन सिटी यूनिवर्सिटी भोपाल मध्य प्रदेश। ये हमारा उद्घाटन समारोह है, जिसे हम 22 अगस्त 2026 को ऑनलाइन सत्र द्वारा आयोजित कर रहे हैं। आप सभी का फिर से एक बार स्वागत। क्या ढूंढते हो आसपास, तुम्हारे अंदर ही छुपा हुआ है कुछ खास। आज एटेकॉन 2026 इनोवेटिव आयुर्वेदा 8th नेशनल कॉन्फ्रेंस के इस ऑनलाइन मंच से हम सब एक नया इतिहास बनाएंगे, जो आयुर्वेद क्षेत्र में एक मील का पत्थर साबित होगा, जिसमें आयुर्वेद को समझेंगे, उस पर बात करेंगे, चर्चा करेंगे एवं नए ज्ञान का उत्थान करेंगे। अमूमन हम एक नई राह का निर्माण करेंगे, नई उमंग, नई दिशा, नए अंदाज से एटेकॉन 2026। सुकून मिलता है उस कामयाबी का जब वो अपनी मेहनत की हो, वो मुस्कुराहट कोई नहीं छीन सकता जिसकी वजह खुद ही हो। अकेला वो भी क्या होगा जिंदगी में जिसे साथ की जरूरत ही ना हो। आप सभी के इस साथ के लिए बहुत बहुत धन्यवाद, जो आप एटेकॉन 2026 के इस सुनहरे सफर में हमारे साथ जुड़े। इसी साथ के साथ हर कदम से कदम मिलाते हुए इस ऑनलाइन सत्र में उपस्थित सभी आदरणीय अतिथि गणों का मैं स्वागत करता हूं, सभी माननीय महानुभावों का मैं स्वागत करता हूं, सभी माननीय प्राचार्य गणों का मैं स्वागत करता हूं, सभी माननीय शिक्षक वृंद गणों का मैं स्वागत करता हूं एवं मेरे सभी प्रिय विद्यार्थी मित्रों का मैं स्वागत करता हूं। सुस्वागतम, सुस्वागतम, सुस्वागतम। नमस्कार, आप सब कैसे हैं? क्या अंधकार से डरना, आओ सूरज बनते हैं, धरती अंबर के तमसारे जो डटकर छटते हैं, एक नूर बने रूहानी सा, रोशन यह आलम हो जाए, आओ सब मिलकर उजियारे का दीप जलाए। किसी भी शुभ कार्य को शुरू करने से पहले भगवान धन्वंतरी का नाम लेना चाहिए, ताकि उनका आशीर्वाद हम सब पर बना रहे। तो आइए इस परंपरा को आगे बढ़ाए। मैं डॉक्टर अमित आवलस्कर सर से निवेदन करता हूं कि वे धन्वंतरी स्तवन गायन करें।
नमस्ते।
नमस्ते सर।
आवाज आ रही है ना मेरी?
आपकी आवाज आ रही है सर।
मैं शुरू करता हूँ।
प्लीज सर।
शंखं चक्रं जलौकान् ददमृत घातम् चारुदोर्भिः चतुर्भिः सूक्ष्म स्वच्छाति हृद्यम् औषुक परि मौलिमं हो नेत्रं कालाम्बोदो ज्वलाननं संग तार पीताम्बराद्यं वन्दे धन्वन्तरिं तं निखिला गाद प्रौदामि लीलम् ये स्तवन मैंने भिम्पलास, मारू बिहार और वृंदावनी सारंग ये 3 रागों में रचा, ये कंपोज किया था। धन्यवाद।
Thank you, Amit sir, for these beautiful blessings of Bhagwan Dhanvantari. A very pleasant and auspicious morning to all. I, Dr. Jayashri, as day in charge for today's proceedings of online session Atacon 2026, on behalf of the entire organizing committee, I extend a warm and cordial welcome to our respected chief guest, Dean LNCT Ayurved College Bhopal, Dr. Sapanjan sir, ATA President Madhya Pradesh, Dr. Ravi Srivastav sir, National President ATA Dr. Suryavanshi sir, Vice President Dr. Sachin sir, our Secretary Dr. Nitin Chandurkar sir, Treasurer Dr. Nitin Wagmare sir, and all respected dignitaries of Ayurveda Teachers Association, all learned faculty members, esteemed researchers, all session coordinators, and my dear delegates, who are all joining virtually today on 22 August from all corners of our country in this 8th National Conference of Ayurveda Teachers Association, Atacon 6 2026. I welcome you all. For this inaugural function, we are profoundly honored to have distinguished panel of visionaries whose expertise continues to guide academic excellence across our nation. Now, firstly, please join me in welcoming Dr. Sachin Chandalia sir for the introductory speech. Sir is Honorable National Vice President of Ayurveda Teachers Association. Sir has been a pillar of strength and leading visionary for the ATA community across the nation. I humbly request Dr. Sachin Chandalia sir to kindly bless his profound words of wisdom. Dr. Sachin sir, are you there?
Yes, ma'am.
Yes,
Thank you, Jayashri ma'am. Good morning to good morning all. Respected Dr. Rahul Suresh sir, National President of ATA, Dr. Sapan Jain sir, Dean LNCT Ayurved College, and Dr. Ravi Srivastav sir, ATA President of Madhya Pradesh, and all my colleagues in the our executive committee, and all the participants in the seminar, and all the faculties who are joining virtually in this today's session. I welcome you all on behalf of ATA in this 8th national conference holding in Bhopal, LNCT University. So I would like to welcome and uh, uh, request everyone to enjoy this 2 days national seminar. It is going to be held in both the manner, virtual as well as offline, online as well as offline. So today it is going to be the online session in which we will conduct a lot of parallel sessions where all the delegates will participate their thoughts, share their thoughts regarding the innovative Ayurveda, and we'll put some new ideas. We always try to bring the best from the people who are leading Ayurveda in the forthcoming future. So every time we go with the new theme, we ask uh, the participants to brainstorm those things and to bring the best ideas in front of the Ayurveda world. So I welcome you all in this two days national seminar, 8th national seminar, Atacon 2026, and wish all my colleagues and the delegates very best of luck, and congratulations to my team also for holding this national seminar. Thank you very much. Thank you very much.
Thank you, Sachin sir, for your wishes and for your introductory speech. Thank you, sir, once again. Now, I warmly welcome Dr. Ravi Srivastava sir, the esteemed president of Ayurveda Teachers Association, Madhya Pradesh, for the motivational speech. As we gather for the Atacon 2026, this event is co-hosted here in the historic city of Bhopal. We are deeply privileged to have such leadership guiding this grand event. Sir's unwavering dedication to spreading traditional knowledge and fostering research serve as a true inspiration to us all. I humbly request Dr. Ravi Srivastava sir to kindly take a virtual platform and address her. Please, floor is yours, sir. Dr. Ravi Srivastava sir. Ravi Srivastava sir.
जी
Yes.
I am audible.
Yes, sir, you're audible. We welcome you, sir, and please go ahead. Thank you, sir.
देश के सभी राज्यों will हमारे ऑनलाइन आज देश के विभिन्न राज्यों में आयुर्वेद जगत के शिक्षक और विद्यार्थी एकत्रित हुए हैं। यह केवल एक सम्मेलन ही नहीं बल्कि विचारों अनुभव इस भाव
Ravi, sir, your voice is breaking, sir. It is not audible now.
कैसी है, पंखों से कुछ नहीं होता, हौसलों में उड़ान होती है। जब ज्ञान और अनुभव का सागर हो तो निश्चित ही हमारे जीवन में हमको एक बहुत बड़ा प्रशस्त मार्ग मिल जाता है। आज का ये आयोजन इसलिए भी विशेष है क्योंकि शिक्षा के जुड़े हुए विषयों को लेके आगे बढ़ रहा है। आयुर्वेद केवल हमारी प्राचीन चिकित्सा परंपरा ही नहीं बल्कि यह भारतीय ज्ञान विज्ञान की एक ऐसी समृद्ध धरोहर है जिससे स्वास्थ्य, चिकित्सा, जीवन शैली और मानव कल्याण की व्याप्त दृष्टि निहित है इसके अंदर। तो हमें निश्चित रूप से विश्वास है कि इस परंपरा को आगे बढ़ाते हुए गुणवत्तापूर्ण शिक्षा, सक्षम शिक्षक, आधुनिक शोध और वैज्ञानिक दृष्टिकोण और प्रभावी संवाद से हम लोग निश्चित रूप से आगे इसमें बढ़ सकेंगे। मैं विभिन्न राज्यों से जुड़े हुए सभी सम्मानीय अतिथि, शिक्षकों और विद्यार्थियों का हृदय से अभिनंदन करता हूं और आपका यहाँ उपस्थित होना इस आयोजन की गरिमा की ओर बढ़ाता है। आपको बहुत बहुत ही धन्यवाद। जय आयुर्वेद, जय हिंद।
Jai Arvind, sir. बहुत बहुत धन्यवाद. Thank you for your valuable insights, sir. Now, we are incredibly fortunate to have with us a visionary leader, our esteemed chief guest, Dr. Sapanjay sir. Sir is Dean, LNCT Ayurveda College, Bhopal, who has dedicated years to the field of Ayurveda and research. Please join me in welcoming Dr. Sapanjay sir. Dr. Sapanjay sir. Are you there, sir?
Ma'am, kindly unmute Sapanjan sir.
Sir is now
Unmute. Oh, actually,
connected. Yes.
I made a call to him. Yeah.
Yes, sir. Dr. Sapanjan sir, please join us.
हाँ, गुड
We look
मॉर्निंग
forward your enlightening words, sir. Yes. Welcome, sir.
सभी को नमस्कार। मेरी आवाज आ रही है?
Yes, sir. You're audible now. Yes.
एटकॉन 2026 में आप सभी का स्वागत है और आदरणीय रवि सर, आदरणीय राहुल सर एंड सभी डिग्निटरीज, सभी को मेरा नमस्कार। एटकॉन 2026 से जो भोपाल में 22 और 23 अगस्त 26 को आयोजित होने वाला है, आज ऑनलाइन सेशन के सभी रिस्पेक्टेड कीनोट स्पीकर्स का मैं स्वागत करता हूं। जैसा कि अभी रवि सर ने बताया कि यह एक आयोजन एक भव्य स्वरूप में आयोजित किया जा रहा है और इसके लिए मैं सबसे पहले धन्यवाद देना चाहूंगा राहुल जी का, रवि श्रीवास्तव सर का, जिनको एलएनसीटी यूनिवर्सिटी ने को होस्ट बनने का अवसर प्रदान किया। इस अवसर पर ऑनलाइन प्रेजेंटेशन में आज जो स्टूडेंट और फैकल्टीज अपना रिसर्च पेपर प्रस्तुत करेंगे, उनको भी मैं शुभकामनाएं देना चाहता हूं एवं बधाई देना चाहता हूं और सभी से अपेक्षा रखता हूं कि ऑनलाइन सेशन के जो भी कीनोट स्पीकर्स हैं उसका सेशन जरूर ध्यान से सुने और उनका, क्योंकि अपना इसका जो उद्देश्य ही है कि वो अपना आयुर्वेद का नॉलेज, इनोवेटिव आयुर्वेद का जो नॉलेज है वो एक दूसरे से शेयर हो और हमारे आयुर्वेद की उन्नति हो। और इसी शुभकामनाओं के साथ में एटकॉन 2026 के सभी आयोजनकर्ताओं को, जिसमें मैं भी हूँ, उनको धन्यवाद देता हूँ एवं अपेक्षा करता हूँ कि यह प्रोग्राम 22 और 23 का एक भव्य स्वरूप लेकर इसका उद्घाटन एवं समारोह समापन भी होगा, जो कि एक यादगार रहेगा। धन्यवाद।
बहुत बहुत धन्यवाद सर, आपकी शुभकामनाओं के लिए एवं आपके मार्गदर्शन पर शब्दों के लिए। वो खुद ही नाप लेते हैं बुलंदी आसमानों की, परिंदों को तालीम नहीं दी जाती उड़ानों की। महकना और महकाना तो काम है खुशबू का, खुशबू नहीं होती मोहताज कद्रदानों की। और आज एटेकॉन 2026 इनोवेटिव आयुर्वेदा 8th नेशनल कॉन्फ्रेंस के इस मंच में हमारे बीच ऐसे ही कद्रदान जुड़े हैं जिनके द्वारा यह एटेकॉन 2026 संभव हो सका। सभी माननीय अतिथिगणों का धन्यवाद। एटीए आयुर्वेदा टीचर्स एसोसिएशन भारत की पहली ऐसी संस्था है जो सभी आयुर्वेद शिक्षा संस्थानों के अध्यापकों को एक मंच पर एकजुट करती है। यह शिक्षकों के लिए एक मंच प्रदान करती है जहां वे अपने विचारों और अपने अनुभवों को साझा कर सकते हैं। इसके अलावा यह संघ आयुर्वेद के क्षेत्र में विभिन्न मुद्दों पर एनसीआईएसएम और अन्य हितधारकों के साथ बातचीत भी करता है। एटीए प्रेसिडेंट डॉक्टर राहुल सूर्यवंशी सर, एटीए सेक्रेटरी डॉक्टर नितिन चांदुरकर सर, एटीए ट्रेजरर डॉक्टर नितिन वाघमारे सर एवं अन्य कार्यकारिणी सदस्यों से बना एटीए आज पूरे भारतवर्ष में फैल चुका है। भारत के लगभग सभी आयुर्वेद कॉलेज से जुड़ते हुए हम हमारा 8वां पर्व मना रहे हैं इस नेशनल सेमिनार के द्वारा। ना थके अभी पैर, ना अभी हिम्मत हारी है, हौसला है हिम्मत है, हौसला है हिम्मत है, जिंदगी में कुछ कर दिखाने का, इसलिए सफर अब भी जारी है, सफर अब भी जारी है। इस बेहतरीन सफर को आगे बढ़ाते हुए मैं निवेदन करता हूं एटीए प्रेसिडेंट डॉक्टर राहुल सूर्यवंशी सर से वे प्रेसिडेंशियल स्पीच मार्गदर्शन करें। डॉक्टर राहुल सूर्यवंशी सर।
Good morning, sir. Am I audible?
Yes sir, you are audible.
Yes. Good morning and namaskar, everyone. Most respected chief guest of honor, my dear office bearers of ATA, respected principals, doctors, teachers, researchers, and students from all over India, and all registered delegates. First, my sincere gratitude to LNCT University Bhopal, Chancellor, VC, Dean Dr. Sapan Jain sir, and the entire organizing team of ATA Madhya Pradesh under the guidance of Dr. Ravi Srivastav sir for Atacon 2026, 8th National Conference of Ayurved Teachers Association. if we see our last 7 conference theme, at first conference when we held in Pune in 2018, first conference theme was quality education. Second is research in Ayurveda. Third one is update in Ayurveda. Fourth conference was held on the theme of evidence-based Ayurveda. Fifth, future of Ayurveda 2050. And sixth was new horizons in Ayurveda. And seventh, future avenues and recent advances in Ayurveda. These are last 7 conference theme. This shows our vision towards Ayurveda. Now, eighth conference theme is our innovative Ayurveda. Today, when we say the theme is innovative Ayurveda, bridging tradition with technology for global wellness, it is not just a theme, it is our responsibility. My dear teachers, colleagues, the future of Ayurveda is not the conflict of tradition versus modern. The future is integration with innovation. So this our theme, I think, gives us very good knowledge and one vision. I once again welcome you all to Atacon 2026. My best wishes to all presenters, delegates, and organizers. May this conference give us new knowledge, new friends, and new energy also. So I'm very thankful to Dr. Ajit Kumar Mane sir, Jayasri Tade sir, who organized this very good inauguration program and handling today, full day, this journey of Ayurved knowledge. So once again, thank you and best wishes. Ayurved JATA.
Jai Arvind sir. Thank you for presidential address, Dr. Rahul Suryavanshi sir. Your efforts for the welfare of Ayurveda is truly motivating, sir. Your exceptional leadership role continues to steer our association towards new horizons in Ayurveda, education, and research. Your leadership and emphasis on integrating evidence-based framework into Ayurvedic education beautifully complements our objective of driving innovation, and it implements our this year theme, innovative Ayurveda. Thank you so much, sir. Now, as we towards conclude our inaugural session, I request our treasurer, Dr. Nitin Bagmare sir, to please deliver vote of thanks. I request Dr. Nitin Bagmare sir to please join for the vote of thanks. Dr. Nitin sir, are you there?
Yeah.
Yes, sir.
Yes.
Thank you, sir.
Am I audible?
Yes, sir, you're audible.
Good
Please
morning.
continue.
Thank
Good
you,
morning,
Dr.
sir.
Jayashree. Respected dignitaries on the dais, esteemed representatives of the National Commission of Indian System of Medicine, Madhya Pradesh Medical Science University, Madhya Pradesh Ayurveda and Unani Council, LNCT University, and office bearers of the Ayurveda Teachers Association, distinguished speakers, respected teachers, delegates, and dear colleagues. It is my privilege and honor, on behalf of Ayurveda Teachers Association, to propose the vote of thanks at the inaugural session of this online conference. At the outset, I express my heartfelt gratitude to our chief guest and all the esteemed dignitaries for gracing this inaugural session with their valuable presence and inspiring words. Your presence has added great significance, dignity, and academic value to this gathering. I extend my sincere thanks to the esteemed representatives and authorities of the NCSM for their continued guidance and commitment towards maintaining academic standards, strengthening Ayurvedic education, and promoting excellence in the Indian system of medicine. I also express my deep gratitude to Madhya Pradesh Medical Science University for its valuable support and encouragement in promoting academic activities, professional development, and meaningful collaboration in the field of Ayurveda. My sincere appreciation goes to the Madhya Pradesh Ayurveda and Unani Council for its constant support and encouragement and contribution towards the growth, preservation, and advancement of Ayurveda and allied systems of medicine in the state. I convey my heartfelt thanks to LNCT University for providing an excellent academic platform and extending its valuable cooperation in making this conference possible. The university commitment to education, innovation, and interdisciplinary learning is truly commendable. I sincerely thank our President, secretary, and all the office bearers of Ayurveda Teachers Association for their vision, leadership, and untiring efforts in bringing together teachers, academicians, researchers, and students from different parts of the country on a common academic platform. My special appreciation goes to the organizing committee and the technical team whose meticulous planning, coordination, and dedicated behind the scenes efforts have ensured the smooth conduct of this online conference. I extend my sincere thanks to all our esteemed resource persons and speakers for generously sharing their knowledge, experience, and valuable insights. Their academic contributions will certainly inspire us and enrich our professional journey. I also take this opportunity to thank each and every delegate, faculty member, postgraduate student, researcher, and participant for joining us and making this conference meaningful through your enthusiasm, interaction, and active participation. As teachers and practitioners of the Ayurveda, we have a shared responsibility to preserve our rich heritage while embracing scientific thinking, academic excellence, research, innovation, and evidence based practice. Conferences such as this provide us with an opportunity to learn from one another, exchange ideas, and strengthen our collective vision for the future of Ayurvedic education and healthcare. The collaboration among NCSM, MPUSU, Madhya Pradesh Ayurveda and Unani Council, LNCT University, and the Ayurveda Teachers Association reflects the importance of collective efforts in strengthening an academic and professional foundations of Ayurveda. Finally, I express my sincere gratitude to everyone who has directly or indirectly contributed to the success of this inaugural session. On behalf of the Ayurveda Teachers Association, I once again welcome you all and extend my heartfelt thanks to each one of you. Let us continue to learn, collaborate, and grow together for the advancement of Ayurvedic education, research, innovation, and healthcare. Thank you all. Jai Ayurveda. Thank you.
Jai Ayurveda. Thank you for the words of gratitude, Dr. Nitin Waghmare sir. Here we conclude our inaugural session. Thank you everyone who joined for this inaugural function. Thank you all the dignitaries, all principals of various colleges, all learned researchers, faculty members. Thank you everyone who joined this inaugural function. Now we will move forward for our online session. Which have around 7 comprehensive sessions starts from 10 a.m. up to 6 p.m. So once again, thank you everyone. So we will start our online session. Moving forward, I'm proud we announced that this year Atacons hold esteemed affiliations and support from the apex bodies. This conference is affiliated with Madhya Pradesh Medical Science University as well as Madhya Pradesh Ayurveda and Unani Council Bhopal. Furthermore, we are deeply honored that our conference is endorsed by the National Commission of Indian System of Medicine, that is NCISM New Delhi. Such collaborations are truly elevating the academic standards of our deliberations. And stepping into the core focus of our gathering, our central theme has been chosen as Innovative Ayurveda, bridging tradition with technology for the global wellness. Innovation. Innovation is the bridge that connects the ancient wisdom with the modern scientific validations. And keeping this theme in mind, all our online sessions throughout the day will be dedicated to and based on this profound theme. So today, on this 22 August, we will be conducting around 7 comprehensive sessions running continuously from 10 a.m. to 6 p.m. And we look forward to an intellectually stimulating day filled with rich insights and academic excellence. So, thank you everyone. We will start with our first session. For first session, I would like to invite our session coordinators, Dr. Meenakshi Palbagal ma'am, Dr. Ankush Dikonwa sir. Dr. Meenakshi Palbagal ma'am is Associate Professor, डिपार्टमेंट ऑफ प्रसूति एंड स्त्री रोग तंत्र, एलन सिटी आयुर्वेद कॉलेज एंड हॉस्पिटल, भोपाल, मध्य प्रदेश. Are you there, ma'am?
Yes, ma'am.
We welcome you, ma'am.
Thank you, ma'am.
Our next session coordinator for this session is Dr. Ankush Dikonwar, sir. Sir is Assistant Professor, Department of Rog Nidan Vikruti Vigyan, Datta Mege Ayurved Medical College Hospital and Research Center, Nagpur. Sir, Dr. Ankush, sir, are you there? Okay, we welcome our session first coordinators, and I request our session first coordinators to continue with the first session. Thank you, Meenakshi ma'am.
Thank you, ma'am. So, good morning to all the dignitaries and welcome to the Academic Feast Atacon 2026. Now, I take the privilege to introduce our guest speaker, Professor Bharti Kumar Mangalam, Madam. I'm just sharing her slides. कैसा है क्या? Ma'am, are you able to see my screen?
Yes, slides are visible. Just maximize it and slideshow.
Is it okay now?
Not. Yes, yes. Now it. Yes. Okay. Continue.
So it's a great privilege for me to invite our guest speaker, respected Dr. Bharti Kumar Mangalam, ma'am. Welcome, ma'am. Madam is professor and head PG Department of Prasuti Tantra and Stri Roga, National Institute of Ayurveda, deemed to be University, Jaipur. Madam has a vast teaching experience of 28 years and a clinical experience of 31 years. And she has worked as research officer in CCRS for 17 years. And she has been working as HOD in Department of Prasuti Tantra and Stri Rog at National Institute of Ayurveda, Jaipur. She has a great academic contribution. She has more than 100 publications in national and international journals. She has published 12 books and 5 e-books, and she has a lot of other publications too. She is editor of 2 journals and reviewer of the 3 renowned journals. She had guided 25 PG scholars and many PhD scholars under her guidance. She has been PI and co-PI for various research projects under the CCRS, like clinical research project of CCRS under Smart 2 scheme, collaborative project entitled Effectiveness and Safety of Ayush L&D. It's the ongoing project, and she has been the part of many other literary research projects contributing to CCRS research databases, clinical research protocols, and Ayurveda encyclopedia. She is vastly interested in presentations and seminars, and she has been extensively integrating these. She has participated in various international seminars and more than 100 national seminars and delivering the lectures in various CMEs and conferences. She has award like Young Scientist Award in her honor, and she is also honoring the Utkrashta Seva Samman 2018. Madam is member of expert committees in preparation of validation of Garbhani Raksha module of NSDC New Delhi. She is also the member of Departmental Research Advisory Committee, PhD course of Sri Krishna Ayush University. She is member of Board of Examiner in Faculty of Ayurveda and Unani Medicine, DU. And she is the founder member and life member and joint secretary of National Organization of PTSR, KAGOF. She is also the chairman of CBDC curriculum of competency-based dynamic curriculum for Stri Roga and Prasuti Tantra. I welcome you, ma'am. Thank you. Now, I take the privilege to introduce our respected chairperson, Dr. Hemlata Jalgaonkar, madam. So, I welcome ma'am. Dr. Mrs. Hemlata Jalgaonkar, ma'am, is principal, Professor and HOD in the Stree and Prasuti Rog Department as well as Bal Roga. She is having a vast experience of 28 years and she has been nominated as the Senate member of MUHS by Governor of Maharashtra, second term 2023 to 2028. She has guided many postgraduate students, including recipients of Tarabai Vishnu Limai Gold Medal in year 2012, 21, and 2023. She has an active contribution towards Ayush promotion and public health awareness. She is having a lot of interest in social activities and having women health initiatives. And she has conducted a lot of camps, including cervical cancer, breast cancer awareness, anemia awareness programs. And she has published a documentary on menstrual hygiene and awareness. Now, the awards and recognition. She has Ayush Ratna Award in her cap, Martanda Award in Vadi Shammat 2023, Bhushan Award 2023, Best Ayurveda Educator Award, Vaidya Lakshmibai Borwankar's Sri Vaidya Award, and Clinical Excellence Award 2026. I welcome ma'am, and now I request Dr. Ankush sir to kindly introduce our co-chairpersons. Now lead to the Ankush sir. Ankush sir, kindly.
Madam, Ankush sir is there in the meeting. If he is not there, madam, you please continue. Maybe because of some technical issue, I think sir is not joined. You please continue, madam. Your voice is not audible. You please do the introduction of remaining two
Hello.
speakers, coordinators.
Hello. Hello, Meenakshi ma'am. Sir is joining. Just give me 1 minute, huh? Please.
Okay, fine.
Okay, ma'am. Okay.
Thank you so much, ma'am. A very warm good morning to one and all present here for this first online session of National Conference Atacon 2026. For this session, we are privileged to have our distinguished co-chair, respected Dr. Rahul Kumar Kamde sir and respected Dr. Manjusha Karkare madam. I welcome both the co-chairs. First, I will share the screen. Dr. Rahul Kumar sir's biodata is on the screen. Is it visible, ma'am?
Yes, sir. It is visible.
Yes.
Please continue.
Yes. First, I would like to introduce Dr. Rahul Kumar Kamde sir. Sir is currently designated as a HOD and Associate Professor in the Department of Prasuti Tantra Evam Stree Rog at KVTR Ayurved College, Boradi, Dhule, Maharashtra. Sir has done his BMS from Government Ayurved College, Nagpur, and MS in Prasuti Tantra Evam Stree Rog from Government Ayurved College, Nanded, and PhD from Bharati Vidyapith College of Ayurveda, Pune. Sir is having more than 20 years of experience. Sir is since 2022, sir is serving as a deputy MS for Lilai Hospital, Boradi. Sir conducted 9 clinical trials so far on different elements using Ayurvedic remedies. Sir is recommended as an international Ayurveda consultant by the Global Ayurveda Academy, United States of America. Sir is felicitated with the Research Excellence Award by the Institute of Scholars, Bangalore. Felicitated with the Best National Researcher Award in 2020 by ATA India. got Global Icon Award in 2021 for excellence in Ayurvedic medicine by Brand Opus India. Sir received COVID Warrior certificate from 5 different organizations in appreciation for devoted service during COVID-19 pandemic. Sir delivered 10 keynote addresses in various national and international conferences, published 13 research articles in various national, international peer-reviewed journals. Sir is having special interest in infertility, menstrual irregularities, PCOD, oligospermia, male and female sexual dysfunction, Garbha Samskar, and Suvarna Prashan. With this, I once again welcome today's co-chairperson, respected Dr. Rahul Kumar Kamde, sir. Second co-chairperson, respected Dr. Manjusha Karkare, madam. Madam currently designated as a professor in the Department of Prasuti Tantra Evam Stri Rog at Parul University, Ayurveda, Gujarat. Madam graduated from R.A. Poddar Medical College, Mumbai, and post-graduated from IPGTRA, Jamnagar, Gujarat, in Prasuti Tantra Evam Stri Rog specialty. Madam is having 20 plus years of academic experience. Madam is PG and PhD guided 3 PG students and having 6 PhD students under guidance. Madam served as a PI for several sponsored research projects. Madam authored 6 books, published 16 research papers in various national, international peer-reviewed journals, which is Scopus and WS indexed also. Madam felicitated with the Prasuti Visheshagya Award, Kashyap Award, and Best Doctor Award. Madam having special interest in infertility, ANC, PNC, PMS, and clinical research. With this, I once again welcome our respected co-chair, Madam Dr. Manjusha Karkare, ma'am. Now, without wasting more time, I would like to request our today's respected speaker, madam, to start the session. Over to you, ma'am. Over to respected speaker, ma'am.
Thank you, sir. Respected all the dignitaries who are joined in this Atacon 2026 conference, and all the participants, the faculties of LNCT and all other colleges. First of all, I would like to extend my thanks to the organizers for giving me this opportunity to share the knowledge regarding the PCOD with all you, the participants, and my friend Hemlata madam is there, and all other Prasuti experts, Manjusha madam, Dr. Rahul Kamde, and all, and particularly my student, Dr. Meenakshi Pal Bagel, and all other students who have joined on this. So, very good morning and welcome you all for this presentation. This presentation is going to be on the Ayurvedic perspective of the PCOD, and what is the historical development of PCOD, and what we have to chalk out the treatment plan and the research updates of the PCOD. So I believe I have got 45 minutes. Am I right?
Yes, ma'am. Please continue. Thank you, ma'am.
Yeah, thank you. So slides changing, Amma. Can you please tell me?
Yes, slides are changing, ma'am.
Okay, thank you. So coming to the PCOD, almost all, starting from the BMS practitioner and the experts from all the colleges and the PG running departments of Prasuti Tantra, we are facing heavily the PCOD cases. And these cases, sometimes they are becoming challenge to even Ayurvedic people for the treatment purpose, or the to stop the recurrence or to stop the further progress of the disease. Nowadays, it is a challenge. The modern people, the sick treatment, they manage with the hormones, and after stopping the hormones, again the recurrence. Anyway, pathology is not reversing here. Only the hormones they are utilizing, and just to ensure that cyclically period is coming. But that is not going to help in the management of the PCOD. we have to reverse the pathology started here, and that is deep-rooted. So that is why the name is changed. PCOD name is changed because multiple endocrine systems involvement is there in this. So now, after the global consensus, it is termed as the polyendocrine metabolic ovarian syndrome. Though the primary, the pathology is starting there, but the multiple endocrine systems are involved here. So that is the reason that we are facing challenges in treating the disease. The prevalence it is increasing day by day, and many of the teenage girls are coming with the PCOD, and of course active reproductive women also. So you can see here 4 to 20% prevalence is there. So this is so high, and we are getting almost the patients already suffering with prolonged amenorrhea nowadays, say 1 year amenorrhea, 2 year amenorrhea with the PCOD. And that is the current challenge to everyone nowadays. So it is not, now it is believed that it is not merely a gynecological nuisance. It is a lifelong, the person, that woman is going to suffer with a sequelae, like the Tiger 1, Tiger Zinda Hai, like that. So the sequelae is diabetes and prone to the other metabolic disease and even the cancers, like the endometrial cancer, breast cancer, and all cases are raising the women with the history of the PCOD. So that is a major challenge for us nowadays to treat it and to reverse the pathology, not simply the management, to reverse the pathology of the PCOD. So after a global consensus process, a consortium of experts proposed that the term polyendocrine metabolic ovarian syndrome, PMOS, and it is replacing now the PCOS. So as to reflect it better, the involvement of the multiple systems here, and even to reflect the solid clinical features underlying endocrine and metabolic pathophysiology. So the reference is given here, but still it is not widely coming into, because the other NIH and all, they have to recognize this PMOS and they have to publish it. So everyone will start using this term. But still PCOD is the popular term to every gynecologist or the other experts who is dealing with this. So let us see the history quickly. So dated back to 1721, it was detected, polycystic ovaries, and then when we were doing our post graduation, that time it was known as teen Leventhal syndrome. It is so popular with that name only, and the prevalence was very less during that time. They have he has reported that first that Irving Stein and Michael Leventhal, they have reported amenorrhea associated with the polycystic ovaries, and they described 7 women with a classic triad of symptoms: amenorrhea, hirsutism, and bilateral PCOD. So that was the first detailed reporting about the PCOD. Then they consequently performed the wedge resection, and they have seen the success, and 2 of these 7 patients, they have got conceived also after performing the wedge resection. So that is the history, and later on it is hormonal assays, and one by one the diagnostic markers goes on increasing, and the pelvic sonography finally confirming the PCOD. This thing. Then formalizing the diagnosis between 1990 and 2006, criteria started developing. First NIH developed during 1990, and 2003 Rotterdam criteria. And still, this is the standard criteria we are following. Means the entire the medical fraternity following for the confirmation of diagnosis of the PCOD. This criteria, even for the research, also we adapt Rotterdam criteria, and now modified Rotterdam we are utilizing. But now it is the polyendocrine metabolic ovarian syndrome. But still, it is ovarian syndrome only. Only the thing changing is here, accepting the polyendocrine involvement causing the metabolic changes in the body. So it is a historic change. It is a result of a 14-year global consensus process involving over 50 organizations. So finally, all these 50 organizations, they supported the name of this polyendocrine. Multiple classification systems we know, and now we have reached to this after the Rotterdam. We have reached the polyendocrine metabolic ovarian syndrome. So Okay, but if you see clinically, all the typical triad may be there, but with the different phenotypes, we see the patients. So ovulatory dysfunction and androgen excess we see, and polycystic ovary morphology and androgen excess, and PCOM and ovulatory dysfunction, PCOM, ovulatory dysfunction, and androgen excess also we see. So these are the different phenotypes reported by Christ and Sedars 2023. But anyway, now we are going with the PMOS more accurately reflecting the complex whole body metabolic and endocrine syndrome. So this whole body, now they have recognized the metabolic changes are happening. But when we prepared the SOP, the PCOD, Aya Delhi, under the able guidance of our leader, Professor Sujata Kadam Madam, this PCOD SOP is prepared by Aya, and we all were there. So that time we came to the this thing, fixing this under the two types, Santarpanadanya and Apatarpanadanya, because in the phenotypes we see the lean PCOS and the obese PCOS with the different phenotypes. So I'll show in forthcoming slides. And diagnosis, I think we can skip diagnosis of modern part. Not very much important for us, because we have to think about our own the Samprapti and the Samprapti Gataka Shatkriya Kala and all, and then we can chalk out the treatment for the PCOD. So what is the Ayurvedic perspective of PCOD here? So based on the Artha-Dishti as an initial phenomenon, it can be considered as the Artha-Dishti-janya Vikara Samuchaya. One term we have coined, because it is a syndrome, so Lakshana Samuchaya usually we see in the syndrome. So Artha-Dishti-janya Vikara Samuchaya is the term given for the PCOD. It is a derived term based on the involvement of the systems as per Ayurveda. The term is given there. So coming to the Nidana, grossly we can divide into Bahya and Abhyantara Nidana. Both are playing role here. Like the Ahara Vihara and Acharana, and the Dosha Prakopa, Dhatu Dushtikara and Sroto Dushtikara Nidanas are also playing role here in the pathogenesis of the PCOD. And Bahya Hetu, again, we have to bifurcate under two. Ahara, both Ahara and Vihara, Santarpana and Apatarpana Hetu. So Santarpanajanya Ahara, maximum what we are seeing here, we have framed based on the Samhita references for the PCOD SOP. So Santarpanajanya Hetu is actually Santarpana is necessary for the body, the nutrition adequately and whatever necessary to the level we have to supply. But Ati Santarpana is considered as a Nidana in many of the instances in starting from the Charaka Samhita we see. So Charaka has described the prefix Ati, which is measured in respect to Prakriti and not by the quantity. So, and it differs from each phenotype. So excessive intake of Snigdha, some examples we are given here. The Snigdha means not the usually whatever the oil we are using for cooking the sabji and all. So that is essential, the fats we need for our body. But some nonsense fats we are consuming daily, and our the children, they are more subjecting to this. So like the peanut butter, mayonnaise and all. So, and all the dairy products, except the traditionally processed cow's milk, ghee and the buttermilk. Even the butter available in the markets can also be considered as that kind of abnormal Snigdha substance. So likewise, you can see Madura and Guru Ahara and Pichila, Navana, Navamadhya. These are considered under this Santarpana Nidana. And Anupamamsa and Varija Mamsa and Paushtika Ahara, to calorie dense food, you can say, Ati Paushtika Ahara. And Avishendakara, of course, we all agree with the Avishendakara Ahara. So coming to the Apatarpanajanya Hetu. So there are again some Apatarpanajanya Hetu identified, causing this metabolic this thing syndrome. Alpamatra Bhojana and non-observance of Ashtavidhi Ahara Vishesharatana and Ekara Sati Sevana and Mansika Hetu. So much what we have observed in lean PCOS, the many students coming with the PCOD, they are under enormous stress. So that we have observed. And Ati Sansodhana also leading to the Aptarpana Janya Hetus. So Abhyantara Hetu, coming to the Abhyantara Hetu, Dosha Prakopaka and Swanidana Janya Dosha Prakopa. We see that, and Anyonya Avarana Nidana is also one of the cause, and Mansika Hetu. So Dhatu Pradoshaja and Upadhatu Dushti and Sroto Dushti, Mansika Karana and Nidana Arthakaroga, Abhyantara, under the Abhyantara Hetu. So coming to the Vihara Santarpanyanya Hetu, Cheshta Dvesha, if you have Dvesha or not also, we are sitting for a prolonged time. In Gopadi, we sit for at least 5 or 6 hours continuously. And in the wards, we are working continuously without any the movement, sitting and working, or in the OT are standing and working like that. And Divasapna, many of the housewives, we see this Divasapna as the reason that after performing a household job, they have a day naps in the daytime also, morning ones, afternoon ones, like that. And Shaya and Asana Sukha, enjoying the pleasure, or even if you are not enjoying, also continuous sitting is a asana, we can consider under the Asana Sukha, under the Vihara Janya Karana. And coming to the Apatarpana Janya Hetu, under the Vihara, Ati Vyayama, Ati Advagamana, and Ati Srema. And Nidana of Jataharani also can be considered here, because some of the metabolic syndromes depicting with the like Pushpagni Jataharani and all, we are watching these kind of the Hetu, Nidra Priya, specifically terms given in Kashyap Samhita, and Danta Sukha, and Sarvashani, eating everything, and Gasmara, habit of excessive eating, particular term is given there in Kashyap Samhita, and Rasana Papa Karmani, taking with the ahara, that comes under the Rasana Papa Karmani, and Ati Swapna, excessive sleep. Some of the Karana we have identified from the Jataharani Nidana, causing the metabolic manifestations of different Jataharani. And so based on the Lakshana of different clinical conditions presented in Ayurveda, we can check out the phenotypes as per Ayurveda also. So like the Avaranajanya Nashtartava and Anuloma Dhatukshaya, further leading to the Arthakshaya, and Dhatu Dushtijanya, Meda Dhatu Dushti and Shukra Dushtijanya Arthava Dushti, and Santarpanajanya, directly you can say Staulyajanya, PCOD, other conditions like Pushpagni, Jataharani, and consequently Dosha involvement and Srota Dushti. The Shatkriya Kala and all, they are common to all these phenotypes, but the manifestation of Lakshana are different in the phenotypes according to Ayurveda. So according to Ayurveda, these phenotypes we have chalked out. And coming to this Santarpanajanya PCOD, Pushpagni Jataharani, we know that Vrita Pushpam Tunari and Sulaloma Gandasha. So it is also depicting the phenotype caused by the Santarpanajanya pathology, obese PCOD plus a hyperandrogenemia. This is one kind of phenotype we have seen in the reported by the SEDAR. And Prameha Purvajanya PCOD and Meda Dushtijanya. So again, this can be bifurcated into two other phenotypes apart from the Pushpagni. So Prameha Purvajanya, wherever the insulin resistance is very high. And but sometimes due to the excessive this thing, obesity, Meda Dushtijanya Karana also, we see the PCOD. And coming to the Apatarpanajanya phenotypes, Vataja Dushti and Kshina Dushti, Dhatukshayajanya, and Arthavagata Bija Dushtijanya can be considered there. And apart from these, we see Avaranajanya, the pathology also in the PCOD cases, where Nashtartava is prominently seen there for prolonged, I was telling. With a 1 year amenorrhea, 2 years amenorrhea, they are coming, unmarried girls, they are coming, and whatever the future reproduction. And okay, not even the reproduction, their health in the future decades, forthcoming decades, they are going to suffer a lot because of the this prolonged Avaranajanya Samprapti particularly. and Nashtartava and Avaranajanya Artavakshaya. So these both can be considered under the Avaranajanya pathology of the PCOD. So coming to the Samprapti, again it is, can also be divided into Santarpana, Apatarpana and Avaranajanya. The above phenotypes can be classified under two categories again. Santarpana, Kapha Medha Vruddhikara Hetu Sevana, you can see here, leading to the Medha Vruddhi, Medha Dhatu Vruddhi and Vayu Marga Varodha, leading to the Agni Mandya, Amotpatti, and Dhatvagni Mandejanya, and further leading to the Srota Lepa in Rasarakta, Medavaha Srotas, and Meda Dhatu Dishti, and Artavaha Srota Dishti, and finally landing into the Artavakshaya. So the sequence you can see here, how Santarpanajanya PCOD is, the Samprapti is taking place. This is the sequel A in the Santarpanajanya, the PCOD. And coming to the Apatarpanajanya, the PCOD, basically starting from the Rasadhatakshaya, Vatavruddhi, Artavakshaya, and less Tarpana at Artava. मेरा क्लास है theory class पुष्पा के साथ यूज होता है इसके साथ हो जाना less tarpana at Artava Vahadhamani and leading to the Abhijata also. So Bija Nirmana is not taking place if Tarpana is not proper through the Artava Vahadhamani to the Garvashaya. And finally, the Eto Chitakala Adarshana is seen. Artavakshaya followed by Eto Chitakala Adarshana of the Artava is also seen. So this is the Apatarpanjanya is more with the the comparable with the Dhatukshayajanya leading to the PCOD, or you can say prominently with the Dhaturupa or Upadhaturupa Artavakshayajanya Lakshana here. So Avaranajanya Nashtartava, what is happening there? Due to the Kaphavarana Papanavayu, Srotorada is taking place by the process of Sangha, leading to the Artavaha Srotoroda and Nashtartava and PCOD with prolonged amenorrhea. So this is the Samprapti of Avaranajanya Nashtartava or the Avaranajanya PCOD cases where Kaphavruta Apanavayu is the avarana of cause there. And diagnosis based on the presenting features, we see there are three different diagnostic criteria sets, and the syndrome could present with the 4 subphenotypes. So hyperandrogenism, ovulatory dysfunction, and the PCOA morphology of the ovary, like that. So you can see A, B, C, D phenotypes. And other classification, sometimes we see the features with the insulin resistance, and sometimes you may not see the ovarian pathology or ovarian pathology, the morphology changes, even we cannot detect on the sonography, but high insulin resistance and followed by Artavakshaya and all we see in some clinical conditions. So insulin resistance, it can be termed as the insulin resistance PCOS. Inflammatory PCOS, this is again another classification. It is believed that starting the process of inflammation is leading to the PCOD. So it also stimulates both the adrenal glands and the ovaries to make more androgens, inflammation, disrupting the hormone receptors and suppressing the ovulation. So inflammation is also one of the cause for the PCOS onset and the anovulation and the Artavakshaya finally. So can come from insulin resistance, smoking and inflammatory foods, environmental toxins and digestive problems. You will see in the net that the Western world, they are categorizing some foods as the inflammatory foods. Environmental toxins, we know xenoestrogens theory is there. We are exposing to xenoestrogens plentifully, even the teenage, the girls, and the junk food and all. And post-pill PCOS, this is also commonly seen in some of the patients who are coming here. And this pill intake is very high in majority of the teenage girls. Once the doctor says, allopathy doctor, you can take it for 3 months and stop it like that. But what these people do, they take it for 1 year, 2 years, like that. They are taking continuously the PCOS, and the pathology is not reversing there. So after stopping, again they are suffering with this PCOS pathologies, termed as the post-pill PCOS. And adrenal PCOS is characterized primarily by excessive adrenal androgens. We see that the androgen, excessive androgen presentation we see clinically in the girls rather than the insulin resistance. So that can be termed under the adrenal PCOS. So diagnosis is of exclusion in nature, actually, PCOS. So it can be established based on the following grounds. We have to take thorough history and a clinical examination and BMI and all we have to check. And we have to check for the signs of insulin resistance and androgen excess signs. And then we can go for the diagnosis. But what are the features we see in the ultrasonography? Enlarged ovary with a string of follicles, or the string of bells, like a necklace pattern of appearance of the PCOD morphology in the, or sometimes it may be central distribution also, but incomplete. More than 10 small follicles of 10 mm in diameter. Now the volume, this was the previous one. Now the volume they are increasing, goes on increasing for the confirmation of the diagnosis. Another the criteria, Adians and the Roberts criteria, external morphological signs given with the ovarian width length ratio less than 1 and decreased uterine width, ovarian length ratio, and the internal morphological signs. One typical the case I have received recently report from some other our alumni of NIA that she said that her Bhatiji, she is I think 28, 29 years woman, and she was taking just withdrawal bleeding every month to ensure that every month cyclical bleeding should be there. That is the common belief in the people that by hook or crook they have to get the menstruation every month. So she was taking it for continuously. Now the sonography is showing that a reduced size of the ovary, and she is not at all getting the periods now. So, so it was suppressing continuously when she was taking that, even the withdrawal. So we usually blame 21 days pill, the 25 days that they are taking it continuously. So the internal milieu is disturbed, and that girl will suffer for a long time this amenorrhea and all. But now we have seen that even the ovary size is shrinking, and she is landing into the ovarian failure and the ovarian shrinkage. So that is the harm we see when they are taking continuously. Though the doctor says that take it for 2 months like that, sorry, 3 months like that, not more than that. But some doctors, they are advising for up to 6 months because they want to ensure that menstruation every month it should come. But this is causing the disastrous changes inside the body. And endocrine profile, we know that we'll get it in all this when the patient is coming, preferably on the day second of the menstruation, or between 3 to 5th day of the follicular phase of the menstrual cycle. So we see many of the patients coming with enormously increased levels of the serum prolactin, TSH involvement. In so many cases we see. So coming to the management part, every woman is unique, and ambi wohi bolte na purusham diksha. So deserves a detailed and in-depth look into what factors are driving her PCOS. एक आपको time देना पड़ता है. First मतलब उसकी phenotype कौन सा हमें detect करना है कि blindly जो 21 days pill देके आपको period लेके आना, and that is not acceptable. Whatever may be the system of medicine you are prescribing, first हमको उसकी निदान देखना पड़ेगा, उसकी संप्राप्ति देखनी पड़ेगी. Then we have to chalk out our the treatment plan. So it is absolutely essential to understand and determine the sources or drivers of PCOS, androgen excess for each and every woman. So nidana pariyojana should be done adequately for these kind of patients, particularly whoever coming for the treatment for the Ayurvedic hospital. So we dedicate some half an hour time for this patient. Some dedicated PG scholars will sit in the base sanskara unit and they give the Nidana Parivarjana prescription after noting in detail the Nidana in that particular patient. So that is very much essential in the cases of the PCOD. So what will be the objective for the management? The objective of treatment includes reduction of the ovarian volume, we have to reduce, so thus we can restore the normal morphology, regularization of menses. That will be the, don't worry, that regularization of menses. We also believe that once menses started, we are reformatting the internal RAM of the computer. So we also tries that immediately we want to induce the menstruation when they are coming. Of course, anyway, that we will achieve. And treating infertility, if the patient is coming with the infertility, then we have to think about ovulation induction, so that we can break that the formation of the cysts there, luteinized unruptured follicles. We can break that cycle, and once ovulation induction is done, then we will hope that cycle will be regular. And same time we want to reduce the androgens also. So majority of the times treatment plan does not comprise the reduction of the androgens. We have to reduce the androgens, so that we can the triggering factors can be stopped. HPO axis disruptors can be stopped. So thus the follicle, the routine maturation of the follicle and oogenesis can be ensured there. So the ovulation and the regular cycle can be expected there. And managing insulin resistance is also, but this is done by Ayurvedic people also. Insulin resistance adequately we'll address through Madhumehari and adding the Lodojunanda. And Sodhan Chikisa, sometimes the surgical methods we are not writing, drilling and puncture. We need not to go for that. This is the routine, the management objective, but we'll bank more on the Sodhan Chikisa. We need not to take up the wedge resection and all. Without drilling, without puncturing, with the Sodhan Chikisa, we do the drilling and we do the puncturing there. And regularization of menses, commonly prescribed medicines in every institution, and in NIA we particularly I bank more on the Deshmul Kotha Ajmoda and Purana Buddha is the common prescription given by our teachers here. Along with that, if still the induction is not taking place, we may go with the Hingvashtak Churna and Tankan Basma and Panchakola Tankana. And before starting the Madhu Tailikavasti, still if the menses onset is not taken, then I bank on the Nabi Purana. And even with the Jyotishmati Taila Nasya also you can do that. And the Jyotishmati Patra, the Churna also you can give to induce the menstruation in divided doses. So ovulation induction can be done with the different formulations everyone is having. That starting from the second day or the third to 5 days, Jati Phal Mishri, the combination or Gandharvastadi and Taila, along with this Gandharvastadi and 9th do, or if Gandharvastadi not feasible to the patient and not available, then where in Vishtaritik you can add, Chitrakadivati you can add, Kuberaksha Ganavati you can do there. And Nakesar Churna Trikatu, starting, this is another the combination that we can give, or some people they are giving Nakesar with the Panchakola also they are giving for the ovulation induction. And Jivini Mahakashaya is also helpful in ovulation induction. And the Nasya Karma is also helpful, like the Satapushpa Taila Nasya or Mahanarayan Taila Nasya, Pratimashanasya. Even Kshirabala Telnasya. So these simultaneously with these drugs we give the ovulation induction, the Nasya Karma also. So it is the important in infertility people, most commonly they fail to ovulate. So in around 40% of women. So anovulation is resulting from several causes. Maybe gynecological conditions such as primary ovarian size, we have to rule out this, or the PCOS. Then PCOS is there, then we'll consider the ovulation induction, and simultaneously we keep in mind the regulation of vata there upon oil, not simply the induction of the ovulation. So Bijotgama and implantation, when PCOD with infertility is there, ovulation induction with the Setapushpa, Jatifala, you can plan and achieve the ovulation, and you can break the vicious cycle of the unruptured follicle, formation of the luteinized unruptured follicle there, and you can ensure the Bijotgama, and of course you can achieve the Phala Prasava. So Garbhashya Bija Prapti is important here. So we have to ensure the ovulation, though if the patient is not coming for even the ovulation, I mean infertility treatment, with some other problems patient is coming, there also you can ensure the Bija Nirmana or the Bija Prapti. So reduction of androgens we can plan through the Lodra Churna or the Lodra Sava, and we can give the counter agents like the Kumaria Sava and Yashtimadu Churna also. So thus relatively if we are enhancing the estrogens, then we can reduce the androgens also. But the proved drugs for the reduction of androgens is the Lodra. Lodra drug is having the the androgenic property. And Gupta Kumari decreased the levels of testosterone and insulin through improving the levels of progesterone and estradiol. So decreasing by decreasing the transcription levels of the steroidal receptors, increasing the aromatase expression, which converts testosterone into estradiol and androstenedione. The peripheral conversion of androgens hai, so usko रोक करके it facilitate the conversion into proper estrogens. So Grita Kumari also helps in regulating hyperglycemia and modulating steroid. So we have some drugs, particularly where we are observing in the patients with excess androgens and all. So we can definitely give, and still the testosterone levels are very high. Then you can subject the patient for the Nasya Karma, full 7 days course of the Nasya Karma, and you can subject the patient for the Virechana if it is needed. And after the Virechana, you can subject the patient for the Vasti Karma also. And Lodra is established drug in bringing down the normal androgen levels. The low, the mid and the high doses was given to the PCOS induced rats for 15 days post letrozole induction to determine the effective dose of racemosa, Simplex racemosa in the treatment of hyperandrogenemia associated with the PCOS. So based on these studies only, I use Lodra majority of the times. Usually it is contradiction to the this thing. Our routine practice. Lodra, what our traditional, what we think this is a Stambhana drug, people may raise their eyebrows that why Lodra is given here, already Arthakshaya is there, already Ethochitakala Darshana is there, why Lodra? So Lodra is for this purpose we have, it has got the multiple actions. It will reduce the insulin resistance also, not only the androgen levels, insulin resistance it reduces, it helps in the pre-diabetic management also. So Lodra is again the ideal choice here in PCOS. Estrogen and progesterone were also assayed along with the testosterone to determine fluctuations in sex steroid levels. So it significantly reduced the testosterone levels. So we have evidence, we can proceed with the Lodra. Even it is helpful in restoring the histology of the ovarian tissue. So bringing the normal functioning of the ovary is very much important in PCOD cases. So line of treatment, Shodhana in Kapha and Vata predominant disease, where we can understand easily when we examine the patient whether it is Santarpanajanya or the Apatarpanajanya, easily, being Ayurvedis. So disease of Kapha due to Santarpana, Apatarpana and Langana classification, you can check out. Diseases of Vata considered Apatarpana, their Brahmana we have to give. And in mixed disorders, Snehana Svedana and Udva Shodhana, like the Vamana and other Shodhana, you can plan it. don't think that here the arthokshaya is happening. So Dalhana said that the Virechana is contraindicated here. It's not like that. We can subject the patient based on the necessity where you want to shed off more androgens, excessive androgens from the body. Subject the patient for the Virechana there. Thereafter, you give the drugs where you want to enhance the quantity of the Rajas Srava or the endometrial growth you want to support. After that, you can give it. So PCOD, if Kapha and Vata Samsrishta Vyadi. So in obese Santarpanajanya cases. So there you can definitely give the, if the kapha predominance is seen, then you can give the preference to the Vamana. And where you want the Anulomana of Vayu more predominantly, then you can plan there for the Virechana. So in Kashyap Samhita, कफजा एते कफजा रोगा एते संतर्पणोद्भवाः. So वहाँ के कहना तो चा तर्पणीयाः है ना. Then ब्रह्मणीयाः where the apatarpana is seen there. Another 3 important kalpas mentioned by Kashyapa is also very handy in managing the PCOD, like the Lashana Kalpa, particularly Lashana Kalpa and the Setapushpa Kalpa. Even in cases of Santarpanajanya, they are very much helpful. So it is mentioned for the Lasana Kalpa. The Lasana Kalpa can be given all kinds of Vata Roga and Pushpa related. So the Artava related disease, Reto disease, and the Sroto Upagata and Gatra Jadeta, etc. So Sroto Upagata issue. So we can give this Lasana Kalpa, where the jointly we see that Gatra Jadeta we are seeing in Santarpanajanya cases, and Pushpa Dushti is also seen there. So there we can use the Lasana Kalpa. And but Kalpa Prayoga, in the Kalpa form, you have to give that to Prayoga, not simply one single dose or something like that. Nasya Karma, I told where the excessive androgens are seen and excessive prolactin levels are there, and anovulation cases also. Nasya Karma is very much important. And where the Medas Dushti is seen. So in those cases, Ruksha Udvartana can be posted the patients for that. And then Snehapana is also one of the Samana Snehapana can also be adapted with the Pipalya, the Anivasana Taila. So why this is Snehapana here? Deham Malanam, Mrudu Karate Deham Malanam, Virihanti Sangam. So that is the where you are observing that Sangha is there causing the PCOD. In those cases, you can give the Snehapana. Particularly in Apatarpanajanya, we see the when Vata is aggravated, maybe the Sangha Janya pathology we see in those cases. And Vamana, I explained already, when the patient is having more the pre-diabetic or the Pramehajanya and Medo Dushtijanya cases, definitely you can pose the patient for the Vamana Karma. But we bank very less on the Vamana Karma. But I prefer Virechana Karma before the Vamana Karma sometimes, because though it is not the order, I want to expel the excessive, whatever the hormones are there in the body, or the Dushta Rajas is there. So it's related to the Pitta. So the once you expel this Dushita Rajas and Pitta and all, so reformatting can be done there, and the normal Artava Nirmana can also be expected there. So the routinely used, everyone knows the Nitya Virechana, or you can give the Sadhya Virechana, or you can give the full-fledged Virechana. But you have to decide whether you have to put the patient on Nitya Virechana or the Sadhya Virechana or the full course of the Virechana. That you have to decide based on the intensity of involvement of Dushti of the doshas. So that clinically, after the practice goes on, if you are practicing, simply by seeing the patient, you can chalk out your the treatment plan there. So Vasti is also important in the cases of the PCOD. That if the prolonged amenorrhea and severe involvement of the insulin resistant signs are the prolactin levels and all there, first initially you can pose them for the Virechana or the Vamana and all, then you can adopt the Asti. But where the Rajas Srava induction is the first importance, like the cases of the prolonged amenorrhea. So there, at any cost, you want to initiate the menstruation in those cases. So there, the first priority will goes with the Vasti Karma there. So, Mother Telecasti is the first we prefer here in NIA for the induction of the menstruation. So there are many drugs are available, like the Dashmula Taila and Mahanarayan Taila, Sachar Taila, even Shetangvadi Taila, Sukumara Grita, so many are there. So even Lasina Taila, but Lasina Taila, be careful that it is a Tikshna Taila, so carefully you have to administer that. And Lasina Grita is okay. And Kalyanaka Phalagruta and all, you can use it where ovulation induction is your primary Vasti for the Vasti purpose. And of course, Uttarvasti can also be done in these cases where the other processes are not responding, patient is not responding to all those, then you can start the Uttarvasti also. With the simple Apamarga, Sukumara Gruta, and Balatailam, Lasnugrutam, Satpushpa Thailand. And Nasya already I have explained. So the research also done with so many different combinations of drugs, like the Lodra Churna with the Krishna Tilapata. We study in one group, and the other group Setapushpa Taila Matra Vasti 60 ml for 2 consecutive cycles. For 7 days each cycle, the Vasti was given in those cases, and the sample size is so less 15 in each group. So overall relief was higher in group B, where the Vasti was given, and significant 40% and 26% patients moderate relief. So group A, the percentage of relief 79 overall. The result was statistically extremely significant with the p-value, and group B percentage of relief 73. So almost they are very near that. And another study, it is again a RCT with the Setapushpa Churna and Chetirvil Churna in the management of PCOD. So the Setapushpa is very effective drug, but there is a practice in NIA that the former HOD, she banks more on the Chetirvil Churna, Professor Shishira Sharma Madam. And this is very effective also in the management. So simple, the drug is very simple, Chetirvil, and available, non-controversial. Getting Setapushpa in all setups is not possible. In all the hospitals, we don't see. But outside Setapushpa also, the less companies are bringing Setapushpa Churna directly. So Chetirvil is easily available. So one of the options that in this study, 2 months it was given at the 2 consecutive cycles. So Setapushpa Churna, 14 patients got excellent effect, and 21 patients a significant result, and 7 patients moderate improvement. So altogether, if you see the Setapushpa Churna effective in almost 70% of the cases. In group B Chetirvil Churna, 50 plus 34 you can see. So if you compare the Setapushpa, Chetirvil is more effective in the management of the PCOD. And some other trials done with the Pata Rikwada and the Kanchanara Rikwada, the management of PCOD, 50 patients in each group. So good number of sample size is studied here. Group A received Pata Rikwada and Arogyavardhini, and Group B received Kanchanara Rikwada and Arogyavardhini. So both the Kwada are given in 20 grams dose in the form of 80 ml Kwada in Apana Kala. Arogyavardhini Vati 2 tab morning and evening for 3 months. So result in group A, moderate improvement was found in 72% patients. While in group B, moderate improvement was found in 46. So both the groups, you can bank on simple Chetirvil Churna. It is so simple. That means the metabolism you are correcting there. So consequently, the Artha Dhatu Nirmana is taking place. So Setapushpa is also equally important drug. And clinical efficacy of Ayurvedic formulations using the Rajapravartini, Varunadikashaya, and Kanchanara Gugulu. So in the preliminary times, we used to think like that. Simply Kanchanara and Varunadi to reduce the Gandhi morphology of the PCOD, and Rajapravartini to correct the menstrual irregularities. So 53 patients recruited under this trial, and 88.3% were completed the study. So assessment was done in 90th day and 180th day for oligomenorrhea, obesity, acne, hirsutism. So results trial drugs has statistically significant effect on the signs and symptoms, mainly oligomenorrhea and the extra hair, body hair. So the drugs have significant effects on reducing the number of cis events because Varuna and Kanchanara both are there. So we have to think about when you are thinking about the veg rejection, in those cases you have to think about the Grandhihara Chikitsa also, when the morphology is severe there. Sometimes you may less ovarian, the volume and all may be there. So in those cases, you need not to add more the Kanchanara and the Varuna or Arogya. You can go more with the Raja Nirmana correcting drugs. But pathology where the severe the morphology is distorted in the ovaries and the cysts are big, then in those cases definitely you have to add these drugs. So there are other studies also carried out, the Patadi Kwada and the Kanchanara Kwada, and Lodra Churna and Satapushpa Tailmatra Basti and Jyotishmatya Yoga and Madhu Tailika Basti in Nashtartava. And Satapushpa Churna with the Tilla Churna in oligomenorrhea associated with the PCOD. And Chitrakadi
स्टेट रोशन तरह से वो चेक करने के लिए आपके सारा डिपार्टमेंट कौन सा का सामान एक्स्ट्रा है सब कुछ पूछने के लिए सोफा बताया था मैंने, तो बोल दिया सोनी मैडम की रूम का है वहाँ पे काम चलेगा तो
मैं थोड़ा ये क्लास में हूँ,
मैडम बताइए क्या एक्स्ट्रा।
मैं बताऊंगी अभी बस हो गए 5 मिनट में। मैं बोलना उनको वेट करना है तो कर ले, नहीं तो मैं बोलूँगी। So combined, sorry for the disturbance, a combined effect of Snehana with Pipalyadi Anvasana Taila and Virechana with Hingu Tribuna Taila and PCOS. Another study, the sample size you can see here in the next column we have given the sample size, and Pipalyadi Anvasana Taila and Virechana with the Hingu Tribuna. So another the study that these drugs. And simply effect of tripla churna in insulin resistance. Simple one biomarker you can take and you carry out the study and you can report. So there are some other case reports also presented here, where in the PCOD we induce the ovulation with the Jati Phaladi churna and Dhaga Misri, followed by second phase support with the Vatajata churna. So this is also very effective, and the patient we have seen the regularization of menses in this particular case, and primary infertility with the PCOD case. Here the same drugs, drugs given Setapushpa Churna with the ghee and followed by Sahpana, followed by Anupana Godugda. So the patient next cycle she got conceived and she is delivered also, this patient, so many days back this. And the secondary infertility with the an ovulation. So Chaturbija Churna was given and the patient got conceived after 2 cycles. So single case reports also very effective, Satapushpa Churna, Chaturbija Churna. And the way the delay ovulation is happening with the PCOS. In those cases also, we have seen Gandharvasta Virenda Taila inducing the ovulation even on the 18th day. So in those cases also, ovulation induction we have seen with the PCOD. And impact of lean PCOS. One toughest challenge was there with the prolonged history of the infertility. In this case, we have done multiple therapies here. You can see in this table. Finally, the patient is very lean. See, you can see the androgen and the excessive the signs of the androgens are seen in this case. She was very lean, but healthy. But once we have corrected this, then patient got conceived, and finally she delivered in our institute only. So these are the different the case reports, and research. So many other studies also done with n number of Lashun Taila and Setapushpa Taila, Setapushpa Churna. So many other cases are also there. Since the time is very limited, 45 minutes, so I have limited my presentation. So thank you very much for joining my session. I hope I could give some knowledge, whatever I have, the practically what we are practicing at NIA. So I thank organizers once again for giving me this opportunity to join online.
Thank you so much, ma'am. I must say, it was a truly magisterial and intellectually invigorating lecture. Now, I would like to request respected Dr. Rahul Kumar Kamde sir for co-chairperson's remark.
Thank you, Ankush sir. Am I audible?
Yes, sir. Loud and clear.
Okay, thank you. It is always a feast to hear Dr. Bharti Kumar Mangalam madam. She has vast experience, and we always look forward for the opportunity to hear her. The cases she had given positive results are remarkable, and day-to-day practice we are seeing all of the gynecological fraternity is seeing more and more cases of PMOS nowadays. The phenotyping she has explained is very precise. That is Santarpanjanya, Apatarpanjanya, or Avaranjanya. And accordingly, if we choose proper medication, we can surely give relief to all the patients. I would like to quote one reference from Sushrutacharya that उन्होंने कहा है कि स्त्रियों में हर महीने अगर मासिक धर्म आता है तो क्लेद निर्हरण हो जाता है, उस वजह से उनको प्रमेहादि विकार नहीं होते हैं। तो अभी जो सिंड्रोम या फिर जो मेटाबॉलिक डिसऑर्डर, अब मॉडर्न साइंस को जो समझ में आया कि ये मेटाबॉलिक डिसऑर्डर तैयार हो रहा है अभी, तो ये डिसऑर्डर पहले से ही था, और जो हेतु है उसके, वो हेतु में एक एडिशन करने की जरूरत है मेरे हिसाब से, जो है विषमासन। जो पर्युषित अन्न का सेवन आजकल हो रहा है, तो उसी वजह से एडोलेसेंस एज से जो भी खाने पीने की चीजें बदल रही है, जो भी दिनचर्या का पालन नहीं हो रहा है, ऋतुचर्या का पालन नहीं हो रहा है, तो और खासकर जो रजस्वला परिचर्या, गर्भिणी परिचर्या, सूतिका परिचर्या बताइए, इनका भी पालन अभी आजकल मॉडर्न डेज में नहीं हो रहा है। तो इसी वजह से ये सारे मेंस्ट्रुअल डिसऑर्डर अभी हो रहे हैं, और धीरे धीरे ये बढ़ते जाएंगे। इसी वजह से फिर जेस्टेशनल डायबिटीज मेलाइटिस भी देखा जाता है, जेस्टेशनल हाइपोथायराइडिज्म देखा जाता है। तो ट्रीटमेंट जो करना है, बीज शुद्धि की चिकित्सा और जो रजक्षय की चिकित्सा है, उसी तरीके से बताया है। मैडम ने बहुत अच्छी तरीके से सारी चीजें बताई। उनके सामने मैं बोलने के लिए, मैं उनसे बहुत छोटा हूँ। एक दो चीजें जो है, जो एक द्रव्य में भी काम करती है, जो मैं यूज करता हूँ, वो थोड़ा सा मैं ऐड करना चाहूंगा, जिसमें मैं अगर सिंड्रोम है, मेटाबॉलिक सिंड्रोम, तो उसमें दालचीनी और हरिद्रा का अच्छी तरीके से उपयोग होता है। और एंटी एंड्रोजन जो मैडम ने रुद्र बताया, तो शायद ज्येष्ठमत का भी उसमें अच्छा रोल है, और शिग्रू भी अच्छे तरीके से काम करता है। बस इतना ही कहना चाहूंगा। बाकी जो आज के चेयरपर्सन है डॉक्टर हेमलता जलगांवकर मैडम, वो भी हमारे सीनियर है, और डॉक्टर मंजूषा करकरे मैडम, इनको भी नमन करता हूँ। मैडम ने भारती कुमार मंगलम मैडम को साष्टांग दंडवत, और एटीए ने मुझे ये सम्मान दिया, इसलिए मैं उनका भी शुक्रिया अदा करना चाहूँगा। एलएनसिटी यूनिवर्सिटी और उनके प्रिंसिपल डॉक्टर सपन जैन सर, इनका शुक्रिया करता हूँ। आखिरी में डॉक्टर राहुल सूर्यवंशी सर को धन्यवाद कहूंगा, और अंकुश सर अभी आप अगले इसके लिए करिए प्लीज। थैंक यू वेरी मच।
Thank you so much, sir. Now I would like to request Dr. Manjusha Karkare madam for co-chairperson's remark.
Hello, good morning, everybody, and thank you, the organizers of ATACon, for giving me this opportunity to be present in this session and participate in this. Actually, it is a privilege to be sharing space with someone as experienced and renowned as Dr. Bharati Madam, and we are indeed very fortunate to have uh, gained some of the pearls of wisdom from her experience. Uh, After she has spoken, there is actually, and Rahul sir has spoken, actually, there is nothing much left to add because most of the points have been already covered. But it's a suggestion that if all these things, all these experiences, all these studies that are taking place so widely all over the country, they could be included in some publication or some particular book, or maybe made available to the PTSR practitioners on some particular portal, then everybody would be gaining access to this knowledge and would be able to implement it in their practice. So, of course, I want to appreciate Madam's presentation and the points that she covered right from the xenoestrogens and the factors that affect the menstruation and the other panacea of problems that are accompanying the PCOS have been very well covered by Madam. And the special icing on the cake was all the cases that she shared and all the wisdom from the particular clinical experiences that she has shared. That was a take home message for given a take home message for all of us. So thank you, Madam. And we definitely hope to hear more from you and hear more, gain more from your experience in the future. And thank you, Atacon, for giving me this opportunity. Good day, everyone.
Thank you so much, ma'am. Now I would like to call respected Dr. Hemlata Jalgaonkar ma'am for chairperson's remark.
Am I audible, sir?
Yes, madam, loud and clear, ma'am.
Okay. Thank you so much. First of all, I appreciate the efforts has been taken by ATA by selecting this integrative and innovative topic, which is a very challenging topic. And I'm very much thankful, and to Bharti Madam that she has delivered a very good talk. She is one of the respected personality from PTSR department, and I can say it is a feast today morning feast that she has shared a lot related to PCOD because PCOS because it is a topic that everyone finds some kind of difficulty while treating in day-to-day practice because there are two types like santarpanjanya and apatarpanjanya. And actually what happened, like we have to go for the ovulation induction and androgen reduction. So there are very few treatment is available from modern science. So what they do is they give OC pills for regulation of the menstruation, and they do and one more surgical treatment as ovarian drilling. And what happened, like madam has shared something related to OC pills. So people, that modern medicine people, they are giving OC pills and OC pills and OC pills, and after that ovaries are like the ovaries are going down, they are become atrophic, and whatever the expected results are there from the ovaries we didn't get, and the patient are suffering from infertility. So that is a more very challenging mode, you can say. So madam has shared everything related to OCPs, PCOS. You know that in her introduction, it has been mentioned in 1920 and 21 that disease has been like come up like kuch to ho raha hai. But it has come, it is more than 50 years. After 50 years, you can say ये दिख रहा है कि it is a lifestyle disorder, and most of the female populations are affected because of that, and which we are failing into the what you can say conception. We are failing for getting fertility also. So madam has given introduction in that way. The diagnosis is more important. Okay. And we have this year shared about like it is a androgen increase at hyperandrogenic stage, and ovulation, main thing is ovulation failure. So while treating the PCOS, my idea is like stress is more important. Okay. And why the stress is there? Because of today's lifestyle, yet daily routine, diet, peer pressure, education policies, and some other things. Because of that, the main ahara dhatu is affecting, and because of that, madam has mentioned somewhere in her presentation that we have to take care about Agni Mandya also. One more idea I also appreciate, that Jata Harani related to Kashyapa, and madam has given more stress in Avaranjanya Samprapti also. That is the very good thing that upcoming practitioners, they can consider these things, and they can give the treatment by taking these points into consideration. You know, madam has given one more thing, one more stress on the one symptom, that amenorrhea is the main problem nowadays, because everybody is facing like when the amenorrhea is there, it is a worry to every female. So the main thing at we have to treat the amenorrhea, and for that also we have to my madam has shared so many line of management, Ayurveda management. Then madam, one madam has given more stress on HAOD and PCOM, that hyperandrogenism, ovarian dysfunction, and PCOM. One more thing, now people are giving more stress is a gut inflammation. Madam, it is very important that we have to take care of the inflammation nowadays, because we are getting results also. If we take that point while treating PCOS, we if you consider this point, we are getting good results. This is a one of the most important thing we can madam has shared. Then diagnosis is more important in this way. Madam has given our madam has shared Avaranjanya Samprapti, Santarpan Janya Samprapti, Apatarpan Janya Samprapti. Everywhere Rasadhatu is affected, and we have to whatever the whatever the drugs or whatever the medication madam has given selected, which is I think they are like Dipan Pachan Dravyas, which is definitely are going to affect the Rasadhatu, and definitely we are getting results while treating the PCOS. Okay. While treating the PCOS, we have to think about the cause, and then we can give the treatment. That here also madam has given more stress on Agnivardhan. Madam has not given, madam has not mentioned this, but madam का जो रोल है ट्रीटमेंट का, वो अग्निवर्धन जन्य द्रव्य यूज करने का ज्यादा लग रहा है. Then नशे is also very important while treating the HPO axis, or while correcting the HPO axis. नशे is always important. One more thing also I like, ki one drug therapy that Lodra has got such a good ability to treat, or such a good potential to treat PCOS, that also upcoming people that we have to consider this Lodra. Shatpushpa, you know that Shatapushpa is again helpful in ovulation, ovulation induction. So this way madam has given a very elaborative lecture. Madam has shared so many research papers also. So this is definitely a feast in the morning. Thank you, madam, for giving such a wonderful lecture. You're like she's the respected stalwart from PTSR family. So my big thank you, and my namaste to madam always. And one more thing, I would like to thank ATA authorities, organizers for giving me an opportunity to share as a chairperson. Thank you so much. We'll see you in upcoming days. And madam would like to hear from more and more from you. Thank you so much.
Thank you so much, ma'am, for your valuable inputs. Now it's time to thanks. So the platform is over to respected Dr. Manisha, ma'am. Over to you, ma'am.
Thank you, sir. Thank you, sir. It's my privilege to express sincere gratitude to our esteemed guest speakers, respected Dr. Bharti Kumar Mangalam ma'am, for sharing her valuable insights and experiences with us. Ma'am, your enlightening lecture has certainly broadened our understanding of the crucial subject of PMOS and from a new perspective. I would also like to thank our respective chairperson, Dr. Hemlata Jalgaonkar Madam, for gracious proceedings and sharing her valuable thoughts. At the same time, I express my indebtedness to the co-chairperson, respected Rahul Kamade sir, and respected co-chairperson, Dr. Manjusha Karkare ma'am, for sharing their precious time and gracing the session. Thank you, sir, and thank you, ma'am, for gracing the session. Thank you. Now, I request the session day coordinators to kindly take the session and proceed the session. Over to you, ma'am. Jai Shri, ma'am. Thank you.
Thank you very much, madam. And thank you very much, Ankush sir. Also, thank you, respected co-chairman and chairman. And lastly, thank you very much, speaker madam, for the beautiful session. आपका बहुत बहुत धन्यवाद। काफी कुछ अच्छा आपने बताया और समझाया। यूं ही नहीं मिलती राही को मंजिल, एक जुनून सा दिल में जगाना होता है। पूछा चिड़िया से कैसे बना आशिया तेरा, बोली भरनी पड़ती है उड़ान बार बार, तिनका तिनका उठाना होता है, तिनका तिनका उठाना होता है। एटीए एटीए की स्थापना का एक महत्वपूर्ण चरण था। एमयूएचएस नासिक में बोर्ड ऑफ स्टडीज में एटीए के सदस्यों का चुनाव, जिससे अध्यापक वर्ग की आवाज प्रभावी रूप से पहुंच सके। 19 अगस्त 2018 को पुणे में पहला ऑल इंडिया आयुर्वेदा टीचर्स कॉन्फ्रेंस आयोजित किया गया, जिसमें गुणवत्ता शिक्षा, शिक्षकों के कानूनी अधिकार, उनकी समस्याएं एवं उनके समाधान पर व्यापक चर्चाएं हुई। और आज 8 साल के बाद 22 अगस्त 2026 को 8वां सेमिनार हम लोग आयोजित कर रहे हैं और उसी चरण में हम लोग हैं, जिसमें आज ऑनलाइन मोड पर यहाँ पर उपस्थित हमारे सभी आदरणीय अतिथिगण अपना व्याख्यान प्रस्तुत करेंगे और साथ ही साथ हमारे अध्यक्ष और सह अध्यक्ष उस पर अपनी राय व्यक्त करेंगे। प्रथम सेशन समाप्त होने के बाद हम अब आगे बढ़ेंगे द्वितीय सेशन पर। द्वितीय सेशन शुरू करने हेतु मैं आमंत्रित करना चाहूंगा हमारे सेशन कोऑर्डिनेटर्स डॉक्टर विपुल दीक्षित सर, डिपार्टमेंट ऑफ बाल रोग फ्रॉम अष्टांग आयुर्वेद कॉलेज पुणे, एवं डॉक्टर किरण मेंडेकर मैडम, एसोसिएट प्रोफेसर, डिपार्टमेंट ऑफ शल्यतंत्र, पीडीईएस, कॉलेज ऑफ आयुर्वेद एंड रिसर्च सेंटर, निगड़ी, पुणे। मैं इनसे अनुरोध करता हूं कि वे आगे आए।
थैंक यू सर।
Good morning, everyone.
Good morning, madam.
On the behalf of 8th National Conference Atacon 2026 Innovative Ayurveda, मैं आप सभी का सेशन 2 में सर स्वागत करती हूँ। मैं आज के स्पीकर, चेयरपर्सन्स, को चेयरपर्सन्स, इनका इंट्रोडक्शन देने वाली हूँ। Now we are starting our online session number 2. It is my privilege to introduce our speaker of session 2, Professor Vaidya Ashish Kate sir. He is a Ayur-Onco palliative consultant, professor and HOD, Kriya Shari department, IGPAC Hospital Nagpur. He is an associate member, Rasayu Cancer Clinic, Pune, Ayur-Onco consultant at Medayu Multi-Speciality Hospital, Shankarpur, Nagpur. Sir pursued his BA MS and MD Kriya Sharir from Sri Ayurved Mahavidyalaya, Nagpur in 1995 and 1999 successively. He is a director at Antoday Ayurved Hospital, Nagpur. His mission is to standardize and promote Ayurvedic Rasayan therapy for cancer patients worldwide. He is a master trainer for the NCSM on writing, research integrity and publication ethics, as well as the standardized Prakriti assessment scale. He pursued he is a distinguished academician and research consultant to the advancement of Ayurveda. Nirama specialized cancer care OPD at his institution and works in close association with the renowned Rasayu Cancer Clinic in Pune under the visionary guidance of Dr. Yogesh Bendare. He performed a very crucial role in various presentations and seminars. He was actively involved as a co-chairperson for paper presentation at Ayurved Parva International Seminar held at Nagpur. He was chairperson and judge at the World Ayurveda Congress in Goa and Dehradun. He will, and in future perspective, he is going to play a critical role as a convener for the poster presentations in upcoming World Ayurveda Congress 2026 in Bhubaneswar, Odisha. Now I would like our chairperson for our online session to Dr. Professor Vivek J. Sir. Sir is MS Ayurved PhD, Professor and HOD, Department of PG Studies in Shalyatantra from Sri Sri Ayurved College, Science and Research Center, Bangalore. He pursued his BAMS, MS Shalyatantra and Doctor of Philosophy from Government Ayurved Medical College, Bangalore, affiliated to Rajiv Gandhi University of Health Sciences, Bangalore. His mission and vision is for integrating the strengths of Ayurveda with contemporary healthcare needs. Sir was awarded with the Dhanvantari Icon Award in 2026 by Guinness World Records. Sir has treated more than 4,000 cancer patients through Ayurveda, Anushastra Karma, Shaman Chikitsa, and through Ayurvedic Panchakarma treatment. Sir pursued an experience over 21 years as a distinguished academician and researcher and clinician. He is a chief Ayurvedic onco consultant and Ayurvedic surgeon at Ayurdham, a multi-specialty Ayurvedic clinic, a specialty Ayurvedic cancer care clinic, and Ayurvedic anorectal clinic at Raja Rajeshwari Nagar, Bangalore. Sir presented many scientific papers on national and international conferences on management of cancer through Ayurveda, and also invited as a resource person and a chairperson at different national and international conferences. Sir has recently published his research paper in Ayush Journal on Oncology. He published the paper on Ksharjal therapy and in specifically carcinoma of the breast. Now I would like to introduce our co-chairpersons of this session. My first co-chairperson is Dr. Prakash Kumbhar sir. He is a BMS MD PhD. He is currently a principal and medical superintendent at EVA College of Ayurved, Supedi, Rajkot, Gujarat Ayurved University. Sir has an experience. He is having a vast experience of 11 years, 3 months. He is a principal medical superintendent at EVA College of Ayurved, Rajkot. He is an associate professor or Professor Krishna Ayurved Medical College, Vadodara. He pursued his MD, PhD from Parul University, Ayurved, Vadodara. His research work contributions are specifically in COVID-19 preventive remedy study. He introduced herbosporin, Ayurvedic blood thinning thrombolytic agent. He innovated different remedies like role on for insomnia, Vediksha herbal dry shampoo in All India Institute of Ayurvedic Sciences Idea Hackathon. He introduced a nano-infused Ayurvedic hair serum, automatic Janu Basti knee pad. He published overall 18 research papers in different peer-reviewed journals. Sir pursued a different vast administrative experience. He had done MOUs with NAC and NABH institutions, initiated NABH accreditation, diabetes and cardiac OPDs, World Heart Day programs. His institute assessed more than 27,000 Prakriti Parikshanas and ranked amongst the India. Contributions in different conferences: World Ayurveda Conference, Pune in 2012, SGM College of Ayurveda, Udupi in 2012, BMK Ayurveda Mahavidyalaya, Belgium 2013, Parul Institute of Ayurveda 2021, World Ayurveda Conference 2024. He has been awarded with the Charak Puraskar by Gujarat Board of Ayurvedic and Unani System of Medicine in 2021, Dr. Jayesh Patel Award appreciable academic and research performance. He has published the book on hypertension, a holistic approach, Ayur Guide to Diabetes mellitus, and he performed the role as a co-chairperson in World Ayurveda Congress in December 2024. Now I would like to introduce our second co-chairperson, Dr. Raj Gopalan Krishnan. He is a BMS MD PhD, Kaya Chikitsa. Sir is a distinguished Ayurvedic practitioner carrying forward 1,000 years of legacy of Ayurvedic excellence from Thottakaran Vaidya family in Kerala. As the grandson of late Padma Shri Dr. Rajgopalan Krishnan Vaidyan, he has built up upon a rich heritage of traditional knowledge and modern expertise. Sir is experienced in Ayurvedic cancer care, autoimmune disease management, integrative oncology, immune modulation, nutrition in cancer, and autoimmune treatment. Sir has contributed in different research areas. He developed the RGK protocol guidelines for diet, fasting, and treatment for leukemia for All India Institute of Ayurveda, New Delhi in 2023. Developed RGK protocol guidelines for diet, fasting, and prevention of cancer for All India Institute of Ayurveda, New Delhi in 2023. He was awarded as a Arogya Kirti Puraskar Award for Best Physician of the Year for Ayurveda Cancer and Immunology Research Treatment in 2023. He has a vast administrative experience. He is a chief physician at Dr. Raj Gopala's Ayur Cancer Care Center for Integrative Oncology and Autoimmune Research, Kollam, Kerala. Department Head of Oncology, Saranya Ayurveda Hospital, Coimbatore. Head of Oncology Department, Vaidya Ratnam Foundation, Ollur, Thrissur. Chief Physician, Cancer Specialty Clinic, Ashtavaidyan, Palmanthol, Moss, Malappuram. Chief Consultant, Oncology and Immunology Wellness Center, Majilis Ayurveda Health Park. Oncology Research Consultant at Vaidyagram Ayurveda Healing, Coimbatore Village. Thank you so much to the all dignitaries to be present here. So I would like to call upon our respected speaker, today's speaker, Dr. Ashish Kate sir, to proceed with the presentation. Respected Dr. Ashish Kate sir.
गुड मॉर्निंग।
Yes sir, thank you.
आप मेरा वीडियो चालू कर सकते हैं?
Yes sir, I have shared the slides.
ओके, नहीं मुझे स्लाइड्स दिख रही है,
Yes
वीडियो
sir.
मेरा बंद है।
Okay sir, you have to switch on your video.
नहीं, वो बोल रहा है कि होस्ट कैन।
Okay sir, sir, yes sir.
Okay, anyhow, good morning to all.
Yes sir, yes sir.
Bring first slide.
Yes sir.
Okay, thank you.
Yes sir.
सबसे पहले मैं इस सेशन के को चेयरपर्सन डॉक्टर विवेक सर, को चेयरपर्सन डॉक्टर राजगोपालन सर और डॉक्टर पारेख सर का बहुत बहुत स्वागत करता हूं। तब साथ में सभी पार्टिसिपेंट्स का भी बहुत बहुत स्वागत करता हूं। साथ में एटाकॉन के सारे पदाधिकारी और खास करके राहुल सर, और जिन्होंने मुझे आज मेरा प्रेजेंटेशन को आपके सामने प्रस्तुत करने का मौका दिया, उसके लिए भी मैं उनका आभारी हूँ। साथ में एटाकॉन की सारी टीम, साथ ही एलएन आयुर्वेद कॉलेज के प्रिंसिपल डॉक्टर जैन सर, जिन्होंने इस टॉपिक को प्रेजेंट करने के लिए मुझे मोटिवेट किया और मेरा हौसला बढ़ाया, उनका भी बहुत बहुत धन्यवाद। साथ में मैं जिनसे ऑन्कोलॉजी ट्रीटमेंट, आयुर्वेद ऑन्कोलॉजी ट्रीटमेंट का सारा के सारा चीज़ सीखा हूँ, ऐसे डॉक्टर योगेश भंडारे सर, उनको भी मैं इस समय धन्यवाद देना चाहता हूँ। ये सेशन टोटली इंटरैक्टिव रखने की कोशिश करते हैं, एक तरफा ना हो ऐसी मैं कोशिश करता हूँ। डॉक्टर किरण मैडम ने जो भी मेरा बायोडाटा प्रेजेंट किया, उसके लिए मैं उनका बहुत बहुत धन्यवाद देता हूँ। साथ में हम सेशन को शुरू करते। किरण मैडम, अगर कोई जवाब देना चाहे,
Yes sir.
क्वेश्चन कोई भी पार्टिसिपेंट अगर कुछ पूछना चाहे बीच में तो भी पूछ सकता है। या आखिरी
यस
में
सर।
पूछ सकता है, या अगर मैं कोई सवाल पूछूं आप उसका जवाब देना चाहे तो ज़्यादा इंटरेक्टिव रहेगा।
यस सर।
कैंसर वैसे भी बहुत बड़ा एक सब्जेक्ट है, उसमें आयुर्वेदिक ऑन्को केयर एक और अलग ही लेवल का प्रॉब्लम है, और उसमें जो टॉपिक मुझे असाइन किया गया वो रिफाइनिंग इंटीग्रेटिव ऑन्कोलॉजी केयर, ये एक और लेवल अप टॉपिक टॉपिक है। लेकिन सब हम जानते हैं कि जैसे हम अभी पढ़ रहे हैं अपने एडवांसमेंट ऑफ आयुर्वेदा, इनोवेटिव आयुर्वेदा की तरफ, तो इसमें हमें इंटीग्रेटिव ऑन्को केयर को रिफाइन करने की बहुत ज़्यादा ज़रूरत है। नेक्स्ट स्लाइड।
Sir, sorry to interrupt. Will you please make your video on?
ओके मैडम, या थैंक यू
Yes,
वेरी
sir.
मच, थैंक यू।
Yes, sir. Thank you, sir.
ओके, मैं स्लाइड्स चेंज कर सकता हूँ कि आपको बोलना पड़ेगा? हेलो।
Yes, sir. I will
हाँ,
change the slides for you.
ओके, थैंक यू
Yes,
मैडम।
sir. Yes, I'm there. Yes.
Okay, thank you.
Yes.
Now, what is refining integrative oncology care and why it is needed? जैसे आप सभी लोग परिचित है, कैंसर एक ऐसी बीमारी है जिसको हम पूरी तरह से आज तक ठीक नहीं कर पाए। आज भी कैंसर का नाम सुनने के बाद में हमारे जहन में एक सिहर उड़ जाती है कि अभी इसका एंड करीब है करके। तो ज़्यादा डिटेल में न जाते हुए हम यही समझने की कोशिश करेंगे कि इंटीग्रेटिव ऑन्कोलॉजी की क्यों ज़रूरत है, उसको रिफाइन करने की क्यों ज़रूरत है। इसको तो नेक्स्ट स्लाइड। तो अभी तक आयुर्वेदा जो है वो आयुर ऑन्कोलॉजी, ये टर्म मेरे ख्याल से 4 साल पहले बैक गोवा जो हुआ था उसमें इन्होंने यूज हुआ था ये वर्ड, और वहां से इसको और आगे बढ़ाना अभी चल रहा है। तो अब तक हम क्या देख रहे हैं, आयुर ऑन्कोलॉजी यानी पैसिव वेलनेस या अल्टरनेटिव मॉडल, उसको हमें कहाँ ले जाना है, इज द प्रिसाइज डाटा ड्रिवन एंड को प्रिस्क्राइब बायोलॉजिकल शील्ड के रूप में। अब ये को प्रिसाइज क्यों होना चाहिए, या डाटा ड्रिवन क्यों होना चाहिए, या को प्रिस्क्राइब बायोलॉजिकल शील्ड क्यों होना चाहिए, ये ही हम इस लेक्चर में समझने की कोशिश करेंगे। और मेरा एक और उद्देश्य है कि अगर जो भी यंग पीजीज है या जो यंग असिस्टेंट प्रोफेसर्स है इन कॉलेजेस, या फिर जो लोग प्रैक्टिस में अभी अभी आए हैं, वो अगर अपना काम ऑन्कोलॉजी पे शुरू करें तो बहुत अच्छा होगा। ये एक बहुत बड़ा ग्रे एरिया या बहुत खाली एरिया है, और जिसमें बहुत ज़्यादा रिफाइनमेंट बोलो या उसमें इनोवेशन की बहुत ज़्यादा गुंजाइश है और स्कोप भी है, और आयुर्वेद कैंसर पेशेंट के लिए बहुत कुछ कर सकता है जो अब तक पीछे रह गया था। तो हम इसी को आगे समझने की कोशिश करते हैं। नेक्स्ट वन, नेक्स्ट स्लाइड।
Yes.
वाई इट इज नीडेड कि बहुत बार जब कीमो या रेडिएशन कैंसर पेशेंट को दिया जाता है तो वो उनकी थेरेपी पूरी नहीं कर सकते बिकॉज ऑफ द सीवियर साइड इफेक्ट्स। और वो साइड इफेक्ट्स ले आते हैं कि वो सारे कीमो या रेडिएशन जो है वो टॉक्सिसिटी तैयार करते हैं, टॉक्सिसिटी को शरीर में डेवलप कर देते हैं, जिसके कारण उनका कीमो थेरेपी पूरी नहीं हो पाती है, बीच में से छूट जाती है, या बहुत बार रेजिस्टेंस आ जाता है। तो उसको हम कोप अप कर सकते हैं या हम उसे कुछ दे सकते हैं क्या। दूसरा है हम इंश्योर बायोकेमिकल सेफ्टी, क्योंकि बहुत बार क्या होता है कि ये एक ऑन्कोलॉजिस्ट के भी बीच में धारणा है, और ये सच भी है कि जब हम हमारे कुछ इम्यून बूस्ट करने वाले हर्बल प्रिपरेशंस देते हैं तो वो कीमो का इफेक्ट कम कर देते हैं, यानी ट्यूमर किलिंग एफिशिएंसी जो है वो कम कर देते हैं, उसको नीचे कर देते हैं, और कीमो का इफेक्ट नहीं मिल पाता। इसलिए मैक्सिमम ऑन्कोलॉजिस्ट स्ट्रेट वे पेशेंट को बोल देते हैं कि आपको कीमो के बीच में या कीमो के एक महीने के बाद या 2 महीने के बाद तक आपको आयुर्वेद दवाइयाँ नहीं लेनी है, क्योंकि उन्हें केवल आयुर्वेद का इम्यून बूस्ट करने वाला इफेक्ट ही पता है। वी हैव अ लॉट ऑफ अदर इफेक्ट्स ऑफ अवर आयुर्वेदिक ड्रग्स, तो उसे हमें रीएस्टेब्लिश करने की जरूरत है। दिस तीसरा, बहुत बार क्या होता है कि जो भी कीमोथेरेपी दी जाती है वो बेसिकली बोन मैरो सप्रेसेंट के रूप में दी जाती है, या वो सेल एक्टिविटी को कम कर देती है या डिस्ट्रैक्ट कर देती है। हम उसको बचा सकते हैं नॉर्मल सेल्स को बाय, अगर हमने पेशेंट की अग्नि या उसका धातु बल इसको प्रिजर्व कर लिया तो। लेकिन हमें इसके लिए कीमोथेरेपी और रेडिएशन के साथ साथ चलने की जरूरत है, जिसको हम इस लेक्चर में भी समझने की कोशिश करेंगे। नेक्स्ट।
Yes, sir.
हाँ, if you allow me to make a slide change, so I think it save our time.
Yes, yes, sir. Definitely. Yes, sir.
ये एक डाटा है जो हमें दिखाता है कि इंडिया में कैंसर बर्डन कैसे बढ़ रहा है। और आप देख पा रहे होंगे कि करीब करीब 15 लाख नए कैंसर पेशेंट रोज यानी हर साल डायग्नोस होते हैं, और करीब करीब 9 लाख के आसपास लोग कैंसर से डेथ हो जाते हैं जो रजिस्टर्ड है। ऐसे कई होते हैं जो रजिस्टर्ड नहीं होते हैं। इसमें लीडिंग कॉज में देखेंगे अपन तो वुमेन्स में ब्रेस्ट कैंसर है, और मेल्स में जो है वो ओरल कैंसर है, बट नेचुरल। उसके अलावा लंग का, सर्वाइकल, इसोफेगल कैंसर, ये भी दिन ब दिन बढ़ते ही जा रहे हैं। ग्रो हो रहा है, ये एरिया बहुत ज़्यादा ग्रो हो रहा है। ऑन्कोलॉजी में पेशेंट्स भी बहुत ज़्यादा ग्रो हो रहे हैं, और ट्रीटमेंट भी बहुत ज़्यादा इसमें आगे बढ़ रही है। नेक्स्ट स्लाइड। अभी हम एकदम शॉर्ट में ये समझने की कोशिश करते हैं कि आयुर्वेद में कैंसर कहाँ है और मॉडर्न का कैंसर कैसे डेवलप हो रहा है। क्या हम जब बोल रहे हैं कि हमें इंटीग्रेट करना है दोनों को, तो दोनों का इंटीग्रेशन के पहले क्या ये पॉसिबल है, इसको हम समझने की कोशिश करते हैं। नेक्स्ट। बेसिकली आयुर्वेद जो है उसमें 3-4 चीज़ों का हमें संहिताओं में उल्लेख मिलता है। उसमें एक अर्बुद है, एक ग्रंथि, एक गुल्म, और एक असाध्य या दुष्ट वन के रूप में। नेक्स्ट। आचार्य चरक ने ने अर्बुद की उत्पत्ति और उसके बारे में सूत्र स्थान, चिकित्सा स्थान, निदान स्थान में कुछ वर्णन दिया है, जिसमें उन्होंने सबसे ज्यादा बल दिया है धातु अग्नि का मंद पड़ जाना। इसे हमेशा याद रखिए। कैंसर पेशेंट में सबसे जो कोर प्रॉब्लम हमारे सामने आता है वो है धातु अग्नि मंद। धातु अग्नि ही मंद हो जाती है, और धातु अग्नि मंद के पहले हमें देखने को मिलता है कि उसकी जठराग्नि भी बहुत ज्यादा मंद या दुष्ट हो जाती है। नेक्स्ट। सुश्रुत अनुसार अगर हम देते तो सुश्रुत ने और ज्यादा स्पेसिफिक और बहुत ही ज्यादा पिन पॉइंट इसकी व्याख्या दी हुई है। उन्होंने कहा है कि अर्बुद किसी भी प्रदेश में बढ़े हुए वात दोष मांस को दूषित करके गोल स्थिर अल्प पीड़ा युक्त बड़ा गंभीर धातु में फैला हुआ और धीरे धीरे बढ़ने वाला होता है। अब ये चीज यहाँ पे हमें समझने योग्य है कि उन्होंने कहा है कि रुत्तम स्थिरम मंद रुजम, यानी उसमें पीड़ा एकदम मंद होती है। यानी यहाँ पे उन्होंने जो बाकी समय जो अर्बुद है या फिर शोफ होता है या हमें जो एब्सेस होता है, उससे उन्होंने अर्बुद को डिफरेंशिएट करके बताया मंद रुजा। उसके अलावा उन्होंने क्या कहा है कि चीर रुद्ध पाकम, चीर रुद्ध अपाकम, यानी धीरे धीरे बढ़ता है लेकिन उसमें पाक उत्पन्न नहीं होता है। ये इतना प्रिसाइज डेफिनेशन है कि हम केवल इसी डेफिनेशन को और एलोबरेट करें, इसको और ज़्यादा फाइन ट्यून करें, तो हमें अर्बुद के विभिन्न विभिन्न कैंसर की हमें संप्राप्ति मिल जाएगी। अब हमारे पास एक कॉमन संप्राप्ति है। हमें जैसे हम अगर लंग कैंसर देखें या यूट्रस में देखें या फिर रक्त यानी ल्यूकीमिया की तरफ देखें, तो हमें संप्राप्ति को और अधिक फैलाने की और उसे अधिक और अच्छे से एस्टेब्लिश करने की जरूरत यहाँ महसूस होती है। उन्होंने एकदम स्पेसिफिक बता दिया है कि अर्बुद और बाकी जो शौफ है उसमें या बाकी किसी भी एब्सेस में क्या फर्क है। इससे बेस्ट हमें और कहीं एक इसका जो संप्राप्ति है इसका श्लोक नहीं मिल सकता। ठीक है। नेक्स्ट। नेक्स्ट। नेक्स्ट स्लाइड।
Sir, एक मिनट. Sir, the slides are not moving. Just a second. Yes.
रिव्यूज, हाँ।
Yes,
तो
sir.
अगर हम उसको शॉर्ट शॉर्ट में देखें तो अर्बुद की संप्राप्ति में कहा है कि पहले तो मिथ्या विहार, फिर धात्वाग्नि मानदेय, फिर त्रिदोष का प्रकोप, उसके बाद जो मांस, रक्त और मेद, ये 3 धातु का उन्होंने दिया था कि इसमें उसका जो है वो सामान्यता ग्रोथ होती है, और इसका कारण उन्होंने दिया था स्रोतोरोध, असामान्य कोशिका वृद्धि। और अर्बुद के लक्षण में भी जो उन्होंने अभी कैंसर के हैं वही बताइए। इवन मैलिग्नेंट और मेटास्टेसिस के लक्षण भी उन्होंने दिए हैं हुए हैं ऑलरेडी आगे के श्लोकों में, अगर हम उसको और विस्तृत से देखें। अब हम शॉर्ट ऐसे ही शॉर्ट में ये देखते हैं कि मॉडर्न कैंसर का कैसे वो डायग्नोसिस करते हैं या उसके क्या कॉज उन्होंने दिए हुए हैं। नेक्स्ट स्लाइड। उन्होंने मल्टी स्टेप कार्सिनोजेनिक मॉडल वहाँ पे एस्टेब्लिश किया हुआ है। तो उसमें उन्होंने कहा कि 4 स्टेज होते हैं जब एक नॉर्मल सेल जो है वो कैंसर सेल में परिवर्तित हो जाता है। तो इसमें एक ये सेल लेवल पे पहले एक सेल बदलता है, बिगड़ता है, और वो फिर अपने जैसे और सेल्स को बनाते हुए चले जाता है। अब इसमें उन्होंने जो पॉइंट रखे हुए हैं वो एक है इनिशिएशन, प्रमोशन, प्रोग्रेशन एंड इन्वेंशन एंड मेटास्टेसिस। यानी ऐसी स्टेज आती है जब वो सेल अपनी जगह छोड़ के दूसरी जगह चले जाता है। नॉर्मल सेल जो होता है वो कार्सिनोजेनस सेल है, अपना साइज बदल लेता है, शेप बदल देता है। और जो नॉर्मल साइट है उस नॉर्मल साइट पे जब वो सेल की साइज और शेप बदल जाता है तो हम उसको कहते हैं कि ये कैंसर में बदल गया है। और इसी दौरान उन्होंने कुछ हॉलमार्क्स ऑफ कैंसर बताया कि ये चीज हॉलमार्क जो है वो क्या क्या है, हाउ इट बिहेव, यानी सेल कैसे बदलता है अपना रूप। नेक्स्ट। नेक्स्ट, हाँ। इनिशिएशन यानी द प्रोसेस बिगेन व्हेन ए नॉर्मल सेल सफर्स इनविजिबल डीएनए डैमेज। ठीक है, दिस म्यूटेशन कैन बी इनहिबिटेड और स्पॉन्टेनियस ट्रिगर बाय एक्सटर्नल कार्सिनोजेनिक लाइक टोबैको। यानी पहले इनिशिएट होना जब, और उसके बाद उसमें होता है प्रमोशन। द इनिशिएटेड सेल इज एक्सपोज टू अ बायोलॉजिकल इन्वायरमेंट और प्रोमोटिंग एजेंट लाइक क्रॉनिक इन्फ्लेशन। शोफ हमारे यहाँ भी बताया हुआ है, ये यहाँ पे आप नोट डाउन कर लीजिएगा कि शोफ उस आयुर्वेद में भी बताया हुआ है। ठीक है। देन इसका प्रोग्रेशन, द सेल एक्वायर फर्दर जेनेटिक म्यूटेशंस बिकम इंक्रीजिबली कोहेटिक एंड एग्रेसिव। उसमें उसका डिवीजन बढ़ते जाता है, एग्रेसिव हो जाता है उसका नेचर, और फिर वो इन्वेंशन करता है अपनी एक जगह से दूसरी जगह की ओर। नेक्स्ट। इसमें उन्होंने जो हॉलमार्क दिए हुए करीब करीब 8 है अभी जो वो फॉलो कर रहे हैं कि एक सेल का स्ट्रक्चर कैसे बनता है। अब उसमें उन्होंने जो चीजें डिफाइन की है, तो यहाँ पे एक ही मॉडर्न का कंसेप्ट हमें ध्यान में आता है कि उन्होंने हर चीज को बहुत ज्यादा डिफाइन या फाइन ट्यून किया हुआ है, जबकि हमारे पास केवल एक संप्राप्ति है और उन्होंने उसको फर्दर स्टेप डाउन किया हुआ है। ठीक है। सस्टेनिंग प्रोलिफेटिव सिग्नल्स, यानी वो क्या करता है अपनी ओन ग्रोथ को खुद ही कंट्रोल कर रहा है, वो इम्यून सिस्टम को बाईपास कर दे रहा है। इन्वेडिंग ग्रोथ सप्रेशन, इग्नोर द बायोलॉजिकल स्टॉप सिग्नल्स जो है उसको वो इग्नोर करता है। बाईपास एपोप्टोसिस, एपोप्टोसिस की प्रक्रिया को भी वो बाईपास कर देता है, और उसके बाद वो एक खुद इतनी जल्दी बढ़ना शुरू कर देता है कि एनेबलिंग रिप्लिकेटिव इनमॉर्टेलिटी, इंड्यूस एंजियोजेनेसिस, बिल्ड न्यू ब्लड वेसल्स। यानी जब इनका एक समूह तैयार हो जाता है उस समूह को स्पेशली अलग से ब्लड सप्लाई के लिए वो एक न्यू ब्लड वेसल्स भी एस्टेब्लिश कर लेते हैं। एक्टिवेटिंग इन्वेंशन एंड मेटास्टेसिस, अपनी जगह से निकल के ये दूसरी जगह पे चले जाएंगे और वहां पे अपना नया आशियाना बनाते हैं, और वो सबसे खतरनाक जगह होती है। उसके बाद रिप्रोग्रामिंग सेलुलर एनर्जेटिक आफ्टर मेटाबॉलिज्म ऑफ फ्यूल, यानी ये क्या करते हैं कि अपने लिए आवश्यक जितनी भी एनर्जी है उसका स्टोर रिसोर्स बनाना, खुद के लिए अलग से रिसोर्स तैयार कर देते हैं। और कैंसर के एंड स्टेज में आप कैकेक्सिया नाम का एक स्टेज आता है जिसे आयुर्वेद में हम धातु क्षय कहते हैं, वो देखने को मिलती है, क्योंकि वहां पे वो लोग इस अपनी एनर्जी खुद ही धातुओं से ही लेना शुरू कर देते हैं। पेशेंट का इंटेक बिल्कुल नहीं रहता है, लेकिन उसके बावजूद भी क्या ट्यूमर की ग्रोथ होते रहती है। और इन्वेंटिंग इम्यून डिस्ट्रक्शन, दे हाइड बाय डेवलपिंग मॉलिक्यूलर क्लॉकिंग डिवाइस दैट ब्लाइंड द इम्यून सिस्टम, यानी इम्यून सिस्टम को वो अपने ऊपर हावी ही नहीं होने देते। नेक्स्ट। इसके अलावा जब ट्यूमर एक छोटा सा बन जाता है तो वहाँ पे एक ट्यूमर माइक्रोन्यूट्रिएंट वो एक डेवलप हो जाता है। वो क्या करते हैं, वो एक ट्यूमर का एक अलग कैरेक्टरिस्टिक ही बन जाता है। यानी जैसा सुश्रुत ने कहा था कि मंद रुजा या ट्यूमर ट्यूमर अपना खुद ग्रोथ करना शुरू कर देता है, तो ये भी अपना ट्यूमर जो है वो एक अलग कैरेक्टरिस्टिक लेके बन जाता है और अपना डेवलपमेंट खुद अपने कंट्रोल में लेके बढ़ना शुरू हो जाता है। और बाकी हमारी जो नॉर्मल मेडिसिन है उसको वो रिस्पॉन्ड नहीं करता है। और यहीं पे हमें रिफाइनमेंट की ज़रूरत है, क्योंकि अभी अगर हम किसी भी ट्यूमर को कम करने के लिए अगर कोई भी आयुर्वेद मेडिसिन देते हैं वो काम इसलिए नहीं करते क्योंकि उसका सेलुलर स्ट्रक्चर पूरी तरह से चेंज हो गया है। नेक्स्ट वन। तो हम एक स्लाइड में समझ सकते हैं कि जो नॉर्मल सेल था वो हाइपरप्लेक्सिया हुआ, सेल डिवाइड फास्टर देन नॉर्मल वन, देन सेल लुक एबनॉर्मल अंडर माइक्रोस्कोप। उसके बाद वो कैंसर बनना या डेवलप होना शुरू हुआ और वो फिर वहां से कहीं और जाके बस गया। उसको हम मेटास्टेसिस या मैलिग्नेंसी ऑफ द कैंसर कहते हैं। नेक्स्ट वन। कैंसर की स्टेजेस उन्होंने दिए। स्टेजेस 2 या 3 टाइप पे डिपेंड करती है कि किस स्टेज का कैंसर है। अब उन्होंने जो पहला स्टेजिंग दिया है वो 0, 1, 2, 3 और 4 इस टाइप का है। अब पहला जो 0 स्टेज है वो यानी कैंसर जो है वो अपनी जगह पे ही है, कहीं भी वो फैला नहीं है। ठीक है। स्टेज 1 स्मॉल ट्यूमर contained to own area. Stage 2 tumor has grown largely and possibly spread to nearby lymph nodes, यानी अभी ये स्टेज 2 में lymph nodes में आ गया। स्टेज 3 tumor has grown deeper into सराउंडिंग टिश्यूज एंड हैड स्प्रेड टू नियर बाय लिम्फ नोड्स, यानी और ज़्यादा टिश्यूज में फैल गया और बड़ा हो गया, साइज बड़ी हो गई। और स्टेज 4 कैंसर हैज स्प्रेड टू अदर टिश्यूज एंड डिस्टेंट एरिया ऑफ द बॉडी, वी कॉल इट एन मेटास्टेसिस। तो इस फिगर में भी आप या इस पिक्चर में आप देख सकते हैं कि पहले एक छोटा ट्यूमर था, उस ट्यूमर के ब्लड वेसल्स भी है, कैंसर सेल्स भी है, और वो अभी कैंसर सेल ब्लड स्ट्रीम में आ गए और मेटासेल लिम्फ नोड्स में भी आ गए। दूसरा इनका स्टेजिंग का क्राइटेरिया होता है कि लोकेशन वाइज कि कैंसर कहाँ पे लोकेटेड है उस अनुसार। और तीसरा स्टेजिंग है ट्यूमर नोड और मेटास्टेसिस की। प्राइमरी ट्यूमर है, नोड्स में आ गया है, मेटास्टेसिस हो गया है। इसी कैंसर के स्टेजेस अनुसार उनका ट्रीटमेंट पैटर्न भी है जो कि हमारे पास अभी अवेलेबल नहीं है। नेक्स्ट। अब हम आयुर्वेद दोक्त अर्बुद या ग्रंथि को मॉडर्न कैंसर बायोलॉजी से कंपेयर करने की कोशिश करते हैं ताकि हमें बढ़ना है रिफाइनमेंट ऑफ इंटीग्रेटिव ऑन्कोलॉजी की तरफ। नेक्स्ट वन। पहला मैम, अगर हम देखेंगे प्राइमरी मैकेनिज्म में कि मॉडर्न ऑन्कोलॉजी का कहना है कि अनकंट्रोल सेल प्रोलिफरेशन, और हम अगर आयुर्वेद का एस्पेक्ट को वहाँ पे चेक करेंगे तो हमारे पास उन्होंने दिया है कि दोष एलिवेटेड हो जाते हैं और वो फिर टिश्यू या धातु का डैमेज करना शुरू कर देते हैं। सेकंड, उनके लेवल पे पैथोजेनेसिस की जो स्टेज है वो है इनिशिएशन, प्रमोशन एंड प्रोग्रेशन, मेटास्टेसिस। तो हमारे पास हम उसको कंपेयर कर सकते हैं षटक्रिया काल से। नेक्स्ट। उसके अलावा उन्होंने जो माइक्रो इन्वायरमेंट और मेटाबॉलिज्म का है कि क्रॉनिक इन्फ्लेशन, तो हम भी उसको कंपेयर कर सकते हैं या तो अग्निमांद्य से, या धातु न्यूट्रिशन का लॉस हो जाना, आम का क्षय, स्रोतोरोध होना, ये यहाँ पे हम उसको जरूर कंपेयर कर सकते हैं। फिर ट्यूमर क्लासिफिकेशन जो है वो उनके पास जो हमने देखे क्लासिफिकेशन के, तो हमारे पास एज सच अभी तक ज़्यादा डिफरेंशिएशन अवेलेबल नहीं है। मेटास्टेसिस का कंसेप्ट उनके पास भी है, हमारे पास भी अध्य अर्बुद या द्विअर्बुद का कंसेप्ट सुश्रुत आचार्य ने दिया हुआ है। तो हम उसको कहीं ना कहीं तो ले कर सकते जो हमारे पास है। नेक्स्ट वन। अगर षटक्रिया काल को हम डिटेल में समझने की कोशिश करेंगे तो षटक्रिया काल से हम कैंसर की ग्रोथ को आयुर्वेद पर्सपेक्टिव से ज़्यादा अच्छे से डिफाइन होके समझ सकते हैं, और इस पे काम करने की ज़रूरत है। इसे ज़्यादा अगर हम अच्छे से डेवलप करें हमारा षटक्रिया काल और उसको कंपेयर करके कुछ चीज़ों को एस्टेब्लिश करें तो हमें ट्रीटमेंट करने में आसानी होगी एज पर द आयुर्वेदा संप्राप्ति। नेक्स्ट। अब हम कुछ शॉर्ट में ट्रीटमेंट एस्पेक्ट्स को चेक करते हैं कि मॉडर्न और आयुर्वेद के ट्रीटमेंट एस्पेक्ट क्या हो सकते हैं। नेक्स्ट। आयुर्वेद के अगर आप सुश्रुत संहिता में देखेंगे तो उन्होंने सर्जिकल शल्य कर्म ये सबसे पहले पार्ट पे ही रखा हुआ है, और मॉडर्न ऑन्कोलॉजी भी सर्जरी सजेस्ट करता है। इवन सुश्रुत आचार्य ने यहाँ तक कहा है कि आपको अर्बुद का निराकरण करने के बाद आजू बाजू के जितने भी शेष अवशेष है वो भी निराकरण करने हैं, और इसी को मॉडर्न सर्जरी में वो जो फेरी के उनके टिश्यूज है, मार्जिन है, उसको क्लियर करना बोलते हैं। उसके बाद हम अग्निकर्म या क्षार कर्म पे जा सकते हैं। उसके बाद पंचकर्म एक थेरी है जो हमारे पास, पंचकर्म चिकित्सा हम यूज कर सकते हैं। उसके बाद रसायन थेरेपी या धातु पोषण के लिए हम उसको यूज कर सकते हैं। ये हमारा ट्रीटमेंट एस्पेक्ट हो सकता है, मॉडर्न ट्रीटमेंट एस्पेक्ट। नेक्स्ट स्लाइड। मॉडर्न जो ट्रीटमेंट एस्पेक्ट है उनका भी पहला कॉल सर्जरी है, उसके बाद रेडिएशन। दे गोज फॉर रेडिएशन टू दैट यूज अ वेरी एनर्जी बीम एंड डिस्ट्रॉय कैंसर सेल और स्पेसिफिक स्पॉट पे जाके उसको ट्रीट करने का। उसके बाद उनके पास कीमोथेरेपी है, यूज पावरफुल मेडिसिन टू किल फास्ट ग्रोइंग सेल्स। उसके बाद इम्यूनोथेरेपी है, हेल्प्स टू ओन इम्यून सिस्टम फाइंड एंड फाइट द कैंसर। अब आज के तारीख में अगर आप सोशल मीडिया पे कैंसर सर्च करते हैं तो इम्यूनोथेरेपी के बहुत ज़्यादा वीडियो आपको या फिर बहुत ज़्यादा चीज़ों को देखने को मिलेगा, लेकिन कॉस्ट ऑफ इम्यूनोथेरेपी एक इंजेक्शन की कॉस्ट अराउंड 2 लाख रुपीज़ है, एंड पेशेंट स्पेंड अराउंड 20 lakhs for immunotherapy, and at the end of the day they are says ki sorry, it is not working for them. Also there are some targeted therapy, hormone therapy, stem cell transplantation. These are other way of treatment for the cancer, but largely and popularly known treatment is surgery, radiation and chemotherapy, because now these are the very not that much expensive nowadays, and it is available all over India. After chemotherapy, immunotherapy, or targeted therapy, all these are very expensive one and very specifically or very minutely managed. Need to manage it very specifically and minutely. Next one. अगर हम अगर हम दोनों को कंपेयर करने की कोशिश करें कि मॉडर्न ट्रीटमेंट एस्पेक्ट और आयुर्वेद ट्रीटमेंट एस्पेक्ट, क्योंकि हमें इंटीग्रेशन के और ही जाना है, रिफाइनमेंट उसी में लाना है, तो क्या हम इसको कंपेयर कर सकते हैं क्या? तो एज सच, truly speaking, if you want to do the action like a chemotherapy, तो हमें ऐसे ड्रग डिलीवरी सिस्टम बनाने की या डेवलप करने की जरूरत है जो जाके कैंसर सेल को किल कर सके। एट प्रेजेंट हमारे पास कुछ ड्रग्स है या फिर जो लोग कैंसर में काम कर रहे हैं उन्होंने कुछ अपने लेवल पे ये सब ड्रग्स डेवलप किए हैं, और वो पेशेंट में दे भी रहे हैं, पेशेंट को ट्यूमर रिग्रेशन भी मिलता है। लेकिन उसको बुक्स में एस्टेब्लिश करना, उसे रिसर्च मेथोडोलॉजी से एक जगह पे प्रस्थापित करना और फिर उसका हर जगह पे प्रचार प्रसार करना, ये अभी हमारे एंड पे बाकी है। तो प्राइमरी टारगेट उनका क्या होता है कि फोकस डायरेक्ट ऑन डिस्ट्रॉइंग अबेंडेंट या ट्यूमर सेल्स को करना है। अब हमारे पास ऐसा सच कुछ है नहीं कि हम जाके टारगेटेड कुछ किलिंग चालू कर दे जैसा उनके कीमोथेरेपी में होता है। उसके बाद थेरेपेटिक मॉड्यूल्स में ये कीमोथेरेपी दे रहे हैं, वो इम्यूनोथेरेपी दे रहे हैं। हम दीपन पाचन या ये ऐसे कुछ चीज़ों को उससे कोरिलेट कर सकते हैं, लेकिन वो ज़्यादा यूजफुल नहीं हो पाते। नेक्स्ट। नेक्स्ट। नेक्स्ट वन।
Yes, sir. एक minute. Yes, sir.
हाँ, प्रीवियसली, प्रीवियस स्लाइड। ओके, नेक्स्ट।
Yes.
हाँ, अप्रोच टू एडवर्स इवेंट्स। अब एडवर्स इवेंट्स मैनेज करने में आयुर्वेद आज आज के तारीख में बहुत ज़्यादा सक्सेसफुल है। अभी जो चीज़ें हैं उसमें हम जो टॉक्सिसिटी डेवलप होती है कीमोथेरेपी या रेडिएशन से, उसे बहुत अच्छे से मैनेज कर सकते हैं, और उसमें अभी हमारी अच्छी पहुंच बन गई है। सो इन दैट केस वी हैव वेरी गुड अपर हैंड फॉर मैनेजिंग द टॉक्सिसिटी। लेकिन वही बात है कि अगर हम उनकी टॉक्सिसिटी मैनेज करेंगे तो फर्स्ट लाइन ट्रीटमेंट में कब जाएंगे। और दूसरा होता है कि जब कैंसर फोर्थ स्टेज में है या फिर थर्ड स्टेज में है या फिर वो स्प्रेड हो चुका है, 2 3 4 लोकेशन पे है, तो हम उसमें पेशेंट का क्वालिटी ऑफ लाइफ या फिर अ, उसका डेली रूटीन को मेंटेन करने के लिए बहुत अच्छे शेप में है। नेक्स्ट। अभी जो हमारा टॉपिक है इंटीग्रेटिव ऑन्कोलॉजी में रिफाइनमेंट, पहले हम उसको डिस्कस करते हैं और उसके बाद ये डिस्कस करते हैं कि हम कहाँ पे अच्छा बेटर कर सकते हैं, कहाँ पे आज हम लोगों को क्या दे सकते हैं, उसको एक चीज़ों को समझने की कोशिश करेंगे विद द हेल्प ऑफ सम रिसर्च publications and those who are working in this area। तो अगर हमें रिफाइनमेंट करना है, पैसिव पैलिएशन से एक्टिव और प्रैक्टिकल सिनर्जी गेन करके एक्टिवली कैंसर ट्रीट करना है, तो क्या हमारे पास में चैलेंजेस हो सकते हैं, उसको हम डिस्कस करते हैं। क्योंकि रिफाइनमेंट करना है हमें, उसको और आगे ले जाना है। जैसे मैंने कहा कि इंटीग्रेशन की ज़रूरत ही आज हमें इसलिए है क्योंकि मॉडर्न के पास जो नहीं है, उनके पास टॉक्सिसिटी कम करने के लिए उतने ज़्यादा अच्छे ड्रग्स नहीं है जितने ज़्यादा अच्छे ड्रग्स हमारे पास अवेलेबल है. So they have the upper hand for killing. We have upper hand for a building, rebuild of a body or rebuild all the dhatus. Next. So moving from alternative to integrative synergy. अब जब तक हमारे पास वो कोर अस्त्र शस्त्र या ऐसे मेडिसिन नहीं आ जाते जिससे हम टारगेट किलिंग कर सके या पेशेंट के ट्यूमर्स को डायरेक्टली कम कर सकते, तब तक हमें सिनर्जेटिकली इंटीग्रेटिव सिनर्जेटिक एक्शन बढ़ानी है इंटीग्रेशन के थ्रू फॉर द रिकवरी ऑफ ए कैंसर पेशेंट. सो करंट चैलेंज क्या होता है, जब भी हम इंटीग्रिटी की बात करते हैं तो मॉडर्न एस्पेक्ट जो है वो इतने ज़्यादा रिसर्च ओरिएंटेड या इतने ज़्यादा लैब टेस्टेड उनका माइंडसेट है कि वो हमारे शास्त्रोक्त वर्णन को एक्सेप्ट करना, पहले तो वो एक्सेप्ट ही नहीं करते. तो उसके लिए हमें उस ही दिशा में पहले बढ़ना पड़ेगा, यानी पहले हमें हमारे ही चीज़ों को रिफाइन करना पड़ेगा. हमारी जितनी भी अच्छी चीज़ें हैं, रसायन हो, पंचकर्म हो, उन्हें एकदम स्पेसिफिक बनाना पड़ेगा. तब जाके हम इंटीग्रेशन और रिफाइनमेंट की बात अच्छे से कर पाएंगे. ठीक है. अभी जैसे धातु क्षय या कैकेक्सिया, ये एक बहुत ही प्रॉब्लमेटिक केस है, सिचुएशन रहती है कैंसर पेशेंट में. जब कैंसर 4 स्टेज में आ जाता है, पेशेंट की रिकवरी लगभग असंभव हो जाती है या असाध्य रोग की कैटेगरी में कैंसर पहुंच गया, ऑन्कोलॉजिस्ट भी बोल देता है कि भाई अभी अपन कुछ नहीं कर सकते. तो उस समय कैकेक्सिया एक स्टेज आती है कैंसर पेशेंट में जब सारा धातु क्षय यानी सप्त धातु का क्षय हमें दिखता है. पेशेंट में सप्त धातु का क्षय दिखता है. अगर हमें उस समय रसायन दे के उसको रिबिल्ड करना है, तो हमें जो उनके कैकेक्सिया के जितने भी क्राइटेरिया उन्होंने रखे हुए, उन वैसे ही हमें धातु क्षय के क्राइटेरिया बनाने पड़ेंगे और वो रिफाइनमेंट करना पड़ेगा कि अगर इस लेवल का धातु क्षय जो हम मेजर कर सके, यानी मैपिंग काइनोटैक्सिक ड्राइव हाइपर मेटाबॉलिज्म ऑफ टू ए क्लासिकल वाता पित्त इशू डिप्लेशन. यानी हम केवल ये नहीं कह सकते कि मध्यम क्षय है या कुछ अपचन हुआ है या अग्निमांद्य है, ऐसे नहीं, उसे हमें एक्चुअल कैलकुलेट करके ही आगे चलना पड़ेगा. तो धातु क्षय को हम पहले अगर मैपिंग कर पाए हमारा धातु क्षय, तो हम कैकेशिया के साथ उसको अच्छे से जोड़ सकते हैं. नेक्स्ट. तो अगर हमने एक बार हमारा धातु क्षय आइडेंटिफाई कर दिया तो हम डाइटरी फार्मूलेशन बना के पेशेंट की हेल्प कर सकते हैं. ठीक है. तो हम उसमें यूज कर सकते हैं जो भी हमारे यहाँ इतने सारे पेय मांस रस दिए हुए हैं या विलेपी, जितने भी आहार द्रव्य और उसके कॉम्बिनेशन दिए हैं उसको हम फाइन ट्यून करके पेशेंट तक पहुंचा सकते हैं. या मेडिकेटेड घी जैसे लाइक दाड़ीमादी या दुकान घृतम, इनको हम दे सकते हैं जो कि बाईपास डाइजेस्टिव वीकनेस ऑफ मंदाग्नि उसको हम ठीक कर पाए. टारगेटिंग मांसाग्नि, वो मांसाग्नि को बढ़ाने का एक हम ड्रग डिलीवरी सिस्टम बना सकते हैं या आहार द्रव्यों में दे सकते हैं. और इसके लिए हमें क्या चाहिए कि धातु क्षय भी काउंट हो जाए, और धातु क्षय को जब हम कम करते जाएंगे तो उसका जो मेजरमेंट है वो भी हम अच्छे से कर पाए. नेक्स्ट वन. दूसरा एरिया है ओवरकमिंग सब्जेक्टिविटी ऑफ अग्नि एंड गट असेसमेंट. अब हमारे पास जो पोस्ट परीक्षण और अग्नि परीक्षण है वो बहुत ही वेग है, उसमें हम रिफाइनमेंट करने की जरूरत है ताकि हम ये बता सके कि इस कहाँ पे अग्नि कितनी मंद है और कितना उसको बढ़ाने की जरूरत है, क्योंकि तीनों प्रकृति के अनुसार अग्नि मंद या तीक्ष्ण होना ये अलग अलग है. नेक्स्ट. थर्ड एरिया जहाँ पे हम रिफाइनमेंट कर सकते हैं वो है सेफ्टी गारंटीज एंड हर्बल ड्रग इंटरैक्शन स्क्रीनिंग. जैसे मैंने आपको कहा कि कुछ हर्बल ड्रग्स जो है वो इम्यून सिस्टम को बढ़ाते हैं. इम्यून सिस्टम को अगर बढ़ा देते हैं तो कीमो ड्रग्स काम नहीं करते प्रॉपरली. इसलिए हमें वो समय यानी जब कीमोथेरेपी देना है और उसके पहले कब हमें हमारे हर्बल ड्रग्स देने हैं, इसका मैपिंग करना है. प्लस अगर हमारा ड्रग कीमोथेरेपी का इफेक्ट कम कर रहा है तो वो भी हमें आइडेंटिफाई करना है. प्लस अगर कोई हर्बल ड्रग या कोई मिनरल या कोई हर्बो मिनरल कॉम्बिनेशन अगर कीमोथेरेपी के साथ में कहीं गड़बड़ करता है तो उसे भी आइडेंटिफाई करने की जरूरत है. ठीक है. सेफ्टी फर्स्ट. नेक्स्ट. फोर्थ एरिया रिफाइनमेंट का ये हो सकता है कि दोष काल और भेषज सेवन काल जो आयुर्वेद का एक अपना सुपर फाइन कह सकते हैं ऐसा अस्त्र है जिसको यूज हम कर सकते हैं टू गेट इंटीग्रेशन। अब इसको कैसे कर सकते हैं कि कीमो के प्री कीमो हम कुछ चीजों को अग्निदीपन वो दे सकते हैं। वो कब देना है, जब कफ काल है उस समय दे सकते हैं। तो आम और डाइजेस्टिव वाइटलिटी को हम मेंटेन कर सकते हैं। फिर जब कीमो दी जाएगी, कीमो देने के पोस्ट इन्फ्यूजन पीरियड में हम कूलिंग पित्त शमन चीज़ों को दे सकते हैं। और इसे ही कब देना है ये हम रिफाइन कर सकते हैं। उसके बाद रेस्ट पीरियड यानी जब कीमोथेरेपी डोजेस हो गए, रिकवरी पोस्ट इन्फ्यूजन हो गया 72 घंटे, उसके बाद में हम रसायन अगर उसको देते हैं तो पेशेंट की फिर से नरिशमेंट या धातु की पुष्टि होना शुरू हो जाती है। और ये हम एस्टेब्लिश भी कर सकते हैं कि हम केवल धातु पुष्टि कर रहे हैं, ना कि हम उसका इम्यून सिस्टम को बढ़ा के पेशेंट का कीमो के इफेक्ट्स कम कर रहे हैं। ये अभी एस्टेब्लिश नहीं है, तो वो स्ट्रेट वे बोल देते हैं कि हमें कीमो के समय आयुर्वेद ड्रग्स आपको नहीं लेने हैं। नेक्स्ट, देन कंडीशन स्पेसिफिक सपोर्टिव केयर प्रोटोकॉल। ये क्रियाकल्प जो भी हम कर रहे हैं उसको हम कंडीशन स्पेसिफिक बना सकते हैं कि अगर स्टेज 1 कैंसर है या उसके 3 कीमोसाइकिल हो गए या उसके 4 रेडिएशन हो गए, उसके बाद हमें क्या देना है, हम कौन से क्रियाकल्प, जैसे फॉर एग्जांपल ओरल कैंसर में, अगर ओरल कैंसर में सर्जरी हो गई उसके बाद में पेशेंट का कीमो हो गया और उसके बाद रेडिएशन भी ले लिया, उसके बाद जो उसके प्रॉब्लम्स क्रिएट होते हैं वो बहुत भयानक होते हैं। इतना ज़्यादा एक्सेसिव हीट माउथ में और बॉडी में शुरू हो जाता है कि पेशेंट कुछ खा नहीं पाता, पानी नहीं पी पाता, इवन ड्राइनेस इतना बढ़ जाता है कि वो हर हर 15 मिनट में पानी पीना पड़ रहा है उसको। यानी एक पेशेंट तो ऐसा था कि जिसने मुझे 3 दिन के बाद इसी इसके लिए इसलिए फ़ोन किया कि सर मैंने आज 3 घंटे के बाद पानी पिया। जो मैं 15-15 मिनट में पानी पी रहा था, वो आज फर्स्ट टाइम आफ्टर 3 डेज मैंने 3 घंटे के बाद पानी पिया। अब आप सोच सकते हो कि हाउ मच वी कैन हेल्प कैंसर पेशेंट विद आवर आयुर्वेदिक मेडिसिन। ठीक है, नेक्स्ट वन, आउटकम डॉक्यूमेंटेशन। ये इसमें हमारी बहुत ज़्यादा कमजोरी ये है कि हम जो भी आउटकम हो रहा है उसको डॉक्यूमेंटेड नहीं करते या उसको प्रेजेंट नहीं करते या एक केस भी प्रेजेंट नहीं करते, वो चीज़ें छूट जाती है। नेक्स्ट, नेक्स्ट वन, डेवलपमेंट और बायोजिनोमिक्स एंड प्रकृति गेटेड ड्रग टॉलरेंस। जैसे अपने हमें ये पता है कि पित्त प्रकृति का अगर व्यक्ति है, पित्त डोमिनेंट पेशेंट है, तो उसमें कीमो के इफेक्ट्स बहुत ज़्यादा मिलेंगे। कफ डोमिनेंट है तो उसमें कुछ कम मिलेंगे। और वात डोमिनेंट है तो उसमें बहुत ज़्यादा फटीक या उसमें टॉक्सिसिटी ज़्यादा आ सकती है। तो वी कैन गिव अ सप्लीमेंट अकॉर्डिंग टू द प्रकृति ऑल्सो, सो दैट ऑल्सो वेरी ग्रे एरिया जहाँ पे हम बहुत अच्छा डेवलपमेंट और काम कर सकते हैं और चीज़ों को और रिफाइन कर सकते हैं। नेक्स्ट, जैसे कफा प्रिडोमिनेंट में मैंने कहा, तो हमें साइंटिफिक अलाइनमेंट करने की जरूरत है। आयुर्जिनोमिक्स जो अभी प्रकृति परीक्षण सबका किया, देश का प्रकृति परीक्षण, और आगे भी हर पेशेंट का अगर प्रकृति परीक्षण हम करें और उस हिसाब से हम ऑन्कोलॉजिस्ट को भी सजेस्ट करें कि आपको ये ड्रग्स दे रहे हैं, इसका ये साइड इफेक्ट आ सकता है, तो उसके देने के पहले और देने के बाद अगर हम उसमें ये मेडिसिन ऐड कर दें तो उसका जो टिश्यू डैमेज है, जो नॉर्मल सेल्स है, वो डैमेज कम होंगे, पेशेंट में बल जल्दी आएगा और पेशेंट का रिवाइव अच्छा होगा। नेक्स्ट, ये फेज वाइज ऑन्कोलॉजिकल सपोर्ट भी हम कर सकते हैं। जैसे मैंने आपको कहा था कीमो देने के पहले बाद में, वैसा अब कैसा रहता है कि पेशेंट एक बार डायग्नोस हो गया, पहला दिन ये रहता है कि डायग्नोस, जिस दिन कैंसर पेशेंट का डायग्नोसिस हुआ उस दिन उसके फैमिली के लिए एक बहुत ही बुरा दिन रहता है। वो पेशेंट के साथ साथ फैमिली ऑल्सो गेट इन होल लॉट ऑफ प्रॉब्लम। अब वहाँ पे हमें ये देखने की और करने की ज़रूरत है कि उसको हम जो पहला स्टेज है बिफोर सर्जरी, क्या हम उसको कुछ चीज़ें दे सकते हैं। अगर वो दे के हम उसका आर्म, उसका शो और उसका कम कर सके, उसके ऑर्गन्स जो भी है उसको क्लियर कर सके, तो हमें सर्जरी का आउटकम बहुत अच्छा मिल सकता है। नेक्स्ट वन, फेज में जैसे ड्यूरिंग इन्फ्यूजन साइकिल, जैसे हमने कहा कीमोथेरेपी जब चल रही है उस समय हम कुछ दे सकते हैं। उसके थर्ड फेज में हम जैसे उसकी रिकवरी में, जैसा उसका अभी इंटरसाइकल रेस्ट विंडो यानी दो कीमो के बीच में 1 महीने का लगभग या 3 हफ्ते का गैप रहता है, तो हम उस दौरान कुछ चीज़ों को दे के उसका रिकवरी फास्ट कर सकते हैं। फिर वहीं पे प्रॉब्लम आती है कि ड्यूरिंग कीमो ऑल ऑन्कोलॉजिस्ट सजेस्ट कि डोंट गो फॉर आयुर्वेदिक मेडिसिन बिकॉज दे हैव दैट डाउट कि हर्बल ड्रग्स कैन हैम्पर द रिजल्ट्स। तो उसे दूर करने के लिए वी हैव टू एस्टेब्लिश the safety of herbal drugs, और we work on only cell development not on the immune system। ये हमें डिफरेंशिएट करके दिखाना पड़ेगा। और उसके बाद प्रो सर्वाइवल या उसके बाद पोस्ट ट्रीटमेंट सर्वाइवल या तो रिकरेंस। बेसिक प्रॉब्लम क्या है आज के तारीख में कि कैंसर रिकरेंस बहुत है, और ये कैंसर रिकरेंस अवॉइड करने के लिए हमारे पास बहुत कुछ है। यहाँ पे ये बहुत बड़ा और एक गोल्डन पीरियड रहता है पेशेंट के पास। उसका पहले तो हो जाता है, फॉर एग्जांपल ओरल कैंसर है और एक टंग कैंसर का पेशेंट है, उसको ऑपरेट कर दिया, टंग उसका निकाल लिया, आधा 1/4 जितना भी होगा। उसके बाद उसका कीमो हो गया, रेडिएशन हो गया, एंड नाउ दे डिक्लेयर द पेशेंट इज अ डिसीज फ्री। बट इन कैंसर नाउ डेज दे से द कैंसर इज नॉट, यू कांट से कि कैंसर फ्री हो गया, इट्स अ कैंसर सर्वाइवल। एक बार उसको कैंसर हुआ तो उनका कहना है कि वो कैंसर ही रहेगा। ठीक है। अब उसका ये सारा साइकिल हो गया, बहुत सारे पेन एंड ऑल फाइनेंशियल बर्डन से पेशेंट बाहर निकलता है। बाहर निकल के बाद पेशेंट को लगता है कि नाउ ही इज फ्री, बट देर इज अ कैच 20 सिचुएशन। वो फ्री होता है लेकिन 2 महीने, 2 साल, 3 साल, 4 साल या कभी कभी 1 साल के अंदर ही कैंसर वापस आ जाता है। और वो मेटास्टेसिस या सेकेंडरी कैंसर जो है उसको अगर हमें रोकना है तो वी हैव टू गिव हिम a total protocol or a standard treatment to delay the recurrence or avoid the recurrence। और इसके लिए प्रोटोकॉल या काम करने की जरूरत है, यहाँ पे जब से ज़्यादा रिफाइनमेंट करने की जरूरत है। और बहुत अच्छा है क्योंकि दैट टाइम ऑन्कोलॉजी इज नॉट गोइंग टू से एनीथिंग कि डोंट गो फॉर आयुर्वेदिक ट्रीटमेंट और पंचकर्मा ट्रीटमेंट। दे से यू कैन नाउ, दिस इज फ्री, you can take any treatment whatever you want। and if we establish some protocol or we establish some guideline or a framework with the help of all our solvers of those who are working in cancer area, we definitely go and advise patient to go for a 1 year therapy or like a 6 month therapy or a 3 month therapy for a panchakarma, for a detox, for a rasayan treatment, and refine your body। So remove the arm or whatsoever inside your body and regain the balance। this very good phase। और जितने भी श्रोता इसे सुन रहे हैं, मेरी सबसे एक रिक्वेस्ट है कि इस पीरियड को कैच करने की कोशिश करिए जब हम पेशेंट को उसका जितना भी बल है उसको वापस स्थापित करके दे सकते हैं, और विदाउट हैविंग एनी इंटरेक्शन विद एनी कीमो ड्रग और एनी रेडिएशन प्रॉब्लम और एनी थेरेपी। ठीक है। दैट्स अ गुड एरिया at present to start a work in a cancer ayurved cancer treatment। Next, uh, these are some slides, we go very fast with this one। All these are some contribution where we can, so all you know what we are doing. The first and best thing we have with us is the rasana treatment। and if we go for a rasana treatment in any stage you can, we can take this call at any stage। हम देखेंगे आगे कहाँ का दे सकते हैं। then we can go for a symptomatic treatment, देन स्पिरिचुअल ट्रीटमेंट, होलिस्टिक सपोर्ट, ये हमारा सबसे तो गुड और प्राइम है ही है। नेक्स्ट वन, इसको हम पास कर लेते हैं, इसको फास्ट ही चल, तो जितने भी सत्वावजी चिकित्सा, डाइटरी मैनेजमेंट, ये सारी किताबी है चीज़ें पेन मैनेजमेंट के लिए, या फिर आप शोधन ट्रीटमेंट। हाँ, तो रोल ऑफ रसायन यहाँ पे आके हम रुक जाते हैं कि हम रसायन को हम क्या क्या कर सकते हैं। कैंसर रिलेटेड फटीक, ये जो फटीक है इसको हम जनरल फटीक से कभी कंपेयर ही नहीं कर सकते। वी डोंट हैव एनी स्केल टू मेजर व्हाट इज अ फटीक आफ्टर अ कैंसर ट्रीटमेंट, और कैंसर पेशेंट का फटीक क्या होता है, या उसका वेट लॉस क्या होता है, उसका धातु क्षय क्या होता है, ये हमारे पास है ही नहीं। मे बी उस समय रहा होगा लेकिन आज अभी हमारे पास है नहीं, तो वी हैव टू अगेन रीबिल्ड कि फटीक एंड कैकेक्सिया जो है, यानी ये इसका पहले तो हम ग्रेडिंग कर लो, और फिर ग्रेडिंग करने के बाद वी नीड सम स्पेशलाइज्ड रसायन टू रीबिल्ड द धातु टू गिवन धातु पोषण, क्योंकि ये धातु पोषण उस लेवल का चाहिए कि जब पेशेंट की अग्नि टोटली मंद है, पेशेंट खा ही नहीं रहा है, और अगेन वी नीड समथिंग एक्स्ट्रा, तो रसायन वहाँ पे बहुत अच्छा काम कर सकता है। वी हैव वेरी गुड रसायन विद सर, लेकिन हीरक रसायन, ताम्र रसायन, सुवर्ण भस्म, रौप्य भस्म, ये बहुत अच्छा काम करते हैं। सोमनाथी ताम्र भस्म इज द मोस्ट वाइडली यूज रसायन फॉर कैंसर ट्रीटमेंट ऑफ ए लीवर कैंसर पेशेंट। बहुत ज़्यादा, बहुत अच्छा ट्रीटमेंट और बहुत अच्छा रिजल्ट। हम मैं आगे भी आपको रिसर्च पेपर्स भी दिखाता हूँ। नेक्स्ट वन, इम्यूनोमोड्यूलेटर है, साइटोप्रोटेक्टिव है, इम्प्रूव द क्वालिटी ऑफ लाइफ। ये क्वालिटी ऑफ लाइफ जो मैंने आपको कहा कि पोस्ट कैंसर ट्रीटमेंट जो हुई है, उसकी सर्जरी, रेडिएशन, कीमो, उसके बाद जो पेशेंट का वीकनेस है उसको हम बहुत जल्दी रिकवर कर सकते हैं विद द रसायन। और मॉडर्न के पास केवल मल्टीविटामिन, सम like multi mineral combination like that, zinc and all these things, but we have a lot of and bunch of drugs with us, so we can use it very well, कोई प्रॉब्लम नहीं। वी ओनली एक्सप्लोर वन थिंग, दैट वन इज ए च्यवनप्राश, बट आई थिंक वे हमारे पास उससे बहुत कुछ ज़्यादा है जो हम दे सकते हैं। नेक्स्ट वन, रसायन हम कहाँ ऐड कर सकते हैं? जैसे मैंने कहा, रसायन हम हर जगह ऐड कर सकते हैं। पोस्ट सर्जरी में ऐड कर सकते हैं, जो कीमो ले रहे हैं उसके बीच में भी ऐड कर सकते हैं। जिस केस में कन्वेंशनल थेरेपी काम ही नहीं कर रही है या फिर कीमो का रेजिस्टेंस आ गया, वहाँ पे हम रसायन थेरेपी बहुत अच्छे से काम कर सकते हैं। जहाँ पेशेंट में हार्मोनल थेरेपी, कई पेशेंट आते हैं जब थर्ड स्टेज, वैसे भी इंडिया में थर्ड या फोर्थ स्टेज में ज़्यादा डायग्नोस होते हैं, और उस समय उनके लिए कुछ ज़्यादा अवेलेबल नहीं है मॉडर्न ट्रीटमेंट में। उस समय आयुर्वेद विद द हेल्प ऑफ रसायना वी कैन डू अ लॉट ऑफ गुड थिंग्स टू हेल्प देम और गिव देम सम होप। नेक्स्ट वन, नेक्स्ट स्लाइड। नेक्स्ट, नेक्स्ट, अपन वैसे भी वी आर ऑलमोस्ट एट द एंड। दिस फर्स्ट वन, this one paper published in Iran basic medicine magazine से, CUONA कॉपर ऑक्साइड नैनो पार्टिकल का उन्होंने सेल लाइन स्टडी किया हुआ है। सबसे आखिरी की लाइन आप पढ़ सकते हैं, उसमें उन्होंने कहा है कि इंड्यूस एपोप्टोसिस वाज कंफर्म थ्रू एक्रेनिक ऑक्सीजन एंड प्रोडियम इन iodine double strength in tumor suppressant genes was up regulated due to कॉपर ऑक्साइड नैनोप्रैक्टिक। तो ये भी चीज है कि आप उस, ये सब चीजों पे अभी काम बहुत अच्छे से चल रहा है। नेक्स्ट, गोल्ड नैनो पार्टिकल इन रेडिएशन रिसर्च पोटेंशियल एप्लीकेशन फॉर इमेजिंग एंड रेडियनाइजेशन। अभी लास्ट एब्स्ट्रैक्ट में आप पढ़ सकते हैं, द पोटेंशियल ऑफ ए गोल्ड नैनो पार्टिकल इन थेरापेटिक एंड डायग्नोस्टिक कैंसर एप्लीकेशन इज बिकमिंग इंक्रीजली रिकग्नाइजिंग। यानी जो हमारा स्वर्ण भस्म है वही ये इनका गोल्ड नैनो पार्टिकल है। तो वो अभी वो लोग भी यूज कर रहे हैं कि भाई इसको हम यूज कैसे किया जाए। वैसे भी अगर कैंसर ड्रग को आप देखेंगे, प्लैटिनम का यूज वो करते हैं, सिस्प्लैटिन वगैरह जो ड्रग है, दे आर डिराइव्ड फ्रॉम द प्लैटिनम। नेक्स्ट, refractory killing of a cancer cell and active human T cell using ZNO nanoparticles, यानी हमारा ये जो है जिंक ऑक्साइड, उनका जो है जिंक ऑक्साइड को उन्होंने यूज किया हुआ है। नेक्स्ट, ये हम सबको ही पता है कि एंटीवायरल और इम्यूनोमॉड्यूलेटिव इफेक्ट तो कैंसर का ही है, रसायन का है। नेक्स्ट वन, नेक्स्ट कर लेते हैं। Then this one is the paper published in Ankle of Oncology, Annals of Oncology, sorry। ये दुनिया का एक हाईएस्ट मैगजीन है, जर्नल है, जो ऑन्कोलॉजी के पेपर पब्लिश होती है। तो आप देखोगे डॉक्टर योगेश भंडारे, उनका जो रसायन कैंसर क्लिनिक है, उनके द्वारा ये पेपर पब्लिश हुआ है एनल्स ऑफ ऑन्कोलॉजी में। इंटीग्रेटेड आयुर्वेदा हर्ब स्टैंडर्ड ऑफ केयर फॉर मैनेजमेंट ऑफ कैंसर और कैंसर ट्रीटमेंट रिलेटेड एनोरेक्सिया। अभी आप सोचो, एक ओनली एनोरेक्सिया यानी भूख न लगना, ये इतना बड़ा प्रॉब्लम है कैंसर पेशेंट के लिए कि वी कांट इमेजिन कि भाई उनको भूख नहीं लग रही है, अब उसको हमें रिवाइव करना है। तो दिस वन पेपर इज एक्सेप्टेड बाय देम, और उन्होंने कहा है कि ये बहुत कॉमन सिम्टम, यानी आधे से ज़्यादा पेशेंट में ये सिम्टम्स मिलता है, और उसके लिए हमारा हर्बल फॉर्मुलेशन और हर्बो मिनरल फॉर्मुलेशन जो है वो बहुत अच्छा काम करता है। नेक्स्ट, this Journal of Cancer Research and Therapeutics addressing and targeting earliest condition of advanced breast cancer related anorexia and cachexia through the रसायना थेरेपी, ये भी डॉक्टर भंडारी सर का ही पेपर है जो जर्नल ऑफ कैंसर रिसर्च एंड थेरेप्यूटिक्स में अभी पब्लिश हुआ है। नेक्स्ट, then management of constipation, अभी constipation is also a big issue during taking a chemotherapy, तो उसे भी हम एड्रेस कर सकते हैं with all the help of रसायना ट्रीटमेंट एंड लाइक ओपियोइड, अभी ओपियोइड यूज होता है कैंसर पेशेंट के पेन मैनेजमेंट के लिए, उसे भी हम हमारा ओरल हर्बल सप्लीमेंट्स देके उसका कॉन्स्टिपेशन को ट्रीट कर सकते हैं। नेक्स्ट वन, नेक्स्ट आगे चले जाते हैं। ये काफ़ी सारे हैं पेपर्स ऐसे कि जिसको हम देख सकते हैं, और मेरी सबसे गुजारिश है जो भी पीजीज या जो भी लोग इसमें काम करना चाहते हैं, वो बहुत सारा मटेरियल जो रिसर्च पेपर अवेलेबल है उसको आप सर्च करें, पढ़ें और समझने की कोशिश करें कि बहुत ज़्यादा अल्टरनेटिव ढूंढने की कोशिश कर रहे हैं कैंसर ट्रीटमेंट के लिए। नेक्स्ट वन, नेक्स्ट, ये एक पेपर है जो रसायना थेरेपी से क्वालिटी ऑफ लाइफ बढ़ती है, इसके उन्होंने किया था पब्लिश, ये भी जर्नल ऑफ थोरेसिक ऑन्कोलॉजी में पब्लिश हुआ है। खास करके जेरेटिक आउटकम ऑफ क्वालिटी ऑफ लाइफ इन एडवांस स्टेज जेरेटिक लंग कैंसर पेशेंट में। अब पेशेंट जेरेटिक है, उसमें भी लंग कैंसर है, तो उसमें हम हेल्प कर सकते हैं आयुर्वेदा रसायना थेरेपी से, ART उन्होंने कहा है। तो उसको आयुर्वेदिक रसायन थेरेपी से हम उसका लाइफ को अच्छे से इम्प्रूव कर सकते हैं, उसका क्वालिटी ऑफ लाइफ बढ़ा सकते हैं। नेक्स्ट, एल्डरली पेशेंट में रसायन काम बहुत अच्छा करता है। नेक्स्ट वन, ये जितने भी है वो आप इसके स्क्रीनशॉट लेके रख सकते हैं, या आप इसके फोटो लेके इसको फिर से सर्च कर सकते हैं, लिंक्स भी दी हुई है, आप लिंक्स भी एक्सप्लोर करके जा सकते हैं। नेक्स्ट वन, अभी ये पहले वाला, एक ही मिनट, हाँ, रसायन आयुर्वेद थेरेपी लीड्स टू ट्यूमर रिग्रेशन, अभी ये एक सबसे बेस्ट पेपर है। सरकारी योगेश सर भंडारी सर का ही पेपर है कि आयुर्वेद रसायन थेरेपी लीड्स टू ट्यूमर रिग्रेशन एंड इंक्रीज सर्वाइवल इन कीमो इंटॉलरेंस आई ग्रेड स्टेज 4 लाइपोमा की केस थी, उसमें एक केस स्टडी में उन्होंने ये एस्टेब्लिश किया है कि हम लॉन्ग टर्म में भी रसायना दे सकते, प्लस हाई डोज में भी रसायना दे के ट्यूमर रिग्रेशन अचीव कर सकते। तो वी नीड सम रिफाइनमेंट कि हमें किस अवस्था में क्या चीज को देना है। नेक्स्ट वन, नेक्स्ट, वही है जो अपन अभी तक डिस्कस कर रहे थे कि कहाँ हम किस चीज़ को ऐड ऑन कर सकते हैं, रसायन थेरेपी कहाँ से कर सकते हैं, पंचकर्मा कहाँ कर सकते हैं, डाइट कहाँ दे सकते हैं, और माइंड बॉडी प्रैक्टिस लास्ट स्टेज में या उसके शुरुआती में भी उसको अगर हम कुछ स्ट्रेंथ दे पाए तो अच्छी बात है। नेक्स्ट, नेक्स्ट, चलो ऑलमोस्ट एट द एंड। नेक्स्ट वन, फ्यूचर में हम क्या कर सकते हैं, वही मैंने जैसे कहा कि दोष काल जो हमारा आयुर्वेदिक सर्केडियन टाइमिंग है उसको वेस्टर्न सर्केडियन ऑन्कोलॉजी या क्रोनोथेरेपी, नाउ दे आर डेवलपिंग दिस क्रोनोथेरेपी, ये चीज को भी आपको, और क्रोनो कीमोथेरेपी, आप वो अभी सर्केडियन रिदम पे आ गए हैं, सो वी हैव अ वेरी गुड टाइम टू गेट इंटीग्रेट विद देम, कि हमारा ऑलरेडी दोष काल बहुत ज़्यादा एस्टेब्लिश है, अगर हम उसको फॉलो करें ड्यूरिंग कीमोथेरेपी जैसे हमने पहले भी डिस्कस किया, लेकिन हमें उसको डिजिटलाइज करना पड़ेगा, या तो उसका स्केल डेवलप करनी पड़ेगी, या तो उसको अच्छे से और एक्सप्लेन करना पड़ेगा। दूसरा है गट माइक्रो ऑन्कोलॉजी एक्सिस, इस पे अच्छा काम हो रहा है और आगे और ज़्यादा काम करने की ज़रूरत है। जो क्लिनिकल टॉक्सिसिटी स्केलिंग है, QOL मैट्रिक्स जो हमारे उसको डेवलप करने की ज़रूरत है। स्टैंडर्डाइज दिनचर्या किट, अगर पोस्ट रेडिएशन, पोस्ट कीमो या ड्यूरिंग कीमो रेडिएशन के, तब अगर हम दिनचर्या पेशेंट को दे सके एक फॉर्मेट में, तो बहुत अच्छा काम हो सकता है। और लास्टली इंटरेक्टिव प्रकृति बेस्ड पैलेटिव केयर कैलकुलेटर्स अगर हम उनको देंगे, आपकी प्रकृति जो है वात प्रकृति है, उस अनुसार आपको ये पैलेटिव केयर में जाना चाहिए, तो वो हमारे लिए बहुत ज़्यादा रिफाइनमेंट हो जाएगा। नेक्स्ट, दीज आर सम चीज की हमें सबसे लास्टली मेरा आज जितने भी इस प्रोग्राम में जुड़े हुए हैं, खास करके एटाकॉन और एटाकॉन से साथ में जुड़े हुए NCSM SCCR और जो भी स्टॉलवर्ड्स है, उनसे एक अपील है कि आयुर्वेद कैंसर सोसाइटी एक हमें बनाने की ज़रूरत है जो कि आयुर्वेद और कैंसर के लिए अच्छे से काम करे। नेक्स्ट वन, इन आवर कॉलेज वी स्टार्ट वन निरामय आयुर्वेद कैंसर OPD। इसके लिए हमारे कॉलेज के जो प्रिंसिपल सर है डॉक्टर मोहन एंडे सर, उन्होंने बहुत अच्छा इनिशिएटिव लिया, मदद की, और उन्होंने इसकी शुरुआत की। तो नागपुर में we are one who have a कैंसर OPD इन प्राइवेट कॉलेज। ये लास्ट ईयर हमने चालू की थी। अभी एक 6 महीने 8 महीने के बाद हमें मंथ में 1 या 2 पेशेंट मिलते हैं जो ट्रीटमेंट ले रहे हैं। इंक्वायरी बहुत ज़्यादा आती है, वो लोग पूछते हैं, जानकारी लेते हैं, बिकॉज व्हेन कैंसर गेट डायग्नोज होल फैमिली नो व्हाट इज द कैंसर। और उसके बाद इतनी क्वेरीज आती है, इतनी क्वेरीज उनके दिमाग में रहती है कि जिनको शांत करने के बाद प्लस दे गेट लॉट ऑफ सजेशंस फ्रॉम ईच एंड एवरी वन। एंड क्या कहते हैं हम कि थोड़ा दुख से कहना पड़ रहा है कि हमारे पास स्टैंडर्ड प्रोटोकॉल नहीं है जिसको बनाने की और उसको रिफाइनमेंट करने की बहुत ज़रूरत है। That's from my side. If anyone want to ask anything, they are free. They can contact me on this my WhatsApp number. Personally, if anyone want any support in the field of cancer and Ayurved, I am ready to help them on at every extent. Thank you for patience listening. Thank you each and everyone who participate and who listen patiently for all these things. मेरा एक ही एम है कि हम कैंसर में आयुर्वेद के द्वारा पेशेंट की जितनी ज़्यादा मदद कर सके उतनी करें। और जो भी कोई अगर इसमें और कुछ करना चाहता है तो मुझे संपर्क कर सकते हैं। ये मेरा व्हाट्सअप नंबर है, आप उसमें कभी भी मुझे मैसेज करिए, नो प्रॉब्लम। ऑल आर वेलकम एंड थैंक यू वेरी मच अटैकॉन। खास करके प्रेसिडेंट राहुल सर, किरण मैडम, प्रिंसिपल सर, LN कॉलेज के प्रिंसिपल सर, जैन सर, आप सबका बहुत बहुत धन्यवाद। और चेयरपर्सन और को चेयरपर्सन, आई एम वेरी गेट ग्लैड इफ यू गिव अ सजेशन एंड अ वेरी गुड रिस्पॉन्स, and whatever you suggest I will definitely try to work on it, and again come back to you with a very good and again a new presentation if Atacon gives me a chance to present all these things. Thank you very much from my side. Now Kiran madam, it's it.
Yeah, thank you so much, sir, for the session was very insightful, and this thought-provoking session will definitely give us an opportunity to at least provide some Ayurveda health care and provide a quality of life to the cancer care patients. Thank you so much. We look forward to get the many sessions from you. Thank you so much. Now I will hand over the session to Dr. Vipul sir. Thank you.
Thank you, Kiran
So
ma'am.
much.
It's now my honor to invite our respected co-chairperson, Dr. Rajgopala Krishnan sir, for their comment.
Vipul sir, you are not audible. Sorry to interrupt.
Sorry. Now audible, sir?
Your voice is very low.
It is now my honor to invite respected co-chairperson, Dr. Rajgopala sir, for their comment and observation.
Good evening, all. I hope you can all hear me properly.
Yes, sir.
Yeah, it was a wonderful presentation by Dr. Ashish. I would just to add some remarks on that. One is Ayurveda. In Ayurveda, first Arbuda is first defined or said as a nidana as a atiyoga of Madhurya rasa. Kurute atupayogena medas leshmajo gadan. Taulya, Agnisada, Sannyasa, Meha, Gandarbudadigan. So before the glucose pathways that has been found in modern 15 years back, Ayurveda has clearly mentioned Arbuda or cancer types of lesions as caused by due to the high usage of Madhurya Rasa, which we see in the public very common nowadays, the rotis, the gulab jamuns, and all the sweets and ice creams that we take in high amount, also the ultra processed foods. These are causing increased Dhatuvagni Mandya, resulting in transformations into Granthi and Arbudas. So we need to understand that primarily Nidana of Arbuda, as per Ayurveda, is increased use of Madhurya Rasa. Then the areas where we can concentrate in integrative oncology is basically one as a standalone therapy where people are not able to go for conventional chemotherapy, radiation, either due to multiple other diseases haunting them, or geriatric oncology where age is a factor and other comorbidities are factors. Second is areas of post chemo and post radiation rehab, and also increasing the efficacy of immunotherapy. Where like immunotherapy, now we know the prognosis of immunotherapy is directly related to certain bacteria in the gut microbiomes, especially Akkermansia is a bacteria. If reduced in number, will hamper the efficacy of immunotherapy. Our drugs like Dadimam, like Dadimastaga Churnas, all the Dadima related drugs said in Adisara Grahini have been shown to increase particularly the mucosal lining of the gut as well as Akkermansia. And post or pre-Dadima therapy or Grahini related therapy before immunotherapy will actually boost the efficacy of immunotherapy drastically. That is the most modern research that we see today. And third one is the palliative care, bedridden patients and late end-stage patients whom we can give them a specialized care through Ayurveda. Also, we need to take into account important regimens like fasting. Fasting now, we clinical fasting, say 1, 3, 5, 7 days, according to the dosha and the dhatu bala of patients, roga and rogi. We can actually inculcate fasting as well as therapeutics like ketosis, or keeping the patient in ketosis by snehapan, shamana snehan, and as well as dietary changes to keep the glucose metabolism down and block the other pathways has been found very useful in controlling tumor growth as well as increasing the efficacy of chemotherapy as well as immunotherapy. So these are the basic things that we can add to the wonderful presentation by Dr. Ashish. I have to leave for a flight now, so that's why they had to put me in earlier. Thank you all, and have a great session.
Thank you, sir.
I respectfully invite our esteemed co-chairperson Dr. Prakash Kumar sir for their comments.
I think you're not. Yeah, please. Sir.
विपुल सर आपका आवाज नहीं आ रही. सर आवाज नहीं है.
Vipul sir, you are not audible. Vipul sir, you are not audible to us.
Now audible?
The voice is very low.
Okay. Now I invite Dr. Prakash sir for their valuable comments.
Dr. Prakash sir, please proceed with your remarks on the speaker session.
Okay. Thank you, ATA, for organizing such a wonderful session. आशीष कावटे सर के बारे में, ही इज ए वेरी एक्सपीरियंस पर्सन. उनके सामने मैं बहुत छोटा हूँ. जितना मेरा सर्विस है उतना उनका उतना एक्सपीरियंस है क्लिनिकल प्रैक्टिस में. बट द ओवरऑल सेशन इज वेरी वंडरफुल सेशन. But he is highlighted and given the guideline to the young generation where you can work. That is a very important. As a senior mentor, as a teacher, he has given the guidelines to the junior faculty or students who have joined this session, where they can concentrate and they can contribute for the treatment of the cancer. Because today's अभी हम कॉन्सेप्ट देखें तो बहुत सारे कॉन्सेप्ट है. पहले हमारा जो कॉन्सेप्ट था सर का धातुक्षय. धातुक्षय जरा इवन द पेशेंट इज संतर्पा ओबेज रहता है, उनके भी धातुक्षय रहता है. इवन देर इज ए वात प्रकृति person, there is also धातुक्षय is there. The approach is entirely different and the patient wise and the treatment the past history का मेडिकल हिस्ट्री आप लिए तो पता चलेगा कि कौन सा अप्रोच लेना है. और ग्रहणी और गट हेल्थ दैट इज वेरी इंपॉर्टेंट इन दिस पेशेंट. क्या होता है इस पेशेंट में बहुत सारे सालों से मेडिसिन लेते रहते हैं, उनका गट हेल्थ इतना खराब हो रहता है ना, आप आयुर्वेदिक मेडिसिन भी देंगे तो इंडाइजेशन होने के चांसेस रहते हैं. इतना अग्निमांद्य रहता है, इम्पेयर्ड डाइजेशन रहता है, उसके वजह से इम्पेयर्ड मेटाबॉलिक एक्टिविटीज भी रहता है. उसके लिए सिर्फ एट दैट टाइम even it is a dhatukshay, we need multiple approach to correct the dhatukshay. Without correcting dhatukshay or agni, dhatu agni and agni jatragni, it is very difficult to give the medication also, ayurvedic also, and get the proper results also. हम सेम मेडिकेशन बहुत सारे पेशेंट में देते हैं बट एंटायरली रिजल्ट अलग अलग होता है. दैट डिफाइंस द पेशेंट कंडीशन एंड इट डिपेंड्स द प्रकृति ऑफ द पेशेंट. कभी वात प्रकृति रहता है तब भी कैंसर का कंडीशन रहता है, कब प्रकृति का रहता है कैंसर कंडीशन रहता है, तो डिफरेंट अप्रोच हो जाता है. उसके लिए गट हेल्थ के ऊपर काम किया तो हमारा जो आयुर्वेदिक मेडिसिन है उसका एफिकेसी बढ़ जाता है. ये मेरा क्लिनिकल एक्सपीरियंस है बहुत सारे पेशेंट में. और जो अग्नि और धातु अग्नि का कॉन्सेप्ट है, इट इज अ वंडरफुल एक्सप्लेन बाय द आशीष सर एंड इट इज एवरीवन हैज टू कंसंट्रेट ऑन द स्मॉल थिंग्स. हमारा जो ओवरऑल हमारा जो आयुर्वेदिक का सेशन देख रहे हो दोष या धातु, उसका लिंक करना बहुत इंपॉर्टेंट रहता है और एक एक साथ एक लेके जाना बहुत इंपॉर्टेंट रहता है. और देर इज अ धातु अग्नि डिपेंड्स द धातु बल. धातु बल जो कॉन्सेप्ट है दैट इज अ वंडरफुल कॉन्सेप्ट ऑफ आयुर्वेदा. इफ यू वर्क ऑन द धातु बल विद द हेल्प ऑफ धातु अग्नि यू कैन गेट द गुड रिजल्ट इन कैंसर कंडीशन. And with a few observation, sir really highlighted the where is the lacuna in the our, and not only the integrity of other science, it is important to gather all the practitioners of the cancer who are working on the cancer, integrate to each other, and they have to share the what are their positive points and what are the negative points. Not only highlighting on the positive findings, they have to highlight on the negative findings, क्योंकि आगे वाला जो है ना उसको लेके चल सकता है एंड उसका ऑब्जर्वेशन वो ये कर सकते हैं. ये कंट्रीब्यूशन हमारे आयुर्वेदिक फील्ड में बहुत इंपॉर्टेंट है. सो थैंक यू आशीष सर फॉर एनलाइटिंग अस and thank you the organizer ETA and giving me opportunity to share my views as a person. Thank you one and all.
Thank you, sir. Now it's my privilege to invite our chairperson, Dr. Vivek J. sir, for concluding and remark the session.
Yeah, thank you, sir. Thank you very much. I just congratulate, and we are very blessed to have Dr. Ashish Kate sir's lecture today. So we could able to gain so many things, sir. So many things I have noted down so that we can include in our practice. So with your vast experience, you have given a lot of inputs to the listeners and also to everyone. So few things, sir, whatever you have told, that is what we have to do more of work, because allopathy doctors, medical oncologists, they don't allow us to give Ayurveda medicines during chemotherapy. They are just worried for the drug interaction. Drug interaction. So now it is the responsibility of Rashatra people, Dravimana people to sit together and to do some whatever the drugs we regularly use. We have to prove that there is no drug interaction. So this is the research work which is needed very much. So you have just shown us the lacuna, sir. And second one you have told regarding Ayurveda Cancer Society. It is really, really required because we are, so many of us are working at different parts of the country and all our informations are scattered. So it is good one Arbuda conference we can make. I request ATA people, Ayurveda Teachers Association people in future, so they can collect all Arbuda Tagnas from different parts of the country so that we can share our thoughts and our success stories, and we can document things. Because sir also told Ashish sir that we are very poor in documentation. So there is a saying, whatever we have not documented means we have not done anything. So that we have to make it. And it's a need of hour that we have to make Ayurveda Cancer Society, and regularly we have to meet, we have to make some whatever informations we have. See, my thing is wherever we are good at, we have to focus on that. So as sir was telling, geriatric oncology, we are very good at geriatric oncology, we can handle so many cases. And main thing is integration. Integration is one part, and Ashish sir has guided us. Don't be happy with only integration. You have to do the main lane of treatment also. So, being a Shalya person, I want to share few of my two cases. What we have treated with the blessings of Pujya Gurudev Shri Shri Ravi Shankar ji. So we have started our cancer unit 11 years back in our Shri Shri Ayurveda College. More than 4,000 cancer patients we have seen, and I am the in charge and head of that center and hospital in the cancer unit. So, sir, mainly I used to give for a breast cancer, I used to give Panyakshara. Few cases I have completely regressed the tumor just by Panyakshara, but it took 1.5 years, 2 years to regress the tumor. But such a Vishak patient we don't get. So everybody they want immediate result and they cannot, and they are worried about the metastasis. If I wait, what will happen? What will happen? So we cannot tell them that this is under control. Though regularly we do investigations, so they are very much worried about it. That's why second case I have given a Charajala injection to the breast tumor, directly to the tumor. So it got burning, ulceration, necrosis, and tumor completely have removed just by doing dressing. No anesthesia, no admission. It was done on a OPD basis. The tumor size was 5 into 4 centimeter. So directly I injected the Charajala to the breast tumor, and it got necrosed, and I have removed everything by bare hand. I have sent to the biopsy also. It has been published in ICE Journal of Integrative Oncology. I think this is the first case where standalone treatment is done, and 2 years follow-up is there for that case. And every 6 months I have done a PET CT scan. So like this, we can come out with so many SOPs, standard operating procedures. And even I think we are good at handling prostate cancer. So many of the prostate cancer standalone, I am giving treatment. Uttarabasti, I am giving. Shilajiti, I am giving. Panyakshara, I am giving. So whatever we are good, so let us do it independently without sending patient to chemotherapy, radiation, and surgery. But we have to be very careful. And rest of the thing is integration also let us do, because first, as sir was telling, we have to start with an integration. After we get experience, after we get hold on the subject, after patients start coming, looking into our experience, then we can go to the fresh cases. So sir has given lot of inputs. Let us all work together. I just want to give one example. I admitted one case, CA cervix in our hospital now. So she is locally advanced CA cervix patient. She is having tremendous pain, tremendous pain. Even morphine is not able to control the pain. So pain management is one of the very good area where we can work. So I have given a Basti to her, and slightly it is under control. So like this, so many Rasayana, pain management, Shara, and Anushastra Karmas we can make use of it. And so many drugs we can make use, and we can control the cancer. So Shruta has told so many things. So let us make it possible. Let us try to adopt in our practice, and let us come with evidence. So one of the big thing what sir has suggested is Ayurveda Cancer Society to help, because Ayurveda we are very poor at research, and we are happy with 5 case, 10 case, whatever we have treated. But we have to do a multi-centric studies where at least 500 cases we have to show them that we have cured with this line of protocol. Only when all Ayurveda Arbuda Tagnas join together, join hands, so we can do a multi-centric studies, so that we can, with bold, we can talk to oncology people, modern oncology. So we have to fight, and Ayur oncology, we should show that we can exist and we can give some good results. So with this, I thank all the co-chairpersons and also Ashish sir and the ATA chairpersons and all the college involved. And I'm very grateful to organizers for giving me an opportunity to share my thoughts. Thank you, Ananda.
Thank you, sir. It's my privilege to propose the vote of thanks for this enriching conference session. I sincerely thank you, our speaker, Dr. Ashish sir, for sharing a valuable insight.
विपुल सर, अगेन यू आर नॉट ऑडिबल सर.
विपुल सर, आपका माइक थोड़ा चेक कर लीजिए, आपका बिल्कुल आवाज नहीं आ रहा है.
किरण मैडम, कैन यू कंटिन्यू प्लीज?
Yes,
प्लीज.
yes, I can continue. Yes. So thank you one and all. Thank you so much, respected speaker. and respected chairpersons, co-chairpersons for sharing their valuable insights and remarks on this very innovative topic, Ayur Oncology Beyond Palliative. I am very much thankful for this opportunity for Atacon 2026 Innovative Ayurveda, the team organizers, and Sapanjan sir and Rahul Suryavanshi sir for conducting this successful session. Thank you one and all. And I will now hand over to Dr. Jayashree ma'am for the further session. Thanks a lot.
Thank you, ma'am. Once again, thank you, our respected speaker, Dr. Ashish Kate sir, respected chairperson, Dr. Vivek J sir, co-chairperson, Dr. Prakash Kumbhar sir, and Dr. Rajgopalan Krishnan sir, for your valuable presence and valuable insights. Definitely, your academic excellence and clinical experiences enrich everyone's mind today. Thank you once again. Thank you, our second session coordinators, Dr. Kiran Mendikar ma'am, Dr. Vipul Dikshit sir, for your flawless coordination. Your efforts and timely support make this second session successful. Now moving ahead for the third session, I welcome Dr. Sonia Dahat ma'am and Dr. Nagendra Thakre sir. Are you both there?
Good afternoon,
Yes,
ma'am.
ma'am.
Yes. So, firstly, I welcome Dr. Sonia Dahat ma'am. Ma'am is Assistant Professor, Department of Rachna Sharir, Sushruta Ayurvedic Medical College and Hospital, Bangalore. I welcome you, ma'am. Then
Thank you,
I
ma'am.
welcome our second session coordinator, Dr. Nagendra Thakre sir. Sir is Associate Professor, Department of Kamalvrutya, SAM College of Ayurvedic Sciences and Hospital, Raisan, Madhya Pradesh. I welcome you, sir.
Thank you.
Now I request both of you to continue with the session. Thank you.
Thank you, ma'am. Good afternoon to all the respected dignitaries, esteemed guests, faculty members, delegates, and dear participants who have joined us online. It gives me immense pleasure to welcome you all to the third scientific session of the Atacon National Seminar. I introduce my guest speaker. To begin with, it is my privilege to introduce our esteemed guest speaker, Dr. Pragyan Tripathi sir. Dr. Pragyan Tripathi sir completed his BMS and MD Dravguna from SDM College of Ayurveda, Udupi. He is also honored with the title of Yog Shiromani from the Sivanand International School of Yoga and Vedant Madurai and holds FEJ from Manipal. Sir is now director of Narmade Ayurved Panchkarma Center, a renowned group of Panchkarma centers and Ayurvedic pharmacy with centers across Madhya Pradesh and other parts of India. Specialty of center is maintaining Pan India pharmacy with most genuine products prepared out of hand-picked organic herbs. His journey has taken him across various rural and forest regions of India, where he has explored and learned various traditional
Nagendra
medicine.
sir, sorry for interruption. Slides are not visible. Sorry for
Yes, sir. 1 second, sir.
slides are not visible. Please.
Okay, sir. His journey has taken him across various rural and forest regions of India, where he has explored and learned various traditional medicine, healing practices. Sir, slide is visible?
Yes, sir. Your
No.
slide is visible. This is speaker slide, right?
Yes, ma'am.
ma'am.
Yes.
Okay. Dr. Pragyan Tripathi sir has extensive experience in Nadi Vigyan, cancer, infertility, migraine, endocrinal disorders, eye vision, Greh Chikitsa, Panchkarma, detoxification, and rejuvenational. He is excellent counselor for various Manas Rog. Sir is having patients from almost 25 countries who all coming to India for special Ayurved treatment for rare disorders. Sir is associated with Indian knowledge system, that is IKS, Ministry of Education, Government of India, as Ayurved expert for Nadi Vigyan. He has also trained several Ayurvedic practitioners from across the country in Nadi Vigyan and Panchkarma. Sir has delivered various lectures related to Ayurveda, yoga, and lifestyle management with Ayurveda at national, international, and local platforms. Sir is also a very popular and established guide on social media for addressing important Ayurveda topics. Today, we are truly honored to have Dr. Pragyan Tripathi sir with us to share his valuable knowledge and experience on the highly interesting topic, innovative single-dose therapeutics, bridging folk wisdom and Ayurvedic practice. Sir, it is indeed a privilege to have you with us. A very warm welcome to you on the Atacon National Seminar online platform. Thank you, sir.
Thank you so much. So, shall we
Yes,
start?
sir.
Sir,
Sir, before going to start, we would like to introduce our chairperson and co-chairperson, sir. Yes,
Sorry.
sir. Yes, sir. Next. Okay. So moving ahead, it is my great honor and privilege to introduce our esteemed chairperson, Dr. Sanjay Patil, sir. Sir is Medical Director, Dean and Principal of Matoshri Asrabai Darde Ayurved College, Yevla, Nashik. Sir has completed his BMS from Smritibai Shaha Ayurved Mahavidyalaya, Pune, followed by his postgraduate studies from RT Ayurved College, Akola. He is currently pursuing his PhD from Parul University, Vadodara. Sir has more than 13 years of rich teaching experience at both UG and PG level. He has made significant contribution to Ayurvedic education and research, with numerous research publications and authoring 9 books covering important areas of Ayurveda. Sir has been invited as a guest speaker at more than 12 academic platforms. Sir has been awarded prestigious honors including Maharashtra Sanman Award, Shiksha Ratna Awards and many other awards. His dedications to teaching, research, academic excellence and the advancement of Ayurveda is truly commendable. Sir, it's our privilege to have you with us as a chairperson for these sessions. We extend a very warm welcome to you and looking forward to your valuable guidance and insightful observation. Welcome, sir.
we are equally delighted to welcome our co-chairperson, Dr. Virendra K. Sir. Sir, BMS, MD, PhD in Samhita Siddhant. Sir is recently working as Principal, Professor and HOD in Samhita Siddhant Department in Govind Rao Banjari Ayurvedic College and Research Center, Maharashtra. He is a seasoned Ayurvedic healthcare profession with extensive experience in hospital administration and clinical.
Yes, sir.
With Ayurvedic gynecology practice and has valuable clinical experience in Salakya including ENT and ophthalmology. Sir has made valuable contributions to the field of Ayurvedic education, research, administration, and clinical practice. He has many research publications and 2 books to his credit, namely Diabetes Mellitus in Indian Medicine and Abhinav Madhumeh Vigyan. In recognition of his contributions, Sir has been honored with the prestigious Dhanvanti Samman. Under his leadership, Om Ayurvedic Medical College and Hospital also received first prize in the Desh Ka Prakriti Pariksha Initiative for its strike rate in Prakriti Parikshan Abhiyan. He has held several distinguished academic, administrative, and professional positions. He has served as chairperson for numerous academic seminars, conferences, and professional scientific events, contributing significantly to academic discussions and scholarly activities. Sir's remarkable journey as an academician, administrator, researcher, author, and clinician is truly inspiring and commendable. Sir, it is indeed a matter of great privilege to have you with us today. A very warm welcome to you, sir. Thank you, sir.
I also extend a warm welcome to our joint co-chairperson, Dr. Manoj Das, sir. Sir is Associate Professor and Head of the Department of Rasashastra and Vaishajya Kalpana at Government Ayurved College, Bilaspur, Chhattisgarh. Sir holds BMS from Sambalpur University, MD in Rasashastra and Vaishajya Kalpana from NII Jaipur, and PhD from Banaras Hindu University. He also has completed an industry program in Pharma Regulatory Affairs from Bioinformatics Institute of India, Noida. Sir is highly respected academician, researcher, and pharmaceutical exports with more than 15 years of distinguished teaching experience. He has guided countless undergraduates and postgraduate students, nurturing excellence in Ayurvedic education. Beyond academics, Dr. Manoj Das sir has made remarkable contribution to the Ayurvedic pharmaceutical industry and senior manager and product in charge. His consultancy role with the Patanjali Ayurved Limited and Biomedicare India Private Limited highlighted his expertise in regulatory affairs and clinical protocols for exports. His scholarly contributions are vast, with over 40 research papers published in Scopus Index and UGC approved journal, a book research methods in Ayurveda, and has contributed chapters in many international publications. Sir has been invited speaker at numerous national and international conferences and also shared some of them. His professional recognitions include honors from the Bioinformatics Institute of India and international recognitions from Natura Pharma Berlin, Germany. His presence as a co-chairperson at Atacon National Seminar is truly an honor, and his guidance will enrich and deliberations and inspire the Ayurveda fraternity. Welcome, Dr. Manoj Das, sir.
Thank you, ma'am. Thank you, sir, for joining us and enriching this session with your valuable presence. Once again, I extend a very warm welcome to our esteemed guest speakers, respected chairperson and both co-chairperson. And now, without taking any more time, I have the distinct pleasure of inviting our esteemed guest speaker, Dr. Pragyan Tripathi sir, to kindly conduct the session and enlighten us with his expert lecture on innovative single-dose therapeutics, bridging folk wisdom and Ayurvedic practice. Sir, we are eagerly looking forward to your valuable insight and enriching presentation. The virtual platform is yours. Over to you, sir. Dr. Pragyan Tripathi, sir.
Thank you so much, Atacon, for having me in this such a wonderful national and global platform. Actually, I call this particular topic as all of us are knowing that the topic is innovative single dose therapeutics, bridging folk wisdom and Ayurvedic practice. So, anybody sharing? Yeah. Okay. So, to start with this topic, I just want to say that I call the folk system of Ayurveda as the lost pages of Ayurveda because after completing my BAMS from STM College of Ayurveda, Udupi, and even during my studies, I got the opportunity to visit more than 250 folklore practitioners. Dr. Bairi was my lecturer for Dravyagun in SDM College of Ayurveda, Udupi. So we used to had a department of folklore. So since that time, I was really interested in folklore medicine, and I have explored many special treatments during my visits to the folklore practitioners. So we'll talk about some of them today. So my slide is getting or I have to share it. Yeah, Nagin sir.
Sir, if you're comfortable, you can share, sir.
No, means if you are sharing, then it's fine.
Okay, sir. I'll share, sir.
Okay. Yeah, fine. So this is the last slide. So,
Yes, sir.
so shall we start from the first one? This is the last slide of my presentation, actually.
Sir, slide is visible, sir?
Yeah, it is absolutely visible. Yeah. So next, we'll start with the first one. These are all the ustads which I got the opportunity to meet during my journey of folklore. Like Prime Minister Narendra Modi ji's presence is there. Yeah, this one only. And the second photo is Dr. Padma Shri, Dr. H.R. Nagendra sir, who came to my clinic to see how this one boy is doing some wonders with folklore stuff along with the studies of Ayurveda he did. So likewise, Dr. Virendra Hegde ji is there. Likewise, there are many people. Next, whom I happened to meet during the journey of folklore. See, now I directly start with some of the very special treatments which I have learned with folklore practitioners. See, most of the times when a patient comes to us with a complaint of vomiting, like the severe vomiting is there, continuous vomiting is there. Even if we are going to give a teaspoon of water, then also the vomiting is happening. In such a condition, what folklore practitioners are doing, this is a story of folklore practitioners of, Chhindwada, a place in Madhya Pradesh. What they are doing is they are taking the dal, the pulse, which is called as the tuar dal or the arahar dal, and they are taking 20 grams of it, and they are mixing it, just putting that dal in 50 ml of water and keeping it for 1 hour. Then they squeeze it, filter it, and ask the patient to drink it sip by sip. After drinking it, just 1 or 2 sips, the vomiting absolutely disappears. Acharyas have mentioned that you have to give anulomak dravyas and basti and this and that, everything. That all those things also we can definitely try. But this is very simple, simplest of all the formulations which I have brought here today. Next. The second one is for calculus, we are knowing that we have Pashan, Bedi, Gokshura, this and that, so many Hazrul Yahud, Bhasm, so many things are there. But a very simple preparation, what they are doing is, because when they grow papaya trees, if you have seen any papaya tree, then there are some extraterrestrial roots from always come out from the papaya that you have to cut, you have to collect, and just 6 grams of that root you have to boil with 50 grams of water, or you can just crush it and mix it with water and prepare like a sharbat kind of preparation and give it for 4 days. They are saying early morning empty stomach. And I have seen in my personal experience the renal calculus of the measurement of up till 10 millimeter, it disappears within a week. That much powerful these all these small formulations are. Next. Next. See, I really want to tell this that sometimes when we talk about folklores, it appears in such a way like, oh, these are all folklore things, and who knows whether these things are really working or not. So after going through all these formulations which are being practiced by the folklore practitioners since generations, when I came back home and I happened to open some of the Nigantus and some of the wonderful practice books like Chakradatta, then you will be very amazed to know that most of these formulations uh, are being written by Acharya Chakrapani and Chakradatta itself. Yeah. So these are some or the other way. Either you will get any like one of these formulations in Panchashat Mahakashaya or any or in various vargas which are mentioned by various acharyas, or if you are not finding it anywhere else, then definitely you will find it in the wonderful book of practice called Chakradatta. Same thing what they are doing with the cows in different ashrams of like I have visited some of the gurukulas in south, and what they do for, because there are many children studying there and they are falling ill, they are getting pratishay, jar, body pain, headache, weakness in the eyes, eye vision will be getting deteriorated because of getting up very early morning and reading for hours. So what they are doing is they are collecting the gomutra from a black deshi cow. Okay, Krishna gomutra they call it. They filter it properly and they just take 25 ml of it and put 1 gram of kesar. They squeeze the kesar in the Krishna gomutra for at least like 5 to 10 minutes. They don't make it hot, or you can just do mardan for a while and keep it in a bottle, and they have such a wonderful sequence they have made to give the medicine, Like up till the age of 1 year, they are giving 10 drops. For 2 years, 20 drops. 3 years, 30 drops. Like that, they are giving to the kids. And Anupan is very simple, like the Samjal or uh, Stanya or Godukta, you can give it. So like that, trying to they are trying to fix the medicines for small, very small kids uh, who are coming to Gurukula sometimes. Will be sometimes surprised ki I have written about 1 year, 2 year, and 3 years of children, the dosage. The likewise in the same pattern, the dosage will increase. The number of drops will be like multiplied by 10 for every single year the child is growing. Yeah. Same way what they are doing for Bal Apasmar, because many patients nowadays with Bal Apasmar kind of conditions, if they are going to doctors, they are sometimes comparing it with autism or sometimes with the milestone development so in such conditions, what very simply they are doing is they are taking Vijaya Mool, Punarnava Mool, Apamarg Mool, and they are collecting it on Sundays early morning, and they are just cutting them into pieces and tying it with a knot and just putting it around the neck of children. Okay, so either all these three or any one of these three we can use for Bal Apasmar cases. And the moment you tie this particular wood piece around the neck of a child, immediately after that you'll see that there is no apasmar stroke anymore felt in the body of the child. Yeah, even sometimes if sometimes it is happening, like sometimes after tying this also apasmar stroke is coming up. In such a condition, what they are doing is they are taking the yellow ripened leaves of shwetarka and they are taking the juice out of it and they are putting it in the nostrils, at least one drop in each nostril, and they are doing it for 3 to 7 days, and the apasmar is getting disappeared completely. Same thing is written by Acharya Chakrapani also in Chakradhar. So it is like it is all Chakrapani has written so many things, but when we actually see that formulation is getting practiced somewhere practically, then only we get the confidence to practice it personally. Yeah. So this is very important thing about folklore practice, that you happen to see so many different practices which are which are going around you and going around your city and going around in the forest areas of various outskirts of your cities in villages. And when we go there, they are when we go there with a surprise that what they are giving for paralysis, what they are giving for apasma or autism, like that. And it is very surprising to see that they are using such a common herbs which we even don't care during our practice after studying BAMS or MD. So it is very important to connect with them and take the knowledge which they are practicing and which we don't even care. So practical practically when you see something, then definitely you are very much confident to include that stuff in your practice also. Yeah, next. So this is a very wonderful thing, that Beauty and the Beast, the wonderful movie of Hollywood we all have seen, I think. So this is a very burning problem starting from John Abraham up till any big star you see on the screen. Many such stars are having the chicken pox marks on their faces. And for them, what they are doing in folklore practices, they are taking the Udumbar Patra, which are having creamy, the bubble kind of structure is there in the leaves. Such patras they are collecting and they are getting it dried up and they powder it and they ask the patient to apply it with simple water, because it is a folklore practice. Definitely, if you are practicing cosmetology, you can ask the patient to apply it with with kacha doodh or with gulab jal or with deshi gai ka ghee or with makhan or anything else, with honey maybe. But in folklores they try to keep the line very simple and very straight. So that is the best part, that we happen to learn the very simplicity of the practice also, and the complication we can make it more complicated by by using our brain, definitely. And same way they are asking the, because it is the outskirts of the, for very deep forest areas are there, so sometimes Javitri is very easily available. So they are asking the patients to apply Javitri with water. Ingudi Fal Majja with water also they are asking to apply at least for 3 days. This is very effective and very commonly used by folklore practitioners, because Ingudi is vastly available and nobody is picking it up, because we have made Punarnava, Ashwagandha, Kutki so globally famous that everybody wants it, and it is very expensive. It is getting expensive every day. But plants or trees like Ingudi, fruits like Ingudi fruits are hardly understood properly even today. And I have not seen any of the practitioners using Ingudi Falmajja for any of the conditions. But I should tell you that. I have seen some of the folklore practitioners who are treating external cancer patients. Yeah, external cancers like some breast cancer, some external opening is there. For such patients also, they are applying Ingudi Fal Majja oil. They are taking out the, they are preparing the oil out of Ingudi Fal and Ingudi Fal Majja, and they give it to the patient for external application. See if it is external, if it is the external cancer of mouth or neck, they are asking it to apply along with kali musli root. If the cancer is like breast cancer, then they ask it to be applied along with guduchi mool. And if the cancers are abdominal, of abdominal origin, then they ask the patient to apply it with jackfruit seed oil. Yes, like that they are practicing in a very variable pattern. Padari Fal Majja is very common, because all of us are eating the bear in the seasons, but we hardly care for the seeds, right? So we have to keep the seeds. So we have to keep the seeds of badri, whenever we are eating it, whenever we are getting the opportunity to eat it in summers especially, and you just have to powder it and mix it with honey and makhan, and you have to apply it. If you are doing it, then I have seen even the marks of the face, variable marks which are present in the faces of different people, like the brown discoloration or the blackish discoloration, or the uneven skin, which nowadays people really care a lot about. For all such patients, badri fal majja along with madhu and makhan external application is very effective. Next. So this is very important thing, because most of the times in every small and big occasions of folklore people, they used to prepare puris. Yeah, puri sabji, puri bhaji. So, or even sometimes they are preparing non-veg in open. Yeah, they are like some cooking some animal or something like that. For so they very oftenly, they or sometimes their children used to get burns. So they do not go to big hospitals for burns. What they do is they take sharkara 80 grams, lavan 10 grams, mix it with water 100 ml, and they mix it very well, and just they dip a cotton cloth and wrap around the burn and try to keep it wet with the solution. Yeah. And in another practice, I have seen that if somebody is getting burn from hot milk or hot chocolate, nowadays they are preparing it at home. Lots of people are doing it because of WhatsApp and YouTube cooking classes. So if you are getting burn out of it, then what they do is you have to, yeah, they take 1 liter of water and they just mixed 2 to 3 ratti of tuna in that, and they just shake it and keep it for 1 hour. And after that, they just collect supernatant water and they mixed some 2 to 3 spoons of honey in that, and they ask the patient to keep on dripping it. They ask the patient to do the parishake for out of it. And I have seen in many patients, like in 7 to 8, within 7 to 8 days, the burns are completely healed up, and within 10 to 15 days, even the marks of the burns get completely disappear. Yeah. So likewise, they are treating burns with very small and very simple and very general and easily available and very cheap formulations. Yes, I should tell that. Next. Yeah. So this is a very big problem nowadays, meniscal injuries and fractures, because either people are sitting with their mobile phones and screens, or they are getting immediately very aggressive on Sundays, that today I want to play cricket for throughout the day, or today I am going to play football, and I will beat everybody, and I'll go with maximum goals today. So in such cases, usually they get fractures, meniscal injuries, ligament and tendon injuries. So this is a very simple combination which they usually give for external application, which is Vijay Sar and Haridra. They are just mixing it with this 20 grams and 6 gram of quantity in on a bandage, or on a over a bark of a leaf, and they just ask the patient to apply it, tie it properly, and they ask to change it in every third day. And in our clinic also, when patients are coming with meniscal injuries, uh, in such cases, we are usually asking the patients for parishek, because as a Panchkarma owner of a Panchkarma center, we have to run that center also very properly and successfully. For that, what we are doing is we are doing the parishek prepared out of the same medicines, Vijay Sar and Haridra. We are doing parishek, and moreover, if the injury is like third degree, fourth degree, in such cases, we are adding Arjuna also. So when we do the parishek out of this combination for like say 10 to 15 days, then after that, if a patient is going for X-ray or MRI or CT scan, definitely the injury will be almost in most of the cases it is 100% healed up, or at least more than 50 to 60% it will be healed up within 10 to 15 days. This I have seen in my practice, and we are doing it almost every week for at least one or two patients. Next. See, this is a very common condition nowadays. Patients are coming with every patient who is coming to our clinic, almost everyone. If you are asking that, what about gastritis, acidity, indigestion, bloating, then the patient will say, yeah, some problem is there, doctor. I am not able to recognize whether it is gastritis or acidity or indigestion. And I have made it very common. The patient will say that I have made it a new trend for my life that I have to go to 2 to 3 times for defecation every morning. This is a new normal for me nowadays. That that kind of indigestion and metabolism disturbances are happening around us, and this is a new normal. This is getting new normalcy for our society, which is very bad, because still the Ayurveda practitioners are alive in between them. So we have to correct the metabolism of everybody. For that, what folklore practitioners are doing is like very simply is for the patients with extreme hyperacidity, where the patient feels that it is absolute GERD kind of condition, and lot of acid regurgitation is there. In all such patients, if you are really fed up of giving Avipattikar, Soothshekar, Kamduga, Shankvati, each and everything, Swarna Soothshekar also, Pitta Shekhar, whatever you know, the antacid medicine, Pantocid also, sometimes if patient is taking by himself. So for such patients, if you are giving dry fried jeera 1 teaspoon post meal, you just try to give for 3 days, and you see the magic of just a dry fried jeera immediately after the meal. Huh? It will lead to complete disappearance of Adhma, Natok, acute abdominal pain, all the gastritis, hyperacidity, and even constipation kind of conditions. I don't know how it is happening, but it is happening with almost all the patients very positively. Kadi patta, they are asking, just like Pantocid in the morning, they are asking the patients to chew at least 10 leaves of kadi patta or curry leaf in the morning, early morning, immediately when they get up. The patient should, you know, pluck, pluck 10 leaves of kadi patta and patient should chew it. Yeah. Out of Apamarga, they are doing Apamarga is like a magic herb for them. With Apamarga, the folklore practitioners are doing, I think, they are treating more than 100 disorders out of Apamarga. And here, what they do is they take Apamarg Patra powder, at least like 4 grams, and some Shank Basma 2 Ratti they are adding. And they are asking the patient to take it in the Saman Kala. So, this is very effective treatment. Same mantra chikitsa also they are doing. Yeah, if the patients comes with a bloating of abdomen, they are they are chanting a very simple mantra which is there in the last slide. So we'll discuss about it in the last slide. Next. So sometimes patients are coming to us with complete Agni Nasha. Yeah? If you are seeing the nadi of the patient, then you'll be able to identify that Pittaj nadi is not at all coming. Or even if Pittaj nadi is appearing, it is very low. You'll see the pulse is not hitting you up. The pulse is dropping from your fingers. That kind of nadi, if you are able to feel, then it is like Agni Nasha kind of condition. For that, Shuddha Prakashan, Shuddha Prakashan is a wonderful combination, very simple combination they are asking to practice. They are asking you to take chana, 21, that bhuna hua chana, you have to take 21 in number. You have to add 2 grams of shunthi, marish, pipali, which is trikatu, shwet, jeera, ajwain, sendho. Or you can take trifla and trikatu, 2 grams each. And you just have to add jeera, ajwain and sendho 2 grams. And you have to prepare kwath out of it, ask the patient to drink it, and ask the patient to lie down with a blanket, and 3 doses you have to give early morning for 3 consecutive days. And you will see that after taking it for once only, right from the very first day, you will see that Agni in the Nadi or the Pittaj Nadi has, started pulsating in a very powerful way. Or after third day, you will be able to recognize that all the, Saman Vayu related uh, Pittaj sthan is really getting very much positively stimulated. Even this is very effective treatment for gallstone patients also. Yeah, because this particular combination makes the pancreas also to stimulate, and the makes the gallbladder also to push more and more bile juice. That is how the pitta is going to increase in the abdomen, right? So this is a wonderful and very simple combination for Agni Nasha. This you have to do when you have really tried Chitrakadi, Agni Tundi, Chitrakaso, and whatever Agni Vardhak medicines you are having and you are knowing. After trying everything, if nothing is working, really working properly, then you should try this Agni Nasha formulation. That is how these formulations I have brought for you, because I happen to meet more than 250 folklore practitioners, and after meeting them, I have collected more than 2,500 formulations from them. And I have brought some very simple, very easy, and some or the other way where the Shastras are also having references, direct references of such formulations only I have brought today. Next. So this is a very complicated condition, which is alopecia. Nowadays, as people are getting very much concerned about their hairs and the hairline and all the hair growth, quality of hairs, color, this, that, everything. So alopecia is really getting very common nowadays. I don't know how. I don't know why. Maybe because Asti Dhatu is getting deteriorated. Nobody wants to drink milk because most of them are not getting proper milk only. Yeah, and if they are getting, then this is the festival season, and we all know that that food officer in the Maharashtra which is doing magic, and we all are very happy about him that he is doing such a wonderful job taking care of the food of at least the people of Maharashtra. And we need such officers in all our cities, definitely. So alopecia we were talking about. So what they are doing is they are taking Jaipal, they crush it, keep it overnight in water, and morning they fry it in til, sarshap or nariyal coconut oil, and also they add equal amount of brita to it, and they ask the patient to apply it at the area of alopecia, particularly if there is a small patch or maybe the big one, they can apply it, and within uh, 8 to 10 days there will be very tiny hair growth can be seen at the area of alopecia localis, alopecia in the local area of it. And if this is really getting very hectic, then what they do is they just take the pickle oil, which is the pickle oil of mango pickles, which is at least 1 year old, and they just collect the oil and ask the patient to apply at the area of alopecia. And I should really tell you that this pickle oil is more effective than any other classical formulation which you know about alopecia. So you must try it. At least if you are getting alopecia by default, then definitely you should try it with pickle oil first. Then you can go for leash therapy and all the Jaipal and everything. Yeah. Next. See, this is a very simple formulation which they practice for varicocele and hydrocele. Okay, what they do is they just take a brinjal and they just make it empty. With knife, very carefully they just clean inside, which is inside the brinjal, and they just take sarshap taila, and they just take haridra, and they apply this particular paste of haridra and sarshap taila inside the brinjal, and they ask the patient to wear it. If the patient is having varicocele or hydrocele, they make sure that particular part of the body of a patient goes inside the brinjal, and they just tie it with chain bandhan, or there are so many bandhanas which are mentioned which we have studied and thankfully passed in BMS, uh, because all those bandhanas were really very complicated, because I think very rarely they practically teach all those bandhanas. They are really very important to tie a particular thing in your body, and it should not fall down. Yeah, when we are doing leash therapy and all in some such parts of the body where it is very difficult to tie anything up, then definitely we do remember what Acharya Vagbhat has mentioned about so many bandhanas. So this is like brinjal we have to tie, because it is very difficult to tie something there. So we ask the patient to wear that guard supporter. Ask the patient to wear the supporter, which they usually wear during playing cricket and all, and keep it overnight. And morning you can open it up. And in most of the patients, I have seen that the hydrocele and varicocele gets disappear even just in one night only. See, if this brinjal thing is not getting, is not entering inside your brain, then definitely you can try it with one more very simple formulation, which is you have to collect the gomutra, gomutra of black cow, deshi kali गाय का गोमूत्र हमको लेना है, and you have to buy a langot or a supporter from the market, and you have to dip that langot or the supporter inside that deshi kali gai ka gomutra. Okay, that is very important, and you can wear that supporter or the langot for overnight. You just have to sleep after wearing that thing, and morning morning when the patient is getting up, and the patient will open the langot, then in most of the cases all the varicocele and hydrocele patients, you will see the magic in one night only. Yeah, this is one night stand for hydrocele and varicocele, I should say. Okay, next. Yeah, so this is jaundice. And very simply, when patients are coming, patients are going to folklore practitioners. In most of the cases, they are collecting one wild variety of shatavari. Even you can take this same shatavari also, which is available in the market and in our clinics also. So that shatavari you have to take and you have to prepare decoction out of it. And they ask the patient to drink the decoction. They ask the patient to take bathing out of that decoction, and they ask ask the patient to prepare a mala out of that shadavari mool and wear that mala also. So that kind of magic they are, they are able to identify out of shatavari in the patients of jaundice also and in the patients of typhoid also. Okay, so in both the conditions we can see uh, Shatavari in a different role, yeah, in folklore practice. Next. So this is all about apasmar, unmad, aptantrak, and prolapse also. So all of we are knowing this, that we are using Changiri Grit for prolapse cases where there is rectal prolapse or where there is uterine prolapse. We are asking the patient to put Shatavari Kalka, and we ask the patient to put it as a douche sometimes, or we do prepare ghee, grita and tela out of changeri, and we ask the patient to apply it. And in 10 to 15 days, I think all the prolapse gets disappear. Yeah. I, recently, there is a place in Ujjain which is called as Seva Dham, and almost 1,000 mentally retarded patients are there, and we have got a phone call from them that for almost 3 to 4 very small children there is very severe rectal prolapse, and we went there with Changeri Grit. That day, unfortunately, I did not had raw Grita in my clinic, so I just prepared Changeri Tail. I took Tilatail and I added Changeri Kalka into it. There was no time. We were in very hurry because they called us immediately, and we have to go somewhere that day. So we prepared oil not exactly how they asked to prepare classically. We just fried the changeri kalka in tilathail, and we took that oil there, and we asked the patients to apply it for 3 to 4 days. And after fourth day, we asked them to call us. And after 4 days, they called us and they said that uh, all the patients, for all the patients, all the prolapses completely disappeared. Huh? That wonderfully Changeri works, all of we are knowing. But this is very rare formulations which they use for apasmar, especially apasmar cases. They are taking Changeri leaves, half pow, means 125 grams, 125 oh, 125 grams, and they mix ghee in it, like 1 to 2 spoons, and a pinch of salt has been added, and they prepare sabji out of it, curry out of it, like changeri, changeri veg, mixed veg, changeri veg, like that. And they ask the patient to eat it with gehu ki roti, wheat roti, simple, very simple. And if the patient is taking it for 10 to 15 days, then you will see that how apasmar, unmad, aptantrak, such kind of very difficult mental disorders are getting completely disappeared within 2 to 3 weeks. So this is a very secret and sacred formulation. We must try it because it is easily available drug all around us, and we all are knowing it, and we all are practicing using Changeri in one or the other way, right? Next. So this is a this is a wonderful combination. There is a plant called as hulhul. Yeah. Anybody knows about hulhul? Or shall I identify the botanical name of it? I also forgot the botanical name of hulhul. Uh, yeah, exactly. Cleome viscosa. Cleome viscosa is the botanical name. And this is bulhul is a wonderful plant which they are using and which they are practicing for variable conditions, especially the condition of Ardit or Pakshaghat. They are saying that if the Ardit or Pakshaghat is very new, if a patient comes to you immediately after getting Pakshaghat, or maybe after 3 to 4 days of getting Pakshaghat, then you have to collect the swaras from hulul plant, and you have to ask the patient to drink it at least 2 to 3 spoons twice daily before food. And you can give the nasse also from the leaf swaras of hulul. And this is a wonderful drug which works for Visham Jwara patients also. Ardit, Pakshaghat, and Visham Jwara. All the three patients, all the three kinds of diseases, you can try hulul in new patients. Like Purva Rupa or the Rupa is just manifestation of Rupa is there, then you can try it. Yeah. For typhoid, we already next. Yeah, we already talked about it. Next. Yeah. So for the patients of anemia, menopausal syndrome, premenopausal, menopausal, postmenopausal, in such conditions, there is a very wonderful community secret from Sindhi community. Yeah. They are taking Deshi Gai ka doodh, adding shunthi, ghee and good. And they are asking the patient to take it every night. And you might have seen, especially in the Sindhi community or people from the northwest side, they are very, sometimes they are having very good height, and they are having very good physique. And even the ladies from their house who are like 60 plus, they are quite tall, the Kashmiri people and all. And they are very tall, very good looking, very strong. And they are living in the mountains, and they hardly get, the low back pain and knee pain and all such pains. How they manage it, even after the menopause, the condition of their bones, how they manage the osteoporosis kind of conditions, they are not getting it at all, because this is a very small, drink which they prepare every night, and they drink it. So we must ask our patients, along with all the Dashmula Rist and everything, whatever we give, Yograj, and all such calcium supplements which we are giving to the patients, or the Vathar Dravyas, we can ask the patient to take Deshi Gai ka doodh 1 glass, add 1/4 teaspoon of shunthi, at least 5 grams of ghee and 5 grams of gur to that drink, and take it at night. Next. See, most of the times when we meet the people who are like having, who have to speak a lot. Yeah, nowadays so many young leaders are coming up. We have seen in we have seen recently at Jantar Mantar, and even yesterday also there were people at Jantar Mantar. So nowadays so many young chaps are coming up as leaders and very good speakers. So for such patients, for such people who have to speak a lot, and they get their thought really, scratched from inside, for such young leaders, we have to cut the haritaki into small pieces, and we have to ask the patient to keep on chewing it, just like supari, saunf, or something else. Many people are asking me, why not you are asking the people to chew muleti, because muleti is very common drug, and whenever we are giving muleti to the patients, then people usually say, oh, this is muleti, we know this doctor, this is coming with just for 10 rupees, this much muleti they are giving, why we should buy it from you? So along with muleti, if we are asking our patients to take badi hari taki pieces to chew it, then definitely it is equally or sometimes more effective than Yashti Madhu also, for throat itching and throat irritation and throat ulcerative kind of conditions. Next, appendicitis. Now we'll be talking about some very acute, serious, and emergency conditions. Appendicitis patients will be calling you and telling that I have got the pain at the side of appendicitis, and it is very severe pain, doctor. And I have called my MD doctor, and he told me that you should get shifted to the emergency ward and you should get it operated. Yeah. In such a emergency condition, if a patient is calling us Ayurveda doctors, what we should do is, we whenever we get calls of such patients, we usually refer the patient to the same hospitals where where they will get, they'll get operated. So this is a very simple combination. We must keep these small medicines in our clinic all the time. Suranjan chhal, the moringa bark, we always should keep in our clinics. And you just have to prepare lepa out of the suranjan chhal, just like the chandan lepa. Or if it is not comfortable, then we can keep the powder of Suranjan chal. And if if you are able to find out fresh Suranjan chal, and if somehow you get the chance to apply the lepa of fresh Suranjan chal over the pain side of appendicitis, the appendicitis swelling and pain disappears within fraction of seconds. With that much confident, I have seen the patients of appendicitis. And excessive lashon intake, immediately when the pain starts, you have to ask the patient to start taking lashon. One lashon, the patient has to chew it, engulf it, then second lashon, then third lashon. Likewise, 5 to 10 lashons. If you are asking the patient to take it, uh, immediately when the pain starts, then you will see that within 5 to 10 minutes, the pain of the patient will also be reduced to almost 90%. And meanwhile, if you are able to find out Suranjan Chal fresh, and if you somehow apply the lepa of it, then the pain and inflammation, both the things will disappear. Early morning, if you are asking the patient to go for a sonography, then there won't be any complication coming at the side of appendix. So that much positively and confidently I am telling you this, because we are doing it at least for 1 or 2 patients every month. Yeah. Next. For Suptivat patients, if there is a numbness in any area of the any part of the body of a patient, might be some old injuries are there, somebody had hit the patient with a stick or something, and in that particular area there is complete numbness. Yeah. If even if you are picking a pen nib over that area, then also there's no pain getting felt by the patient. For such patients, what they are doing it, they are preparing lanka tel. They are taking tel taila 100 ml, and they are taking 2 to 3 red chilies, and they are preparing the tail pak out of it. And if you are asking the patient to apply it with gloves in their hand, don't apply it. If you are applying it, don't apply it with bare hands. Usually what we do it is we take a feather of any bird, and we put that feather in the lanka grit or lanka tail, and we apply it with that feather, so that there will be some nervine stimulation also. And lanka tail is getting absorbed within a minute or two. And after 10 to 15 minutes, if you'll prick in that particular numb area of the patient, then the patient will say that, no, now I am feeling something is happening there. At least 20 to 25% difference is there. Even if the numbness is persisting from more than 2 to 3 years, in such patients also, within 10 to 15 minutes, lanka tail is capable of getting the sensation back. That much powerful and fast acting it is. Next. For angina patients, these are all the photos which you are able to see is all the photos which we have, somehow we clicked during the visits of forests and various folklore journeys. So for angina patients where there is severe chest pain, patient comes to you, or sometimes if we are doing some panchkarma procedure inside our clinic, and immediately if patients start getting acute chest pain, then what we should do immediately is we take the Erenda Thaila and we like 1 to 2 teaspoon, 1 teaspoon, and we add Sandho Lavan to it, 1/4 teaspoon, and we just triturate it properly. And in hot condition only, we apply over the chest of the patient from upside down. So like that, if you are doing for 2 to 3 minutes, then all the angina pain disappears within 5 to 10 minutes. After that, you can refer the patient to some cardiologist, or if you want to, if you have some ECG machine and all, you can check it, or you can proceed. At least the pain will disappear within 5 to 10 minutes. That is the best part of these small, formulations. Next. For Punsavan, this one is uh, very simple and beautiful combination. This is my favorite. Palash Patra. You have to take 3 Palash Patra because already 3 are coming in one order. So you can take that one leaf, which is composed of 3 leaves, right? And fresh you have to take. You can crush it very small. When it is very small and very soft, that in that stage you have to take Palash Patra, and one leaf you have to take. Early morning you have to crush it, and patient can chew it, or you can prepare swaras out of it and ask the patient to take it right from the very first day of pregnancy. Yeah, first day of pregnancy is very difficult to identify. So whenever the patient comes to know, from that day you can start, and it can be continued for the complete pregnancy period. And even if the patient is having tendency of recurrent abortions, or frequent miscarriages are happening to the patient, or even if previous children, which are previous babies which are born, are having less weight, or their complexion is also not very good, then with this Palash Patra Prayog, all such things will be corrected. Yes, that is how it is. Next. For hernia, for hernia patients, usually we do refer, yeah, all the Ayurvedic doctors, most of the Ayurvedic doctors. But these are very small and simple things which they are doing for the patients of inguinal hernia and like that. They are telling that copper rings are to be worn on both the big toes of a patient, and karna chedan also they are doing at a particular site. And they used to take, because most of the folklore practitioners are taking bidi, they are having habit of smoking bidi. So they used to have the bundle of bidi, which is a very good paper, smooth paper is there. So, so what they do is they take the paper of that BD bundle, and in that paper they used to apply the kshir, which is collected from any of the Panchakshiri Vrakshas, and that particular paper they used to put or stick on the side of hernia, and likewise the hernia within few days gets completely sticked. So these are very simple and small and unbelievable and difficult to believe, at least difficult to believe and digest kind of formulations which they practice. Say there are many, but I am just telling you the my favorite ones. So same way they are next, same way as they are practicing for asthma or shwas or hikka, which we talk about. They are taking godugda and they prepare kheer out of it along with godugda and rice, and they keep, if 250 grams of kheer is there, they put 6 grams of Arjuna bark powder in that, and they put it in open overnight, especially on the night of Purnima. And and they ask the patient to eat it early morning, empty stomach. They are doing it for every Purnima, and within 2 to 3 Purnimas, the patient's asthma, shwas, hikka almost gets disappeared. Next. For psoriasis patients, whatever the medicine you are giving, you must add haldi, tulsi, and neem. that has to be taken at least 5 grams each. See, when we talk about folklore, they consider neem and tulsi as completely opposite property plant. Okay. If a patient, I have seen in a folklore clinic that a patient came after 1 year of continuously intake of 1 cup of neem patra juice every day morning, and the complete nervous system of that patient got completely diminished. Yeah, there was a ED to the patient, and the patient became completely blank. Brain was not working at all like that. It was the patient was looking completely blank. Okay, so I asked the folklore practitioner. He has taken the neem patra juice for 1 year. Early morning empty stomach for 1 year continuously. Now the nervous system is completely has gone completely down. How you are going to treat it? So he said the best antidote for neem is tulsi. So I'll ask the patient to take the same quantity of tulsi juice at least for 3 months, and he gave it to the patient, and after 3 months the nervous system which had gone completely down, the patient became so prompt, so active, and all the ED and everything, all the the nervine numbness was completely disappeared, got completely disappeared. So like that, if we are adding tulsi, neem, which are having contradictory properties, and haldi in between, then it is really going to help the autoimmune disorders like psoriasis to get reversed or to get immunomodulized in a very short period of time. That is how it is. Yeah. Next. For Mutra Avrodh, many times patients are calling us at night that, doctor, I have taken so many things, but still I am 65-year-old and my urine is getting completely obstructed today. You are treating with you are treating me for prostate with 100 medicines, all the Bangshil, Fortage, Gokshuradi, Punarnava, and all the Mutra Dravyas you are giving, Niri, this, that, everything. Still today, uh, this is night 1 a.m. and my urine is completely obstructed. What to do? So this is a very simple practice which they are doing in folklores. They are taking the Arati Kapoor, the Karpur. They are taking the Arati Karpur and they are asking the patient to go to the toilet, and they ask the patient to touch that Arati Kapoor exactly at the urinary opening. And if the patient is touching the Arati Karpur exactly at the opening point of the urinary system, within 3 to 4 seconds, the urine will be flushed out. That much simple and effective it is. No need to go to any urologist or any big hospital at night 1 a.m. Morning, you can ask the patient to go anywhere, or maybe the patient will be completely all right by the morning. Yeah. Next. So this is a wonderful cappuccino preparation which is there for Yakshma. Next, which is there for Yakshma, because many of the patients who are coming to us nowadays. Next, Dr. Sonia, can we put the next slide? Many of the patients are coming to us with a Yakshma kind of condition, right? They are really tired. They are telling that their children are really tired after the school, tuition, and everything. And we really need a very good and healthy drink to again to regain the energy immediately, so that we can work more, or my children can go for playing, or can go for music class, or can go for anything else, right? So for that, one cappuccino they are preparing out of cow's milk. They take godugdha 250 grams, they add mishri 50 gram to it, pipli 10 grams, and they just boil it with 250 grams of water. Sheer pak is done. Then they are adding 10 grams of gogrit, 20 grams of madhu, and they are doing exactly how we prepare filter coffee, or how we prepare the cappuccino coffee. They just what they just do the in churning for this for this particular preparation, and within 5 to 10 minutes a wonderful cappuccino kind of preparation is ready, and it is if a person is taking it regularly for 10 to 15 days, yakshma, even the yakshma kind of conditions where all the saptadhatu kshay is there, all the energy has gone down, then in such conditions also, there is very good energy boost up will be felt. Yeah. Next. So many times we are not getting proper madan phala in the market. So for such conditions, they are saying that dambuti, vasa leaf and marich, that can be taken together for inducing the woman, especially in the sadhyo woman cases, or else we can take the shwetarka twigs, fresh twigs, along with unopened flower, the kali, and added to the jaggery, and if that we are taking that, it induces sadhyo woman, at least 2 to 3 vegas will be there, and it will be a very good cleanup for the upper upper respiratory tract also and upper body also. Yeah. Next. So for hysteria, this is like not so common. Yeah. Definitely we should conclude now. So this is like for cancers also. Next, we can keep on moving the slides. Atisar bleeding also we can skip. We can see something for cancer. Yeah, or cancer also, because already they talked so much about cancer, so we can skip it. See, for infertility patients, next. For infertility patients or the hyperacidic patients, what they are giving is just Ambalaki churn and mishri. In most of the cases, wherever there is PCOD or ED, or or sometimes tubal blockage is there, for all such patients in folklore practice, most of the folklore practitioners are just giving uh, ripened amlaki, which is ripened in the tree itself and hand picked. Such amlaki they are collecting on the auspicious days, and they are powdering it, adding mishri to it, and they are asking both the couple. They are asking the couple to take it. Yeah. So like that, there are so many other things which we can talk about maybe some other day. So next, keep moving. So I think this is this is it. So last we'll conclude with one of the very important
Hello.
mantra, which is my favorite mantra, which is there.
Hello.
Yeah.
Hello, sir. Please tell about the diabetes of
Okay, sir.
medicine. Previous
Yeah,
slide, previous slide. Please take this slide.
sure, sir.
Yes. Okay.
Yeah. See, about diabetes, they are doing so many things. Especially what they do is they take the Arka Dugda and they take Godugda, and they are taking 1 teaspoon of Godugda and adding Arka Dugda one drop in that, and they are asking the patient to drink it early morning. Next day, they are this one they are doing in Vardhaman Kram. Up for 10 days, they are increasing the cow's milk also and Arka Dugda also 1 drop daily. They are increasing 1 drop daily, and second day 2 drops, third day 3 drops, like that, and after 10 days they are reducing it. So it is like exactly Vardhaman Shwetark Dugdha Prayog, we can call it. Yeah. So likewise, when they are doing it for 19 days, this Vardhaman Kram, the patients who are on insulin, uh, their insulin dosage will get minimized to the very minimum dosage of insulin. And if they are not on insulin, then this is very effective treatment to to start the pancreatic function. Yeah. Or to fix the genitourinary tract metabolism, which we consider in prameha. Yeah. And kupilu dip is another combination which they are giving. They are taking raw kupilu seeds and they are crushing it. They are adding it to 1 liter of water, and they are asking the patient to drink the supernatant water every day morning, half cup, and they ask the patient to fill the bottle again with the fresh water. So like that, they are doing at least for 90 days, because whenever whenever that sugar level is coming raised in the blood report, So for such conditions, we consider it as Vatash Prameya. Now it is not Kafaj, no more Pittach, now it is Vatash Prameya. And as all of we are knowing that Kupilu is one of the best Vatahar Dravya, and you cannot reverse a disease which has become really consistent or incurable without the Visha Prayog. For that reason also we have Visha Varga with us. Yeah. So if they are using Shweta Arka Dugda, they are using Kupilu, they are using Sitafal leaves. So like that, they are they are using so many other dravyas. What they consider is if the disease has come from sugar, which is the source of which is sugar cane, then then the solution is also lying in the sugar cane. So if the disease has come from sugar cane, then for the treatment they are giving the sugarcane root only as a treatment for diabetes. Like that they think, and like that they talk, and like that they treat. Thank you so much, Atacon, for this wonderful opportunity. God bless. Jai Ayurved, Jai Bharat.
Thank you very much, Dr. Pragyan Tripathi sir, for such an insightful and engaging lecture on folk practices. You are wonderful.
Sonia ma'am, please continue.
Thank you so much. Yes,
For
thank you
making
very
the
much,
session
Dr.
so
Pragyan
informative and
Tripathi
engaging.
sir, for such an insightful and engaging lecture on folk practice. Your wonderful presentation in real life experience made the topic very interesting and very easy to understand. We truly appreciated the knowledge, experience, and value with us. Thank you, sir, for your time and making the session so informative. Now I invite Dr. Virendra Shah sir to share his observation and comments on the session.
Namaskar. This innovative single dose therapy session was a nice session, but we are now in the global age. If we want to propagate any pharma preparation, either single dose or the multiple doses, it should be scientifically studied first. That pharmacodynamics, pharmacokinesis, any drug when we are using for any condition, it should be very keenly studied, and then only it should be propagated. Anyway, the Dr. Pragyan Tripathi has a effort to keep this matter, this subject before the learned peoples, and they will definitely think over it, and we will have this treasury of the folk medicine in our day-to-day practice of Ayurveda in future. That's the thing of this. This is the this may be the take-home message of this topic, and I'm thankful to the organizer for giving me this chance, and ATA, LN City College, and everyone who is directly, indirectly engaged in this conference. Thank you. Thank you very much. Over to Madam.
Thank you, sir. Thank you for your comment and observation on session. Now I invite Dr. Manoj Das sir to share his observation and comments on the session.
Thank you, ma'am. Actually, I first of all give a very good, excellent presentation by Dr. Pragya Tripathi sir. He has narrated a lot of things in different diseases. Actually, what I observed that actually these are very, very eager to know all the people. Actually, I also learn a lot of things from his presentation. He has described all the things in a simpler way. But I think actually many more things can be done in this topic. What I actually, if you see our Charak Sahita, that is, there are say 9 Chatuska they have described, 7 Chatuska they have described. If you narrated all the things in this Chatuska, for example, if you think that this is a single dose for, and what are the folk medicine you can interpret in single dose for? That is the Yojana Chatuska, the 4 chapters of Yojana Chatuska. And another thing is Kalpana Chatuska. And also the first 4 chapters is Bhesa Chatuska. If you see all these things in these 3 Chatuska, that is Dirghan Jiviti Adhyaya, Apamark Tanduli Adhyaya, and this Arogya Adhyaya, all the things are described there also. And in Chakradatta also, he has also narrated all the things in Chakradatta. But from my point of view, I think that whether these conditions are in this Vikara Avastha or in Roga Avastha or in Vyadhi Avastha. If you think that all these things actually, whenever there is a disease in a Koshtha or disease in a Sakha, that is all the dhatus are there, or in Marmasthisa, in Marma, or any Asthi, or in Anubandhit dhatu. If these folk medicines or in these medicines be effective, it's a great for all of us. So I congratulate Dr. Pragyan Tripathi sir for his speech. And also I also recommended the scientific person, those are present here. They should go for the research also, whether it is effective in any avastha of a disease, whether it is Vyadhi avastha, in his Roga avastha, in Bekar avastha. Then it will be helpful for all the doctors, all the Vaidyas, those are practicing Ayurveda. So very short of time, but I congratulate all the persons those are present here, and also specifically this Pragyan Tripathi sir. Also, I am very much thankful to Dr. Sonia ma'am and other Nagendra sir for inviting me to say something on this topic. Thank you, sir. Thank you for giving some opportunity to me.
Thank you, sir, for your comments and observation of the session. Now I invite Dr. Sanjay Patil, sir, for his concluding remarks on this session. Over to you, sir.
Thank you, madam. Good afternoon to all. Respected dignitaries, esteemed guests, fellow scholars, PG scholars, UG scholars, and faculties, and all dear participants. It is my privilege to deliver the concluding remarks for this very interesting scientific session on the topic innovative single dose therapeutics, bridging folk wisdom and Ayurvedic practices, presented by Dr. Pragyan Tripathi sir. The presentation has beautifully highlighted important aspects of healthcare, value of traditional knowledge, and its potential role in modern therapeutic practices. Folk medicine represents practical experiences and observations of the generations, while Ayurveda provides a well-established scientific philosophical framework for understanding health, disease, and treatment. The concept of single dose therapeutics is particularly relevant in present era, while the simplicity of patient compliance, safety, affordability, and effectiveness are highly important. The folk medicine we are accepting after only the scientific validation, standardization, quality control, safety assessment, and clinical evaluation. When we got this folk medicine scientifically proven and in all parameters and make evidence-based medicine, then research community, research society will accept it. So in this folk medicine, we need to standardize, we need to evaluate chemical composition, mode of action of drugs. We need to try to research RCT designs on it for each and every formulation in each and every disease. So then it will definitely bridges the gap between folk medicine and Ayurveda practices. So I hope this session will inspire researchers, teachers, and students to document valuable traditional practices and converting promising observations into evidence-based therapeutic approaches. So Dr. Pragyan Tripathi sir told various formulations for various diseases. It can be helpful, it can be tried, it can be assessed, or each and every formulations told by the Dr. Pragyan Tripathi sir will be the next research topics for our PG students with proper references in Sanhitas, with finding proper references in Sanhitas. So I appreciate the presentation of Dr. Pragyan Tripathi sir on the behalf of everyone present in this Atacon seminar 2026. So I also thankful to organizers of this Atacon seminar, and with this I conclude the session with the hope that our traditional knowledge will continue to inspire innovative research and meaningful healthcare solutions. At present day, there is no prominent solution for the diabetes or prameha. So we can try these formulations and do research and can success in future. So lastly, I once again thankful to Dr. Pragyan Tripathi sir for a very nice presentation and bridging the gap, research gap between the folk medicine and Ayurveda practices. Thank you. Thank you all. Over to. Thank you, sir.
Thank you.
Thank you, sir, for your insightful concluding remarks and valuable expert commentary, which added great depth and perspective to the session. We sincerely appreciate your time and guidance. Now it's time to vote of thanks. आदरणीय अध्यक्ष महोदय, मंचासीन सभी सम्मानीय अतिथिगण, वरिष्ठ चिकित्सकगण एवं उपस्थित सभी साथियों, आज के एटाकॉन सेमिनार के इस महत्वपूर्ण एवं ज्ञानवर्धक सत्र के समापन पर वोट ऑफ थैंक्स प्रस्तुत करना मेरे लिए सौभाग्य की बात है। सर्वप्रथम मैं हमारे प्रथम वक्ता एवं आज के सत्र के सम्मानीय वक्ता डॉक्टर प्रज्ञान त्रिपाठी सर का हृदय से आभार व्यक्त करता हूं। आपने अपने बहुमूल्य समय में से समय निकालकर अपने ज्ञान, अनुभव एवं महत्वपूर्ण विचारों से हम सभी को लाभान्वित किया। आपके उत्कृष्ट व्याख्यान के लिए हम आपके अत्यंत आभारी हैं। धन्यवाद सर। इसके पश्चात मैं हमारे चेयरपर्सन डॉक्टर संजय पाटिल सर का हार्दिक धन्यवाद करना चाहूंगा। आपके कुशल मार्गदर्शन एवं गरिमा ने इस सत्र को और भी अधिक सार्थक बनाया। थैंक यू सर। मैं हमारे को चेयरपर्सन डॉक्टर वीरेंद्र शाह सर का भी हृदय से आभार व्यक्त करता हूं। आपके सहयोग, मार्गदर्शन एवं उत्साहवर्धन के लिए हम सभी आपके आभारी रहेंगे। इस क्रम के हमारे को चेयरपर्सन डॉक्टर मनोज दास सर का विशेष धन्यवाद, जिन्होंने अपनी महत्वपूर्ण उपस्थिति एवं सहयोग से इस सत्र की गरिमा बढ़ाई। इसके बाद मैं एटाकॉन ऑनलाइन सेशन के इंचार्ज डॉक्टर जयश्री ताड़े मैम एवं अजीत वाहने सर का हार्दिक धन्यवाद करता हूं, जिनके अथक प्रयासों से यह कार्यक्रम सफलतापूर्वक। अंत में एटाकॉन की पूरी आयोजन टीम, सभी सहयोगी को एवं तकनीकी टीम का हार्दिक धन्यवाद करता हूं और अपनी सहयोगी कोऑर्डिनेटर डॉक्टर सोनिया राहत मैम का भी हार्दिक धन्यवाद करता हूं। थैंक यू टू ऑल। थैंक यू सर।
Thank you, sir. Thank you, sir.
अजीत सर, ओवर टू यू सर। डॉक्टर
Yes, sir. I'm here. So thank you all the
Thank you, ma'am.
respected speaker, co-chairpersons for this third session, for your valuable presence and valuable remarks. And thank you, the Dr. Sonia ma'am, Dr. Nagendra Thakre sir. Your flawless coordination, efforts, and timely supports make this third section successful. So thank you once again. Now moving ahead to our fourth session, that is 2 p.m. We are 30 minutes running late, but we will start our session soon. So for this session, I welcome Dr. Deepika Survase ma'am and Dr. Adil Khan sir. Both are you there?
Yes, sir. Yes, ma'am.
Yes, ma'am. Good afternoon.
Yes,
Yes,
good
good
afternoon,
afternoon to
ma'am.
both of you.
Can we start the session, ma'am?
So for this
Yes, madam,
session,
please
I
start.
firstly welcome Dr. Deepika Survase ma'am. Ma'am is Associate Professor, Department of Kaya Chikitsa, Parul Institute of Ayurveda, Gujarat. Our next joint session coordinator for this session is Dr. Adil Khan. Sir is Associate Professor, Department of Shalyatantra, LN Ayurved College and Hospital, Bhopal, Madhya Pradesh. I welcome both you and request to continue with the session. Thank you.
Thank you.
Yes, thank you, Jayashree ma'am, and thank you, Ajit sir. So it's an honor to introduce our today's guest speaker, that is Dr. Bhavna Prashar ma'am, Chief Scientist. Yes. So my slide is visible?
Yes, ma'am.
Yes, yes. It's my honor. Good afternoon, everyone. Myself, Dr. Deepika
One
Survase. It
request
is
to
my
ma'am.
honor to introduce our guest speaker, Dr. Bhavna Prashar ma'am, Chief Scientist and Principal Investigator at Ayush Center of Excellence at CSIR, Institute of Genomics and Integrative Biology in Delhi. Ma'am
Deepika
has
ma'am.
pioneered. Yes.
Can you make the slideshow, please?
Ma'am, Bhavna Prashar ma'am has pioneered the groundbreaking field of Ayurgenomics, which integrate the ancient wisdom of Ayurveda with modern genomics, molecular biology, and conceptual method. Her research has established modern biology and genetic correlation of core Ayurveda principles like Tridosha and Prakriti, helping build the scientific framework and personalized and predictive medicine. Ma'am has more than 20 original article paper published in a top of international journals. Ma'am has also honored with the prestigious National Dhanvantari Award in 2025 by Ministry of Ayush. Ma'am has also several among distinguished nationals honor. So please join ma'am. Have a warm welcome from a family of Atacon. Now I request Dr. Adil sir to introduce chairman and co-chairperson of this session. Thank you. Over to you, Adil sir.
Thank you, ma'am. Thank you, Dr. Deepika, ma'am. May I audible to all?
Yes, sir, you're audible and kindly make the slideshow and your video on.
I hope the slide is also visible to all.
Yes, it is visible.
Distinguished dignitaries and all the participants, a very good afternoon and warm welcome to this session. It is my distinct honor and great pleasure to introduce the esteemed chairperson of this session, Dr. Namrata Joshi ma'am. She is Professor and HOD of Rashastra and Bhashaj Kalpana, Faculty of Ayurveda, Institute of Medical Science, BHU. With over 21 years of distinguished experience in Ayurvedic teaching, research, and academic administration, she has made remarkable contribution to the field of Ayurveda research, drug development, and research methodology. Dr. Joshi ma'am is the recipient of prestigious Best Thesis Award from the National Institute of Ayurveda, Jaipur. She has authored many books and book chapters to international publications, published over 16 index research articles, and guided numerous MD and PhD scholars. She has also been actively involved in Ministry of Ayush sponsored research projects, including COVID-19 initiatives, and served as Swayam faculty member for courses on Ayurveda, drug development, biostatistics, and research methodology. We are truly honored to have Dr. Namrata Joshi ma'am with us today. Please join me in warmly welcoming our chairperson, Professor Dr. Namrata Joshi ma'am. It is my great privilege to introduce our co-chairperson for this session, Dr. Sarita Sunil Butra ma'am. Dr. Sarita ma'am is the Principal Professor and HOD of Sharir Kriya at G.J. Patel Institute of Ayurveda Studies and Research, Anand, Gujarat, with over 33 years of distinguished experience in Ayurvedic education, research, and academic leadership. She is an accomplished researcher, PhD guide, and resource person at numerous national and international academic forums. Her contributions have been recognized with several prestigious honors, including the Best PhD Thesis Award, Best Research Paper Award, and the Women Excellency Award for Ayurvedic Professionals. We are honored to have such an eminent academician and inspiring leader as the co-chairperson of today's program.
Please join me in warmly welcoming Dr. Sarita S. Bhutra ma'am. It is also my privilege to introduce our respected Joint Co-Chairperson, Dr. Sandeep Binokar sir. Dr. Binokar sir is currently serving as Associate Professor and Head of the Department of Agatantra and Vyavhar Ayurveda at Government Ayurveda College, Nanded, Maharashtra. With more than 19 years of experience in teaching and research, he has made significant contributions to the field of Ayurvedic toxicology and medical education. He has been honored with 12 national awards, including the prestigious Kerala Ayurveda Research Award and the Best Teacher National Award. He has authored 9 books, published over 70 research articles in reputed international journals. We are privileged to have such a distinguished academician and researcher as the co-chairperson of Atacon. Please join me in warmly welcoming Dr. Sandeep V. Binokar sir. It is now my great pleasure to invite our esteemed speaker, Professor Dr. Bhavna Parashar ma'am, to deliver today's keynote address. Ma'am, we are grateful for your presence and eagerly look forward to learning from your expertise. Ma'am, the virtual platform is now yours. Over to you, ma'am.
Thank you for the kind introduction, and I also thank Dr. Srivastav and his team, Dr. Deepika, for inviting me and constantly, pursuing for joining in time and all. So I look forward to this session. Maybe we are slightly late, so we will have to, maybe a few slides I will cut down for benefit of other speakers also, because everything will get delayed otherwise. So can I share the screen now? Yeah.
Yes, yes.
Yeah, it's visible, right?
Yes, ma'am, it is
Yes,
visible.
ma'am.
Great. Yeah. Yeah, so today I was asked to talk on the innovative aspects of Ayurveda and how innovative research has gone into it to understand the fundamental principles. So Ayurgenomics is one area where we have worked since last 20 years to understand the molecular aspects of Ayurvedic fundamentals like Vat, Pitta, Kapha, and Prakriti. So I'll be talking on those aspects, our initial findings. So as we all know, we are blessed with the Ayurveda, which is not just bits and bits of knowledge here and there, but it's a 3-sutra Ayurveda, which is a complete framework. It's a framework with a connection between Hetu, Linga, Aushadha, external Hetu, internal Hetu, how this clinic to basic biology, understanding everything breaking down into Vat, Pitta, and Kapha. Even the medicines are in terms of Vat, Pitta, and Kapha. Features are in terms of Vat, Pitta, and Kapha. And Hetu are also described in terms of Vat, Pitta, and Kapha. So there's a common language through which we have been given this translational framework, which is very much needed and being aspired for even in the modern medicine. So as we all know, they have said that Hetuling Aushadha Jnanam, Swastha and Atur Parayanam. So when they say that Swastha, which means they are talking about an individual-centric approach, and Atur means individual-centric approach in even treatment. So for that, it has also given the understanding of Swasthya in a very, very elaborate manner. Unlike the modern definition of health, which is just physical, mental, social well-being and not merely the absence of disease. Whereas in our Samhitas, well-being has been described in terms of what would you call a physical well-being. Like not only first thing is absence of disease, signs and symptoms of disease, but it also describes how a healthy person would look like or feel like: voice, complexion, build, nourishment, strength, immunity. All these things have been described in Charak Samhita, Viman Sthan as Dhatu Samya Lakshana. Even hunger, taste, digestion, proper sleep, undisturbed and sound sleep, proper excretion of all waste, mental and social, spiritual well-being has also been described. Absence of any kind of perversions of mind, intellect, and sensory cognitive ability. So this tells that it is the swasthya in itself was also so well described, and this is a clinical parameters of swasthya that are described in Charaka, whereas we have also been given the biological system level, what functioning should go well to be able to enjoy health, which is in terms of samadosha, samadhatu, samagni, malakriya. All that if happens internally, biological systems function in harmony, then you will enjoy this prasanna atma, indriya, and mana. So it is not just described in terms of what is externally looking healthy, but what will go into biology to make that thing happen has also been described. And all of this has been described in terms of dosha, dhatu, mal, and agni and all. So, but there is no hard and fast parameter as to only if you sleep for 8 hours or only if you are able to digest this much amount of food. No, there is a variability also incorporated into it, that different prakriti or different dosha proportion individuals, same thing, build, nourishment, voice, complexion, appetite, whatever is described for health, the variability in it is also described for prakriti. So, and all of that is considered normal. So we are not only blessed with the understanding of health in depth, but also accommodation of all variability, which will also account for health. And that variability will not only look like different health parameters, but that variability is also linked to how we are going to respond to different kinds of environments. How are we respond to sensitivity to triggers? How are we going to be susceptible to certain disease conditions? How will we respond to medicines and drugs and even the diet? So this variability is not just variability for the sake of classifying somebody as Vat, Pitta, or Kapha, but this has been linked to how preventive medicine will be prescribed, how therapeutic medicines will be prescribed, how they will be warned against certain environmental triggers. So this is a very complete description about health, variability, and its implication in future health. So as you can see, Tridosha has a common organizing principle. External factors, whatever may be they will ultimately affect dosha, and this dosh dhatu mal agni vyapar will ultimately create what are the features of health, what are the features of disease. And looking at that, you break it down into Vat, Pitta, and Kapha, and accordingly select the therapies. So this is a full translational framework that we are blessed with. Now, in case of modern medicine, people are also trying to understand health to disease transition, and they are also bothered by the associated variability in it. It's not that everybody will get the same disease if they are exposed to the same kind of environmental trigger. So they are also concerned about variability and what is the factor which determines that variability, and whether we can predict a priori as to who will get what disease, who will progress to the next stage faster, and who will respond to the given treatment in a beneficial way, or who will respond in an adverse way. So these are the questions, burning questions, even in the modern medicine right now. And we are talking about Ayurveda, describing all of it based on Prakriti as well as an individual's bala. So can we asked a question whether we can have a clubbing of these two systems and make some framework which will allow us to explore this Vat, Pitta, and Kapha in the molecular language or a genomic language. At the same time, will it provide a novel ways to identify predictive markers associated with this variability? As we all know, Prakriti in Ayurveda has been described in several contexts, such as in the predictive medicine, who will respond to what, who will get more of a, what kind of disease. So all the Nanatmaj Vyadhis have been described, which they tell that if somebody is of that Prakriti, they will end up having that kind of a disease more frequently. They're also talking about Prakriti in looking at, in prescribing the lifestyle and nutrition in a personalized manner. Prakriti has also been described to be the integral part of patient examination in Dashvid Pariksha. Okay, so it is very much relevant in all P5 medicine components that are described in modern medicine. So why is it so much important? Question is that because Prakriti is actually patterned right from the time of development. As per Ayurveda, they say there is Shukra Shonit Prakriti, there is Kal Garbhashay Prakriti. So basic Shukra Shonit Prakriti forms the major template for Vatpit Kapha proportions. And on that, during the development, whatever experiences are there for, or exposures of diet, lifestyle, stress are experienced, those will also affect those three dosha. And final patterns are kind of, hardwired for an individual. And these hardwired patterns remain invariant throughout the lifetime. and they give rise to different clinical presentation of health in terms of different phenotypic attributes, its responsiveness to environment, disease susceptibility. Why? Because it is these three doshas only which fluctuate during the day-night cycles, during the seasonal cycles. So depending on what is your baseline constitution or baseline proportion, these responses will also be varying. Here, for one example, I can tell that if somebody is of Vat Prakriti and is of also in the old age, they will have more Vat-like perturbations. Similarly, if somebody is of Vat Prakriti, in the monsoon season, normally Vat has been told to be increased. So in monsoon, they have all the more propensity for increase of Vat. So this determines their responsiveness to environment, season, age, external environment, internal environment. And that's why it is so much important in Ayurveda for both predictive medicine, personalized medicine, preventive medicine, as well as personalized therapeutic medicine. Why, again, coming back to Tridosha, when we are saying that they are starting right from the time of fertilization, even in Shukra and Shonit, which means that every individual cellular level also, they have a presence. So, for example, in cellular level, Vat is high or Pith is high or Kapha is high. That will also determine how it will translate into metabolomics, proteomics, interactome. So at every level we find, now this level is more familiar to Ayurvedic audience perhaps, that we have been told that different organ systems are also having a dominance of certain dosha owing to their particular functions that they have to perform. So, and also doshas have been described to be residing in certain tissues and certain dhatus and certain organs more dominantly. And that means that even if somebody is of Vat Prakriti, or Pith Prakriti or Kapha Prakriti, their Prakriti will have the same Vat, Pith and Kapha, but on different organ systems, their impact would be different. For example, in lower gut, Vata is said to be residing in lower gut. So Vat Prakriti might have more presence of Vat in lower gut, and therefore manifestations related to that will appear more in their Prakriti. Similarly, in adipose tissue, we know Kapha is resident in adipose tissue. Somebody is of Kapha Prakriti, their adipose tissue will have even more Kapha, and they have more chances of gaining weight or something like that. Likewise, liver is more dominant of Pitta. So, Pitta Prakriti individuals will have more presence of Pitta functions expressing in terms of digestion, metabolism and all. So this tells that Ayurveda has talked about cumulatively overall effect of Vat Pitta Kapha dominance in overall organ systems, and that gives rise to different types of clinical presentations even amongst the healthy individuals. Because Vat has certain functions like signaling, movement, transport. Pitta has energy metabolism, digestion, conversion and assimilation of nutrients. Kapha has more of a growth, maintenance of structures, storage and building up of structures. So these features will be overtly functioning in the respective Prakriti people, giving rise to different kinds of inter-individual variability in health parameters. So like if you have more of a Pitta, skin of Pitta individuals might experience more pigmentation, melanin, or body temperature. Likewise, people of Kapha Prakriti might experience more of a heavy body build, or they have a more of a fat accumulation like that. So because this is all linked with the internal biological systems functioning, it has more importance in understanding disease variability as well as variability in response to environment and drugs. So, and it is not that it has been once made, it is made for the entire functioning, even subsequent to the birth. Everything is actually determined by patterns of Prakriti. As you can see here, they are saying about the replenishment of body tissues with the nutrients. What they are saying is dhatavo hi dhatu ahara prakritim anuvartante. They will always follow the baseline patterns. Even if you are eating different, same kind of food, everybody would not assimilate it in similar way. Likewise, they're also talking about Desh, Kal, Ok, Satmya, etc. also play a role in identifying how the Shonit is being made. So in a way, giving these two examples, they have told that these patterns are quite hardwired, and they are to an extent influenced by external environment as well as geoclimatic condition, and that determines the overall health continuity as well. Now, so much so that they have said that even different Prakriti people, Vatadi Prakriti Nam, Vishuddha Rakta, even if it is a blood which is Vishuddha, but Nana Varnata is because of the different Prakriti. Like example, like prolonged bleeding time because of Kapha, prolonged bleeding time because of Pitta, thick blood in Kapha. Those kind of examples tell us that there is a lot of pattern attached to dosha, and that is all driving the entire physiology and also prediction of the diseases. And this has therefore been integral part of the clinical examination that involves both Prakriti examination and Vikriti examination. So it is not only for the health maintenance and preventive therapy, even while designing or devising the treatment for an individual, one is advised to look at the Prakrutavastha of that person's Swara, Gandha, Sparsha, Varna, and identify how much is the deviation and accordingly plan the treatment. So now that means that Prakriti is coming out of proportions of three dosha, and these three doshas are conducting the entire physiology. So if I want to understand the molecular or genomic basis of three dosha, I may Prakriti is a very open kind of a model for us to identify people of extreme Prakriti and look at their molecular profiles. What are the molecular, how do we identify Prakriti? By their structure, function, activity, response to environment, and all those things. But how do we look at the genomic profile? There are multi-omic signatures to be identified at the genetic level, at the RNA level, at the protein level, at the epigenetic level, and at the metabolomic level. And now a new thing which is coming up is a gut microbiome or a microbiome level. Gut is a major part of it. So what we, so just because I am not aware of the overall, I was not aware of the overall audience. I thought maybe students would also be there. So therefore, I kept some few slides related to what is gene, genome, and chromosome, and what is RNA, difference between DNA, RNA, protein, metabolites. So as we all know, in the cell, we have a nucleus, and in the nucleus, there are chromosomes, and chromosomes harbor genes, and the genes have these sections called promoter, where the initiation of transcription and all starts, and this is a part of gene. And gene also has components like intron, exon. Okay, so this is the chromosome. Chromosome also has protein called chromatin and histones, and around which this double helical DNA is bound. Now, when we say DNA analysis, we are actually looking at this alone. When we say epigenetic analysis, we are looking at the histones and acetones bound to this DNA. So that will enable whether the DNA is available for transcription or is silent. Like, so now this DNA, as we all know, it is having sugar, phosphate, but each of these bases are called as ATGC, adenine, thymine, guanine, and cytosine. And this is forming the basic, the double helical, the code of DNA. Now, in this chromosome, there are several non-genic regions also, which do not code for protein, but they have other functions. But the gene is a segment of DNA that contains instructions necessary to produce a functional product like protein, but sometimes even the regulatory RNA molecules. These are the fundamental units of heredity, and they are transmitted from parents to offsprings, entire chromosome, but these genes will actually perform the function of transcription and translation. So DNA has to replicate also. If cell division has to happen, it has to multiply and make a 2 copies, so that each cell division, after cell division, each one gets 1 copy. But during the functioning of the cell, DNA has to transcribe into RNA, and that RNA is read by ribosome to produce the protein. Okay, so this is the called a central dogma: DNA to RNA, RNA to protein, and these proteins are the workhorses of the cell. What do they do? So this is how it happens in the promoter. Some transcription factor binds, it will start encoding, RNA coding sequences are transcribed, and these RNA coding sequences are into pre-RNA. So the exon, intron, everything is there. But at the end, these introns are spliced out and only protein coding region remains, and that will then become a will be read by ribosome, as I said, and will be made into protein. So all these all these genes actually are written as a script for performing different cellular functions to produce those proteins, which will do these functions of building, maintaining, responding to environment, reproducing, and so on. So now if I were to say that I want to look at the molecular correlate of Vat, Pitta and Kapha in terms of DNA at RNA and protein level, what do I need to do? How do I proceed? So for us, it's more of a clinical work. We look at the human population, stratify them into Prakriti groups, and these Prakriti groups can be then looked for genetic variations by looking at their peripheral blood, and from the blood, cells are isolated, and those cells are then treated in a way that DNA comes out of them or RNA comes out of them, and at different levels, we can look at the RNA DNA, we can look at the protein level, then we can look at the physiological differences. So this is how one can actually understand when we say Vatpit Kapha are doing all these things, what functions in molecular sense they are doing. Moreover, when we say there is a variability in them in different Prakriti individuals, what molecular changes are observed between them, and whether those molecular changes are just random changes or they have some value in terms of how a person will respond to environment, how a person will have a susceptibility to disease, and so on. So for that, our armamentarium is how do we analyze Prakriti? To identify people of different Prakriti, we need to have a questionnaire pro forma. This questionnaire is developed on the basis of Prakriti features and assessment method. So this was the hypothesis whether there is any molecular correlate to Vat, Pitta and Kapha, and if so, how do we proceed? So first step was we identify Prakriti features from Samhita, arrange them in a mutually opposite guna manner. So Ruksha is there, it will give rise to Ruksha, Pachita, Alpa, Shariraha. But if there is a Sarata and Sandrata or Snigdhata, it will have Sara, Samhata, Sthira, Sharir, Snigdhanga. So we have all kinds of mutually opposite or similar gunas, and those have been converted into this kind of a questionnaire where from top to bottom you analyze, examine a person clinically and note down each feature separately. So now, having done that Prakriti stratification, so we, because our Prakriti concept is also talking about Deshanupatini, Kalanupatini, Vayonupatini. So these factors would influence the manifestation of Prakriti features. So to avoid all other factors influencing Prakriti, we had to keep a homogeneous geoclimatic condition. For example, when we do for West India, South India, East India, we compare amongst them rather than mixing each other. So first study that I will describe today is of the Delhi NCR region. Same geoclimatic conditions, same homogeneous genetic background people. They were analyzed for Prakriti following all ICMR biomedical research guidelines, taking informed consent, and then moving on to doing the Prakriti analysis. So when we did Prakriti analysis, we found all 7 types of Prakritis, Vat, Pit, Kapha, and all that. But since we wanted to see the effect or the difference between what is the molecular level difference between Vat, Pitta and Kapha, we had to take people who were at the end of the spectra, Vat or Kapha or Pitta, so that we can clearly delineate the differences underlying them. So we took these circled individuals, and that too because Vayonupatini is also there. So not only geographical condition, we also took very small window of 18 to 35, 40 years of people, so that no age-related changes would also influence the analysis of Prakriti. So this is a very important research methodology point. You compare apples versus apples and not apples and oranges. Otherwise, you will find differences and cannot attribute them to dosha Prakriti. So what we saw when we analyzed this, we identified these people of extreme prakriti. We took their peripheral blood through after doing all that informed consent and everything properly, and then separating serum, plasma, CBC, ESR, and then also some cells for isolation of DNA and from the nucleus, and from isolation of RNA from the nucleus. All that has been done, and then we analyzed for all the biochemical parameters that we are generally used to see in clinical diagnostics. And whether these parameters, we all know there is a normal range, disease range, right side or left side, and there is a normal range. But whether in the normal range, different, even if the people are healthy, they may vary with each other, and whether that is the case is what we asked. We did find differences with respect to hematocrit values, packed cell volume, RBC, hemoglobin, prothrombin time to be differing between healthy individuals of a defined age group coming from the same geoclimatic condition, but only difference is their prakriti and their biochemical parameters had a difference. And even in terms of uric acid, HDL-LDL ratio, total cholesterol, triglycerides, they were seen to be more in kapha, packed cell volume, RBC count, hemoglobin, they were more in case of pitta in comparison to both vata and pith, vata and kapha. Similarly, we also performed using that RNA that I showed. We also wanted to check whether certain genes are more expressed in certain prakriti, because they have to perform, each gene also has a function. So if those genes which are related to Vata function, are they more expressed in Vata individuals? That is the hypothesis, right? But then we had to check that. So what we performed is a whole genome gene expression study. And that gene expression study we did on 19,000 genes. And we found that there were certain genes which were amongst even healthy individuals, their RNA levels were differing between Vata, Pitta and Kapha. Now, whether this transcription RNA level RNA level variation is observed, which means that those genes are getting more expressed in certain prakriti. And now we wanted to check what kind of genes they are, which are getting more expressed in Vata prakriti in comparison to Pitta and Kapha. Which are the genes which are more expressed in Pitta prakriti in comparison to Vata and Kapha. So that is how we did that analysis. And we also had to see whether randomly one or two genes are coming like that, or there is a specific enrichment. There is a kind of a higher score of individuals, higher score in terms of any particular functional category. So genes are also classified on the basis of the functions in which they take part. So the blue I am showing is cell cycle, transport. So these are the gene ontology or a gene class or class of genes. So multiple genes of this class were seen to be more expressed in case of males or females. Cell cycle related genes were also more expressed in Vata individuals in comparison to Pitta and Kapha. Similarly, innate immune response related genes like NK cell mediated cytotoxicity and all that were more expressed in Pitta. Likewise, fibrinolysis related genes were low in Kapha. So it showed that even in the healthy state, normal functioning wise transcription levels of different genes is slightly varying between these Vata, Pitta and Kapha. Now, whether that will have an overall impact on their functions, overall physiology is something we wanted to check. And we also wanted to see whether this RNA level difference is just a transient difference or it has any genetic determinant at a DNA level which will have impact on this transcription. So one of the gene which was expressed more in Kapha individuals and less in Pitta individuals was EGLN1, which is a oxygen sensor gene at the cellular level. EGLN1 gene is a master regulator of hypoxia. So if there is a normal oxygen level present in the cell, EGLN1 is up, and it actually will degrade the hypoxia inducible factor, and that will keep other inducible genes silent. But if the oxygen level goes down, then EGLN1 goes down, and that will prevent HIF1 alpha from getting degraded, and that HIF1 alpha will further switch on other hypoxia inducible genes. Now this frequency of, now this gene expression was different between Pitta and Kapha. So imagine a core process like oxygen sensing. It is sensing less oxygen in case of Pitta, and therefore it is getting down, and it is showing this kind of a molecular phenotype. Now what we wanted to see is this happening all the time? So for that we did the DNA level analysis of this particular gene ke few positions, not entire gene, few positions which will have impact on the expression also. So at this position number, particular position number 479200, there is a, for every DNA position, there is a number. And this number, at this number, where T was high in case of Kapha, T was low in case of Pitta. So this TT genotype was high in Kapha and low in Pitta. And this TT genotype also was, we checked whether this TT genotype people who have more TT genotype, what is their expression level? So their expression level was high in case of Kapha, and that was coinciding with the DNA level genotype frequency on this position. So this told that this genetic variation that we are looking at in terms of ATGC variations in a particular position, it has got something to do with even the RNA level differences. And this differences, what does it mean? Why should we bother about those differences? Now we wanted to check what will be the implication of that difference of DNA as well as RNA on the overall health status or overall responsiveness to oxygen in individuals. So therefore, what we did was people who are residing at high altitude, who all the time face this problem of low oxygen levels, their frequency of TT genotype was similar to that of Pitta. And those individuals who go from low land to high land and they fall sick because of high altitude pulmonary edema, their TT genotype frequency was similar to Kapha individuals. Now this tells that people who will, of a Kapha individual, extreme Kapha Prakriti individual, if they try going to high altitude, they may have to be cautioned that they might actually have a problem in adjusting immediately. So that means the variation that we observed is not just a random variation, but that variation has a value in terms of predictive nature to response to environment. So this is the benefit of looking at Prakriti, identifying genetic variation linked to Prakriti, and that variation also is linked to overall environmental responsiveness to hypoxia. So this is the innovative framework that I'm talking about. And now one more thing. If I was to not do Prakriti analysis and pull all Vatpitka Prakriti individuals into one group and the overall genetic background people of that place in one group, we don't see any difference. We see difference only when we resolve them into Vatpitka Prakriti. So that's the power of Prakriti. So now this oxygen sensor gene allows actually has a differential effect on adaptation to low oxygen conditions. Natives naturally adapted to high altitude conditions, and Pitta had a similar genotype. And those which were having problem with HAPE have a genotype like that of a Kapha Prakriti. And this was the paper, this is not only in the Indian high altitude and patients we checked, we also checked in the global population. Wherever they were residing in high altitude, their one particular genetic position related genotype was similar to that of Pitta. And that's why it's even more proved that this genetic variation that we identified through Prakriti has a role in predicting the high altitude adaptation. So this was our PNAS paper we published in 2010. Subsequently, we have also looked for other genetic variations which might be differing between different dosha Prakriti. This paper is also published in So these genetic variations are also published in PNS, and subsequently more genetic variations are published in this is a wrong annotation. This is published in JTM 2015. So one of the gene that is again I would like to focus on is a von Willebrand factor, which is a platelet glycoprotein, which is involved in bleeding thrombosis axis. So this particular genetic variation, as you can see, again, there is a lot of difference between kapha and pitta, and this kapha associated variant is a wild type variant, and it is associated with thrombosis, whereas pitta one is associated with bleeding. So this again combined genetic effect of EGLN1 and VWF can identify a outcome of hypoxia in terms of thrombotic. So they can predict the outcome in terms of thrombosis in the hypoxic environment. Now, as we told about disease susceptibility, drug response, environmental response. So, the previous example that I gave of EGLN1 and VWF is related to environmental response and disease susceptibility. Now, there were more genes studied, and there were found to be differences in those ATGC percentage or at those particular positions, which are responsible for differential drug response of a modern medicine. So people in modern medicine have already identified that certain genes and the single nucleotide polymorphism. So at one position, if A and T are changing, that means it's a single nucleotide polymorphism. So a single nucleotide polymorphism is associated with less dose of requirement of anticoagulant warfarin. What we found was Pitta Prakriti individuals had a higher allele frequency than Kapha of that SNP, which tells that this target population of Pitta Prakriti might require a lesser dose of warfarin. So this has to be tested in disease population and subsequent, but at first we got this kind of differences, which will also determine not only personalized therapy of Ayurveda, but also that of a modern medicine. Drugs can also be affected by Prakriti. So this is something I wanted to summarize. It's a 35, our own Ayurveda. If we systematically explore that and use the methods described in Ayurveda for stratification of either Prakriti or Bala or Vikruti, we can do healthy individual stratification, and these variations underlying those Vat, Pitta and Kapha Prakriti are not only just random genetic variations, but they are also associated with certain responsiveness to environment, disease susceptibility, and so on. So this is how we can make a full circle of understanding the variability that we started with the question, whether we can understand variability at the molecular level and whether we can predict for some people that they have to be more cautious or so. So we have done further researches in terms of several studies, replication in other cohorts, and many other studies. So just wanted to tell that, as I told about gene, exon. So entire genome, all chromosomes ke, sirf exons, when we sequence them to read them in in an individual's DNA, that's called exome sequencing. So we have performed whole genome exome sequencing of Prakriti individuals from 2 different genetic background cohorts. And we find that there are 115 SNPs, which are single nucleotide polymorphisms, which match exactly even in both populations to be differing between Vat, Pitta and Kapha. And this can actually become like a diagnostic or associated with Vat, Pitta and Kapha with more confidence, because they are seen in 2 different genetic populations and they are shown to have associations with certain physiological traits as well as certain disease susceptibility traits. So in this we have again found a genetic variation in one gene called SERPIN-A10, in which the genetic variation T linked to higher protein levels of inhibitor of coagulation suggests that higher coagulation inhibition in Pitta. So even in VWF, we had found a genetic variation linked to bleeding. Exonic variations, we found a gene in variation in F2, which will indicate that low dose of anticoagulant required for Pitta. So in a way, hypoxia and hemostasis axis actually converges in different studies, even if we do different populations, if we do, Pitta Prakriti and Kapha Prakriti are shown to be differing with respect to this hemostasis axis. We have also gone on to look at the gut microbiome differences in extreme Prakriti individuals. These papers are all published, so you can look at them in more details. And we also look at, now we are doing this clinical examination of Prakriti using clinical proforma, for which we have developed machine learning algorithms and all. But we, if we were to explain it to modern medicine audience, if there is any objective way by which we can tell that whenever we are saying something of dry nature or smooth nature, are there any measures? So these measurements are also available, and we have been performing this in our subsequent studies. Likewise, a response to environment or shigra samarambha, shigra shobha, that kind of gunas that are described for vata and kapha different. We are also measuring them in respect to heart rate variability, in response to orthostatic stress. So these are the things that we have subsequently done. You can find those papers already available free, kind of free online in PubMed. One of the things that we publish is different extreme Prakriti individuals from two different genetic cohorts, genetic background cohorts. They have similar response to orthostatic stress. When we are giving a tilt to them, the heart rate variability changes, and these differences are consistently seen to be differing between Vata, Kapha, and Pitta. So with this, I think I will stop here. What I will tell is that there's a lot of literature to read for students and young faculties, where apart from, so the studies that we have done, we have published, whatever I described, they have been published in literature. Other groups have also done DNA level variations amongst Prakriti, epigenetic variations, microbiome, we have done, and one more group has also done. So at every level, DNA, RNA, epigenetic, microbiome, people have shown healthy individuals of different Prakriti are showing differences. So one can read more in detail about them. And there are technologies and techniques available for evaluation of all of these. In modern science, we can, but our forte is doing a good clinical analysis, identification of very proper group of individuals to be studied further at molecular level. That is more of our kind of a responsibility. So this is just a summary that we do Prakriti analysis, do their stratification. We have done machine learning for these molecular level differences. We are also developing cell lines for these Vatpit of extreme Prakriti individuals and look at actual cellular level, what is differing in them. As I said, cell cycle related genes were more expressed. The cell proliferation rates we have observed to be high in Vata cell lines. So this not only at an overall physiological level, but even at the cellular level, we are able to see that Vatpit of healthy individuals, extreme Prakriti individuals, cell lines, immortalized cell lines are actually showing differences. So with this, I think I will stop. You all might be aware about Rashtriya Prakriti Parikshan Karyakram, Desh Ka Prakriti Parikshan Karyakram. In these, the Prakriti methods and the questionnaires developed by me and our group at IGIB have been adopted, and people are using that for Prakriti analysis. So this is just a, so this is our IGIB multidisciplinary team, genomics students, pharmacology students, physiology students, and statistics, computational biology. We have a huge group of people who, and we are also having tie-ups with Ayurveda institutes where students come and do their work and stuff like that. So with that, I thank you, and I hope I have met with the time and not shooted up with it. Thank you very much for your kind listening.
Thank you so much, ma'am. We are grace to have you for this session. On behalf of Atacon program, I sincerely thank our esteemed speaker for the insightful session on Genomics, an innovative research framework for translational medicine. Your valuable insights and expertise have enhanced our understanding of this emerging field and inspired all the participants. We greatly appreciate your time and contribution. With great respect, I request our Honorable Co-Chairperson, Professor Dr. Sarita S. Butala ma'am, to share their valuable observations and reflections on the speaker's thought-provoking presentation. Over to you, ma'am. Sarita ma'am, over to you.
Unmute है.
Ma'am, you are audible.
Unmute. It is not going to unmute.
You are audible, ma'am. Ma'am, now you are not audible.
Ma'am, kindly unmute yourself.
Maybe as organizers, you please unmute for her.
Yes. Yes, ma'am, please continue.
Thank you and sorry for the same. भावना मैडम को सुनना मतलब ये तो फीस्ट हो जाती है हमेशा. The things they are doing and they are expressing and the total study on the genes. Every time it is new learning. But still, I can say, madam, you are doing great work. And one topic is what madam covered, concerned with the gut microbiology and the added. That is something new for the Prakriti genetical assessment or the Prakriti genes and the gut microbiology. And madam, I just want to ask maybe, Prakriti analysis is good. You are doing on the molecular level. But can we do something concerned with the Gunanusar? Because gun, I feel that these are the things which are changing or the exposing the lakshanas accordingly. And many times it happens. There are similarity in the Prakriti, but gun dominance is different. So can we focus on that? That is one thing what from my side. And you have enlightened the new research area, many keys and many tips you have given for the new researcher, how you can take the project or the research work. So that is very great thing. And variability in the health, there are, we can say, the variability in the Prakriti. You have correlated that very nicely. But Tridosh, Trisutra, the same time I can add Trayopastamba also, we can correlate with the Prakriti in different way. So it's very nice way. And Swastha definition, you have expressed very differently and very nicely. So it's from my side. Thank you very much. Thank you very much, madam. Atacon team, they had, as madam already told, they have constant taking follow-up and updating everything. So thank you very much and giving me the opportunity for this session. Over to you, sir.
Can I
Thank you
answer
so much,
the
ma'am.
level question?
Yes, madam, most welcome.
I'm happy you raised that point. As I showed you in the earlier slides, that all the Guna-based questions are only incorporated in the questionnaire. Now,
yes,
we can analyze overall Prakriti as well as same questionnaire we can analyze using the Guna dominance also. And as I said, in the heart rate variability, it is a Shigra Guna and Stimit Guna, which is very contrasting. So their response is very Shigra in case of Vata and Stimit in case of Kapha. And we could observe that in response to orthostatic stress, when we tilt them for 60 degree, the heart rate variability differs. So and at Guna level, clinical examination, and at Guna level, certain parameters we are assessing, and I hope next time I can elaborate on that. Thank you.
Yes, thank you. Thank you very much, madam.
Thank you so much, ma'am, for your valuable insights. I now request our esteemed joint co-chairperson, Dr. Sandeep Binokar, sir, to share their valuable observations and remarks on today's insightful lecture. Over to you, sir. Binokar, sir. Respected Dr. Binokar, sir.
Might be there is some problem with the mute and unmute from your side. I don't know.
1 minute, 1 minute. Please give me. Binorkar sir is co-host now. Now request sir.
Okay, ma'am. I think Dr. Binokar, sir, is not there at present.
Sir is there. Sir is there. I can see sir.
Sir is there.
Hello.
Yes.
Am I audible,
Yes,
sir?
Yes, sir. You are audible, sir. You are visible
Yes,
also, sir.
Sorry, actually, I could not unmute myself. That was the problem there. Now I hope I am audible now.
Yes.
First of all, it is my pleasure to comment on this particular very informative session by Dr. Bhavna Parashar, madam. Already several comments have been given by Bhutra madam, and I just wanted to share that I was having my personal experience at IGIB, ma'am. Most probably Bhavna Parashar madam may not be remembering that, but I was the participant in Ayurgenomics workshop in March 2021. I think it was 3 days workshop there, and where the entire IGIB team they taught us how to extract, isolate, and amplify the DNAs and correlate the properties of DNAs according to the Prakriti. So it was very great experience, ma'am. And today also you have discussed regarding the demonstrations of the various potentials of ayurgenomics and individual understanding of the health, disease susceptibility, and therapeutic responses also. Uh, I congratulate Dr. Bhavna Parashar madam for such an informative and thought-provoking and highly relevant presentation, ma'am, because everyone know that all the efforts which have been means taken by you, all those are the gigantic efforts by the entire IGIB team. I am thankful to the organizers of the Atacon 2026 for providing this opportunity to co-chair this session. And thank you one and all.
Thank you, sir, for sharing your perspective. May I now respectfully invite our.
You had come to IGIB also. So I think we had an online session and then hands-on was later.
Yes, ma'am. Yes, actually, we had a hands-on training by I think Mukherjee ma'am, and the other team was also there. And then we had several presentations in the 3 days. So it
Right.
was very informative, ma'am.
Yeah.
Thank you.
Thank you.
Thank you, ma'am, and thank you, sir. May I now respectfully invite our honorable chairperson, Professor Dr. Namrata Joshi, ma'am, to share their reflection, observations, and concluding remark on today's enlightening lecture on Ayurgenomics. Over to you, ma'am.
Thank you, Dr. Adil. First of all, I would like to say my apology that being late in this session, and I was not able to attend on time because I was busy in some meeting. And what to say about this lecture? Actually, both the co-chairperson have already spoken about the lecture itself. I'm not a person of Sharir Kriya. Still, as I'm working with, I'm from Rash Shastra. As I am working on cancer research, so many things regarding proteomics and genomics I am working with. In that regard, I must say that Madam is doing a wonderful job. In fact, it is a wonderful lecture as well as the work she is doing. That is wonderful. That is remarkable because in Ayurveda, we used to talk about many things about our Shastra. But in present scenario, all these fundamental need to address in the contemporary science. And Madam is doing a good job in that regard. In fact, if I say that, like if we talk about the Shukra Prakriti, what we have read in our BMS, that Shukra Shoni Sayoga Yuva Bhave Dosh Utketa, and accordingly our genotype and then the phenotype works. And in today's scenario, whenever we talk about the treatment part or whatever part, apart from the genetic aspect, we also go for the epigenetic aspect. And for both aspects, I think the Prakriti analysis is a must. And the second thing is more about, if we talk about treatment also, in today's scenario, as Ayurveda says, prevention is better than cure, and everyone, हम फिर से उसी दायरे में आ गए कि we are talking about the preventive aspect. And once we know about the prakriti in a better way at the molecular level, we will definitely able to address the preventive aspect of our science, what we used to tell about. Moreover, as I said that I am working with the cancer research, and we daily we talk about the genomes, proteomics, and every even our if we talk about our food and even our medicine, every thing is working on a particular molecular target, and that molecular target how it is working, and that too depends on the prakriti and personalized person to person. It will show a variation. So in that regard, again, I say it is a challenging topic, and Madam is doing a wonderful job. And I really appreciate one of the slides Madam has presented. I was not aware that this is the work of Madam, and I have shown that slide in which she has shown her research regarding the level of different biomarker in our body in particular Prakriti people. Actually, I have presented that slide with special, given reference of Madam itself. Ki, such work has been done while I was presenting my cancer research somewhere. And like Madam told us that master regulator of hypoxia, TT genotype, which is high in cough Prakriti people. And in practice, we see that the cough Prakriti people, it is very difficult for them to survive in the high altitude. And she has given a scientific base to those fundamentals and those findings of the Ayurveda. That is really, although it seems कि बहुत छोटी छोटी बातें हम बता रहे हैं, but उन छोटी छोटी बातों को बताने के लिए the way she is working, that is tremendous. And I congratulate ma'am for doing such a nice job. And I also thankful to the organizer, because by this platform, though I am joining on an online mode, I am able to connect with madam directly. Once again, thank you.
If I may just add, because you are working on cancer, you will actually enjoy reading another paper.
Yes, ma'am. Yes, ma'am.
Which is on the cell proliferation rate differences in Vatpit Kaph Prakriti. And, difference in the response to UV radiation.
Sure, ma'am. Sure.
Thank you. Thank you.
Thank you, ma'am, for leading this discussion and sharing your feedback. As we reach the end of this enriching session, I now hand over to the proceeding to my co-coordinator, Dr. Deepika Sarvase, ma'am, who will deliver the concluding vote of thanks. Over to you, ma'am. Deepika, ma'am.
Yes. Thank you, ma'am. First of all, I apologize, Dr. Bhavna, ma'am, that we have exceeding her time. But as a junior faculty in Ayurveda, I am very glad and very impressed with the work that Prakriti and genomics. Genomics is a very emerging field of our Ayurveda, and chairman and co-chairperson have added many points, but being a junior, I would like to emphasize and focus on that the ma'am is trying objectifying the Lakshana and Guna. That is a need of Ayurveda, because modern people, without any proof, they will not admire the research work. And that is a need for the all Ayurveda, which is the main work you are doing, ma'am. And in our institute also, we are doing the Bhallatak Rasayana and Ayurgenomic study. So I think now onwards also we will have a touch with you, and we are very inspired. And thank you so much for your very precious time, ma'am. And I'll thank Dr. Namrata Joshi, ma'am, Dr. Sarita, madam, having additional, they have also added some values in your lecture. And I also thank Dr. Sandeep, sir, and I thanks to all the organizing committee members of Atacon, Jayashree ma'am and Dr. Ajit sir, because we are working a lot on this session today. So thank you everyone. And Bhavna ma'am, we will share the token of appreciation in the form of certificate to your mail, ma'am. Thank you so much for your time, ma'am. Over to you, Jayashree ma'am.
Thank you very much, session coordinator. And thank you, respected speaker, respected chairperson, and respected co-chairperson for their time with us. Thank you, Deepika ma'am. Thank you, Adil sir, for your coordination. Now
Thank
we
you,
will
sir.
move forward for the next session. Our next session is by Dr. Harish Patankar sir on topic Ayurvedic cosmetology and trichology. And for this, the session coordinators are Dr. Priyanka Shinde Madam, Associate Professor, Department of Rachna Sharir, BSDTs Ayurved Mahavidyalay, Wagoli, Pune, and Dr. Nandakishore Kade Sir, Professor and HOD, Department of Rog Nidan and Vikruti Vigyan, Shri Gurudev Ayurved College, Gurukunja Ashram, Mojri, Amravati. I request Dr. Priyanka Shinde Madam to come forward and start the session. Towards you, Madam.
Hello, am I audible?
Yes, Madam.
Yes. A very warm welcome. I take this opportunity to introduce our speaker, Vaidya Harish Patankar sir. Sir is MD in Kriya Sharir and he is a PhD scholar. He is a renowned Nadi Tadnya, running 108 clinical centers worldwide across Dubai, Europe, Russia, and Australia. He is chief consultant at Arogyavardhini Chikitsalaya, Pune. He is director of Kesha Ayurved, India's first Ayurvedic hair testing lab and research center, and director of Kaya Ayurved too. He is a founder of Prachin Samhita Gurukul. He is the winner of Best Ayush Startup Award in the year 2022, which was presented to him by Honorable Prime Minister Narendra Modi ji. He has represented India at BRICS Nation Conference, which was held at Russia, and also honored with the International Ayurveda Ratna Award in the year 2025. He has trained 1500 plus doctors across 75 plus batches in Ayurvedic cosmetology and trichology. He has also been the faculty of MUHS Nashik. He has conducted specialized certification courses for delegates from USA, Japan, France, and Russia since the year 2009. He has authored books too. A few of them are Dravyagun Vidnyan, Kesha Ayurved, and Ayurvedaच्या Smrutitun. He had also been a featured guest on DD Sahyadri, which is a government channel. He has performed care, that is vision care, that is Netra Tarpan, which is a specialized treatment in Ayurveda for 6,500 plus patients, and he had also been honored by the police commissioner for his outstanding work. I welcome you, sir. Next, I introduce our chairperson. Next, I introduce our chairperson, Dr. Ghanshyam Kodwani, sir. He holds a dual MD degree in Rog Nidan and Kai Chikitsa. He is retired professor and HOD from the Department of Rog Nidan at Government College, Nagpur. He has 37 years of undergraduate teaching and 20 years of postgraduate teaching experience in Rog Nidan as well as in research methodology. He has a clinical experience of over 30 years. He has published 20 plus articles in peer-reviewed journals. He is the former member of Board of Studies at BHU. He is a former member of Scientific Advisory Committee for the Medical Research Council of Maharashtra. He has received Best Teacher Award in the year 2008 by Directorate of Ayurveda Maharashtra and Mahayush Kamal Puraskar in the year 2017. He is a recipient of Shri Dhanvantari Puraskar in the year 2013-14 and Panchakarma Puraskar in the year 2015 by Shri Khadiwale Pratishthan. I welcome you, sir. Next, I would like to introduce our co-chairperson, Dr. Rohini Rakesh Salve, ma'am. Ma'am is HOD and Associate Professor. She is from the Department of Panchakarma. She is currently working at Government Akhandanand Ayurved College. She has a teaching experience of 17 years in UG and 8 years in PG. I welcome you, ma'am. Our next co-chairperson for this session is Dr. Meghnandini Khandare, ma'am. She is professor in the Department of Dravya Guna from LN Ayurved College and Hospital, Bhopal. She has 20 plus years of teaching experience. Please join me in welcoming our guest speaker, Vaidya Harish Patankar sir, who is a true pioneer and visionary leader, bridging the traditional ancient sciences with modern medical applications to share his expertise on Ayurvedic cosmetology and trichology. Over to you, Dr. Patankar sir.
Guru Sri Madhavanathay Namaha. Thank you, Madam Ji. Thank you very much, respected Shinde ma'am, for such a nice and excellent introduction. Also, I would like to congratulate Ayurveda Teachers Association for organizing such an extraordinary 8th International Conference, Atacon 2026, and the theme was Innovative Ayurveda. It's my really fortunate to represent myself in front of such a audience, and with respected all the teachers in front of me, Dr. Sarita Buttada ma'am, Dr. Ganesham sir, Adil Khanji, and all respected teachers, and today's my chairperson and co-chairperson of this lecture. Okay, so I welcome all again, and I will start my presentation on Ayurvedic cosmetology. Today, I will try to represent this topic with some different views. As being a hardcore clinical practitioner, I want to represent some cases, and then I want to explain how we are going to treat such cases with some different methodology. So we are representing here one case of 16 years female patients, around 62 kg weight. Okay, whole scalp baldness since almost 14 years. It means from almost age of 2 years, she is facing the problem. Slowly converted into alopecia totalis. Okay. A general examination, I have no, like Mala, Mutra, Sveda, and other are represented here. I want to show in front of you a case study indirectly. So treatment which we planned, Krumigana plus Keshayu Churna, tablet K-Rays, Krumikutar, and Rechakvati. Okay. Kuntal oil, Mandar lep was very excellent in such conditions. Vidangarishta, Velvex soap, Anagen Grow serum, and Keshaprash. With this particular treatment, you are seeing some before and after results in this case. Okay. So before you are seeing, this is after. How? Let's discuss today why given Krumigana plus Keshayu Churna, why tablet K-Rays for dominating particularly such kind of conditions, Krumikutar and Rechakvati. Okay. Another same different case, but almost age of almost 30. Alopecia patches, you are looking at front area, occipital area, also left and right side. And totally it is covered in next case. Okay. Whole treatment protocols and the medicine, Supta Kesha Yoga and other medicines I have prescribed over here. how we are getting these results. Okay, it's very exciting. So starts from the Vagbata. Athata Ayush Kami Adhyayam Vakhyasamaha. So I repeat, Vakhyasamaha. Ayurveda is like we have to hear it from someone. If someone is telling, then we have to listen. If anything is written, then we can read it. But when anything is like told by someone, then we have to listen it very carefully. And that's why the word Vakhyasamaha comes here. Before that, the word is Athata Ayush Kamiya. It means whoever who want a good, long, healthy life, it's written for, it's told for him. Our acharyas, our gurujis, my respected guru Vaidya Samir Jamadagni sir, told us one thing. Always remember, whenever you will read Vagbata, always remember it is in Sutra. Everything is in Sutra. It means it is in code language. Then you have to decode the code language. Okay, that's so simple. Then how to decode it? Then he have given some instructions to decode that if we just change Ayush Kamiya, and if I want to make a Kesha Ayurveda, like a brand, you know that Kaya Ayurveda, we have another brand. If I want to particularly work on hair, then I have to read it at like Athata Keshayush Kami Adhyayam. If I want to work on the skin only, then I have to read it like Athata Kayayush Kami Adhyayam Vakhyasama. The same way, if I want to work on the Garbhashaya, then it's like Garbhayush Kamyadhyam Vakhyasama. If I want to work on the Vrukka, then it is Vrukkayush Kamyadhyam Vakhyasama. So whatever you want, you can just put that word into that Leshokta like Samprapti, Leshokta like Tantra Yukti you can use here, and you can just replace the word and you will get the whole Vagbata with the different vision and different meaning. And this is can be achieved then only when we will listen it carefully. And that's why Ayurveda is from Vakya Sama category. So if we just listen Ayurveda with any one of our acharyas, our guru, then it becomes so much easy. So all the students, all the teachers, all the faculties over here present, I will request every student, don't miss anybody's lecture, any teacher lecture. कोई भी टीचर आपको अगर लेक्चर देने आ रहा है तो उनका लेक्चर आप बिल्कुल भी मिस नहीं करना है, क्योंकि आयुर्वेद शास्त्र ये गुरुमुख से आता है और किसी भी गुरुमुख से आप थोड़ा भी आयुर्वेद सीखेंगे तो आपको बहुत ज्यादा आएगा. दैट्स सो सिंपल. ओके, सो लेट्स डिकोड द कोड लैंग्वेज. एक श्लोक हम सब लोग पढ़ते हैं. दोष धातु मला मूलम सदा देहस्य तंचला, या दोष धातु मला मूलम ही शरीरम. यही त्रिदोष सिद्धांत है. त्रिदोष सिद्धांत में वात पित्त कफ चेति त्रयोदोषा समासता बताया है. मतलब एवरीवेयर वी हैव टू सी ओनली दिस थ्री, वात पित्त एंड कफ. तो वो एक विजन हमारी आनी चाहिए हर चीज में तीन चीजें देखने की. लेट्स ट्राई टू फाइंड आउट इट. व्हेन आई वाज traveling in Russia for my lecture, as here also in introduction Dr. Shinde ma'am given the introduction very nicely. I have represented Russia too many times, okay, for the BRICS as Ayurveda ambassador, also for one day in Ayurveda day, on yoga day also. Okay, in my previous visit, when I have explained this Vata, Pitta and Kapha, the Dr. Vitali from Russia, he is very Ayurveda learner and very enthusiastic person. And he taught me how to see the Vata Pitta Kapha in single watch. Okay. तो एक घड़ी में भी आप वात पित्त कफ को पढ़ सकते हैं, एक घड़ी में भी आप वात पित्त कफ को समझ सकते हैं. Then he explained me that second kata, you know that minute kata and tas kata jala every hour. Okay. So one is from belongs to vata dominancy, second belongs to pitta dominancy, third belongs to kapha dominancy. Just see the speed, just see the size, just see the adi, madhya, anta, everything. If you are ready to explore the sutra vistar, vayu pittam kapha shiti trayodosha samasata, and the another shlok vayoho ratri bhuktanam te anta madhya adhika kramat, each and every shloka, each and every sutra vistar you can find out in this watch also. It was very surprising for me. Then he explained the same thing in Prakriti also. तीन लोग सामने से आ रहे थे, सर ने कहा कि डॉक्टर साहब मुझे इनकी प्रकृति बताओ। अब मैडम ने बहुत अच्छी तरीके से जीनोम की कैटेगरी में किस प्रकार से प्रकृति कितना डीप हो सकता है वात पित्त का वो बताया। वो सूक्ष्म परीक्षण है आयुर्वेद का, और अभी ये जो है ये स्थूल परीक्षण है। आयुर्वेद दो तरीके से पढ़ा जाता है, स्थूलाति स्थूल में भी आप देख सकते हो और सूक्ष्माति सूक्ष्म भी आप इसको देख सकते हो। तो स्थूल अति स्थूल में सिखाते वक्त हमारे आचार्यों ने पर्वतों के बारे में बताया, जल के बारे में बताया, वायु के बारे में बताया, और इस सृष्टि में ये वात पित्त कफ को कैसे रिजेम्बलेंस करते हैं इसके बारे में हमें बताया, और वो देह में भी वात पित्त कफ बताया, और सूक्ष्माति सूक्ष्म आप करते जाते हैं तो वाग्भट जी ने एक रोमकूप में भी वात पित्त कफ को बताया। और अभी आपने लेक्चर में सुना कि एक सिंगल जीनोम में भी आप वात पित्त कफ को फाइंड आउट कर सकते हैं। तो जितना सूक्ष्म करेंगे उतना सूक्ष्म आपको आयुर्वेद पढ़ने को मिलेगा, और जितना स्थूल करेंगे उतना स्थूल भी पढ़ने को मिलेगा। तो जैसे ये तीन लोग सामने से आ रहे थे, सर ने हमें कहा कि डॉक्टर साहब कैन यू गिव मी द प्रकृति ऑफ दिस थ्री पर्सनैलिटीज। अब मैंने कहा सर हमें तो आयुर्वेद में फर्स्ट ईयर में से 70 क्वेश्चंस ऑलमोस्ट होते हैं पूरा प्रकृति परीक्षण का, और उसके बाद हम बता पाएंगे। तो सर ने कहा नहीं नहीं इतना डीप नहीं है, आप बस यूं ही मुझे बताओ, थरोली बताओ कि क्या है वात पित्त कफ इनकी प्रकृति। और मैं सोच ही रहा था तो उन्होंने मुझे बेल्ट की तरफ देखने को कहा, एंड ही जस्ट एक्सप्लेन द कफ पित्त एंड वात प्रकृति विद द हेल्प ऑफ बेल्ट। Generally you will find this is a simple rule, generally those who belongs to kapha prakriti, मैं भी याद कर रहा था हमारे कॉलेज के भी सभी टीचर्स ओके, कि जो अम्बिलिकस के ऊपर बेल्ट पहनते हैं वो जनरली कफ प्रकृति बिलोंगिंग होते हैं। बेल्ट मस्ट बी एट अम्बिलिकस लेवल, जो अम्बिलिकस पे बेल्ट पहनते हैं वो जनरली पित्त प्रकृति के होते हैं, एंड जिनका लो वेस्ट बेल्ट होता है बहुत बार बिलो द अम्बिलिकस लेवल होता है वो जनरली वात प्रकृति के होते हैं। सो इट्स सो इंटरेस्टिंग। अब आप जितना हो सके उतना वात पित्त कफ को जितना एलोबरेट करेंगे, घड़ी में एलोबरेट करो, बेल्ट में एलोबरेट करो, आप कहीं पर भगवान के दर्शन लेने भी जाएंगे तो उन प्रकृतियों के एंजॉय करो। वात प्रकृति वाला आएगा किसी मंदिर के बाहर तो एक चप्पल राइट साइड को रखेगा, दूसरी लेफ्ट साइड को रखेगा, ओके, घंटे भी वो इतनी बार बजाएगा कि भगवान के भी कान फट जाए, और वो अंदर जाके दर्शन भी इस प्रकार से लेगा कि वो कम से कम 10-12 बार वो अपने हाथों के इशारे करता है, और 7-8 राउंड लगाए बिना वो रुकता नहीं है। सेम पित्त प्रकृति का वहां पे भगवान के दर्शन करने आ जाता है तो वो पहले टोकन लेता है, फिर चप्पल स्टैंड पे ही चप्पल लगाता है। पित्त के बहुत व्यवहारी होते हैं, ओके। दर्शन घंटी भी वो एक ही बार बजाएगा, अंदर जाएगा एक ही बार नमस्कार करेगा, एक ही राउंड लगाएगा। लेकिन कफ वाले अगर आएंगे तो आते ही पहला जो स्टेप होता है वहीं पे वो चप्पल रखेंगे, जहां से मंदिर की पहली सीढ़ी शुरू होती है। घंटी बजाते वक्त देखेंगे ऊपर, बोलेंगे इतना ऊपर घंटी कौन रखता है, चलो मत बजाओ, भगवान भी सोए हैं, क्यों उनको डिस्टर्ब करें। अंदर जाने के बाद दर्शन भी ऐसे लेंगे कि पूरा मंदिर को प्रदक्षिणा नहीं लगाएंगे, भगवान गणेश जी जैसा खुद को ही प्रदक्षिणा लगाएंगे और बोलेंगे कि भगवान के द्वार पर थोड़ा बैठना चाहिए। तो प्रकृति जो है वो हमें स्थूल रूप में, सूक्ष्म रूप में, सब जगह पे देखने को मिलती है, और इसको सम हो गया तो वो देह निरोगी है, और उसमें कुछ वैषम्य आ गया तो वो देह रोगी बन जाता है। और इसलिए शास्त्र कहता है रोगस्तु दोष वैषम्यम दोष साम्यम अरोगता। तो इसको और हम डिकोड करेंगे तो रोगस्तु वात दोष वैषम्यम, रोगस्तु पित्त दोष वैषम्यम, रोगस्तु कफ दोष वैषम्यम, ऐसा वो डिकोडिंग हो रहा है। इसको और डिकोड हम करेंगे तो रोगस्तु प्राण वात दोष प्रकार वैषम्यम, रोगस्तु उदान वात दोष प्रकार वैषम्यम, रोगस्तु समान वात दोष प्रकार वैषम्यम, इतना वो पर्टिकुलर जा रहा है। तो जब भी हमारे पास कोई स्किन डिसीज का पेशेंट आता है या कोई हेयर डिसीज का पेशेंट आता है, तो प्राण वह स्रोतस के दुष्टि के क्या क्या हेतु है, वो उसमें होते हैं क्या, वो फाइंड आउट करो। उदान वह उदान के स्रोतस के दुष्टि के कुछ मतलब पूरे उदान के दृष्टि में आप देखेंगे कि वाक प्रवृत्ति प्रयत्न ऊर्जा बल वर्ण स्मृति क्रिया, ये सब उदान के कार्य है। तो वर्ण किस में आ जाता है, वो उदान में आ जाता है। तो कभी भी स्किन टैनिंग का पेशेंट आता है, मिलाज्मा का पेशेंट आता है, चेहरे के ऊपर वैवर्ण्य लेके कोई पेशेंट आता है, तो आपको डायरेक्टली पित्त दोष की तरफ जाना नहीं है, आप ये उदान दोष की विकृति है क्या ये भी फाइंड आउट कर सकते हैं। और रोगस्तु उदान वात दोष प्रकार वैषम्य, ये सूत्र को ध्यान में रख के उदान को कैसे सम कर पाए, उदान को कैसे अच्छा कर पाए, इतना अगर आप वहां पे ट्रीट करते हैं तो वो मिलाज्मा ठीक होता है, वो फ्रेकल्स ठीक होता है, वो लेंटिगो ठीक होता है, चेहरे के ऊपर आया हुआ कार्ष्ण भी ठीक हो सकता है। तो हमें हर बार कोई भी डिसीज हमारे सामने, कोई भी पेशेंट हमारे सामने आने के बाद उसका डिकोडिंग करना है। कोई पेशेंट आ जाता है एक्सेसिव ड्राइनेस का, स्किन के ऊपर उनको एक्सेसिव ड्राइनेस है, अब आप क्या कर सकते हैं, यही श्लोक को और सूत्र विस्तार कर सकते हैं, रोगस्तु रूक्ष गुण से, है ना, रूक्ष गुण जन्य वैषम्य। अब वात का ही है, लेकिन अब वात में किसका, प्राण उदान व्यान समान अपान, अब इसमें भी कौन से गुण का वैषम्य हुआ है, ये अगर आप फाइंड आउट करते हैं तो आप और पर्टिकुलर मेडिसिन दे सकते हैं। जैसे आपको चिकित्सा जो दी है, इन्हीं गुणों के आधार पर द्वंद्व चिकित्सा दी है, तो रुक्ष गुण का वैषम्य हुआ है तो आपको स्निग्ध चिकित्सा देनी है, लघु गुण का वैषम्य हुआ है तो आपको गुरु चिकित्सा देनी है, शीत गुण का वैषम्य हुआ है तो आपको उष्ण चिकित्सा देनी है, खर गुण का वैषम्य हुआ है तो आपको स्निग्ध चिकित्सा देनी है। और यही तो द्रव्य सामान्य, गुण सामान्य और कर्म सामान्य ग्रंथ में आता है, जो हमने देखना चाहिए कि हम इसको समान कैसे कर सकते हैं। द्रव्य समान, गुण समान, कर्म समान, हम अलग अलग आहार से, विहार से या कर्म से भी हम इसको ठीक कर सकते हैं। जैसे आपको पता है कि अगर हम चने की दाल खाएंगे तो द्रव्यतः ये बात बढ़ाने में सक्षम है, अगर गुणतः किसी हम फैन के सामने या किसी भी पूर्ववात का हम सेवन ज्यादा करते हैं तो गुणतः वात के दोष की वृद्धि हो जाती है, और अगर हम व्यायाम ज्यादा करते हैं तो कर्मतः वात दोष की वृद्धि हो जाती है। तो ये जो वात दोष की वृद्धि हो गई है वो रुक्ष गुण से हुई है, लघु से हुई है, शीत से हुई है या खर से हुई है। इस प्रकार से अगर हम रोग का दोष वैषम्यता ढूंढेंगे तो हमें चिकित्सा करने के लिए भी बहुत आसानी आ जाती है और हमारी चिकित्सा बहुत ही सुंदर और शाश्वत हो जाती है। इतना ही नहीं, इसी एक श्लोक को आप और सूत्र विस्तार करेंगे तो आपको पता चलेगा कि पंच महाभूत भी इसी से बने हैं, षड्रस भी इसी से बने हैं, क्योंकि वात किससे बना है, वात आकाश और वायु से बना है। आप पित्त को देख लीजिए, वो हम अग्नि से बनाए इसे देखते हैं, कफ को देख लीजिए वो पृथ्वी और आप से बना है। तो क्या श्लोक का विस्तार और बड़ा हो गया, रोगस्तु आकाश वायु वैषम्यम, और रोगस्तु अग्नि वैषम्यम, और रोगस्तु पृथ्वी आप वैषम्यम। इन्हीं दोनों महाभूतों से षड्रस बनते हैं। शांभोग्नि शांभु तेजा ख वायु अग्नि गोणिल ही द्वयल बने क्रमाद्भूतेर मधुरादि रसोद्भवा। तो श्लोक का विस्तार और बड़ा हो जाता है, और रोगस्तु मधुर रस वैषम्यम, रोगस्तु अम्ल रस वैषम्यम, रोगस्तु लवण कटु तिक्त कषाय रस वैषम्यम। इन शॉर्ट, रोगस्तु षड्रस वैषम्यम, षड्रस साम्यम अरोगता। इस प्रकार से अगर हम देखेंगे, क्योंकि कफ वैषम्य है, इसका मतलब मधुर रस का, अम्ल रस का और लवण रस का वैषम्य है। जब मधुर रस से वैषम्य निर्माण होता है तो घन कफ की वृद्धि होती है, जब अम्ल रस से वैषम्य निर्माण होता है तो द्रव कफ की वृद्धि होती है, और जब लवण रस से वैषम्य निर्माण होता है तो स्राव रूपी कफ की वृद्धि होती है। तो कफ का वैषम्य भी, मतलब रोगस्तु दोष वैषम्य में रोगस्तु कफ वैषम्य भी अगर हम निकालना चाहते हैं तो भी वो कफ वैषम्य मधुर रस से है, अम्ल रस से है या लवण रस से है, ये अगर हम सटीकता से निकालेंगे तो हम बहुत अच्छी चिकित्सा दे सकते हैं। जैसे एक रोगी हमारे पास आया था जिसको पालित्य था, लवण रस के कारण उसको पालित्य आया था, तो उसकी चिकित्सा करते वक्त केवल लवण छोड़ के जितने बाकी बचे हुए पंचरस है, हरित की पंचरसा अलवणातो वरापरम, केवल हरित की उसको खिलाया, 3 महीने में उसका पालित्य पूरा चला गया। तो इस प्रकार से अगर हम किसी भी श्लोक को डिकोड करेंगे, उसका सूत्र विस्तार करेंगे, तो हमें एक सिस्टम मिलता है जो ग्रंथ में दिया है 3+7+3+5+6+11। तो एक टिपिकल फॉर्मेट है। हम केश आयुर्वेद का आयुर्वेद में हमारा सॉफ्टवेयर भी इसी से बना हुआ है, हमारा मेथोडोलॉजी भी इसी से बना है, और जितना हो सके उतना सूत्र विस्तार करके हर एक चीज को डिकोड करने की कोशिश की है। ओके, स्थूल रूप से सूक्ष्म रूप तक इसका डिकोडिंग किया है। ग्रंथ में कफ वृद्धि हो जाती है तो रस वृद्धि होती ही है, रस वृद्धि है तो मूत्र की दृष्टि होती ही है। रस, कफ और मूत्र की दृष्टि, इसका मतलब शरीर में पृथ्वी महाभूत आप महाभूत की वृद्धि हुई है, और पृथ्वी और आप महाभूत है, इसका मतलब मधुर रस की दृष्टि है ही। तो अपना एक्स ये है, दोष धातु मलामूलम ही शरीरम, सपोज दिस इज एक्स। तो जब तक हम किसी भी मैथमेटिक्स इक्वेशंस में एक्स को नहीं मानते, तब तक हम किसी इक्वेशन को सॉल्व नहीं कर सकते। आयुर्वेद में दोष धातु मल ये अपना एक्स है, आयुर्वेद में षड्रस अपना एक्स है, आयुर्वेद में पंचमहाभूत अपना एक्स है, और जितना हम इस एक्स को जल्दी समझेंगे उतना जल्दी हम किसी भी सिस्टम को डिकोड करके रिजल्ट्स अच्छे दे सकते हैं। मॉडर्न साइंस में सेल ये एक्स है, आयुर्वेद में दोष धातुमल पंचमहाभूत षड्रस ही एक्स है। इसलिए मैं हमेशा कहता हूं कि अगर हम सब लोग सामान्य सोचेंगे तो सामान्य ही निदान होगा, अगर हमें कुछ विशेष निदान करना होगा तो हमें विशेष सोचना भी होगा। तो हमें सोच अपनी चेंज करनी है, और शास्त्र ने दिए हुए तत्व, शास्त्र और व्यवहार, इस त्रिसूत्री को ध्यान में रखते हुए हमने सूत्र विस्तार करना चाहिए। सूत्र विस्तार की कला हम अगर आत्मसात करते हैं, इस यूनिक फॉर्मूला को डिकोड करते हैं, त्रिदोष सप्तधातु त्रिमल पंचमहाभूत षड्रस और एकादशविद भाव के आधार पर किसी भी रोगी का हम अगर व्याधि का निश्चय करते हैं, नामकरण करते हैं, तो हमें निश्चित रूप से वहां पे यश मिलता है। हमारे शरीर में भी जैसे वात पित्त कफ है, वैसे त्रिदोष और केश संबंध ऐसे आप सीखेंगे तो आपको हेयर रूट, शाफ्ट और टिप ऐसे उसको बाइफरकेट करेंगे तो आपको आदि बिलोंग्स टू कफ डोमिनेंसी, मध्य बिलोंग्स टू पित्त डोमिनेंसी एंड अंत बिलोंग्स टू वात डोमिनेंसी। इस आधार पर रूट, शाफ्ट, टिप का बाइफरकेशन मिलेगा। इतना ही नहीं, अगर हम उसी श्लोक को वयोहोरात्रि भुक्तानाम ते अंत मध्य आदि का क्रमात् का सूत्र विस्तार करेंगे तो फ्रंटल एरिया जो है हमारा वो वात बिलोंगिंग आ जाता है, जो मिडल एरिया है वो पित्त का बिलोंगिंग है, और जो पीछे का ऑसिपिटल एरिया है वो कफ बिलोंगिंग होता है। तो कोई भी पेशेंट जो टिपिकल एम शेप बालनेस लेके आता है वो वात डोमिनेंसी में ज्यादा पाया जाता है। जो पेशेंट माथे के ऊपर के बाल उसके चले गए ऐसा आ जाता है, पित्त डोमिनेंसी का मिलता है। और जो पीछे से फोटो निकालने के बाद जिनके हेयर लॉस हुआ है समझ में आता है, वो हमें ज्यादातर कफ डोमिनेंसी में देखने को मिलते हैं। हेयर रूट को भी आप वात पित्त कफ में कन्वर्ट करेंगे तो आपको पता चल जाएगा कि एनाजन फेज है, ग्रोइंग फेज है, कैटाजन ये एक थोड़ी सी रेस्टिंग फेज है, और टिलोजन फेज है, शेडिंग फेज है। तो ये भी आदि मध्य अंत में आता है, कफ पित्त वात में आता है, और एनाजन बिलोंग्स टू कफ डोमिनेंसी, कैटाजन बिलोंग्स टू पित्त डोमिनेंसी एंड टिलोजन फेज बिलोंग्स टू वात डोमिनेंसी। तो एक फेज में हम वात पित्त कफ निकाल सकते हैं। एक शाफ्ट में भी अगर हम उस शाफ्ट का ट्रांसफर सेक्शन ले लेंगे तो उसके 3 पार्ट मिलते हैं, क्यूटिकल, कॉर्टेक्स और मेडुला। मेडुला सबसे इनर मोस्ट अंदर का आदि पार्ट है, मध्य पार्ट कॉर्टेक्स है, और अंत पार्ट क्यूटिकल है। तो उसको आदि मध्य अंत के हिसाब से डिवाइड करेंगे तो इसमें भी हमें कफ पित्त और वात की डोमिनेंसी मिलती है। इसके ऊपर भी मैंने एक पेपर वर्ल्ड आयुष कांग्रेस में प्रेजेंट किया था दुबई में, और वहां पर भी हमें फर्स्ट प्राइज मिला था। ओके, और उसमें हमने हर एक मेडुला के डिफरेंट डिफरेंट जो 5 टाइप्स होते हैं, कंटिन्यूअस, इंटरप्टेड, फ्रैगमेंटेड, सॉलिड और नन, इनको माइक्रोस्कोपिकली एनालिसिस करके उस रोगी की प्रकृति हम कैसे डिफाइन कर सकते हैं, इसके ऊपर भी एक रिसर्च पेपर पब्लिश किया था। सो इसमें कुछ इंटरेस्टिंग फाइंडिंग्स मिले थे, जैसे वात डोमिनेंसी के जो हेयर शाफ्ट के सैंपल्स होते हैं मेडुला के, उसमें सॉलिड और नन टाइप ऑफ मेडुला पाया जाता है, पित्त में फ्रैगमेंटेड और इंटरप्टेड मेडुला पाया जाता है, और कफ में कंटिन्यूअस टाइप ऑफ मेडुला पाया जाता है। देयर आर 5 टाइप्स ऑफ हेयर मेडुला पैटर्न, कंटिन्यूअस, इंटरप्टेड, फ्रैगमेंटेड, सॉलिड और नन। तो इतना बड़ा वो त्रिदोष का सूत्र विस्तार होता है। मतलब केश और त्रिदोष संबंध आप सूत्र विस्तार करेंगे तो इतना बड़ा आ जाता है। और बहुत चीजें हैं, लेकिन समय की उपलब्धि कम होने के कारण मैं आपको एक कंसेप्चुअली सबका एक विंडो दिखा रहा हूं। तो उसी प्रकार से अगर हम केश और सप्त धातु संबंध देखेंगे, तो जैसे पूरे शरीर में जो बाल होते हैं वो भी एक एक धातु के बिलोंगिंग होते हैं। पूरे शरीर के बाल रस धातु बिलोंगिंग है। पूरे शरीर में बाल खींचने के बाद अगर वहां से जीवन कार्य ब्लड निकल रहा है तो रक्त धातु बिलोंगिंग है। जहां पे मांस धातु ज्यादा है वहां के बाल जो अनुलोम विलोम इस संरचना से चलते हैं वो मांस के है। शरीर में जहां पे मेद ज्यादा है वहां पे बाल हमेशा कम होते हैं। आप देखो स्फिक्स स्तन और उदर के यहाँ पे। शरीर में जहां अस्थि सारता अच्छी है वहां पे बाल बहुत अच्छे होते हैं। मज्जा के बाल यानी पक्ष्म नेत्र भ्रू के बाल और शुक्र के बाल यानी हमारे शरीर में सेकेंडरी सेक्सुअल कैरेक्टर्स प्रेजेंट होने के बाद आम पीठ में कक्षा जंघा प्रदेशी जो बाल आते हैं वो सप्त धातु के स्थूल रूप से केश के साथ संबंध हम उनका लगा सकते हैं। उसी प्रकार से सूक्ष्म संबंध अगर हम लगाना चाहेंगे कि एक केश में ये 7 धातु क्या काम करते हैं, तो सूत्र विस्तार मिलता है हमें। प्रीणम जीवनम लेपा स्नेहो धारण पूर्ण ही गर्भोत्पादश्च धातुनाम श्रेष्ठम कर्मत कर्मात् स्मृतम। तो एक केश में रस धातु प्रेरण करता है, रक्त धातु जीवन करता है, मांस धातु लेपन करता है, मेद धातु वहां का स्नेहन करता है, अस्थि धातु धारण करता है, केश में मज्जा धातु बालों को अंदर से पोषण करता है, और शुक्र धातु हमने सुना है बाल बच्चे पैदा करता है। तो अगर बाल चले गए तो नए बाल वहां लाने का कार्य भी शरीर का सार्वदेहिक शुक्र जो है वो केशगत रोमकूपगत जाके ये कार्य को करता है। ये सिस्टम हमें समझ में आ जाए तो पेशेंट आके लक्षण बताएगा मेरे रूखे सूखे बाल है तो आपको रसक्षय पता चलेगा। पेशेंट आके कहेगा कि बेजान बाल है तो आपको रक्तक्षय पता चलेगा। पेशेंट आके कहेगा कि मेरे हेयर का थिकनेस कम हो गया है तो आपको मांसक्षय पता चलेगा। पेशेंट आपको बताएगा कि मुझे एक्सेसिव ड्राइनेस है या एक्सेसिव ऑयली है तो मेद दृष्टि हो गया है, ये आपको पता चलेगा। पेशेंट अगर आके बोल रहा है कि मेरे बाल बीच से टूट रहे हैं तो वो अस्थिक्षय है। पेशेंट बोलेगा कि बाल अंदर से खोखले हो गए, वो बादाम ड्रॉप की ऐड आ जाती है, बालों को अंदर से पोषण करता है, तो वहां पे पूरन की जरूरत है क्योंकि वहां पे मज्जाक्षय है। और अगर नए बाल नहीं आ रहे हैं तो वहां पे शुक्र का क्षय है, हमने उसके ऊपर ध्यान देके उसके अकॉर्डिंगली रस धातु के लिए शतावरी घनवटी आप देंगे, रक्त धातु के लिए आप ताप्यादि लोह देंगे। मतलब आपको अभी औषधि कैसा देना है, रस पोषक और केश, रक्तवर्धक और केश, मांस पोषक और केश। तो रस पोषक और केश में शतावरी घनवटी अच्छा काम करता है, रक्त पोषक और केश में ताप्यादि लोह अच्छा काम करता है, मांस पोषक और केश में आप पटोल निम्बादि गुल दे सकते हैं, शतावरी घनवटी दे सकते हैं, मांसी घनवटी दे सकते हैं। मेद दृष्टि और केश ऐसा कार्य आपको करना है। हेयर रूट पेन भी कभी कभी पेशेंट्स को होता है तो आप सिंहनाथ गुगुल जैसा, मेदोर गुगुल जैसा, मेद केशायवटी जैसा औषध दे सकते हैं। अस्थि पोषक और केश कैटेगरी में आप ताप्यादि लोह दे सकते हैं, आप साथ में टैबलेट कैलैक दे सकते हैं। आप अस्थि का पोषण करने वाले अस्थि पोषक वटी आप यहाँ पे दे सकते हैं। मज्जा धातु और केश में आप ब्राह्मी वटी दे सकते हैं। शुक्र वर्धक और केश में आप शुक्र स्तंभक वटी या कपि कच्छू वटी या फिर अश्वगंधा घनवटी इस प्रकार की औषधियों का प्रयोजन कर सकते हैं। तो आपको वो पर्टिकुलर धातु वर्धक केश औषध आप अगर सिलेक्ट करेंगे तो हेतु फाइंड आउट करना है, लक्षण फाइंड आउट करना है और औषधि देना है। तो हेतु लिंग औषध ज्ञानम स्वस्थातुर प्राणम त्रिसूत्रम शाश्वतम पुण्यम बुबुदयम पितामह, यही त्रिसूत्री है। तो हेतु अगर वात का मिल गया आपको लक्षण भी दोष धातु मल में वात के मिल गए तो आपका औषधि भी वातगण और केश होना चाहिए। इस प्रकार से हर एक चीज सूत्र विस्तार में काउंट होती है और इसलिए आज का हमारा सिद्धांत आ रहा है एवरीथिंग इज काउंटेड। हर एक चीज काउंट होती है। स्थूल सूक्ष्म सूत्र विस्तार भी करो और सूक्ष्म रूप से सूत्र विस्तार भी करो। तो आज का टॉपिक स्किन एंड हेयर दोनों होने के कारण जैसे भी हमने आपको हेयर में सिखाया वैसे अभी स्किन में भी थोड़ा फास्ट हम देख लेते हैं कि त्रिदोष का सूत्र विस्तार किस प्रकार से होता है। हमें तो अभी हमने देखा कि वात जो है उसमें उदान वायु जो है वर्ण्य का कार्य करता है, वहां पे व्यान है आकुंचन प्रसारण का रोमकूप में भी काम करता है, पित्त में ब्राजक पित्त शरीर की कांति के ऊपर हमें उसका संबंध देखने को मिलता है, कफ का संबंध है। ओके, मतलब वात पित्त कफ का स्किन के साथ तो संबंध है ही, डायग्नोस्टिक एंगल में तो है ही, हम यहाँ पे ट्रीटमेंट के लिए भी उसका संबंध निकालते हैं। तो हमने अभी एक बुक पब्लिश किया 19 जुलाई को जिसका नाम था ईसीजी ऑफ स्किन। तो ईसीजी ऑफ स्किन एक सबसे अलग टॉपिक सूत्र विस्तार का, अभी जो मैंने आपको सूत्र विस्तार की कला सिखाई उस सूत्र विस्तार को ध्यान में रखे हमने एक बहुत बड़ा सूत्र विस्तार का एक वॉल्यूम 1 निकाला स्किन डिसीजेस के ऊपर। elevated, flat and depressed type of skin disease. There are only 3 types of skin disease. Skin diseases के केवल 3 ही टाइप्स होते हैं, या तो स्किन डिसीज एलिवेटेड होता है, या फ्लैट होता है, या डिप्रेस्ड होता है। तो जिस प्रकार से एलिवेशन, फ्लैट और डिप्रेस्ड वेव्स है, इन वेव्स को कोरिलेट ईसीजी के साथ किया है, क्योंकि ईसीजी में भी हमें इसी प्रकार से वेव मिलते हैं। तो इस मेथोडोलॉजी से 3000 स्किन डिसीज को आप बहुत अच्छी तरीके से डायग्नोस कर सकते हैं। तो वायु, पित्तम, कफोश्चेती, त्रयोदोषा, समासदा जैसे 3 ही दोष है जिसमें दुनिया में आए हुए सभी डिसीजेस का आप नामकरण कर सकते हैं। उसी प्रकार से स्किन में भी 3 ही दोष है, एलिवेटेड, फ्लैट एंड डिप्रेस्ड। इनको अगर हम एलिवेटेड लीजन्स, फ्लैट लीजन्स और डिप्रेस्ड लीजन्स वृद्धात्मक, स्वस्थान और क्षयात्मक के एंगल से, दोषाणाम त्रिविधा गति के एंगल से लेते हैं, तो एलिवेटेड लीजन्स बिलोंग्स टू कफ डोमिनेंसी, flat lesions belongs to पित्त dominancy and all depressed lesions belongs to वात dominancy। तो उनमें हमें एक डोमिनेंसी भी देखने को मिलती है जिनको इनको हम बहुत अच्छी तरीके से क्या कर सकते हैं, हम ट्रीटमेंट दे सकते हैं। एलिवेटेड, फ्लैट एंड डिप्रेस टाइप ऑफ लीजन्स को अगर हम समझेंगे तो हमने एक मोबाइल नंबर सिस्टम दिया है इसमें, तो हम किसी भी प्रकार को, किसी भी सिस्टम को इस मोबाइल नंबर की सिस्टम में डाल के डिसीज का डायग्नोसिस कर सकते हैं। हमारे आचार्यों ने कभी भी चरक डिसीज, सुश्रुत डिसीज, वाग्भट डिसीज ऐसे नामकरण नहीं किए हैं। हमें आयुर्वेदिक प्रकार से डिसीज का नामकरण करना चाहिए। आयुर्वेदिक निदान करेंगे तो हम आयुर्वेदिक चिकित्सा दे पाएंगे, एलोपैथिक हम निदान करेंगे तो हम एलोपैथिक चिकित्सा दे पाएंगे। कोई भी चिकित्सा पद्धति खराब नहीं है, उस चिकित्सा पद्धति का डायग्नोसिस होना चाहिए उस डिसीज को ट्रीट करने के लिए। जैसे एलिवेटेड टाइप ऑफ स्किन डिसीजेस में हम सॉलिड फील्ड एलिवेशंस देख सकते हैं, लिक्विड फील्ड एलिवेशंस देख सकते हैं, गैसेस फील्ड एलिवेशंस देख सकते हैं। ये अगेन सूक्ष्म रूप से सूत्र विस्तार है। ऑल सॉलिड फील्ड एलिवेशंस बिलोंग्स टू कफ डोमिनेंसी, ऑल लिक्विड फील्ड एलिवेशंस बिलोंग्स टू पित्त डोमिनेंसी एंड ऑल गैसेस फील्ड एलिवेशंस बिलोंग्स टू वात डोमिनेंसी। उनके भी आपको सब टाइप्स में एग्जांपल देखने को मिलेंगे, जैसे वॉट एंड स्किन टैग ये कफ डोमिनेंसी में आते हैं, वेसिकल्स और पस्चुल जैसे लीजन्स जो पित्त डोमिनेंसी में आते हैं, और एडिमा जैसे, शोथ जैसे जो वातज डोमिनेंसी में आ जाते हैं। द सेम वे जैसे एलिवेटेड हमने देखे, वैसे फ्लैट टाइप ऑफ स्किन लीजन्स में भी हमें 3 टाइप मिलते हैं, हाइपोपिगमेंटेड स्किन लीजन्स, हाइपरपिगमेंटेड स्किन लीजन्स एंड डिस्कलरेशन। Hypopigmentation belongs to kapha dominancy, hyperpigmentation belongs to pitta dominancy and discoloration belongs to vata dominancy। तो श्वित्र वगैरह जो प्रकार होते हैं, पिट्रेसिस अल्बा है, श्वित्र है, विटिलिगो, ये सब कफ डोमिनेंसी में आते हैं। मेलाज्मा, फ्रेकल जैसे एग्जांपल जो है वो हाइपर पिगमेंटेशन वाले पित्त डोमिनेंसी में आते हैं, और स्किन टैन हो या फिर लेंटिगो जैसे केसेस हो ये वात डोमिनेंसी में आते हैं। और जितना हम सटीकता से वात पित्त कफ को आइडेंटिफाई करेंगे उतना हम सटीकता से वहां पे औषधि दे सकते हैं। और इसलिए डिप्रेस टाइप ऑफ स्किन लीजन्स को भी अप टू एपिडर्मिस, अप टू डर्मिस, अप टू हाइपोडर्मिस, इस प्रकार से वात बिलोंगिंग एपिडर्मिस में आते हैं, पित्त बिलोंगिंग डर्मिस में आते हैं, और कफ बिलोंगिंग हाइपोडर्मिस तक चले जाते हैं। अब आपको लगेगा कि ये केवल मॉडर्न और आयुर्वेद का कुछ कोरिलेशन है क्या? नहीं, ये हमारे आचार्यों ने बहुत सोच समझ के ऑलरेडी लिखा हुआ है। उल्टा थैंक्स टू मॉडर्न साइंस कि उन्होंने इसको और प्रूव किया कि इस प्रकार के प्रकार होते हैं, जैसे स्किन और सप्त धातु संबंध। हमारे आचार्यों ने उस समय स्किन के 7 लेयर्स बताए, अवभासिनी, लोहिता, श्वेता, ताम्रा, वेदिनी, रोहिणी और मांसधरा। ये तो अभी अपना ये हम कह सकते हैं कि अभी मॉडर्न में स्ट्रैटम कॉर्नियम, स्ट्रैटम लुसिडम, स्ट्रैटम ग्रैन्युलोसम, माल्फिंजन लेयर, पार्टिकुलर लेयर, रेटिकुलर लेयर, सबक्यूटेनियस लेयर, अभी 7 लेयर पता चल गए। 150 साल पहले या 100 साल पहले हम कह सकते हैं हमारे आचार्यों ने 4-5 हजार साल से ये 7 लेयर्स बताए हैं। तो इस प्रकार से भी हमने इसका थोड़ा सा कंसेप्चुअल स्टडी करना चाहिए, और वो स्टडी अगर हम करते तो हमें पता चल जाता है कि हर एक धातु का एक लेयर बताया है जो धातु डोमिनेंसी बताता है। तो रस धातु डोमिनेंसी का अवभासिनी है, रक्त धातु डोमिनेंसी का लोहिता है, मांस धातु का श्वेता है, मेद का ताम्रा है, अस्थि का वेदिनी है, मज्जा का रोहिणी और शुक्र का मांसधरा है। हर एक के डिसीज भी अलग अलग है। तो रस धातु के सिद्म पद्म का कंटक अधिष्ठान है, रक्त के तिलक आलक नेच्छ व्यंग है, मांस के चर्मदल अजगल्लिका है। अब इसका फायदा क्या होता है कि उस पर्टिकुलर डिसीज की ट्रीटमेंट करनी है तो कौन से धातु के ऊपर हमें जाके ट्रीटमेंट करनी है, ये लॉजिक हमें इससे समझ में आ जाता है। और उसका मेडिसिन कहाँ मिलेगा, तो हमारे आचार्यों ने उसका मेडिसिन बताने के लिए रस धातु का, रक्त धातु का, मांस धातु का, हर एक का एक एक अध्याय दिया है। उस अध्याय में अगर हम जाएंगे, ज्वर निदान, रक्त पित्त, गुल्म, प्रमेह, कुष्ठ, शोष, उन्माद, अपस्मार, तो हमें इसका और कोलैबोरेटिव पढ़ाई करने को मिलता है, क्योंकि स्किन डिसीज हर एक डिसीज में आता है। आई रिपीट, एवरी डिसीज इज अ स्किन डिसीज। तो पांडु में भी आपको स्किन डिसीज देखने को मिलेगा, कामला में आपको स्किन डिसीज देखने को मिलेगा, रक्त पित्त में स्किन डिसीज देखने को मिलेगा, अतिसार में स्किन डिसीज देखने को मिलेगा। हर डिसीज में स्किन डिसीज आता है, क्योंकि हर एक व्याधि की जो परीक्षण विधि है वो दर्शन स्पर्शन प्रश्न से शुरू होती है, और दर्शन परीक्षा आप त्वक की ही करते हैं। केश और त्वक से ही दर्शन परीक्षा शुरू होती है, और इसलिए हमने दोष धातु मल को कभी भूलना नहीं है। पर्टिकुलरली अपने टॉपिक के लिए अगर हम केश और त्रिदोष संबंध, सप्त धातु संबंध, त्रिमल संबंध निकालते हैं, त्वक और त्रिदोष सप्त धातु त्रिमल संबंध निकालते हैं, इन्हीं के आधार पर एक मोबाइल नंबर बना के हम यूनिक डायग्नोस्टिक पैटर्न हमारा क्रिएट करते हैं, 3+7+3+5+6+11 के पैटर्न के हिसाब से। तो इस प्रकार के रिजल्ट्स आपको, चाहे वो सोरेसिस हो, चाहे वो और कोई व्याधि हो, इसमें आपको मिलेगा। अब यहाँ पे इस पेशेंट में दशांगगत प्लस आम काढ़ा दिया है। आई ऑलवेज से स्किन इज द लार्जेस्ट आमाशय, स्किन इज द लार्जेस्ट आमाशय, स्किन इज द लार्जेस्ट मलाशय। तो देखो, एक ही स्किन को सूत्र विस्तार करके, क्योंकि जो आम ज्वर में आमाशय से निकलता है वही आम त्वक में जाके रहता है, और उसको पाचन करने के लिए वहां पे अग्नि आ जाता है। तो जहां पे अग्नि है वहां अग्न्याशय, जहां आम है वहां आमाशय, जहां गर्भ है वहां गर्भाशय। तो अगर आम पूरे त्वक में आके रह रहा है, इसका मतलब पूरा त्वक क्या हो गई, पूरा त्वक आम का आशय हो गया। इसलिए त्वक जो है वो लार्जेस्ट आमाशय है। तो केवल आम पाचक वटी से शुरू करेंगे, आम काढ़ा से भी शुरू करेंगे, तो भी आपको एक्सलेंट रिजल्ट मिलेगा, क्योंकि आम पाचन से ही आदि स्किन डिसीजेस ठीक होते हैं। रस सारता ही त्वक सारता है, रस सारता ही रसोपिश्लेष्मवत, रस ही कफ वृद्धि है। तो जो मैंने पहले ही आपको बताया कि ये सब सिंक्रोनाइज्ड है, इस सिंक्रोनाइजेशन को हमने ध्यान में रखना चाहिए। इस प्रकार के क्रॉनिक एक्जिमा के केसेस भी रसपाचक प्लस कृमिगण टैबलेट केरेस, कैशोर गुगुल, आरगवत कपिलावटी, ऐसे औषधियों से, जो जैसे मैंने अभी कहा कि रस धातु को अच्छा करेंगे तो अपने आप त्वक अच्छा होने वाली है, क्योंकि रस सारता ही त्वक सारता है। तो उसके एक एक पाचक, उसके साथ अगर पर्टिकुलर उस कृमि पे जाने वाले कृमिगण औषधियां हम देते हैं तो एक्सलेंट रिजल्ट हमें मिलता है। तो हमें बस सोच बदलनी है। हर एक डिसीज को, केश हो, स्किन हो, या कोई भी शरीर का व्याधि हो, दीपन, पाचन, शमन, अनुलोमन, रक्त मोक्षण, या सभी प्रकार की चिकित्साएं करते समय, पंचकर्म की भी चिकित्साएं करते समय कुछ सिस्टम हमने ध्यान में रखने चाहिए। अगर वो सिस्टम त्रिदोष सप्तधातु त्रिमल पंचमहाभूत की हम ध्यान में रखेंगे, और उस आशय से हम औषधियों को पढ़ेंगे, उस आशय से। तो अगर इंद्रलुप्त है, कृमि है और केश्य कार्य आपको करना है, तो आप करंज का फूल दे दो। कफ वात शामक रसायन और मेद दुष्टि के ऊपर आपको काम करना है तो आप भृंगराज दे दो। आपको शुक्र क्षय जैसी संप्राप्ति और केश्य कार्य करना है तो पाटला दे दो। ट्राइकोप्टिलोमेनिया जैसे व्याधि है, जो खुद पेशेंट अपने हाथ से बालों को खींचता है, तो आप ग्रंथ में आया हुआ नागकेशर दे दो। पुरुषज कृमि है और कुष्ठ है, स्किन डिसीज के साथ केश विकृति है, तो आप सप्तपर्णा दे सकते हैं। धी ध्रुति स्मृति के विकृतियां है और उसके कारण केश पतन हो रहा है, तो आप ज्योतिषमती जैसा औषधि दे सकते हैं। आपको कटु पौष्टिक देना है तो पाठा है। छोटे बच्चों में स्किन डिसीज और हेयर डिसीज के प्रॉब्लम है तो अतिविषा जैसा आप मेडिसिन दे सकते हैं। तो इस प्रकार से कौन सा मेडिसिन हम प्लान आउट करें, इसके लिए ये चीजें समझना बहुत जरूरी है, क्योंकि हमारे ग्रंथकर्ताओं ने किसी एक वनस्पति को भी कुछ वर्णन उसका किया है, तो वो वातग्न है, पित्तग्न है या कफग्न है, कौन से दोष के ऊपर, कौन से धातु के ऊपर, कौन से मल के ऊपर क्या कार्य करती है, इस प्रकार से हमें उसका वर्णन जो किया है वो पढ़ने को मिलता है। जो मैं हमेशा कहता हूं कि चित्रक के बारे में भी अगर हम देखेंगे तो उसका श्लोक पढ़ते समय हमने ये ध्यान में रखना चाहिए कि चित्रक के अर्शोगण बताई है, लेकिन वही चित्रक जो है वो पित्तज अर्श में कष्ट देती है, वो कफज अर्श में उत्तम है। ओके, तो इस प्रकार से उसका दोष क्या है, उसका धातु क्या है, ये हम समझेंगे तो हम बहुत अच्छी तरीके से चिकित्सा दे पाएंगे। केवल आयुर्वेद के सूत्रों का विस्तार यहां तक ही सीमित नहीं है। कॉस्मेटोलॉजी एंड ट्राइकोलॉजी में जितने भी मॉडर्न मशीन्स है, उन मशीन्स को भी हम इसी सूत्र का विस्तार करके यूटिलाइज कर सकते हैं। जैसे अभी आज आयुर्वेद टीचर्स एसोसिएशन का इतना अच्छा सेमिनार चल रहा है, वो हम ऑडियो विजुअल माध्यम से लेटेस्ट मॉडर्न मशीन्स के जरिए तो सीख रहे हैं। जूम के माध्यम से, एक मोबाइल के माध्यम से हम अपने अपने जगह से इसको सीख रहे हैं। तो टेक्नोलॉजी किसी की भी नहीं है, जो यूज करेगा उसकी है। तो आयुर्वेद अगर टेक्नोलॉजी को यूज करेगा तो टेक्नोलॉजी आयुर्वेद की है, मॉडर्न साइंस यूज करेगा तो वो मॉडर्न साइंस की है। इसलिए इनोवेटिव आयुर्वेदा, ये कंसेप्ट ही मुझे बहुत अच्छा लगा। तो हमने हर एक फील्ड में इनोवेशंस लेके, ऑलरेडी हुए हुए इनोवेशंस को भी ध्यान में रख के हमारे आयुर्वेद के साथ हम उसको कैसे यूज कर सकते हैं वो देखना चाहिए। जैसे ग्रंथ में पंच छाया आई है अवभासिनी के ऊपर, नाभसी, वायवी, आग्नेयी, जलीय और पार्थिवी छाया। उस हर एक छाया का एक एक महाभूत है, पृथ्वी, आप, तेज, वायु, आकाश। इस प्रकार से हर एक महाभूत एक एक कार्य करता है वहां पे। जैसे आकाश में क्लैरिटी, लाइटनेस, फ्रेशनेस स्किन का वो मेंटेन करता है। वायुवीय छाया जो है वो ड्राइनेस, रफनेस, स्केलिंग को मेंटेन करती है। आग्नेय छाया रेडियंस, वार्मथ एंड ब्रिलियंस को मेंटेन करती है। जलीय छाया मॉइस्चर, स्मूथनेस और सॉफ्टनेस को मेंटेन करती है। पार्थिवी छाया फर्मनेस, टेक्सचर को मेंटेन करती है। ओके, और इस हर एक के ऊपर जाने वाली एक एक मशीन है। तो जैसे वैक्यूम सेबिस्फियर है, वो नाभसी छाया को कंट्रोल करते हैं। डैंड्रफ रिमूवल एयर जेट है, वो वायवी छाया से दुष्ट चीजों को, डैंड्रफ भी निकालने को, क्षेपता बहिर्मलाना, इस सूत्र का विस्तार करके आप उसको यूज कर सकते हैं। अग्नि का जो है आरएफ जो है वो आप यहाँ पे यूज कर सकते हैं। उसका आरएफ के रेडिएशन से वहां पे कोलाजन रिमॉडलिंग होता है, थर्मल स्टिमुलेशन होता है। ओके, ऑक्सी हाइड्राजेट में आप केवल जल महाभूत का ही तो इस्तेमाल कर रहे हैं। मॉइस्चर, स्मूथनेस, सॉफ्टनेस हिल गया है तो हाइड्रेशन मेंटेन करने के लिए, ऑक्सीजन इन्फ्यूजन के लिए। ओके, इंपोर्ट स्किन के सभी उसका जो टेक्सचर मेंटेन करने के लिए आप ऑक्सीहाइड्राजेट को यूज कर सकते हैं। और माइक्रोडर्मा एब्रेजन जो है, जिसमें क्रिस्टल और डायमंड के फंक्शंस है, वो आप एक्सफोलिएशन के लिए, स्मूथर टेक्सचर के लिए यूज कर सकते हैं। पृथ्वी महाभूत का फर्मनेस, टेक्सचर या स्ट्रक्चरल इंटीग्रिटी खराब हुआ है तो उसको ठीक करने के लिए कर सकते हैं। तो शास्त्र में जो कुछ दिया है उसका हमने ज्यादा से ज्यादा सूत्र विस्तार करना चाहिए। सूत्र विस्तार हम करते रहेंगे। तो जैसे भी शिंदे मैडम ने भी लेक्चर में बताया कि बेस्ट आयु स्टार्टअप अवार्ड का विनर है 2022 के, इंडो डच आइकॉन नेदरलैंड्स में मिला है। ओके, उसी के साथ रशिया में भी आयुर्वेद एम्बेसडर के तहत एक दिन आयुर्वेद डे पे जाने का मौका मिला, ब्रिक्स को रिप्रेजेंटेशन करने का मौका मिला। यूके में, लंदन में भी काया आयुर्वेद के क्लिनिक्स है। ऑस्ट्रेलिया में है, अय्या दिल्ली के साथ भी, और जामनगर के साथ भी रिस्पेक्टेड कोटेचा मैम, रिस्पेक्टेड नेसरी मैम, इन सभी के गाइडेंस से एक केशायुर्वेद, काया आयुर्वेद को बहुत अच्छी तरीके से सिस्टमेटिकली और विद केस स्टडीज, ग्लोबल एंटरप्रेन्योर्स कॉन्क्लेव दुबई में भी इसके ऊपर प्रेजेंटेशंस किए हैं काफी, और अभी लंदन में भी हुए हैं। 100 से ज्यादा इसके बैचेस हुए हैं। अगर हम अपने सूत्रों को विस्तार करेंगे, शास्त्र के ऊपर हम अतीव श्रद्धा रखेंगे, आयुर्वेदोपदेशेषु विधेय परम आदरः, तो उसमें जो सॉफ्टवेयर का एक पासवर्ड दिया है परम आदरः, तो उस परम आदर को हम ध्यान में रखेंगे तो हम भी अपने आयुर्वेद शास्त्र की जो गरिमा है वो और बढ़ा सकते हैं, उसको और ऊंचाई पे लेके जा सकते हैं। पूरा जो वर्ड है वो आयुर्वेद के लिए वेटिंग में है, वो आयुर्वेद की सेवा चाहता है, लेकिन लेटेस्ट टेक्नोलॉजीज को यूज करके हमने इस पूरे आयुर्वेद को लोगों को हम सर कर पाए, उनको इजीली एक्सेप्ट हो पाए, डाइजेस्ट हो पाए, इस मॉडल में हमने रिप्रेजेंट करना चाहिए। मैं पूरे टीचर्स ग्रुप का बहुत ही मन से दिल से आभार व्यक्त करता हूँ, उन्होंने मुझे यहाँ पे अपने विचार प्रेजेंट करने का मौका दिया। शॉर्ट में मैंने हेतुलिंग औषध, त्रिदोष, सप्तधातु और त्रिमल को हम कैसे सूत्र विस्तार कर सकते हैं इसको रिप्रेजेंट करने की कोशिश की। वैसे तो 8 डेज का बहुत बड़ा लंबा चौड़ा कोर्स है इसके ऊपर, पर जितना हो सके उतना सूत्र रूप में, नाति संक्षेप और नाति विस्तार करने का मैंने प्रयास किया। इसी के साथ मैं रुकता हूँ। थैंक यू वेरी मच।
Thank you so much, sir. It was a very wonderful session. I invite Dr. Ghanshyam Kodwani, sir, to present his remarks.
सभी को नमस्कार मेरा।
नमस्ते सर।
एटिकॉन की तरफ से जो आज का प्रोग्राम अरेंज किया गया ऑनलाइन, ये न्यू कमर्स, नए विद्यार्थियों के लिए बहुत अच्छा इनोवेटिव प्रोग्राम है। बहुत अच्छा लगा सुन करके। विशेषकर डॉक्टर हरीश पाटनकर ने जो हमें एक सूक्ष्म बुद्धि के ऊपर फोकस किया कि आप स्थूल रूप से मत देखिए, किसी भी चीज को बहुत सूक्ष्मता से देखिए। उन्होंने जैसा बोला कि सामान्य सोचने से सामान्य निदान होता है, आप विशेष सोचिए। मुझे सामान्य विशेष सिद्धांत अलग तरीके से मालूम था, लेकिन आज मुझे सामान्य विशेष सिद्धांत का नया ज्ञान हुआ कि सोचने में भी सामान्य विशेष सिद्धांत रहता है। आप लोगों ने, आप डॉक्टर पाटनकर सर ने जो केश के ऊपर बताया कि आप त्रिदोष के ऊपर से केश संबंध बता रहे हैं, ये एक अलग कल्पना हमें लगी। आयुर्वेद में केश और प्रकृति केश में वर्णन है कि कफ प्रकृति वाले के कृष्ण केश रहते हैं, वातज वाले के पिंगल रहते हैं, बट उसमें भी आपने अलग अलग करके उसका डिवीजन किया। ये एक अच्छी सोच हमें लगी। और केशों की चिकित्सा करते समय आपने जो सप्त धातु के द्वारा उसका संबंध बताया है, ये एक अलग कल्पना हमें लगी कि हम देते हैं, हम केश की चिकित्सा करते समय केवल रस धातु का ही विचार करते हैं, उसी के हिसाब से चिकित्सा देते आ रहे हैं। लेकिन आपने बताया कि नहीं, उसके साथ रक्त धातु की भी दे सकते हैं, उसके साथ आप मांस मेद अस्थि मज्जा धातु की भी चिकित्सा दे सकते हैं, और आप देते हैं, और आपका अनुभव भी अच्छा है। ये एक नए विद्यार्थियों के लिए बहुत अच्छी उनको एक कल्पना मिली है, और उनको आगे जाने के लिए बहुत अच्छा संबंध मिलेगा। उसी तरह आपने त्वचा रोगों के बारे में भी अच्छे से वर्णन किया है। जैसे हम त्वचा रोग में जो भी डिफॉर्मिटी स्किन पर देखते हैं, उसमें आपने डिविजन्स किए, एलिवेटेड है, फ्लैट है, या डिप्रेस है। ये एक नई कल्पना आपने यहाँ हमारे सामने रखी, अच्छा लगा सुन करके। और उसी हिसाब से आप चिकित्सा भी करते हैं, ये एक अच्छी बात है। और आयुर्वेद में जो एक स्थूल रूप से वर्णन है, ये केश का या त्वचा के बारे में या त्वचा रोगों के बारे में, या हम स्टूडेंट को जैसे बताते कि भाई कुष्ठ रोग जितने भी बताए हैं ये सब त्वचा रोगी है, वो सब स्थूल रूप में है। आप उस स्थूल कल्पना को बहुत सूक्ष्मता से बताने की आपने बहुत अच्छी कोशिश की। एक नई कल्पना मुझे बहुत अच्छी लगी कि आप बेल्ट पहनने वाले व्यक्ति का बेल्ट किस स्थान पर है उसके आधार पर आप प्रकृति का डिसीजन लेते हैं। पर मेरे दिमाग में एक ही प्रश्न बार बार आ रहा था कि कफ प्रकृति वाली की तो टमी बड़ी रहती, बेल्ट उतना ऊपर जाएगा कैसे? उसका तो बेल्ट नीचे खसक जाता है। ये बड़ा अलग कल्पना थी, अलग सोच थी, सुनकर अच्छा लगा। और इसी तरह से ये जो आयुर्वेद टीचर एसोसिएशन ने आज का प्रोग्राम अरेंज किया है, एक अच्छी इनोवेटिव कल्पना है। और इसमें मुझे उन्होंने कुछ बोलने का चांस दिया है, चेयरपर्सन का सम्मान दिया है, इसके लिए मैं उनका आभारी हूँ। थैंक यू वेरी मच।
थैंक यू सर, थैंक यू वेरी मच।
Thank you, sir, for your valuable remarks. Now, I invite our co-chairperson, Dr. Rohini Salve, ma'am, to present her remarks. Rohini Salve, ma'am. Please unmute yourself. I can see ma'am in meeting, but
Give me 1 minute, ma'am. I will check.
yes, I can see her in meeting, but maybe till then I will ask our other co-chairperson. Dr. Meghanandini, ma'am, would you be able to
Yes.
give remarks now?
Yes, yes. Am I audible?
Yes, ma'am, you are audible.
Yeah,
Please.
okay. Okay. Thank you, Harish Patankar sir, for giving such a informative lecture. Uh, Cosmetology is now a very flourishing field, and sir is doing a very good job in that. And he is training our students also. And because why this is the need of this hour? Because these beauty parlors are spreading like mushrooms, and they are claiming so many tall claims. We are doing this and we are doing that, and people are going to them. So we need doctors and we need cosmetologists, especially from Ayurveda, which can people can trust on. And sir has given us specific cosmetic concepts. His concepts like observation for understanding people's prakriti by observing them. Then Madhya, Anta, that concept. Then Sutra Vistar. These were so innovative ideas given by sir, and I was really very happy to see whatever he was explaining, and I was really understanding something new from it. And thank you, sir, for giving us such a highly informative session. And because we need so many people in this industry, as it is a very fastest growing consumer market globally. So thank you so much, sir. Thank you for explaining it so nicely.
Thank you.
Thank
Thank
you
you,
so
ma'am.
much, ma'am. Thank you so much, ma'am. Is Rohini Sarve ma'am available now?
Am I audible?
Yes, ma'am. You're audible
Sorry,
now.
no,
Yes,
no,
you're
sorry,
audible now.
extremely
Please.
sorry. I was not able to actually unmute myself.
It's okay, ma'am.
So,
Please proceed
yes,
with your remarks.
yes. Good afternoon, everyone. Thank you. I got the opportunity to co-chair this very interesting session on Ayurvedic cosmetology and trichology by Dr. Harish Patankar, sir. Like it is said, Ayurvedic cosmetology and trichology is one of the most demanding branches today. It is not just beauty, it is about swasthya se saundarya. Healthy skin and hair reflects healthy internal metabolism. So, actually, Dr. Kodwani sir has already very beautifully summarized the lecture. But I would like to add some that Dr. Harish sir beautifully explained different clinical cases with exact Samprapti Ghatak and Samprapti Bhanga. And the most important question for a practitioner, that is how. Then Sthula and Sukshma Prakriti Parikshan by Yukti Praman. And there were many new concepts, for example, correlation with Dhatu, Dosha and Mala, etc. Classifying all the skin disease into the three types, that is elevation, flat, and depression, etc. And the most important sentence, that is skin is the largest amasya, which is clinically very important. So, a very informative lecture. As a clinician, we also learn very new things, which will we will now use in our day-to-day practice also. Lastly, I would like to thank you, organizers of this 8th National Conference of the Ayurveda Teachers Association. And I will like to congratulate Dr. Harish Patankar sir for his wonderful lecture. Thank you.
Thank you so much, ma'am, for your valuable.
थैंक यू वेरी मच सर और मैम हमेशा हमारे कॉलेज डेज से हमें मोटिवेट करते आ रहे हैं, और हम जुवेकर सर के पास भी साथ में सीखने को थे, तो उनकी तरफ से हमारी स्तुति सुनना हमें और बहुत अच्छा लगा. इट्स लाइक ब्लेसिंग्स फॉर अस. थैंक यू मैम. थैंक यू वेरी मच.
वेलकम.
So on behalf of organizing committee, I would like to express profound gratitude to our respected profound keynote speaker, Dr. Harish Patankar sir, for sharing valuable expertise. Then we are deeply grateful for chair and co-chair persons for this session, for your valuable remarks and observation. And thank you, Priyanka ma'am, for coordinating this session. Thank you for your untiring efforts and managing our timeline very smoothly. Now moving ahead to our sixth session. The speaker for this session is Dr. Mohammad Nisam sir, and topic is diagnosis and management of headache. And for this session, we have coordinators, Dr. Shanti Nair ma'am and Dr. Amol Deshpande sir. Are both are here?
Yes, madam, am I audible?
Yes, you are audible. So I firstly welcome Dr. Shanti Nair ma'am, Associate Professor, Department of Agat Tantra, Sri Swaminarayan Ayurved College, Ahmedabad, Gujarat. I welcome you, ma'am.
Thank you, ma'am.
Then I welcome Dr. Amol Deshpande sir, Associate Professor, Department of Rachna Shari, Mahatma Gandhi Ayurved College, Hospital and Research Center, DMIHER, Wardha, Maharashtra. I request you both to move ahead for the next session. Over to you. Thank you.
Okay. Thank you, ma'am. Good evening, one and all. I warmly welcome all of you to the session 6 of today's academic series on behalf of Ayurveda Teacher Association on today's topic diagnosis and management of headache, a highly relevant in clinical practice. It is now my privilege to introduce our esteemed speaker, Dr. Mohammad Nisam Sir, Assistant Professor, Department of Shalakya Tantra, Government Ayurveda College, Kannur. Sir is a distinguished academician and clinician with over a
Madam,
decade. Yes, ma'am?
kindly rewind your slide. It is now Sangeeta
Yeah, yeah.
Salvi ma'am slide.
Amol, sir? Hello, Amol. Okay. Sir is a distinguished academician and clinician with over a decade of teaching experience in the field of Ayurveda. He holds a BMS degree from Nangelil Ayurveda College, Kodamangalam, and MD in Kriya Sharira from Government Ayurveda College, Kannur, and an MS in Shalakya Tantra from Government Ayurveda College, Tripunithura. His academic contribution include presentation at various national seminars and active involvement in curriculum development. He has been appointed by NCISM as an HSET expert for the UG Shalakya CBDC syllabus framing workshop. Dr. Nisam sir has also contributed a chapter to an upcoming publication on Kriya Kalpa authorized by Dr. Shrija Sukeshan currently in a pre-publication stage. And his areas of interest include Ayurvedic management of ophthalmic, ENT, and headache disorders, integration of modern diagnostic modalities with Ayurvedic therapeutic. We welcome you, sir.
Is my voice is clear? Hello. 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 Hello.
Yes, Amol, sir.
Hello. Hello.
Yes, sir.
Is my voice is clear, ma'am?
Yes, sir.
Okay.
So your voice is clear
Sir, can
but
you,
not louder. Will you please increase your voice volume?
Is it okay now?
sir, kindly increase the volume, sir?
Hello. Is it okay now?
Yes, sir.
Okay. Then for our today's session, we have with us our chairperson, Dr. Sangeeta Salvi ma'am. Ma'am is the principal professor and HOD of Shalakya Tantra at Tirak Ayurved Mahavidyalaya, Pune. She has over 30 years of teaching experience along with the specialty in ENT practice. Has been a professor since 2007 and has performed more than 5,000 ENT surgeries with a special interest of ear surgery, otology, and cochlear implant. She completed BMS in 1991, Diploma in Shalakya Tantra in 1994, and MS in 2000. And ma'am also a PhD holder from 2019. She has served as a founder member and a president of Association of Shalaki and a general secretary of Association of Integrated Medical Specialist of India.
Her research interest includes degenerative hearing loss, tinnitus, chronic allergic rhinitis, pollution-related ENT disorders, and yoga. With a research on Madhu, Ashwagandha, Apamargakshar, Yashti Madhu, Grita, Rasayan Chikitsa, and yoga. She presently working on a textbook of Shalakya Tantra. She has received a Best Paper Award, Best Teacher Award, and Legend Shalaki Award. She has guided more than 50 PG students and is currently guiding 6 PhD scholars. She has served as examiner, referee, resource person, keynote speaker, subject expert for the Pune University and MUHS, and CCIM expert for standard treatment guidelines. Most importantly, she served as a chairman of NCISM syllabus committee for UG and PG Shalakya Tantra, and also organizing secretary of the International Conference on Shalakya Tantra in 2019. I welcome you, ma'am, on behalf of Ayurved Teacher Association for today's conference. Welcome you, ma'am.
Now, may I take the privilege of welcoming our co-chairperson, Dr. Sri Kumar M.K. Sir, who is MS in Shalakya Tantra, Associate Professor, Department of Shalakya Tantra, Government Ayurveda College, Tirunelveli, Kerala, is a highly accomplished academician and researcher over 23 years of teaching experience in Ayurveda. A university first rank holder in BAMS Government Ayurveda College, Tripunitara, he secured first rank and gold medal in MS Shalakya Tantra from IPGTRA and was honored with National Ayurveda Scholar Award during his PhD from IPGTRA. He is a recognized guide, a PhD guide and PG guide from KUHAS, and his research contribution includes projects in cataract preventions using Pratimarsha Nasya and Anjana, as well as clinical translation research in Ayurvedic ophthalmology. Dr. Sri Kumar serves in a multiple academic and regulatory capacities, including Board of Studies, and he is a member of Institutional Ethics Committee in KUHAS, Research Committee member, expert panel member of CCRS, and Data Safety Monitoring Board member. Sir has more than 20 publications, and he has authored a book called Anusandhana, a research methodology biostatic book. His excellence has been recognized through several prestigious awards, including Dabur Ayurveda Award, Nagarjuna Research Foundation Award, National Ayurveda Scholar Award, and Atacon Best Teacher Award in 2025. So we welcome you.
Our joint co-chairperson, Dr. Sunil Borkar sir, BMS, MD and PhD, is the professor and HOD of Kai Chikitsa at Sri Gurudev Ayurved College, Gurukunj Ashram, Mosri, Maharashtra. With 22 years, more than 22 years of teaching, clinical and academic experience. He completed BMS from Vidarbha Ayurved College, MD Kai Chikitsa from National Institute of Ayurveda, Jaipur, and PhD from MUHS, Nashik in 2025. He has published several research articles and completed MUHS funded research and research project and participated in 2 sponsored multicentric clinical trials. His research covers Ambat, Sandigatvat, liver disorders, psoriasis, chronic renal failure, and dyslipidemia, including on MUHS funded study on Kshirabala Tel Matra Basti with and without Janubasti, liver disorder clinical trials, and research on Erendamul in dyslipidemia. He has contributed actively to the academic community as a guest speaker, chairperson, co-chairperson, expert faculty, jury member, and reviewer at various professional forums. His academic interest encompass the Kai Chikitsa, evidence-based Ayurveda, clinical research, teaching, and research guidance. He regularly contributes through conferences, presentations, seminar, workshop, CMEs, and health-related newspaper articles. And now we come to the most awaited part of this session. It's my privilege to invite our esteemed speaker, Dr. Mohammad Nisam sir, to deliver his expert talk on diagnosis and management of headache. Sir, we are eager to learn from your knowledge and your clinical experience. With a great pleasure, I welcome you and request you to kindly take over the session. The virtual platform is yours, sir. Nisam sir?
So you are not audible. Hello, Nisam sir. Sir, you are not audible, sir.
Sir, you are not audible. Sir, are you able to share your slides, or I will share it for myself?
Hello. Can we unmute, sir? Hello. Hello. Can we unmute? Madam, can we unmute, sir? Sir has put a message like he has joined
Yes,
from
yes,
another
yes,
link.
yes, I will.
Yes, ma'am.
Yeah. Am I audible now?
Yes, sir. Yes, you are audible now.
I'm sorry, there was some technical issue.
No issue, sir.
All right. So thank you so much, ma'am. First of all, I would like to thank the organizers for giving me this opportunity. And it's actually a great privilege to have a session with stalwarts of Ayurveda like Sangeeta Salvi ma'am, Sri Kumar sir, etc. So very good afternoon, one and all. Without any delay, let's start with the presentation.
Sir, do we share the PPT from our side?
Should I share or will you share the presentation?
Sir, we will share. Okay, we will share. Amol sir.
If necessary, I can share. No problem.
Okay, sir, you can share then. No, sir, Amol sir is sharing.
Yeah.
Yeah, okay.
Okay. Sir, could you please click that hide on that message? Yeah, thank you. So next slide, sir. Next slide, sir. Okay, as we all know, headache is a pain or discomfort arising from the pain-sensitive structures in the head. So actually, headache is a common complaint that we are encountered in our OPDs, especially not only the complaints comes into specialist OPD or Shalakya OPD. Headache is a presently complaint encountered by almost all practitioners, including the general practitioners. And the relevance of headache is it affects majority of the population, and it reduces the quality of life in a greater extent, and it even make the life of the person who is suffering from headache very miserable. So moreover, the headache affects the people mostly in their productive years of life. And when it comes to the diagnosis of headache, actually a proper differential diagnosis is very much essential, because most of the people coming to our OPD who's having a modern consultation history or modern medicine history, they say that I'm suffering from migraine. But when we analyze the case in detail, most of the cases may not be migraine, because the modern people, they have the management for almost all conditions are painkillers. So they will console the patient, or they will address the patient saying that you are suffering from migraine, and they will prescribe some painkillers. So moreover, a headache may be a sign of some life-threatening emergencies or life-threatening conditions. So having a proper differential diagnosis is very much essential when we address a patient who's having any kind of headache. Next slide, sir. So headache arises from intracranial and extracranial structures. Actually, the brain itself is insensitive to pain. The brain tissue is not sensitive to pain, but the headache arises from other pain-sensitive structures located in the head, like arteries, intracranial venous sinuses, then dura mater and dural arteries, cranial nerves, and other extracranial structures, including the bone. Next slide, sir. So, in order to diagnose the headache properly, we should have a clear understanding of the international classification of headache disorders. Actually, next slide, sir. Actually, the ICHD third edition is available right now, and it is published by the International Headache Society. The ICHD classification is a very vast classification, and it is very much difficult for us to by heart the classification. So we can refer the classification for having a clear-cut understanding of different types of headache. And ICHD classification is the official classification of WHO. It is a hierarchical classification. Hierarchical classification in the sense, for example, when it comes to migraine, they have different subcategories, and each subcategory has again many subcategories. So a lot of a diverse classification we can see in ICHD classification, which makes it difficult to by heart. At the same time, it's an easy tool for us to refer regarding headache. Almost everything related to headache is available in the ICHD website. The link of the website is given in this slide, or you can find the website by just Googling ICHD3. Next slide, sir. So the ICHD classification has three parts. Part 1, primary headaches. Part 2, secondary headaches. And part 3, painful cranial neuropathies, other facial pains, and other headaches. So these are the three parts of ICHD classification. Next one, sir. The primary headaches. Actually, the primary headaches, under the classification of primary headaches, there are 4 diseases. First one is migraine. Second one is tension type headache. Third one is trigeminal autonomic cephalgias. And fourth one is other primary headache disorders. Next one, sir. And the part 2 is secondary headaches. So all the secondary headaches comes under part 2. And the part 2 includes headache attributed to injury to the head and neck, or headache attributed to cranial or cervical vascular disorders, non-vascular intracranial disorders, a substance or its withdrawal, headache resulting from any type of infection, or headache resulting from any disorder of homeostasis, headache or facial pain attributed to disorder of the cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, or other cervical structures, and headache attributed to psychiatric disorders. All this comes under the part 2. And part 3 includes neuropathies, facial pains, and other headaches. So it has 2 classifications: painful lesions of the cranial nerves and other facial pains, which includes headache like trigeminal neuralgia, trigeminal neuralgia or occipital neuralgia. All this comes under this classification. And the last classification is other headache disorders. Next one. So as I mentioned earlier, the primary headaches include migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headache disorders. Due to time constraints, I'm planning to explain migraine in detail. Next one, sir. So migraine is classified like this. This is the hierarchical classification of migraine given in the ICHD classification, which include migraine without aura, migraine with aura, and migraine with aura has a further subclassification like migraine with typical aura, brainstem aura, hemiplegic migraine, and retinal migraine. Then other classifications are chronic migraine, complications of migraine, probable migraine, and episodic syndromes that may be associated with migraine. So these are the hierarchical classification of migraine given in the ICHD classification. Next one. So migraine is an inherited episodic disorder involving sensory sensitivity. We are all aware that it's an episodic disorder, and it is ranked as third most prevalent disorder and seventh specific cause of disability. So this statistics gives us an idea regarding the disease load or disease burden of migraine caused in the society. Next one. So it affects quality of life. Like any other headache, it affects quality of life and ability to participate in work, family, and social events. And the diagnostic difficulty is it may get confused with other types of headache, especially tension type of headache. So some tension type of headache is the most important differential diagnosis of migraine. And the major subtypes, as I mentioned earlier, the major major subtypes of migraine are migraine without aura and migraine with aura. Next one. It has a prodromal and a postdromal phase also. So prodromal phase means prior to the onset of migraine, the patient may have certain symptoms, and postdromal symptom phase means some hangover phase, or at the end of the migraine or after relieving from migraine, the patient may have certain symptoms, which is known as postdromal phase. So it is seen only in some patients. Not all patients give the history of prodromal or postdromal phase. The prodromal phase usually starts hours or days before the headache, and postdromal phase is usually after following headache resolution. Next. The symptoms of prodromal phase include hyperactivity, hypoactivity, depression, cravings for particular foods, repetitive yawning, fatigue, neck stiffness, and of pain. So all these symptoms make the patient aware that the patient is about to have a migraine attack. So most of the patients, they become vigilant after having the symptoms. Next slide. The first classification, first type of migraine is migraine without aura. So it is previously the name of this migraine, this condition was common migraine or hemicrania simplex. So the condition is characterized by a recurrent headache disorder, which is having specific features and associated symptoms. The duration of migraine is for when it comes to diagnosis of headache, the duration is very much important. So when it comes to migraine without aura, the duration is usually 4 to 72 hours. Next slide, sir. Then typical characteristics of the disease are unilateral location. Most of the patients suffering from migraine without aura, they are having a unilateral pain. Only one side of the head may be affected. It may be either right side or left side. And the patient may have alternate affections of the either right or left side. Then pulsating quality. The quality of the pain may be pulsating in nature. The intensity of the pain may be moderate or severe intensity. Usually it is a debilitating disorder, and it makes the patient to stay in bed. Next one is aggravation by routine physical activity. Routine physical activity like walking, climbing stairs, or other routine activity may worsen the condition, and the disease may make the patient to avoid daily routine activities. Then the condition is usually associated with nausea, vomiting, photophobia, and phonophobia. Next slide. So this is the pattern of the migraine. It affects one half of the body. Next slide. Next one is migraine with aura. So actually the term aura means transient focal neurological symptoms. Transient means these are temporary. Focal means it affects, it is due to involvement of focal areas of the neurological system. So the aura usually precede or sometimes accompany the headache. Usually aura comes first, followed by the headache. And sometimes the aura may extend into the phase of headache as well. So some patients also experience a premonitory phase which occur hours or days prior to the headache. As I mentioned previously, there may be a prodromal phase. Next one, sir. An aura is usually unilateral, and it is fully reversible. It includes visual, sensory, or other central nervous system symptoms. Usually the aura develops gradually in the sense, usually it may take 5 minutes or more to develop the aura. Aura starts gradually, and within a period of not less than 5 minutes, aura develops and it reaches its peak. And it is usually followed by headache and associated migraine symptoms, which means aura usually lasts for up to 1 hour. So from 5 minutes to 1 hour, aura may last, and usually it is followed by headache. And the headache may follow the aura within 60 minutes. Next slide. So aura usually occurs before the headache and may begin after the headache phase has commenced or continue into the headache phase. Most common type of aura is visual aura, and the next in frequency is sensory disturbances, and less frequent are speech disturbances like aphasia. Sometimes the patient may exhibit multiple types of aura. Multiple types of aura means the same patient may have visual aura, sensory aura, aphasia, like that in a single attack of migraine, which means patient may first have visual aura, which is followed by sensory aura like that. So in a single attack, the patient may have multiple aura symptoms. Next one. Visual aura. The most common type of aura is visual aura, which accounts for about 90% of aura symptom. So the commonest aura symptom is a fortification spectrum. Fortification spectrum means a zigzag figure near the point of fixation. The fortification spectrum develops as a zigzag figure near the point of fixation, and gradually it may shift to right or left and assume a laterally convex shape with an angulated scintillating edge. In other cases, scotoma without any positive phenomena may also occur. So usually the aura symptom is a zigzag or a fortification spectrum, and in some cases there may be scotoma may occur as an aura symptom. Next slide. So this is a picture of previous slide, sir. This is the picture of fortification spectrum. This picture is very much helpful to show or helpful to take the history of the patient in the clinic. When a patient approaches me with visual aura, usually I search for this image. Just search for fortification spectrum. So the image, Google will give us the image, and we can show this picture to the patient so that the patient can confirm that this is the aura symptom the patient is experiencing. Next slide, sir. So sensory disturbances. So second in severity or second in incidence is sensory aura. So sensory aura usually it is presented as pins and needles or numbness. Usually patient experiences it as tingling sensation or numbness. So it's moving slowly from the point of origin, and it usually affects one side of the body, face or tongue. Less frequent are speech disturbances or usually aphasia. Next one, sir. That's also an important one. Previous slide, sir. Some patients may have migraine without aura, or some patients having migraine with aura may have migraine without aura attacks as well, which means the patient, it is not mandatory to have migraine with aura always. Sometimes the patient may have migraine with aura, and some other times the same patient may have attacks of migraine without aura as well. Next slide, sir. So migraine with aura is again classified into migraine with a typical aura, migraine with brainstem aura, hemiplegic migraine, and retinal migraine. Next one, sir. So migraine with a typical aura, in which the aura consists of visual and or sensory and or speech or language symptoms, and motor weakness may be absent in such cases. It is characterized by gradual development. As I mentioned, usually it will take not less than 5 minutes, more than 5 minutes to develop the aura symptom. And duration of each symptom is not longer than 1 hour, which means the aura lasts for 60 minutes. Next one is migraine with brainstem aura. So brainstem aura, in case of migraine with brainstem aura, the origin of aura symptoms are usually from the brainstem. And the symptoms include dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, and decreased level of consciousness. So these are the symptoms exhibited by the patients who are suffering from migraine with brainstem aura. In this case also, there won't be any motor or retinal symptoms. Next slide, sir. Next type of migraine is hemiplegic migraine. As the name implies, it is associated with hemiplegia, or the patient is having motor weakness. And the motor weakness is temporary or transient, and the patient reverses naturally after the period of aura. It is fully reversible. Next one, sir. Next one is retinal migraine. So retinal migraine, in retinal migraine also, it is fully reversible symptoms, and it affects monocular, or one eye of the patient is affected in retinal migraine, and the patient may have symptoms of positive or negative visual phenomena, which include scintillations or scotoma or blindness. Next one, sir. And this is also transient, which means after the period of aura, the patient returns to normal. So risk factors of migraine. The risk factors of migraine can be classified under two headings: non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors include genetics, gender, which means females are more prone to migraine at a ratio of 3:1. Age, usually it occurs in late childhood to early adolescence. And modifiable risk factors include ineffective acute treatment, acute migraine medication overuse, obesity, or stressful life events. These are the modifiable risk factors of migraine. Next slide. Migraine triggers. So migraine triggers are actually patient specific. From patient to patient, the migraine triggers may vary, but it include food additives, caffeine, artificial sweeteners, delayed or missed meals. And in order to identify, the best way to identify the migraine trigger is to advise the patient to avoid the suspected trigger for a period of 4 weeks, and then to slowly reintroduce it. If during reintroduction, the trigger causes migraine, which means we can assume that it is the probable migraine trigger in that particular patient. Next slide, sir. And when it comes to modern management, they have two options. First one is prophylaxis and the treatment. Treatment mainly includes different kinds of painkillers, NSAIDs, and other certain drugs which are used to manage migraine. And for prophylaxis, the limitations of prophylaxis is it should be used daily. And the prophylaxis is intended to reduce the frequency, severity, and duration of the migraine attacks. But the limitations are it has adverse effects, then response varies considerably between patients, then contraindications and drug interactions may be there. Some medicines, some class of prophylactic medicines are expensive and less accessible, and treatment usually needs regular follow-up and long-term adherence. Here comes the importance of Ayurveda, because with Ayurvedic management, we can almost completely make the patient disease-free. That is the importance of Ayurvedic management in case of any kind of headache, especially in migraine. Next slide, sir. So tension type of headache. Tension type of headache is the most important differential diagnosis of migraine. So let me briefly describe tension type of headache as well. Next slide, sir. So it is having a prevalence of 30 to 78%, and exact mechanism, like migraine, exact mechanism is unknown. And most important finding is pericranial tenderness. Next one, sir. So pericranial tenderness is typically present indirectly. Even in between attacks, the patient is suffering from the pericranial tenderness. The patient may say, I'm having difficulty to touch my scalp. Especially during attacks, the condition may aggravate. And during the attacks of tension type of headache, the patient may feel even difficulty to comb his or her head. So that much tenderness may be there in case of tension type of headache. Then easily detected and recorded by manual palpation. Next slide, sir. So for manual palpation, we can make out the presence of pericranial tenderness by making small rotating movements with the index and middle fingers by applying firm pressure. And these are the areas where we can locate the pericranial tenderness. It includes the frontal, temporal, masseter, pterygoid, sternocleidomastoid, splenius, and trapezius muscles. So usually the patient suffering from the tension type of headache may have pericranial tenderness in all these areas. And next slide, sir. These are the other differentiating points of tension type of headache, which include the duration. Usually, in case of migraine, the duration is 4 to 72 hours. But in the case of tension type of headache, the duration is usually 30 minutes to 7 days. And usually the tension type of headache is bilateral location, pressing or tightening quality compared to the pulsating nature of the migraine. And the severity may be mild to moderate. When it comes to migraine, it is moderate to severe. And it is not aggravated by routine physical activity. That is an important differentiating feature when in the case of differential diagnosis of migraine and tension type of headache. In case of migraine, the patient may feel difficulty to conduct routine physical activity, and the routine physical activity may aggravate migraine. On the other hand, in case of tension type of headache, it is not aggravated by routine physical activity, and the patient may have no nausea or vomiting. That is also an important differentiating feature. But in the case of tension type of headache, the patient may have either photophobia or phonophobia. But in case of migraine, usually they coexist. So that is also an important differentiating feature. Next slide, sir. So the third kind of headache is trigeminal autonomic cephalgias. Usually it is also a unilateral headache, and it is affected. It affects in the orbital area, and it is usually associated with conjunctival injection and or lacrimation, nasal congestion and or rhinorrhea, eyelid edema, forehead and facial sweating, miosis and ptosis. Headaches like cluster type of headache, cluster headache comes under trigeminal autonomic cephalgias. Next slide, sir. There are also other types of primary headaches which include primary cough headache, which means the headache which is precipitated by coughing, and primary exercise headache, which is precipitated by exercise. Then primary headache associated with sexual activity, which means during sexual activity or during orgasm, the patient may experience severe headache. That is primary headache associated with sexual activity. Then primary thunderclap headache. Thunderclap headache means the patient may experience severe type of headache or severe intensity headache all of a sudden. That is thunderclap headache. Then cold stimulus headache. Cold stimulus headache is otherwise called ice cream headache, and it is precipitated by ingestion or inhalation or exposure to cold stimulus. Then external pressure headache. External pressure headache is usually precipitated by external pressure on the scalp. Then primary stabbing headache. Primary stabbing headache is also short duration headache that occurs like stabs on the scalp. Then nummular headache. Nummular headache usually occurs in circular or oval areas on the scalp. Usually small to large patches of headache may be seen on the scalp, which is seen in nummular headache. Next one is hypnic headache. Hypnic headache is a particular kind of headache in which the headache usually occurs during sleep. So at the mid of sleep or during deep sleep, the patient may wake up with severe headache, and the headache lasts for around 4 hours. 4 hours, and the patient may not be able to sleep. Another one is new daily persistent headache, which is a kind of headache that persists for a long time. Next one, sir. So when it comes to Ayurvedic management, we should have a clear-cut idea or understanding regarding the Shirashula. Next slide, sir. So we all know that there is a classical reference which says Urdhva Moolam Adashaga Sheha Purusham Viduhu. Our Acharya has given has given that much importance to our central nervous system and Shiras. Next one, sir. So in Ayurveda also we can consider primary headaches and secondary headaches. So primary headaches are usually mentioned in Uttarasthana or Shirashula Adhikara, and secondary headaches are mentioned in different other contexts. So we are all aware about the classification. Next slide, sir. And when it comes to migraine, we can say that Ardhavabedaka satisfies almost all criteria of migraine. But at the same time, we cannot say that Ardhavabedaka means migraine alone. Any other kind of headaches, for example, a unilateral sinusitis may mimic the clinical features of Ardhavabedaka. So we cannot say that Ardhavabedaka equals migraine, but migraine comes under Ardhavabedaka. Next slide, sir. And when it comes to dosha predominance of migraine, we can see different opinion by different acharyas. When we refer Charaka Samhita, Charaka has opined that Ardhavabedaka is of Vadiga or Vada Kabaja origin. And Susruta says that Ardhavabedaka is Sani Vadiga. But in the commentary, Chakravarti says that some acharyas opine that Ardhavabedaka is Vada Paitiga. And although Vagbara says Ardhavabedaka is Vadiga, which means Arthetu Mudrihi so Ardhavabedaka. the sloga comes immediately after Vadika Shirashula. So Acharya Vagbada says that it is of Vadiga origin, but at the same time, when he explains the treatment, he says that Ardhavavediga Apyesha Tada Dosha Anvaya Kriyaha, which means the treatment or management of Vadiga Shirashula should be adopted in Ardhavavediga depending upon the dosha predominance. So even in Vadiga Shirashula Chikitsa, we can see that Acharya has explained management of Pittanubandha Vadiga Shirashula Chikitsa or Kabanubandha Vadiga Shirashula Chikitsa in the management of Vadiga Shirashula itself. So which means whenever we manage any headache or whenever we manage migraine, we should be aware that there may be other dosha anubandha, especially anubandha of Kapha. Next slide, sir. So this is the management. Ardhavavediga Apesha Tada Doshanyat Kriyaha Shirisha Bijabha Margamulam. When we refer the qualities, the properties of all these drugs, we can say that it may be either Vadahara or Kabahara or Tridoshahara. So which means always in the management of Ardhavavediga, Tridoshas are important, especially Kabadosha is important. Next slide, sir. So diagnosis. To make a clear-cut Ayurvedic diagnosis, two slogas or two references should be there in our mind. First one is Darshana Sparshana Prasnehi Parikshedacha Roginam. When we examine a Rogi, we have three modalities, Darshana, Sparshana, and Prasna. When it comes to headache, as we all know, we cannot, there are no other measure to make out headache. So the only way to get details of the headache or the only way to have a clear-cut diagnosis is prasna, which means proper history taking. So history is that much important when we approach a case of headache. And another important slogan is Rogam Nidana Pragrupa Lakshana Ubashayaptibihi. In like any other disease, Nidana, Pragrupa, Lakshana, Ubashaya, and Samprapti. All these are very much important in the diagnosis and management of headache. First one is Nidana. So when we approach the patient by assessing very carefully about the diet and lifestyle habits of the patient, we can say that which are the predominant or probable doshas under the particular condition. Another one is pragrupa, especially conditions like migraine. There are pragrupa or oral symptoms, prodromal symptoms. These are very much important. Next one is Lakshana. As I mentioned earlier, for example, in case of migraine, in order to differentiate migraine from tension type of headache, the only way is to having a clear-cut examination or detailed examination of symptoms. Next one is Upashaya. In case of headache management, Upashaya has a very crucial role. Sometimes the diagnosis may be very confusing. So in such cases, we can rely on Upashaya and Samprapti. As I mentioned earlier, sometimes there may be involvement of other doshas as well. For example, in Ardhavavediga, even though it is explained as a Vadiga condition, there may be involvement of Kabadosha. So in such cases, we should have a Samprapti Vikritan, or we should have a clear-cut understanding of the Samprapti prior to prescription of the medication. Next one, sir. Then treatment approach. So this classical reference, Tatra Alpe Lankhanam Pathyam, Madhya Lankana Pajanam, Prabhude Shodanam Tadvi, Mula Dunmule and Malan. This Mula Dunmule and Malan is very much important in case of headache because especially headaches like most of the headaches, especially headaches like migraine, they are having a recurring nature. So this Mula Dunmulanam or uprooting this particular condition or preventing the recurrence is the most important part in the management of any kind of headache, including migraine. So practically, what we do is we manage the condition under 4 steps. First one is Pajana Dibana, second one is Shodhana, third one is Shamana and Rasayana. These 4 are the steps that we can relay to manage the condition. So, adoption of this condition or these steps may depend upon the condition of the patient. If the patient is having a very good acne, we may skip the step of Pajana and Dibana. And if the patient is having Prabhuda dosha, especially in case of most of the chronic disorders or most of the headache cases, Shodhana therapy may be essential. And after Shodhana, in order to remove the remaining dosha, Samana Chikitsa may be adopted. And Rasayana is another important thing that we should to concentrate, because these headache disorders or migraine in particular is having a relapsing nature or recurring nature. So Rasayana therapy is very much important to prevent the recurrence. Next one, sir. So these are the commonly used drugs in our OPD. Actually, when it comes to drugs, a lot of combinations are mentioned in our classes. But the thing is, since I work in a government setup, the availability of medications are limited, or we are forced to rely on the medicines that are available in our pharmacy. But fortunately, all these drugs are sufficient to manage most of the almost 100% of headache disorders that are approaching our OPD. So usually we use Gandharva Hastadi Kashaya, Pajanamrita Kashaya. These two Kashayas are excellent yogas for Pajana Deepana. Then Varanadi Kashaya, especially if there is Anubandha of Kaba, Varanadi Kashaya is a good yoga to start our management. Similarly, Rasna Bugulyadi Kashaya, in some kind of headaches, especially if the patient is having chronic sinusitis, or if there is involvement of Kaba in the Samprapti, Rasna Bugulyadi Kashaya is a good option. Then Dashamula Kartalang Kashaya, again it is a Vada Kabahara yoga, and it may manage pain as well. So Dashamula Kartalang Kashaya may be given. Then Vidaryadi Kashaya, Vidaryadi Kashaya is Vadahara, it is a good yoga. Then another one is Patyasharangan Kashaya. In almost all kinds of headache, actually when we refer the Falastrudi of Patyasharangan Kashaya, we can see that almost all headaches are listed under the Falastrudi of Patyasharangan Kashaya. The only thing is that we should have a clear-cut identification or understanding of the condition. Then churnas like Vaishyanta Churna. Vaishyanta Churna is usually, in case of headache, it can be given in the initial stages to have a good acne of the patient. Then Ashta Churna is usually given, especially in pediatric patients. Ashta Churna is good to boost the acne of the patient. Then Kachuradi and Rasnadi Churna. Actually, Kachuradi Churna and Rasnadi Churna both are usually used as Tala. Actually, Tala is a modification or modified form of Murda Daila, in which we mix the churna with some suitable oil like Shirabala Daila or Shuddhabala Daila, and we will heat the combination. Then we will place it at the drachma of the patient. So we can use it as an alternative form of Piju or something, or it's a form of Murda Daila practiced in our areas. Another one is Guligas, Shaddarna Guliga. Shaddarna Guliga is again, we may give in some patients, especially if there is some involvement of Amasya Gadavada or something is suspected, Shaddarna Jurna can be used. Or Dhanandra Guliga is an excellent medicine that can be used, especially during attacks of headache. Then Taila and Grida can also be used. Taila like Shirabala Taila, Shuddhabala Taila, Anataila, Shatpala Grida, Indagana Grida, or Rasna Dashamula Grida. These are the common yogas that we use in the management of most of the headaches. So prior to the prescription of Taila or Grida, we should make sure that the patient is free from Kapha in the Samprapti. If Kapha dosha is involved in the Samprapti, prescription of any form of Snehadravya may aggravate the condition. So these drugs, both Taila and Grida, can be administered either internally or as Nasya. And also it can be used for Murda Daila as well. Next slide, sir. Then usually Kriyakalpas used are Rukshana, Snehapana, Vamana or Virejana, Nasya, Vasti, and Murda Daila. So these are the Kriyakramas usually used in the management of headaches. Next slide, sir. So I have incorporated 3 cases with my presentation. The first case is migraine with retinal aura. So it was a kid who, and her age was 6 years. She had a history of 2 years, and the aura appeared 1 year back. So aura was actually retinal aura. The patient was having uniocular hemianopia at the time of headache. And the condition, the aura preceded the headache, and usually it develops within a time of 15 minutes, and it is usually lasts for 15 minutes, and after that it is followed by headache. Next slide, sir. So the patient was already under allopathic management when she approached our OPD, and on her examination, her paranasal sinuses were normal, and her visual acuity and fundus were normal. But when we assessed the nidana of the patient had a habit of daily intake of milk and fish, and she also regularly took curd and black gram. Next slide, sir. So considering her nidana, actually the patient was a lean girl. All other things supported Vada, but at the same time the nidana supported Kapha. So in order to remove the kapha dosha, initially we have done a Sadhyavamana, and Sadhyavamana was done with the HT Kashaya. So after following Sadhyavamana, the patient had a weaker acne. So in order to boost the acne, we have administered Vaishwandra Vasti. So actually in Vaishwandra Vasti, it's a combination of Gandharvastati Kashaya or Amrutotana Kashaya with the Vaishwandra Churna. So after Vaishwandra Vasti, there was Acne Deepana, and we have done Achas Nehabana with the Vidayati Grida. So after getting Samyak Snigdha Lakshana, Abhinga and Ushmasweda were done, followed by Virajana with the Gandharvarandam with milk. Then Nasyam was done with Varanadik Shiragava, which is mentioned in the Shiroroga Adhigara. And finally, Shirodhara with the Balada Ila was also done. So in this case, actually, although there was involvement of Kapha initially, we have managed the Kapha initially with the Vamana, followed by use of Sneha Divya or Brahmana. Next slide, sir. And this is the opposite of the first case. In this case, this lady was suffering from migraine with the brainstem aura. As you can see, she was an obese patient, and her BMI was 43.5. The patient was already a diagnosed case of vestibular migraine and BPPV. For both these conditions, she was under allopathic management. And on examination, she had a mild frontal tenderness, and her BCVA was normal. Next slide, sir. Next slide. Okay. Actually, we managed the condition with the internal medications like Varanadi Kashaya. Again, Varanadi Kashaya is Kapahara. So, Kapha Medohara. So, we opted for Varanadi Kashaya. Then Avibhatti Churna was given for Anilomana. Then Triphala Gugulu was given. Again, Triphala Gugulu is Kapahara Drevya. So, Triphala Gugulu was given. Then Pratimarshan Asya was done with Nimbasava. The patient was having sinusitis. So, and considering the Kapha background of the patient, Asava Asya was taken. And for that, Nimbasava was taken. Then during IP management, the patient was underwent Sadhya Snehana, followed by Utkleshana, then Sadhya Vamana with the HT Kashaya. Again, HT Kashaya, Sadhya Vamana was given to the patient, and followed by Uddurtana was done with the Koragulatha Churma. Again, Uddurtana is Kapha Medohara, so Uddurtana was done, and followed by Rukshavasti. For Rukshavasti, Makshiga, Lavana, Shadapushpa Kalka, and Chirvilyodi Kashaya were taken. Next slide. So the patient was discharged on 3/3/2022, and after that she came for a review on 6th month of 2022. So this was her review. There was no episode of headache for actually this 4 months. I think it was a mistake. Then giddiness of head was there. Actually, she experienced some vertigo, and Hallpike maneuver was positive at that time. So since there was no attack of headache, we were prescribed. The medicines were given, and the medicines included Varanadi Kashaya, Anjanara Gugulu Guliga, and Triphala with the Kanmada Rasayana. Kanmada means Shilajudha Rasayana. So this was the prescription. Next slide, sir. So the difference between the first case and the second case is that in the first case we have done Snehana or Brahmana, but in the other hand, in the second case, since the patient was having a heavy kapha background, the patient was Stula, Rukshana therapy was given. This is another case in which the patient was having 10 years history of migraine with Tora. The patient was under homeopathic management for that. And the pain severity, the patient given a severity of 10 out of 10 pain at the first consultation. Actually, the patient was a person who is attending the gym regularly. He was using again kapha danas like curd, and patient was on red meat regularly. Patient was having day sleep. At the same time, he was having heavy workout. So the medicines given was Patyasharangan Kashaya, and the patient was also having a history of sinusitis. So in that case also, Patyasharangan Kashaya was given, then Avibhakti Churna was given, Nasya with Nimbasa was given, and Talam was given with the Kachuradi Churna and Rasnadi Churna and Kshirabala. So these are the treatments. These were the treatments given to this particular patient. And I have advised IP management for this condition, but due to the family situation of the patient was unable to do the IP management. Next slide, sir. So the patient came for a review after 1 month, and after 1 month, the patient had only 2 episodes of headache. So at the first episode, the pain severity from 10 out of 10, then pain severity reduced to 5 out of 10. And during the second attack, the patient had the pain, there was no pain. Pain was not there, but the patient experienced only visual aura. But the patient was under my treatment for around 1 year. And during the whole 1 year, the patient was reluctant to take admission. The patient had attack of migraines repeatedly, but at the same time the severity was very less. Sometimes there were no pain, only aura symptom was there. The patient was happy with that, but at the same time the patient was not willing to took admission. So this case highlights the importance of IP management or Shodhana therapy in the management of migraine. Next slide, sir. So simply, this case underlines the slogan, Doshaha kadajit pupyandi, jita lankana padunehi, yetu samshodhanehi shuddhaha, natesha punarudbhavaha. So in the management of migraine, our aim is this punarudbhava, or we should prevent the punarudbhava or recurrence of the case. For that, we should always adopt Shodhana therapy in the management of headache to prevent the recurrence. Next slide, sir. So let me conclude my presentation. My conclusion is that differential diagnosis of headache is always essential. So differential diagnosis in case of modern terms and Ayurvedic with Ayurvedic parameters like Darshana Sparshana Prasna or Nidana Pragruva Lakshana Upashaya Samprapti. It is very much essential to have a successful management of the case. Then Roga and Roga Pariksha is essential to make Ayurvedic differential diagnosis. Then selection of drugs or treatment should be based on Dashavida Pariksha. So Acharya has mentioned that Sukshma Samishesha or whoever give importance to this Dashavida Pariksha, he or she will not will never make any error in diagnosis or management. So that is the importance of Dashavida Pariksha. So Dashavida Pariksha is that much important in the management of headache. So let me conclude. Ayurveda does not aim to manage headache. Instead, it is the ultimate cure. That is my conclusion. Thank you so much.
Amol sir. So you're not audible.
Hello.
Thank you, sir.
Sir, you're not audible. Shanti ma'am.
Yes, madam. Sir,
please continue, ma'am. Yes.
Yeah. Thank you, sir, for a wonderful session. Now, may I request our co-chairperson, Dr. Sri Kumar, sir, to kindly remark today's session. Sri Kumar, sir?
Yes, madam. Am I audible?
Yes, sir, you are audible. And you are clear,
Okay,
sir.
okay. Okay. Respected Chair Dr. Sangeeta Salvi ma'am and co-chair, I am very gladful to be a part of this Ayurveda Teachers Association webinar. And first of all, I would like to congratulate Dr. Nisam for their excellent presentation and the presentation of the 3 cases. Actually, he has very clearly emphasized on the importance of differential diagnosis, and he has discussed 2 conditions, mainly part of one of the most common presentations, the OPD, that is migraine and tension headache. And he has clearly elaborated how to differentiate between migraine and tension headache, that there are a lot of similarities and the diagnosis is very important, and we can use some methods which is mentioned in Ayurveda like Talam to understand the dosha predominance of the presentation. And in his Ayurvedic part also, he has clearly elaborated the dosha predominance of Artha Vedaka. Actually, one Acharya mentioned it as a Vata that may be due to the acute exacerbation causes of this migraine. And one Acharya mentioned it as Vata Kaphaja. Dr. Nisam clearly mentioned that some sort of sinus headache are mimicking, or some sinusitis may be leading to the acute attack of the migraine. And some Acharya Delhana clearly mentioned about the Vata Pitta. Actually, it is due to the tension or the reduced sleep, and the skipping of the meals is one of the most common exacerbating causes or irritating causes of development of migraine. And Acharya Susruta clearly mentioned it is as a tridosha. So it is due to the recurrent nature of the chronic phases. So he has clearly mentioned the involvement of the doshas to the vata and how it can be differentially diagnosed for the treatment approaches. And while entering to the treatment, he has clearly emphasized on the importance of Shodhana therapy for the management of the headache. And I am hereby remembering one of the most important slogan mentioned by Acharya Susruta, that is Teshamante Hidam Nasyam Sarpir Madhurasanidam. So that is the concept. Actually, he has clearly mentioned the Shodhana Nasya should be followed by the Brahmana Nasya. This is the classical approach of treatment of migraine. So the Shirisha Bija Apamarga Moolam, it is a Swarasa Nasya. So it is a Tikshna Nasya. So Acharya Susruta clearly mentioned about the common management. That is Samanya Chikitsa of the Shiro Roga, that is Matu Taila Samayuktehi Shiram Sedi Vireji. That means Shiro Virejana Nasya followed by the Krida Nasya is the ultimate treatment of the migraine. So in his presentation, Dr. Nisam clearly elaborated how we have to approach a patient with the migraine and what should be the treatment aim. And he has elaborated the importance of tala in the management of the headache. And in Kerala, we are using the tala to understand the dosha predominance of the presentation. That means the tala as a snigdha tala or a ruksha tala that can be used, and we can use it as an acute or an emergency management of the pain for the presentation of the headache. In any type of the headache, tala is found to be a very effective treatment. And he has elaborated the 3 cases, and in his conclusion part, Dr. Nisam emphasized on the importance of differential diagnosis and the importance of Shodhana therapy in the management of the headache. So I would like to congratulate Dr. Nisam for the elaborated and concise presentation with the prominent and highly important presentation of the 3 cases. So thank you, Dr. Nisam, and I am very, very much thankful for the Ayurveda Teachers Association for giving me a chance to speak about this presentation. Thank you.
Thank you, sir. Now, may I request our joint co-chair, Dr. Sunil, sir, to share his views on today's session. Sunil, sir.
Thank you, ma'am. Thank you.
Yes, sir.
Firstly, I would like to congratulate Dr. Nisam sir for his thoughtful, along with his clinical knowledge shared while presenting the all modern aspect of the headache. Actually, all of all of you or all of us know that very headache is a very critical patients for all physicians or Shalakya Tantra or every faculty, every branch of Ayurveda has to face this headache patients. And in that case, when there is a addition of emotional part or emotional quotient of that patient in headache, it is very difficult to treat that patient. uh, Sir has very precisely explained about the classification of headache, and it is very necessary to follow that modern classification of headache, because some every point has to be covered while we taking the history or while we managing the case of headache. For that purpose, it is very essential to think about the all classification part of headache. Nowadays, as per my opinion, most of the headache is causes due to the involvement of Vat Pitta dosha, or only either it is due to the Pitta dosha or either it is due to the dosha. Because the reason behind that, there is a modern lifestyle changes are there. That's why we have to concentrate on the Pitta dosh along with Vat also. And also we have to think about the Rakta dosh also, because Rakta has presence of or the composition of all 5 Mahabhutas. That is all gunas of that 5 Mahabhutas are there. That is Vistrata, Dravata, Ragaha, Spandanam, Laguta, Tatha Bhimadinam Guna Hete, Drishyante, Chatra, Shonite. All these qualities of Panchamahabhuta are represented in the Rakta Dosh also, and we are using the
Shodhana procedure for Raktadosh also in so many types of headache also. So these are the few points from my side to include in the today's nice presentation given by Dr. Nisam sir. I also thankful to chairperson and co-chairperson, and along with that, I also thankful to Amol Deshpande sir and Shanti Nair madam for their nice conduction. Thank you.
Thank you, sir. Now, may I request our respected chairperson Sangeeta Sali, ma'am, to share her valuable views in today's session. Ma'am,
Yes,
Sangeeta,
ma'am.
ma'am. Thank you, ma'am.
Yes, ma'am. Yes. Good evening, everyone. Um, Thanks to Ayurveda Teachers Association for organizing this type of lectures, because it's very important for the students to know the basic concepts. One thing which I really appreciated of Dr. Nisam was the way he has explained the topic point wise. So that is very important when somebody is learning from you. So basically, the classification, then how the quality of life is affected. The most important thing which I really liked was when he was explaining about the risk factors, he explained it in two ways. One is modifiable and second is non-modifiable. So if we think in this way, that whether things can be modified or not modified, so that makes a lot of difference when you're treating the patient. So if things are not modifiable, you have to be very clear to the patient that you are going to get headaches, but we will try to reduce the um, affinity of the headache. So this type of classification explaining is really very important. And while treating, when he explained the Ayurvedic line of treatment, the most important thing is pachan, deepan, then if required shodhan, and then rasayan chikitsa. So again here, if you go stepwise, this makes a very big difference, because when he has explained specifically migraine, we know that it recurs. So if you go stepwise, the episodes of migraine are going to reduce. So once if you get a migraine, say after every 3 days, the episodes are going to reduce, say once in 3 months, once in 6 months. And this line of treatment is nowhere mentioned in the modern science. So going to the basics of management according to Ayurveda is the most important thing which should be practiced by all of us. And lastly, the three examples which he has given. All three were different types of, presentations. And here we come to know that initially migraine was explained as a neurogenic headache, and now it is explained as a vascular headache. So once you say it is a vascular headache, then the association of Dushita Rakta and Pitta and that management. So this makes a lot of difference. And even the kalpas which he has explained, the Kriya kalpas, the medicines, they were really very useful for the people who are going to start practice, because headache is really definitely a topic which is difficult to treat. And patients with migraine have come to us with a total loss of quality of life. So if we try to give confidence to the patient with our treatments, I think that will really help. So well done, Dr. Nisam, and congratulations to ATA also. So thank you very much, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, the co-chair, chairperson Salvi ma'am, and other co-chairpersons for your valuable insights. Thank you, Shanti ma'am, for her nice coordination. Once again, thank you all the audience for your patient listening. Thank you so much.
Thank you so much.
Thank you, sir. Thank you, ma'am. As we come to end of this academic session, it was my pleasant duty to propose a vote of thanks on the behalf of organizer Atacon, means Ayurveda Teacher Association, and Atacon 2026. I express our sincere gratitude to our esteemed speaker, Dr.
Shanti
Mohammed
ma'am,
Nisam sir, for sharing his expertise and
most
valuable. हाँ ma'am. Hello. Hello.
voice volume is very lower.
Hello. Now it is clear, ma'am.
Sir, it is audible now. Sir, you are audible.
Okay, sir. Thank you.
Sir, you are audible.
On the behalf of organizer of Ayurveda Teacher Association 2026 Atacon, I express our sincere gratitude to our esteemed speaker, Dr. Mohammad Nisam sir, for sharing his expertise and valuable knowledge. I extend heartfelt thanks to our respected chairperson, Dr. Sangeeta Salvi ma'am, and our distinguished co-chairperson, Dr. Shrikumar sir and Dr. Sunil Borkar sir, for their guidance and gracious presence. I also thank to all delegates, faculty members, postgraduate scholars, and students for their active participation and enthusiastic involvement. With this, we conclude the session number 6. Thank you. Thank you all.
Thank you so much.
Thank you very much, all the Thank you very much, respected speaker, respected chairman and co-chair, respected chairperson and co-chairperson for this session. And I thank you, Dr. Amol sir and Dr. Shanti madam for coordinating this session. Now we will move forward to the session number 7. Our last session, the session will be on tool development in health research, designing an Ayurvedic mental status assessment instrument. And it will be conducted by our session coordinator, Dr. Pallavi Pardesi Madam, Assistant Professor, BVDU, College of Ayurveda, Pune, and Dr. Akshay Pargaonkar Sir, Associate Professor, Department of Dravya Guna from Mahatma Gandhi Ayurveda College, Hospital and Research Center, Wardha, Maharashtra. I request Dr. Pallavi Madam and Dr. Akshay Sir to start the session. Towards you, sir.
Okay, thank you, sir. Good evening and welcome to all respected dignitaries, distinguished faculties and dear participants. Now we'll start our today's last session. I would like to welcome our eminent speaker, Dr. Anand Lakshmi ma'am, chairperson, Dr. Bairesh sir, co-chairperson, Dr. Manjunath Aki sir, and the second co-chairperson, Dr. Rishi Sharma sir. It is my honor and privilege to introduce to you our today's speaker, a name that needs little introduction in the field of Ayurvedic academics, Dr. Anand Lakshmi ma'am. Ma'am served a professor and head of department Kriya Sharir at the Government Ayurveda College, Kannur, Pariyara. Her academic journey begins with a BMS from the Government Ayurveda College, Tiruvananthapuram, followed by postgraduate degree in Shalakya Tantra and later a second postgraduate specialization in Kriya Sharir from Government Ayurveda College, Pariyara. She went complete her PhD from Kerala University in 2019 with her doctoral work focus on developing an instrument for screening mental health based on Ayurvedic concept, a truly pioneering
Ma'am, sorry to interrupt you.
Hmm?
Will you please display ma'am introduction slide?
Okay. Akshay sir, kindly share the PPT. It's a PPT. Introduction session 7. Sorry.
Pallavi ma'am, is it visible now? I am sharing my screen.
Yes, ma'am. Okay, sorry, ma'am. Ma'am complete her PhD from Kerala University in 2019 with her doctoral work focus on developing an instrument for screening mental health based on Ayurvedic concept, a truly pioneering contribution bridging classical Ayurveda understanding with modern psychological assessment. With over 22 years of teaching experience, ma'am is a university recognized postgraduate and PhD guide, having mentioned numerous scholars in the discipline of Kriya Sharir. Her academic footprint extends far and wide with 43 presentations at national and international seminar, 16 publications in peer-reviewed journal, and the distinction of chairing and moderating 13 national and international academic sessions. She has authored and edited several notable works, including Frequency Asked Question, in Kriya Sharir and has served the Kerala University of Health Science, is an academic council member and continue to serve as a board member to this day. Beyond academic, ma'am has remained deeply committed to community health, leading health awareness initiative, palliative care program and charitable healthcare outstretch across Kerala for well over a decade. Once again, I warmly welcome Dr. Anand Lakshmi ma'am. Now I would like to introduce our esteemed chairperson, Dr. Bairesh sir. Bairesh sir is a distinguished Ayurvedic physician with postgraduate degree in Kai Chikitsa and postgraduate diploma in hospital and health management. He currently serves as the principal of Adi Chanchandgiri Ayurvedic Medical College, Nagaru, and also consulting physician at Apollo Ayurved Hospital, India's first NABH accredited Ayurveda hospital. Sir has an expert in healthcare quality and accreditation. He has played a significant role in drafting and revising the NABH Ayurveda accreditation standard and has served as a trainer for NABH accessor. He has guided over 20 postgraduate scholar, contributed extensively to research and academic publication, and delivering numerous lecture, workshop, radio, television talks on Ayurveda and healthcare. A recipient of the Gold Medal and Dabur Ayurved Award for Academic Excellence. Sir has also contributed to the documentation of traditional healing practice and has been actively involved in organizing several state and national level academic events. We are truly honored to have such an accomplished academician, clinician, and administrator as the chairperson for today's session. I warmly welcome Dr. Bairesh sir. Now I hand over the session to my colleague, Dr. Akshay Pargaonkar sir.
Thank you, ma'am. Good evening, respected dignitaries. Am I audible?
Sir, yes, continue.
Yeah. So it is a privilege to have with us a distinguished panel of academician and experienced Ayurveda professional to chair and co-chair this session. It is my privilege to introduce our first co-chairperson, Dr. Manjunath Akki. Dr. Manjunath Akki holds MD in Panchakarma from DGM Ayurvedic Medical College, PG Studies and Research Center, Gadag, and BMS from Taranath Government Ayurvedic Medical College, Bellary. He has more than 19 years of teaching experience, including 14 years of PG teaching and 3 years of PhD teaching, along with extensive experience in Ayurveda and Panchakarma practice. He is currently serving as a principal, professor, and head of the Department of Panchakarma at Samta Ayurvedic Medical College, Hospital and Research Center, Alanda, Kalaburagi. He has been a recognized PG guide in Panchakarma under Rajiv Gandhi University of Health Sciences, Bangalore since 2012 and has guided 24 postgraduate scholars. He was also recognized as a PhD guide in Ayurveda Panchakarma in 2021 and has guided various PhD scholars. Dr. Manjunath Akki has published more than 29 articles and has been actively involved in research projects, CMEs, workshops, seminars, and academic presentations. He has also served as a peer review board member of various journals. His academic contribution have been recognized with award including Best Case Paper Presenter in 2017 and Best Faculty for Excellence in Teaching and Training in 2021. With his extensive experience in Panchakarma, teaching, research, and postgraduate guidance, we are honored to have Dr. Manjunathan Akki as a co-chairperson for today's session. A warm welcome to you, sir. Now I'm introducing our second co-chairperson, Dr. Rishi Sharma, sir. Sir holds a BMS and MS in Shalya Tantra and is currently serving as a principal of Sri Ganganagar College of Ayurvedic Science and Hospital. He has 12 years of teaching experience, including 5 years of assistant professor and 5 years of associate professor and 2 years as a professor in field of Shalakya Tantra. He has been actively involved in research and academic work. His research interests include areas such as Dushtavrana, Sandhigat Vat and osteoarthritis, Amlapitta, Rajonivrutti, PCOS, Nasir, Rasayan, and Prameha and obesity. With his rich academic teaching and research experience, we are very pleased to have Dr. Rishi Sharma sir with us as a co-chairperson for today's session. A very warm welcome to you, sir. With our distinguished chair and co-chair in place, we are now ready to begin the session. So it is my privilege to invite our respected speaker, Dr. Anand Lakshmi ma'am, to address the gathering and share her valuable insights. Over to you, ma'am. Thank you.
Respected delegates and respected teachers, am I audible?
Yes, ma'am.
Okay. Respected chairs and co-chairs, let me now, since my internet seemed to be a little unstable, I would like to close my video and I will start the presentation. Is that okay?
Sure, ma'am. Thank you, ma'am.
Okay. Am I audible? Can somebody confirm?
Yes,
okay,
ma'am.
thank you. So let me again welcome all the chair and the co-chairs to this presentation, all the delegates, and I gave me an opportunity to present the topic. So the tool development, we all know it's very important in health research designing for mental health. And it is very important that such tools should be developed for any mental health assessment. We know that mental health has several attributes to it. It has several attributes, of which major ones has to be like self-realization. There is a sense of mastery and there should be autonomy. So these are the things which are given in several psychology books, but it has to be remembered that our science has also given several hints as to how and why we have to develop some measures by which we can understand the mental health status of the people. So we know that there is a difficulty in developing a reliable and a valid method so that we can define a case in a non-referred population. So we know that different attitude scales are used for the assessment of mental health, but instead of health, what we do is we assess the mental morbidity. So whatever mental health assessors are present, usually in modern science, they assess the depression scale, the substance abuse scale. Somewhat is a significance for developing research is essential because there is a demand for such instruments. Why? Because they are important in understanding the mental well-being of the individual, and we can understand that if it lacks in the present case, we can evaluate and get a correct measurement of the mental health status of the person. And if by chance he is having a lesser mental health state, then we can to take initiatives by which we can create awareness, or we can measure, some therapeutic, or whatever measures we can, intervention measures we can take. Let it be counseling, let it be medicines, whatever it is, that can be taken, but only if we demands the development and validation. So we know that several measures are existing now, but the thing is that in several measures, validation and process of validation has not taken place, and in the way it should be, as in quality messages. So as we know that sattva is assessment, there is triguna quality. So we know how sattva guna, rajoguna, and tamogunas are influencing mind. So that part of Ayurvedic concept is a basic foundation for evaluating the mental health status. I need not tell it, everybody knows this. Now why it is interesting for a person who is not from Ayurveda? Because it is a unique concept. It has got a distinct description. and we know that it is genetically determined, and we can understand that it refers to a psychological dominance. It is not, one person cannot be entirely sattvic tendency or rajasic tendency. It cannot be like that. That is a psychological dominance. So whenever we say about the mental health status, there has to be some protective factors as well as risk factors. So certain protective factors such as grounding, adaptability, those things come as protective factors, whereas aggression and jealousy, those things within the physiological limits, it is needed, but if it is above the physiological limits, then they are considered as risk factors. So this risk and protective factors we can see that they are coined in the term of trigunas and inside the sattva-rajas tamoguna. So why? Because we know the triguna's role in the mind, and but the effort has to be made to quantify it. Several works have already been done, and why this helps? Because it helps in the identification of the vulnerable group. If it has been identified, then what is the use? Is the early identification is overall efficiency in the society. I'm not saying that if the risk factors are meant within the physiological limits, it is not causing any trouble, because there may be some sort of anger in a person, but some certain things in the life can make you angry. It is not that that is not the, but the physiological boundary is what that makes the person vulnerable or not, whether he is vulnerable to a mental health threat, that is to be measured. So this is an attempt to tool development. Here is an attempt to create a psychobiological model that which we can translate it to a psychometric accessible tool. It was an attempt to make it a accessible model and validate it in a representative samples. So we know that there is a dominant objective was our dominant objective was to translate the researcher's need into a set of specific questions or in a tool which has to be applied in a very standardized manner. So we know all of the people know about the steps in the tools. We know that very well. I'm just saying it. Whenever we have to make a set of questions, we know that methods include materials and methods. We should cover these much of steps. Like there should be an item generation. Items are the questions. So items should be generated. We know if we are going to ask a person, Satvigaha. So are you so there is a character or characteristic feature or a trait in Satvik that is honesty. So if you are going to ask a person, are you an honest person? It is most likely we are going to get an answer, yes. So we have to make it in a way that the person should not feel that honesty is being tested. So there is an indirect way of asking it. So in item generation, we cover all of these things. After item generation, we have a set of questions in which we select certain items. Items are, as I told, they are questions. Then they should be worded correctly. There should be formatting and scoring of the questions or the items. Then a very cardinal symptoms, which actually comes as a validation. It is a validation method. That is translation and back translation. Then a very important step, I have seen several people omitting during the tool development is pre-test. Whenever I see certain PhD thesis to review, I have seen that this test is being omitted by so many researchers. But I don't know why. It's a very easy step, and it will catch several mistakes we have done in the prior step. It's a very easy step. Pre-test can be done in if you are eager and enthusiastic, it can be completed within a week. But I have research thesis where they have simply omitted this step. It's very important and very cardinal in my experience, and the madam who helped me with research research is Dr. Rama madam. She's widely very important. She has a very important role in qualitative researches all over India. So she gives so much importance to pre-test, which is a sixth step. It's not that it's first step, second step. People can go in parallel ways also. Then, of course, we have to do a pilot study, then test, retest, which is again a method to validate the scale and has to be done. Then final administration. In my case, I did the final administration in Thiruvananthapuram, in Kannur, in NIT Kozhikode, and in ex-convicts. So I did this in all this geography. I did it in Thiruvananthapuram and Kannur to understand the geographical variations, whether the tool differs according to the geographical. One is in the southern part of Kerala and the other one is in the northern part of the Kerala, because the diet, sometimes the temperature and the weather, all these are changes are there in these parts. So this geography, whether these have got any difference, whether this makes, that's again a validation method. Then finally, data analysis should be done in any type of tool development. The research design can be called, if it is a psychometric approach, then it can be a descriptive study. Sometimes it is sometimes people take prevalence, or sometimes it is a cross section. Those is up to you and up to the researcher who is doing the study. So this comes under a semi-quantitative method, and setting was in Trivandrum, but the validation has been done in Kannur and NIT Kozhikode. So study population which are 40 years and who gave informed consent. All the people who had psychological morbidity under medication, narcotics and alcoholics were excluded from this study. The sample size for my study where the tool was developed was taken as 400 because it was according to a principle called nulli principle. That is, if you are thinking that I may have a 36 set of questions in my tool, then it is ideal to have 10 subjects per variable. So if I am taking 36, then 36 into 10, 360. So on an average, some of them may get excluded, or some may give some wrong answers. So all this then we took it together as 400. This is comes under a principle called Nunn-Nellis principle, which is which is explained in a health development health scale development book, which is very popular in India. Sampling technique which I did was stratified multi-stage sampling, where villages and cluster sampling was also done. And as I said, the sampling size were formulated. The population was in urban, rural, and coastal areas was taken, because in Kerala state we can see urban, rural, and coastal areas. After that, the taluks and blocks which is not very important. It was just rural village I took was Nedumangad, which is a rural village. Then sampling accordingly, the samples from each taluk village that was also done. Urban coastal population. The chosen ward in urban was Manvilla, and coastal ward was also selected. The coastal area was Kovalam, and accordingly we can select the samples as per the statistician. So when the validation was done, actually in the validation that there need not be any sampling technique, that we should not give importance to sampling in validation section. It need not be theory. But as we were going, since we wanted to know whether the prevalence in Trivandrum was same as that of Kannur, we took as much sample as we can. So we took it as around 100. And in NIT Kozhikode also, whether predominantly only students were there, which was a NIT campus. So that was around 100. And further validation was done in ex-convicts in Trivandrum Central Jail, which was Central Jail, the same jail, ex-convicts from the roll call. They have a roll number which is with their address and telephone. So that was taken. And again, I will repeat that validation samples is not that much necessary as we take 400 samples where we have a particular, follow a particular way, that is none in a list. That is not needed here. But since we wanted to know the prevalence, we did it in 100 samples. See, these are all ethical consideration where the written consent was taken, confidentiality was maintained, no remuneration was taken, and full freedom was given to the participant. And since we were doing in urban, rural, and coastal villages and things like that, we took permission from appropriate authorities and on their whenever they ask, whenever we are given that proper guidance only, because we have to get one point in Manvilla and to take the houses in and around that place. For that, we needed that authority consent from these places. Now, coming to the item generation part, the expert panel was needed, who gave a technical advice, and also item generation also they have. So this was an expert step, which I took was 6 experts. Some people take as much as 10 experts. Some people take 8 experts. It's up to you that how many experts are needed. And then agreeing on the measure. So instruments not based on Ayurvedic views were also taken during this stage of the item generation, because if we are thinking that the Triguna has only role in mental health status, then we have to check in with other measures also, whether these are having some sort of coming to a point with whatever items which are mentioned in our science as comparable. Is it comparable with the items of the other measures, or is it disagreeing with the items of those measures that we saw? And decision on the nature of the measure was also made at the first level of the study itself, that how we are going to classify mental health as poor, mental health medium, or mental health good. That way we decided from the very beginning of the study itself. Because I have seen researchers doing all the work and then thinking of how we have to make the how we have to take the 3 or the 3. Am I going to take it as 3, or am I going to take it as fairly medium, better, good, better? So those things they think afterwards only. One thing which I would like to tell the researchers who are going to take tool development as their research is, they have to decide on the nature of the measures. Like, are you going to fix in 3? Are you going to fix on 5, 7? You can fix anything you want in a reasonable way. Reasonably well contained way you can take, but it has to be made at the beginning of the study. That measures or at least at the items generation level itself, you have to think whether I have to make it in how many levels of the, if it is mental health. So say if you are doing on some other thing, you can, morbidity, you are saying whether the morbidity prabhuda, madhyama, avara, that also you can decide. Whatever thing, it has to be decided prior to the study. So the item generation, we know these steps. I need not go through it again and again. There is conceptualization and operationalization, domain identification, and we have to define the concept. So the domains were fixed as Sattva, Rajo, Tama, Guda. This is again up to the researchers. The researcher can fix the domain and then fix the sub-dimensions also. It is up to the researchers. There is no need that the guide and the researcher can sit and fix the domains, and they can see whether the domains are completely covering all the constructs they wish to cover. That is very important. So here I took the sub-dimensions also, sub-dimensional behavioral attributes of Sattva, Rajas, and Tamo Gunas I did. Then as everybody does, the reviewing literature review was done. Then item generation was done from experts as well as from the focused group discussion. As the experts gave bioregulatory principles, several several differing and opinions, as well as several inclusive opinions came as the guna description, concept of combinations, because in some cases you are not able to understand between rajas and rajoguna and tamo. There is a little bit blur in between those two. So those concept of combination was discussed by the experts, and faculty expressions were also expressed by the item generation level. I found this faculty, FGD very, very important in the tool development. It's a very, very important step, because they had given so many points at a very small time and very small resource. With very small resource, we get so much of inputs from the faculties, because there are 8 people who are coming together and they will give you inputs at the same time. That's a very important step of the FGDs. FGDs were the measurable attributes are grading, scoring. They gave me so many inputs about literary hints and measurable scoring sentences in local languages, developing appropriate wordings to be used, and collecting data to understand people's actual thoughts and feelings, which is whenever you have to think about mental health status, means should know that we should understand what they actually, what the individuals actually feel, actually what is their beliefs, what are their perceptions, what are their thoughts. So those things has to be understood at the basic level itself. So these inputs were given by the FGD sessions. In my FGD sessions, in item selection, it was very, we know that in focus group discussion, whatever they told, we got a pool of 105 items with repeating, and some were overlapping. That is the main thing we saw. And I have seen in my PG students also, when they bring with the pool of items, many of the items will be repeating. There will be some construct difference in some of the, such a construct is you are attributing, you are thinking of some depression, you are thinking of a motivation scale, for example. Then the construct should understand, make their confidence should come, the feeling, enthusiasm should come in the motivation. So should see that those, whether these things came under that construct, but are you actually measuring what you are intent to measure? So if they are not intending to measure, those item has to be removed at this level itself. So item selection is a very, very important step, and relevance and adequacy, which we can see several faculties may be given all these checklist, whether my items are relevant, medium relevant, non-relevant, and these experts can categorize. I know several faculties here must have already done that. The people will send us a set of questions and we have to see why it is relevant, why it is not relevant, why do you think it is not. You can even give a score for that. And finally, there will be a ranking can be made. So among the items, I can get a maximum rank for a particular score. All the experts must have given good marks for that particular, because it is highly relevant. Highly content is also best. So content adequacy is there, relevance is there, clarity is there. So they will give high marks to that questions, when that question should be there in your tool, because it has got that first rank. So that ranking should be made, which is a very important step. I have seen several researchers, not giving that much importance to this step, because they think that, and I have seen faculties also not giving importance when they are given the opportunity to say whether this is relevant, content adequate. They'll just see, when they when they are in OP or somewhere very busy with their things, they will just mark it as, okay, this is good, this is bad. Like, no, you have to sit, take 3, 4, 5 hours to do it properly, like we do in journal evaluation and things like that. That much importance is there for the item evaluation. So those experts who have time to give you, they should be given or sent this your items. Wording and sequencing, everybody knows I'm not giving because there is shortage of time. The wordings and sequencing, short term and jargons, acronyms, abbreviations, those things, double barreled. Double barrel means in one question itself you're asking two different things. So those things should not be come under your items. Sequencing should be done, which, sequencing when you are selection is different from sequencing. People always confuse the selection and sequencing. Selection is from the pool, you selected certain items. Sequencing is which item you would love to put first. That is sequencing. So if you are asking a person a bit of a personal information at a very start, then he may not or she may not reveal it because their willingness to answer, or you have a social image, especially in mental health or mental attributes. There is always we have a social desirability quotient is there. I want to feel that I am like good among, I have to be perceived, image is there. So social desirability make us skip or say and not true things about. Even if we know that we are giving wrong answers, we will particularly mark the wrong answers only. That comes under social disability. So if we put those things in between, there is a chance that they may, in any social scale, there is chance that 68% may be correct. All the 40 other people will not come come and tell you the truth. So social scales have such a disadvantage. If you are doing a diagnostic scale, means that doesn't have this disadvantage of willingness to answer and things like that. What you see as a head circumference, if it is 55 centimeter, it is 55 centimeter. There is no here and there. But when you are measuring a mental health attribute, that social desirability scale, and this percentage by which they give the correct answer, or that have a very important role. Then formatting and scoring, everybody knows. I'm not getting into details because of the lack of time. This is a very, very important step, translation and back translation, because this comes under a validatory method. So if I have something in English language, okay, then I have to give it to a person who will convert it into my local language. If it is Malayalam, if it is Bengali, whatever it is, then the third person has to give an English expert has to be given, and he has to be asked to make this Bengali or Marathi into an English language. But they should not be given the original one. Very, very important. They should not be given that blinding should be done. Blinding and you have to check the first and the final version and see how much they are similar to each other. There can be a mathematically ranking also can be done, by which we will be sure that one is the way which with everything is same. That first and third set is similar means the ranking will be 1. If it is 0.7 means the ranking has gone mistake several times, but still it is good. But below 0.6 means that there is some mistake with the original one and the third one. So that translation and back translation is a sort of a validation step. So what is pre-test? As I said, several experts, we can do it with experts, we can do it with peer review can be done, we can do it with those people we intend to give the questionnaire, or application will be done in those people. There also we can do the pre-test. They will review and give you opinions about of the formatting, clarity, readability, and about the content. The testers will be asked to complete the items which will be listed, and they will be asked to do it at the same time. And since mine is a self-administered questionnaire, they were asked to fill it by themselves. When after completing the set of questionnaire, they were asked to think out loud and say what they want to say, that, okay, the third question, I'm not able to answer it correctly. It has a mistake here. I don't think this is applicable. I see the options, I've got this much problem. So that think out loud is very important at this step. So after the pre-test, I have to remove or modify certain questions, which I didn't even think it was such an important step, and I had to remove around 11 items. These numbers are not very important because it is different in different researchers and different people. The pilot work, we know it's very much important because it gives a clue about how this tool is going to be working among the people you are going to administer it. So this is not very important. Then I did the reliability test along with the pilot testing. But if you have resources, means if you have money, if you have people, if you have time, you can do it as a separate step also. But here I did it in among the 50 people from the pilot study only. I took 20 randomly by lottery method, and I gave them. That is, it is a test retest. We know it's a reliability. I am giving the tool now. Then I am giving a tool in another time and see whether the time factor has affected your. If it is completely different from the first one, means the time has definitely affected. See if major incident should not happen. So like in Kerala, if flood happens, and then flood will affect the mental health status of the individual. So that way, the major incident should not happen. It should be in it's a uniform structure, and then you can administer it. And then you can see whether the first and second scores. The same way you can see if it comes as 1 means it is completely agreeing with the first score, which is good. If it's 0.8 is also, it's very good. But if it is less than 0.6 means you have to think whether your questions are good or not, and you have to go back to the first step and do it again so that we don't have that mistake. So this is a reliability test by which we can understand that whether our questions are or items are good or not, or we need to be changed. So these are the modifications which I did, which is not important here. And final administration has to be done, which I did in Trivandrum. Along with this, I give a reference with the WHO subjective well-being scale also I gave, because their mental health status in an Ayurvedic scenario, I think several morbidity scales were available, and several other Ayurvedic scales are also available, I agree. But they were so lengthy that particularly my gate didn't agree, because mine took some time. At the same time, they are giving some other scale, this reference scales. Why? Because we wanted to look at the validity. That's why we gave the two scales together. What the precautions I took was, people don't have time, so you give lengthy questions, mean they are going to get frustrated. So additional validity, as I told, I did it in Kannur district, but there also I gave the WHF scale along with my scale. An additional validity was given in NIT scale, where I collected their CGPA also. And administration in ex-convicts was done, which was done in Trivandrum Central Jail. I took the addresses of the ex-convicts, and the crime ranking scores was there, which is a secondary data. Let me tell you, it was a secondary data. I didn't do it myself, but that what they had with them, I took it and used it in my study. Then data analysis was done. Demographic profile of the study population was done, which is not actually very important at this tool development stage. In tool development, I need to show though this much people scored this much in mental health is not important here. Here, what we have to understand as the steps of developing a tool which is important to a mental health. So this was the male-female frequency, location, urban, rural, and coastal. Then about their educational status, about their how many primary, secondary educations they had, skilled workers, how many had government jobs, manual labor, skilled laborers, income, etc. See, this is the main important one, isn't it? So when we check the convergent validity, it was seen that convergent validity with the other instrument, it was positively there was a correlation. That is, if you are giving a scale which was assessed to mental health, those who have poor mental health scored less in WHO SUBI scale also. So that means these two concepts, which was supposed to check the subjective well-being as well as the mental health, which is not exactly similar, but still comparable. They did what they had almost similar positive Pearson's correlation about 0.41. And convergent validity instrument developed is comparable to the other set designed to measure the similar concept. That's the convergent validity. Then ROCA curve was also found out by understanding the sensitivity and specificity, since it is a, you are giving it as in a segregation. You are understanding population to understand as a first level method. Then we have to give the sensitivity specificity also. So these are the sensitivity specificity range of the instrument, which is actually not important at this point, but I have to say that in several cut points I tried with the sensitivity specificity and it gained majorly at 40.5 levels. Here is where we check the score patterns of the instrument. Then I understood that, okay, the score pattern should be like this, because this is a point where I got the sensitivity and specificity maximum. So the positive predictive value, negative predictive value, and accuracy of the scale was 75. So if I put it in 38.5, my score, it will be accuracy is only 55. If I see if I try to increase the cut point to 42.5, then the accuracy is 62. So I took the phase whether my scale was accurate to the most high score. So that is the point where I will fix the cut value. This is the score cut pattern where I make the persons, poor, medium, or high mental health. That cannot be. I have seen several people doing this as categorically as 1 to 30 as poor, 30 to 60. No, it is not how to be done. We had to test the sensitivity, specificity, and then understand the cut points. See, these are the mean and standard deviation, which is not very important. And this is the score pattern, mental health ratings, individual scores, which is not very important. About the Kannur district data, about the gender distribution locations, not very important. Again, in Kannur district also, I got the almost similar, not exactly similar, but almost similar. Scoring pattern was a little different from that of the Trivandrum. Mental health ratings were similar, but it was little bit different. NITC also small. There was small variations in these geographical areas, but it was not that different by which we can say statistically it was not much different. Then scoring pattern was also seen, which was also a little bit different from that of Kannur and Trivandrum. But see the ex-convict scoring pattern, it was totally different from the people who have normal mental health, people who did not have any obvious mental health. So that was scoring pattern was extremely different. So that just suggests that this is somewhat different from the people where we have a vulnerable population and you gave them and they had a different scoring pattern, means this has got a potential to be applied in the people and find the so people who have little aberration have a little different scoring pattern. It's only a subset of population. I couldn't do it in much because there were several legal issues. People call from social services. They ask, why do you want to do it? Even if you get sanctioned authorities, they will give you sanctions. But still people will want, what is the, why you are applying this? What is that you want to gain from the study? So there were so many questions. So I could not take, I wanted to take more from the ex-convicts, but I could not because of the legal formalities. So there was a completely different picture when the score was checked with ex-convicts. So this we can see, which was very much different from the normal, normal population. Median also, you can see the difference. So that's criminal ranking, and when the ranking and the scores are, the people who had good scores had got lesser criminal sanguine. People who had bad scores in mental health status have a better criminal sanguine. But again, I will say that criminal ranking was not done by me. It was a secondary data. So these are the different sets of data, which is main study in Trivandrum, Kannur, NIT, and see the ex-convicts pattern, which is very much different from that of the original one. So the conclusion was it was mental health status. But what I would say at this junction is it's only a preliminary and a very basic level study. We can take the study People who like it can come and make the study into different branches. They can take this Sattvarada Tamas course if they need. I was simply looking at the mental health only, and I compared it with the subjective well-being status. So instrument had 38 items and equal weightage was given. Cutoff score of 40. I showed how I arrived at 40 because I have seen people doing the categorically they will divide the score. If it is total 90, then 30, 30, 30 they will do. That is not to be done. It has to be done by assessing the sensitivity, specificity only. The self-reported instrument could be completed in 12 minutes. At the end, it was like that. The instrument developed had a reliability showing instrument is stable with time. It has an internal consistency of 0.8 before deleting and 0.9 after deleting. It has space validity and content validity. And what is the deliverability is that it could screen, that is the main important thing, individual based on the mental health, can be used in scenarios where the mental health assessment is needed in case of all other achievement scores are similar values. So this was the thing I have published in JAME, Journal of Ayurveda and Integrative Medicine, after I think 2-3 years of giving, redacting, changing, etc. These are the publications. References. Thank you. Thank you very much. I have several other data with me. If you are interested, you can contact me through Pallavi Doctor, and I am very happy to explain. Thank you.
Thank you so much, ma'am. We would like to now hear the reflection and observations of our respected chairperson, co-chairperson, Dr. Manjunath sir and Dr. Rishi sir. Dr. Manjunath sir.
Hello, sir. Good evening to all. Congratulations to Dr. Ananda Lakshmi Madam for her presentation over the tool development in health research, designing mental health status assessment, and she has conducted a research over the 400 samples and prepared questionnaire and even the domains based on this Triguna Siddhanta and all. And presently, it's very, very important to know the mental health status of the individual. That will help for the diagnosis and the prognosis of the treatment also. Samadosha Samagnisha Samadhatu Malakriya Prasanatmendriya Manas Swastam Ityapedete. Manas is also plays an important role to be healthy. And presently, most of the people they are suffering with this mental disorders because of the changes in lifestyles and behaviors, etc. Everyone will be having their own tensions, anxiety, etc. and all. And most of them will not visit to the hospitals or take the consultation or the treatment. They will neglect it. So in Ayurveda, we are having many treatment measures, particularly it has been mentioned Daiva Apurusha, Yukti Apurusha, and Sattva Chikitsa. Early diagnosis and early treatment will give us a better result. So in this region, the madam what she has prepared, it was good, and many other tools also are available. We can utilize about the mental health status assessment of the individuals that will help for the prognosis and also disease, treatment aspect. Thank you. And I am very much thankful for the Atacon, the total team of the Atacon for giving me opportunity to co-chair this session and share my opinion. Thank you. Thank you, Nanda.
Thank you very much, sir. Now I invite Dr. Rishi Sharma sir for his brief remarks.
Akshay sir.
Yes, sir.
Yes, sir.
I think sir is not in the meeting.
Yeah, shall we move for the
Yeah,
chairperson's remarks?
please, sir. Please.
Yeah, thank you, sir. So we have now reached to the concluding part of this session. So this is my privilege to invite our respected chairperson, Dr. Baresh, sir, to share his concluding remarks and expert comments on and overall observation on today's session.
Good evening, everybody. So, this being the last session of a marathon day from morning, I've been observing all presentations here. At the outset, I'd like to thank the organizers for giving me this opportunity to chair this nice session. Madam had also published this article, as she mentioned in the last, almost roughly about a year back. Right, ma'am? So the pain she has taken in developing this tool really makes us wonder. Like many a times, we just go through some internet, download some skill, and just apply it during our post graduation or PhD studies. But when you go in deep to develop a tool like this, you know what are the variabilities there. You come out with lot of questions. Like to explain it in a simple way, you write an article on a simple topic, you give it to somebody for them to read and understand. What you were trying to communicate, what they understood would be completely different. That is where when you're developing an tool like this, changing it to a different language, again retranslating it, whether you get the same word, that really takes a good amount of expertise and time also, and overall a great patience, because bringing it from that number of elements and the words you pick up, and the focus group discussion wherein all like-minded people should sit together, come out with the thoughts. Really appreciate your effort, ma'am. Probably after this particular conference, you can take it one step further, where it can be developed into an instrument where it can be easily administered. Probably I don't know how we are going to do that, because right now it is in the form of a self-administered questionnaire, if I'm not wrong, where a person can go through the questions and tick it. Because way back, probably around 2 decades back, I think if it is the same Dr. Shah Jahan who came out with a Prakriti identifying tool. The same person is the co-author with you, right, ma'am?
Yes,
Anandalakshmi.
yes.
So 2 decades back, he had developed the Prakriti analysis software. And today, Madam has come out with one mental assessment protocol. I really appreciate, ma'am, because we find it difficult to understand this Triguna concept. Madam had missed the conclusion, what she had given in an article, that there was something like all these factors, she had brought it into 4 criteria: that strongly agree, disagree, strongly disagree. And then that would have brought into the final assessment of, okay, moderately or good mental health status. So probably in our curriculum, we need to include this, especially under the Manasaroga Chikitsa, where we can train our future doctor that they have a tool based on Ayurveda to assess the mental status of the patients or even a normal individual. And congratulations once again, ma'am, and thank you, the organizers, particularly the coordinator, Dr. Pallavi Pardesi, madam. She's been coordinating for the past 2 months or more to ensure that everything goes well. And I do participate in this session. Thank you. Jai Shri Gurudev.
Thank you. Thank you, sir.
Thank you. Thank you so much, sir, for your valuable feedback and guidance and encouraging encouragement to our participants.
Akshay sir,
Now I invite.
Dr. Ishu Sharma is there, sir.
Okay. So now I invite Dr. Rishu Sharma, sir, for his remarks.
Hello. Am I audible?
Yes, sir.
Yes, sir, you are.
Yes, sir.
The total session which was presented by ma'am was absolutely knowledgeable and was absolutely on the line of Ayurveda research values. I sincerely thanks Dr. Ananda Lakshmi ma'am for their kind knowledge to the participants. Thank you. Thank you so much, ma'am.
Thank you, sir, for the kind words.
Thanks, ma'am. Thanks a lot.
Thank you, sir. We have now reached the concluding part of this academic session. I invite Dr. Pallavi ma'am to propose the vote of thanks.
Okay.
I
Now
would
time.
I would like to thank Pallavi again and again. She was so patient with me. Thank you. All the organizers also. Thank you very much.
Thank you, ma'am. Now time is vote of thanks. We sincerely thank you, our speaker, Dr. Anand Lakshmi ma'am, for her insightful session on tool development in health research, designing mental health status assessment, and for sharing her valuable research with us. We are equally grateful to our chairperson, Dr. Baire sir, co-chairperson, Dr. Manjunath Aki sir, then Dr. Rishi Sharma sir, for their guidance and presence. Our heartfelt thank you also go to Ayurveda Teacher Association for organizing this platform and to all participants for their active engagement. Thank you all. Thank you, ma'am.
Thank you, respected speaker, respected chairperson, and respected co-chairperson for the last session. I also thank you, Dr. Pallavi madam and Dr. Akshay sir for coordination of this session. Thank you all. यह हमारा अंतिम सेशन था, अंतिम सत्र था और तत्पश्चात कार्यक्रम के अंत में बस इतना ही कहना चाहूँगा कि इस दुनिया में ना तो कुछ मुश्किल होता है और ना ही आसान होता है। सारा खेल तो बस मानने का है। जो मानता है कि उसके लिए मुश्किल है और जो मानता है कि उसके लिए आसान है, उसके लिए आसान है। क्योंकि मुश्किल नहीं है कुछ इस जहां में, बस जरा कोशिश तो करे। ख्वाब बदलेंगे हकीकत में, बस जरा कोशिश तो करे। ऐसी ही कोशिशों को दुनिया सराहती है, सलाम करती है। हमारी ऐसी ही छोटी सी कोशिश एटेकॉन 2026 के माध्यम से, जिसे आज हमने हमारे प्रमुख वक्ताओं के द्वारा आयुर्वेद के विभिन्न अंगों पर चर्चा की और जिसे अध्यक्ष सह अध्यक्ष द्वारा मार्गदर्शन मिला। और अब इस अंतिम चरण में मुझे काफ़ी खुशी मिल रही है कि आज का एटेकॉन 2026 का ऑनलाइन का प्रथम पड़ाव हमने सफलतापूर्वक पूरा किया। एटेकॉन 2026 इनोवेटिव आयुर्वेदा 8th नेशनल कॉन्फ्रेंस, जिसे एटीए द्वारा आयोजित किया गया और आज आप सब हमारे साथ जुड़े, हमें सहयोग दिया। मैं आप सभी का हार्दिक आभारी हूं। मैं सदैव आपका ऋणी रहूंगा। यहां तक हमारा साथ देने के लिए बहुत बहुत धन्यवाद। अब मैं मेरी को होस्ट डॉक्टर जयश्री तायडे मैडम से निवेदन करता हूं कि वे आभार प्रदर्शन करें, वोट ऑफ थैंक्स करें। जयश्री मैडम।
Thank you, Ajit sir, for giving me opportunity for vote of thanks. As we bring successful online session today, myself, Dr. Jayashri, stand before you all with sense of gratitude. Firstly, I extend my sincere thanks to Dr. Rahul Suryavanshi sir, National President ATA, Dr. Nidil Sandurkar sir, Secretary ATA, and all dignitary members and all organizing team who working tirelessly for the welfare of Ayurveda and supporting Ayurveda Teachers Association. Thank you organizing team for giving me opportunity as online day in charge. It was really wonderful, enriching experience for me. Nextly, I am obliged to all esteemed speakers of 7 comprehensive online sessions based on theme Innovative Ayurveda, whose profound academic excellence and clinical experiences enrich everyone's mind today. Thank you all respected chairperson, co-chairpersons for their valuable presence and remarkable observations for their respective sessions. And thank you all my session coordinators, starting from first session, I would like to thank Dr. Meenakshi Pal Bagel ma'am, Dr. Ankush Dikonwar sir, Dr. Vipul Dikshit sir, Dr. Kiran Mendekar ma'am, Dr. Sonia Dahat ma'am, Dr. Nagendra Thakre sir, Dr. Deepika Survase ma'am, Dr. Adil Khan sir, Dr. Priyanka Shinde ma'am, Dr. Nandakishore Kale sir, Dr. Shanti Nair ma'am, Dr. Amol Deshpande sir, Dr. Pallavi Pardesi ma'am, and Dr. Akshay Palgavkar sir. All our session coordinators have worked tirelessly. They keep us on track and manage our timeline very smoothly. My heartfelt thanks to our technical team, Dr. Samadhan sir, Dr. Pavan sir, our student Dr. Akshay Mahamulkar, whose behind the scenes hard work ensured our virtual platform ran smoothly without any glitches. And my sincere thanks to all registered delegates, all learned faculty members, researchers, students who joined this virtual platform throughout the day. Last but not the least, I thank my co-in-charge for this online session, Dr. Ajit Vahane sir, for his timely cooperation and guidance. Thank you, sir. So, with this vote of thanks, our online session officially ends here. But tomorrow we transition to our grand offline session. We look forward to meet all you in person at CL Chowsky Auditorium, Ellen City University, JK Bhopal campus for our 6 highly engaging academic sessions. So, see you all there. Dhanyavad. Jai Ayurved. Jai Bharat.
जय आयुर्वेद. थैंक यू वेरी मच मैडम. राहुल सूर्यवंशी सर ज्वाइन हुए हैं क्या मैडम? मुझे पता नहीं.
सर नहीं
नहीं
दिखा
है.
दे रहे.
ओके ओके, नो प्रॉब्लम, नो. Thank you, madam. Thank you very much. And thank you all the respected faculty members.
Yes, sir. All the session coordinators who are present here, kindly on their videos, we will take one screenshot, please. Thank you.
ये ऐसा फोटो लिया जाता है, मुझे पता नहीं था.
नहीं सर, स्क्रीनशॉट ले, हम यहाँ पे प्रिंट स्क्रीन करके ऑप्शन होता है, तो मैं ऑन करती हूँ, उसमें हमारा स्क्रीनशॉट ऑन मतलब लिया जाएगा.
ओके मैडम, बढ़िया.
पल्लवी परदेसी मैम are there, and all other delegates also who are there, doctors Geeta Pandey ma'am, Durgesh Gupta sir, Yash Agrawal sir, they can also on their videos. We will take one screenshot here. Yes, Dr. Akshay. Okay, so we'll take. Thank you, everyone.
Thank you, madam. Thank you. Thank you, Akshay, for the wonderful help. It was really nice.
Yes, sir. Thank you.
Can we log out?
Yes, sir.
Finally छोड़ दिया आपने. Thank you.
Thank you,
Thank you all.
everyone. Thank you, Dr. Akshay, for cooperating throughout the day. Thank you, managing all the recordings.